And when you go home, you will have permission to buzz the tower. You will be able to bring all this information that you learn over the next few days back to your home institutions so your patients can benefit. Now, when you get home, the charge nurse might start screaming, "Goodness gracious, great balls of fire!" Because if you work in an institution where I do, especially over the last 3 years, it's been a bit of a dumpster fire, hasn't it? But you won't panic because you will have the information you need to address all the different clinical problems that can come up. And you'll never lose that love and feeling, that love of providing great care to patients, because we are all on team patient, and we have to work together to make sure that they get the best care. And if you're working in an emergency department, you're not happy unless you're going Mach 2 with your hair on fire. It is a chaotic environment. We have to make decisions quickly on a thin slice of information. And sometimes that information and decisions that we'll be making will have life or death consequences. But you love it. I know you love it, or you wouldn't be here. And communication, so key. We have a multidisciplinary department. There are nurse practitioners, PAs, NPs, MDs, DOs, techs, staff members. We all have to work together and communicate effectively for patients to get the best care. And at some point during the course, we may take your breath away because we have such a great faculty, of course, but also the information may seem overwhelming to you. Don't worry. Don't panic. We've got the Slido system set up so you can ask questions in real time. We have the panel discussions to answer your questions. And also, you can reach out to any of the faculty members with questions after this course going, I didn't really understand that. Or can you give me more information on what you're talking about? And the reality is, in our job, people will die. Everyone dies eventually. But remember, you can do everything right and still have an adverse outcome and still have a death. But it won't be because you didn't have the knowledge to address the case. So when you get back home, your ego will be writing checks your body can cash. So strap in EM boot camp because we are heading to the education zone. Woo! Something. Give me something back. Thank you. And now we will commence with our regularly scheduled program. I like making an entrance. All right, I've got the first lecture. And then while they get that, do I have to stay in a box here now? Do I have to? Okay, I have to stay in a box. That's hard for me. All right, so my name's Ken Milne, and I think Rick's in the back there, our course director. I think they give me all the orthopedic lectures because look at me, and also because I started an orthopedic residency, but I didn't finish an orthopedic residency. I became very sensitive in the early 90s, and being anaphylactic to latex tends to be a barrier to operating. And after a couple of anaphylactic reactions in the OR, they felt it best that I might pursue another course of career. And so I actually switched out and did primary care. So I have my primary care residency, and then I went back and double board certified in emergency medicine after that. Another reason might be because I do the orthopedic lectures because I've had most of these injuries. And the knees are probably my weakest joint. So let's start with a little bit of anatomy on the knee. Who designed this? Really? Yes, wonderful range of motion. It can travel back and forth in one direction, but it doesn't have a lot of stability. You hit that thing on either side or even front or back, and you go down hard. And so that means the soft tissue is so much more important. They're called the cruciate ligaments for a reason. They're crucial. Then you've got your lateral stabilizing ligaments, your medial and lateral collaterals, and then the muscles around that. But it doesn't offer much protection, and the knee often gets hurt. So this just shows with some of the muscles and on top of that knee for the anatomy. You got your quadriceps up front, you got your hammies in the back, and down the side you got that big iliotibial band that can cause some real irritation for people. And we often see patients coming to the emergency department with iliotibial issues. And we often get plain films, and they're often not very helpful, right? They're not very helpful when we get the picture because it's usually the soft tissue that's getting you into trouble. But the standard views, you get your AP front and back, you get the lateral, and then this then says a sunrise view or a sunset view. I live in a place where it's the only place in the world apparently that you can see the sunset twice. So it's over a great lake up in Ontario, Canada, and we have this cliff. And you go down and you watch the sunset and drop below the horizon. And then as soon as it dips, you hike up the cliff and watch it go down again. It's really neat. But if you're in the city, you'd call this a skyline view, looking at the patella straight on to see how it fits in that femoral groove. You can consider using the Ottawa ankle rules, which is a clinical decision instrument. It's available on MD Calc, so you can figure out, do I even need an x-ray in this? Is it a hill I'm going to die on and not get an x-ray? If somebody's like, I want an x-ray, I'm like, yeah, okay. It's not a hill I'm going to die on, but there is a clinical decision instrument that can help inform whether or not you need to get that x-ray. And really, we're using that to rule out fractures. So, the Ottawa knee rules, created in Ottawa, Canada by Ian Steele, probably one of the most validated clinical decision instruments, only behind the Ottawa ankle rules. 5 components, pretty easy. If you have isolated patellar pain, get an x-ray. That's usually from somebody landing on a direct blow on their kneecap and you're looking for a fractured kneecap. Okay? Isolated proximal fibular pain. That is what you're looking for, is the head of the fibula is broken, and it can happen with a Maisonneuve fracture. That's when you do an E version of your ankle, and it comes up, and the force comes out the head of the fibula, and you actually fracture your fibula, and you're sitting there focused on the ankle, and that's why the joint above and joint below comes in. That's a Maisonneuve fracture. So that's what that's looking for, the head of the fibula. And then if they're not able to actually flex past 90 degrees, that's a sign of getting an x-ray. And then that clinical one of not being able to weight bear immediately after taking steps, immediately after in the department. And then the final one, if my knee hurts, I'm getting an x-ray because I'm over 55. Then there's the knee exam, and look at all these exams there are. There's the McMurray test, the Lockman, the anterior drawer, the posterior drawer, the pivot shift test, all these different tests. I have to tell you, most of the time, when people come in with this big fat knee, or it's really painful, trying to get your hands around that can be difficult. Trying to do that Lockman can be difficult, even for me. Putting them down and doing the Apley and just seeing if you can grind on that medial meniscus, it's not going to change my management. I'm going to say, you sprained your knee, 2 weeks of rest, cast, and or not cast, 2 weeks of rest, crutches, and some NSAIDs, and we'll see you back, or you'll be seen at your primary care facility. We have a YouTube link if you want to go through all those different exam findings. So let's focus in on some specific injuries. There's the cruciate ligaments, the ACL, and the PCL. The ACL goes out way more often than the posterior. And when it goes, the patient will tell you, oh, I felt it pop. I have to tell you, I've done 3 ACLs. I know what you're thinking, Ken. You only have 2 ACLs. Yes, I blew out my graft. So I did my right one, I did my left one, and then I did my right one again after it had been surgically repaired. Every time I felt that pump, the instability, I could still walk on it, right? But there was nothing. It was just very sloppy in the joint. And I got the big hemarthrosis. So you got this big bowling ball of a knee when it happens. The exam can be difficult to do it at that time. And usually the x-rays are negative for bony injuries. You may see something called a Sagon fracture. Sagon fracture. You may see that Sagon. It's a little avulsion fracture. that gives you a hint that you're looking 90% of the time at someone who's torn their ACL. And we'll show you an x-ray with that Seguin fracture. But usually all you see is soft tissue swelling. Big, huge knee on x-ray. Crutches, pain control, knee immobilizer, see someone else in a couple of weeks. Here's the Seguin fracture. Here's a little clinical pearl though. If you ever see a positive arrow sign on an x-ray, that means something's going on. If all x-rays came with the positive arrow sign, I wouldn't miss anything. And I've missed a few things, but having a positive arrow sign is really helpful. So this shows that positive arrow sign on the lateral aspect of the knee, and that's the Seguin. It's a little fleck, you know, and if you miss it, you call it the mother flecker, but it's a little fleck showing that you've probably torn 90% of the time your ACL. Again, there can be a meniscal injury in there as well. You put them in a knee immobilizer, you get them on some crutches, activity is tolerated, and maybe some NSAIDs, and refer to ortho. ACL. A tibial spine fracture, so where the cruciate ligaments come up, you'll see those cruciate horns, anterior and posterior. You can also see a little avulsion fracture off that, and that would also signal that you've probably got an ACL injury. Large effusion is helpful for saying, ooh, I think you've got a hemarthrosis. And if you look at that lower x-ray, it doesn't have one positive arrow sign, it has two positive arrow signs. And so it's showing the anterior horn has a little avulsion off of it, but that white arrow is also showing, yeah, it's got a Seguin fracture there. So it's got probably an ACL tear. And then there's the unhappy triad, or the Donahue terrible triad. So that was mine, my left one. When I blew out my left ACL, I had all three of those things. I did my ACL, my MCL, and my medial meniscus. Got a big hemarthrosis. It's usually from a lateral force to the knee. I did mine playing soccer. The other one was volleyball. Usually needs surgical repair, yes. Now, that's sort of an orthopedic, it all depends, because the older you are, the less likely they are to repair these ACLs now. So I don't tell people, oh, you're going to need an ACL repair. If they're younger, and you can define that by your own age, because that's how I define young. Anything younger than me is young, and anything older is older. So when I was 35, 34 was young, and 36 was old, right? It changes. But with the orthopedic surgeons, they may choose to operate, they may choose not to operate based on how old that patient is and how active they are. And so there are some of the mechanisms of injuries that can lead to Seguin fractures. You see the football, or now with the FIFA World Cup going on, those lateral, either a varus injury, so the varus would be a medial blow going to the outside, or a valgus injury hitting on the outside of the knee and pushing it in and getting that medial meniscus to go and medial collateral ligament to go, the unhappy triad. And then with meniscal injuries, there's so many different types that you can knock off your meniscus. You can get a bucket handle tear, you can get a little tear, you can get a horn tear. They just rip. These little cartilaginous things rip. And you'll find that you get a patient who comes in saying, my knee clicks. It clicks on me. I can feel it. I think I can hear it, but I can feel it clicking. Or they may say it locks on me. I had a free-floating body in my knee for a while, and I used to just get under the couch with one foot and push with the other to pop the knee back in because, you know, I have problems, issues. So, but if you get a free body in there, it can lock up the knee and get stuck. And so if it's got a mechanical locking, they'll often take those into the OR and do an arthroscopy and try to pull that loose body out. Collateral ligaments, the MCL goes way more often than the LCL, so if you're thinking, geez, I wonder if it's going to be the MCL or the LCL, it's usually the MCL that goes. Children can get partial tears, grown-ups tend to tear the whole thing. The lateral collateral is a little sneaky. It's sometimes hard to pick up, and it's all about getting them into physio and getting them to rehab. You can refer them to ortho. Sometimes that MCL will need surgical repair, depending on age and stability. They rarely, and I'm trying to think of, when I've ever gotten an emergency MRI on a knee unless I'm worried about something else, not this kind of ligament injury. Okay, now joint dislocations. So This is not your patella dislocating. When people come in and they say they've dislocated their knee and their patella's pointing towards the wall while their nose is looking at you, that is not a knee dislocation. That's a patellar dislocation. This is when the whole knee goes pop, and it usually pops out and pops back in. And it takes a lot of force to do that, so it pops out and pops back in. But when it pops out, it's at a high risk for a vascular injury. An important artery is running down the back there. Something that goes thump, thump, thump that your leg requires to stay alive. And so if you suspect that there has been a dislocation, and they'll come back in, the x-rays will show that it's located. It's not a dislocated knee. If you suspect that it's dislocated, that's when you're going to get the CT angiogram, looking for that popliteal injury, looking for vascular injuries distal to the knee. Bicruciate ligament instability, okay. If you blow out your ACL and your PCL, then you've probably dislocated your knee, and you've just got this really sloppy knee on exam. It just moves all over the place. Again, you're looking for a popliteal injury. If that popliteal injury is not identified and you have a vascular injury and you cut off that blood supply to the lower part of your leg, this can happen. And you're walking around on one leg. So you need to know, if you have a high index of suspicion, that this is a dislocated knee, to consider a popliteal injury. The patellar dislocations are a lot easier. They come in, the knee is bent because they can't straighten it. Their nose is pointing forward, their toe is pointing forward, and their patella is pointing to the wall. All you have to do is extend the knee and push medially, inwards, medially on the patella, and it pops back in. There's no vascular structures that you have to worry about, like the popliteal artery, so you can pop those back in. They may require a little sedation, but not necessarily. Distal femur fractures. You have to have major force to fracture your femur, major force. And you'd look for other injuries. If you've got enough force to break your femur, you should be looking for other injuries in the axis, or in the axis. So, this one has a Salter-Harris 2 injury. So there are different injury patterns. They're listed A, B, B, whatever. I have never spoken to an orthopedic surgeon and given him that nomenclature. I haven't. Not since I've been practicing emergency medicine. I just go, yeah, it's broken. It's all in pieces. Maybe if it's interarticular or not, but usually they can access these images digitally and we don't have to have that descriptive discussion. But this requires reduction. This requires surgery. You put them in a long splint to hold them immobile, adequate pain control. Often you need a CT scan to really get an idea of where all those pieces are. Tibial plateau fractures. These can be sneaky. I've missed a couple of these over the years. They can be really sneaky, right? You don't see it on plain film. It shows up really nicely usually on CT. But if you have some kind of axial load onto that patella, onto that tibial plateau, it can depress that tibial plateau and you end up with a fracture, and that can cause a lot of osteoarthritis down the road if it's not surgically corrected and fixed. Oh, and it has a positive circle sign, even better. Now I don't have to just look for the arrow. I go, oh, they mean right here. I don't have to look at the rest of the x-ray. Very helpful. Osgood-Schlatters disease, one of my favorite medical conditions, only because I love saying Osgood-Schlatters. Who doesn't? Ooh, you've got Osgood-Schlatters, and people are like, oh, really, do I? Oh, that sounds so wonderful, right? It's like clinical gestalt. I mean, it just, I love the name. So Osgood-Schlatters disease. So this is when kids are growing really fast. They're going through their growth spurt. They avulse where their patellar tendon inserts into the anterior tibia. They're growing so fast, sometimes it can be sports related, but they're growing so fast it pulls out and they get that bump on the front of their tibia, right? And it's sore, take some time, rest, some NSAIDs, all good, but they had Osgood-Schlatters disease. And if you tell them that to their dying day in their past medical history, when they won't remember, that they had a STEMI or COPD or anything, but when you're taking that path, oh, I had Osgood-Schlatters disease. I guarantee you they'll say it. All right, child abuse, something serious here. Look for those positive arrow signs, but that big arrow at the top of the screen, that's a metaphyseal corner fracture. that is a really good indication that there's been some physical abuse. And then those little arrows along the bottom, that's called a bucket handle tear. And again, signs of abuse. Child Protective Services. Osteoarthritis of the knee, yes, very common. Risk factors, trauma, my age, right? Obesity can do this as well. Sports-related, repetitive stress, post-surgical stuff. First, you get joint space narrowing. So the joint narrows. So when you see the plane films, you'll see that space in the knee narrow. And then you get that white part of the bone becomes much brighter. That's called sclerosis of the bone. So that's a second sign that you got osteo. Third is you'll get these little punched out cysts, subchondral cysts, and then you'll get osteophytes, little bone spurs growing out from where that's banging away. Those are the 4 signs of osteoarthritis of the knee. Acetaminophen, not an NSAID. It's more of an osis than an itis. It's not so much inflammation. It's more of an osis than an itis. Itis means inflammation. We call it osteoarthritis, but it's a bit of a misnomer. Gout of the knee. Gout of the foot is really easy, isn't it? You walk in, you go, yeah, that's gout. No diagnostic dilemma. But somebody comes in with a big, red, hot knee. It can be, is this septic? Is this osteoarthritis? Did you have a trauma? Could it be pseudogout or gout? So gout, if you tap it, you'll see these biopharyngent crystals, right? That's your telltale sign. Another thing is if they've always had a repeat attack in the same joint is gout. Different joints where it jumps around is pseudogout. So acute gout can hit you in the knee. Not as often as the big toe. Also had that. So if you get gout of the knee, you can tap it. If you're not worried about cellulitis and going through infected skin and stuff like that. You need to see those crystals, not you personally, but the lab. The uric acid level may be normal. So you can have someone with terrible gout and their uric acid level is normal. Do we call that not gout then? Do we go, oh no, sorry, the lab test's normal, you don't have it. Meanwhile, the person's like, seriously? Really? My knee's killing me. I treat people, not labs. So you can have a really high uric acid level and go through your whole life without a gout attack. You can have normal uric acid levels and have devastating gout. So I treat the patient, not the labs, and I find that the labs misdirect me more than they help me. A key for this, though, is you don't use allopurinol when they have a gout flare. That's a bad. You make things worse, bad, okay? Now, you can use steroids, you can use NSAIDs, you can even use colchicine. That may give them diarrhea and GI upset, but you don't give them allopurinol when they've got an acute attack. That's for prevention, not for acute treatment. And then pseudogout, look at it, it's got a positive red arrow sign. It must be really important. And here you see calcifications because it's caused by calcium. So you get calcium in the joint. And you've probably seen x-rays like this and you go, what the heck is that? And you'll see it up in the shoulder, you'll see it in the knee, sometimes in the hip, but you'll see the calcium deposit there. That is pseudogout. And it tends to skip around different joints, and it's NSAIDs and steroids for this. Usually older patients, much older, much older, I bet, is Rick still here? 70s, in their 70s usually, whereas gout is usually more in their 40s and 50s. Now the septic joint, again, a very painful joint, usually monoarticular, a single joint is red and inflamed and hot. If it's little kids, less than 2 years of age, you're thinking staph. If it's older kids and they're into that, hey, how you doing stage, then you're going to be thinking gonococcal. You're going to be looking deeply into their eyes and see if you see pus coming out of their eye and they've got a hot knee, think gonococcal, okay? So gonococcal in the older individual that's sexually active, but in the little kids, staph. And then post-surgical, of course, staph or strep, right? Staph or strep for that. Now, the joints don't like infection, and it can chew through the cartilage fairly quickly, so you have to be careful to jump on these early. Start some antibiotics, but I'd be calling the orthopedic surgeon if it's a post-op thing, because this will need to be washed out usually. I haven't seen them not take them to the OR. And you can get an IV started. You can order up whatever 3-letter test you want, CBC, ESR, CRP, I don't care, right? Because I'm going to treat the knee. If I see a red hot knee and the patient, let's say, has a fever too, and they're like 2 weeks post-op total knee replacement, and their CRP is normal, is that okay? My pretest probability, it doesn't matter what the CRP says. It doesn't matter what the white count is. It doesn't matter what the ESR is. This person clinically has a hot joint. If you have an open knee wound, so where I am in Canada, there's a lot of chainsawing accidents. I have a nice scar right here on this knee. The chainsaw was idling and I was getting tired and I just dropped the bar right through the knee, right? So what do? I take a shot with my cell phone camera, and my wife was at work, and I send it to her, and then I ghosted her. Because that's the kind of husband I am. And I just had blood just pouring down, but I had to finish what I was doing, right? But she's like, oh my God. Yeah, anyways, it was merely a flesh wound. Anyways, you don't end up married for 30 years if you don't know the nerves to push. So with this, you're looking for an open joint, right? It can be hard to tell clinically by, lifting up. Is it transmitting through to the joint or not? I don't know. I can't tell. You may get a hint on a lateral view, seeing some air in the joint. Okay. But these usually require some infusion of some fluids like methyl blue or some saline to try to do that. I have not been the person that does that. I've referred them on by that time. Yeah, saline and methylene blue. All right, patellar femoral syndrome. If there's any runners in there, you can fall asleep right now because you know what this is like. You get that kneecap pain from repetitive strain injury, chondromalacia. Rub, 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 rub. Doctor, it hurts when I go for a run. I'm just spitballing here. Stop running for a bit and then start up again. Okay, because it's usually activity related for these things. Bursitis of the knee. There are so many bursa around the knee. There are some few that are really important, a few that really can sort of set you down a diagnostic thing. The sometimes I see it's is this infectious or is this just a bursitis, right? And so, the tip-offs can be red, but sometimes they're both red. You don't want to do an IND. You don't want to go, hey, you look like you have an abscess of your knee. I'm going to take out my number 10 blade and make a 2-centimeter incision and release the evil humors. This would be bad. Okay, if you are going to do it, you would aspirate it because you can create a sinus where that thing will drain and stay open for a very long time if it's a bursa. So you go in with a needle and drain them. You don't do an incision and drainage. You can do a needle, you can aspirate, but don't do an IND, please. Antibiotics if it's looking yucky, right? The suprapatellar bursitis, this is the interesting one. That's the one that's in the blue at the very top of the picture. The blue in the very top of the picture. You see how that could communicate with the joint itself. So if that was an infected bursa, the rest of them are sort of protected. The joint is sort of protected. But this one, the joint isn't protected, and that can go into the joint and be in an interarticular infection, and the cartilage and the interarticular surfaces do not like infection. And they can be impressive. Like, look at that thing. Holy smokes. But how you tell that it's not somebody's ACL? It's not circumferential. It's not a bowling ball knee. It's a huge mushroom cap on the top, a muffin top. It's not completely around the whole knee. If you blow out your ACL, it's your whole knee that goes, and you've got a bowling ball there, not just a big, huge muffin top. Patellar and quadricep tendon ruptures. So you can blow out your quad, and it depends on if you blow it out above the patella or below the patella. That's how you know whether or not where the injury is, because where the patella will be contracted. So if you cut it here, if you blow out infrapatellar, the kneecap, of course, your quad's going to pull your kneecap into your thigh. You go, oh, your patella's right there. I know where it's torn, right? Key is that they lose their extensor mechanism. So they'll be sitting there, you hold their leg up straight, and it goes, ring. Go straighten your leg. They can't. So you straighten the leg for them, and they go, ring. That is a loss of the extensor mechanism. That means you've blown out your quadricep tendon. You usually just splint these. Interesting, fluoroquinolones can do this. And you probably knew that about the ankle, right? Blowing your Achilles tendon when you gave some Cipro for 3 days for their bladder infection. We didn't know this until millions of prescriptions went out that you could blow your Achilles tendon this way. And in fact, that risk is maintained for months, not days, not weeks, but months, up to a year sometimes. So you have to go, oh, have you been on a fluoroquinolone lately because you blew out your quadricep or your Achilles? And they go, oh, no. Okay, no, but did you have a bladder infection this year? It can be that long. Popliteal or Baker's cyst, this is the one in the back. I had one, not me personally, but I had one recently in the emergency department, and it mimics a DVT. This person had a big, swollen, tight, tender calf, right? The whole leg, boom. But it was a sudden onset, which sort of made me think, okay, is this a Baker's cyst? There was a lot of squatting and kneeling involved in this person's job when it happened. And at the end of the day, you get an ultrasound and you figure it out. And the ultrasound shows you both, whether they had a DVT or a Baker's cyst. And this was a ruptured Baker's cyst. That's in the back of the knee. Achilles tendon injury. So this is a push-off injury. You see this in jumping sports. You see this in, things like diving board sports, gymnastics, trampolines, those types of things, and you blow the Achilles. Now, they'll hear a real sharp snap, right? And then the foot will be in an equine position, pointing down. They can't, pull it back. It just sits there and hangs down like this. And you can probably feel a gap when you palpate along that Achilles at the back of the heel. And you can get an ultrasound out. I'm an average sounder, I'm not an ultrasounder, but I'll take a look and see if I can see the gap there. That'll be a tip-off. But the key to this is that when you splint them, almost always we're splinting the foot flat at 90 degrees, right? You want a 90-degree angle when we're splinting the leg because we don't want that Achilles tendon to shorten and get stiff and require a lot of physiotherapy. That's with ankle injuries, not with Achilles injuries. We actually want that Achilles to be short so it can reconnect. And so you splint these in a plantar position with the toe pointing down. Equine, like a horse, walking on their toes. That's where the equine position comes from, walking on your toes, and then you send them off to surgery. This is an injury I've had. This is a plantar tendon tear. This is the medial body of your gastrocnemius. I got this from a diving board injury. So it's a push-off mechanism. I volunteer as a summer camp doctor for about 10 years. And the early teenage boys, 13, 14, would have a contest called the Screaming Eagle. And there was a 3-meter springboard that went out into the lake, and they would jump and then scream out across the lake as loud as they could, and whoever had the best scream would win this Screaming Eagle award. And so, being the type of person I am, I joined in. And I went, and I'm like in my 40s, and I jump, and snap, oh, you couldn't hear it just across the lake. That scream was heard in downtown Toronto. I think even the U.S. may have heard it. It was a high-pitched scream. I won the award. I was very proud, thank you. But when I limped back to the cabin, and my wife was there, and she goes, oh, Ken, what's wrong? And I'm like, oh. And I explained what I was doing. She goes, as long as you're going to act like a teenage boy, no sympathy for that injury. Okay? And so it's rest, ice, tensor bandage time, NSAIDs. MRI of the knee? Nah, they're rarely ever needed, okay? Or CT, but CT usually more often for tibial plateau fractures. There's an algorithm at the end to consolidate some of your information about knees. Thank you very much. My first lecture is done. I'll be leaving now. Oh my goodness, he was in the audience. 70 is still young. Spring chicken.
Oh, geez.
You weren't there for that, were you?
Yes, I was. I was
My last lecture. It was my first and last lecture.
So, good morning. I hope you had a chance to go back to your room last night and study the manual extensively. in preparation for today. So we're going to do a little bit more of this. This is a friend of mine. He did a study of 10 million emergency department visits seen by about 98 physicians, 98 claims. 90 doctors were involved in 98 claims. So 10 million visits, 98 doctors. And basically that showed, this is over a 4-year or 5-year period, that in that period of time, 1 in 11 physicians was going to be named in a suit. This is a group that basically takes their risk management very seriously. In terms of their suit risk has been very much less than the average. So this is what they found. The leading cause of suits in their case was neurologic, which has to be something to do with stroke. Either too much, too little, too fast, too slow, something like that. Missed the diagnosis, missed the opportunity, lost opportunity to recover, et cetera, et cetera. GI is next. There's got to be some appendicitis in there, you would think, for sure. And then look at all the others are about the same. Cardiac, GYN, ortho, respiratory, they're all about the same. But that doesn't help us as much as some specific diagnoses, which we're going to look at coming up. What was the resolution of these cases? So there were talking about 98 cases, 70 of them were dismissed. So we paid money on 21 of them. 21 of them was settled by some kind of payment, and then only 6 of them went to court. 6 out of 98 went to court, and that's the general rule. And when doctors go to court, they usually win most of their actions. However, one of the risks of going to court is the awards may be substantially better, higher than if you had settled. So it's like, are you feeling lucky, punk? If you want to take it to court, statistically you're going to win, but you're going to be playing a high-stakes game in terms of how much money is involved in this case. So this is often the decision of the insurance company. This is not about your honor or you're right or wrong. It was basically about how little money can we spend to resolve this problem. And if it means that we settle, we settle. And sometimes the doctors say, oh, no, I want to go. I want to fight this. And they say, fine, you're welcome to fight this. We'll give you the lawyer. But if you lose, we were able to get a settlement for this. This is the settlement that, this is the award that was given in the court. You pay the difference. So most physicians at that time will back out because they don't really have the intestinal fortitude to keep up and realize it would be paying out of their own money. One of the things that was most interesting is let's stratify these people to see who were the people who were getting sued. And the fact of the matter is that the only thing that mattered in terms of the number of suits that you had is how many patients you saw. It didn't matter whether you were a male or female. It didn't matter whether you were board certified in emergency medicine or not, which gives you the heebie-jeebies. It's like, what did you do that residency for? Whether your rate of admission, high, low, testing, no testing, didn't matter. None of that mattered. All that mattered is how many patients you see in your career. So this basically says it's going to happen to most of us, especially 1 in 11 in 5 years. Well, you have a 25-year career. So the likelihood of you being sued is pretty good. This study looked at the doctors who were sued and the change in the behavior induced by that they're being sued. You would think that the first thing they would do is order more tests. Got to order more tests. That wasn't the case. I think it wasn't the case because they couldn't possibly order more tests. They were already ordering the maximum number of tests, in my cynical point of view, because I think that younger physicians tend to be testing machines, I think. However, what did happen is their Press Ganey scores improved immediately. bam, up, all of them. So the idea here is that these guys got the message that you got to treat patients like you wanted to be treated, that you have to basically make that extra effort, whether you like it or not. It's part of the job, non-negotiable. So their scores got better, not their ordering. That didn't change. Here's the survey, internet survey. 804 people were asked to respond to a case of missed appendicitis. Somebody goes, they're seen in the ER, and then there's a little shared decision-making about whether we're going to get a CAT scan or not, those kinds of things. And there's an explanation of, well, we can do this, we can do that, here's your options, what do you think, that kind of thing. So a little shared decision-making. Then there was another case where they gave more to shared decision-making, and this about the case that ultimately was a ruptured appendix. They gave more information. And in the third case, they gave no shared decision-making information at all. They said, what was the likelihood of you making a claim under these settings? A little bit of shared decision-making with the patient, a lot of shared decision-making with the patient, no shared decision-making with the patient. The likelihood of them complaining or or seeking out a lawyer, 12%, 11%, 41%. The idea here is basically patients like to be involved in the decision-making. Here's a case where the number of suits was fourfold, or complaints were fourfold. Now, obviously, this is theoretical. This is 800 people on the internet. But it seems to be, at least in this case, that shared decision-making would have, even a small amount, would have substantially decreased the likelihood of people complaining. And not only that, basically the patients, the internet patients, higher trust, rated their physician more highly, were less likely to find fault. Those kinds of things were in this case that was presented to them. So they had a better view of the physician when the physician was involved with shared decision-making. The outcome was the same in all three cases. The outcome was bad in all three cases, but how the patients perceived the physicians and the errors that occurred were different in this as a result of the shared decision-making effort. Goveris is an insurance company that insures, they insure hospitals. And so they're insuring emergency departments, and they're insuring the people who work in the emergency departments. So these are employed doctors. These are not contract doctors. Contract doctors have their own insurance. These are doctors who are covered by the insurance of the hospital. Basically, it indicated that we are the fourth leading cause of suits in the hospital. I'm surprised it's that low. Here are the body systems. Now, their body system list is a little different. They have cardiology at the top, which I think is really much more easy to understand than neurology. Neurology basically came in it was third. So it was infections and cardiovascular. The infections that we're talking about here tend to be, well, maybe there was a missed sepsis, that was possibly, but what about these other infections, like these infections that involve the spine, the spinal epidural abscesses, and the necrotizing fasciitis, and those kinds of infections, which are really serious in terms of their outcome. So those were on the list. And that's kind of strange. Now, we often say, these are all nuisance suits. Nuisance suits. Well, in the nuisance suits, 36% of the people died. That's a pretty good nuisance. Grave injury, 2%. Permanent major problem, 8%. Significant permanent injury, 15%. Minor permanent injury, 9%. And varying severity of temporary injuries was 30%. So you got to give them a break and say at least 60 or 70% of these injuries that involved in lawsuits were serious and permanent, if not involving death. Top risk management issues were clinical judgment. That's basically you made the wrong diagnosis or you waited too long to treat the patients. Clinical systems, I don't really know what that means, to tell you the truth. It's like, but it was only 10%. EHR, documentation, 10%. I'm going to show you that that number is really less than that, because we say, oh, the record, if it's not written, you didn't do it. Well, that's ridiculous. That's not true. Can't be writing all that stuff. It's my custom and practice. When you can start saying it's my custom and practice to do this, then that replaces the fact that you didn't write it down. Predisposing issues related to getting sued. ER environment is nuts. Rushed, high pressure, premature focus on what you think the initial diagnosis is, the right diagnosis, and then you start ignoring other information that doesn't go with your prejudiced initial diagnosis of, which is called anchoring bias. So this is basically saying don't prematurely clamp down and say this is the diagnosis when there's other information coming in that doesn't agree with the diagnosis. And if you were to review this chart yourself after the visit, you would say yourself, well, these things don't go along. That diagnosis was incorrect. Not using tools, the guidelines, the PCARN guidelines and the PERC rules and all of those other things, which are designed to help you not make errors. Communication breakdown about providers and the like, you can understand that. Lack of caution regarding the top 3 drugs. The top 3 drugs that, in their experience, were antibiotics. Well, we give out a lot of antibiotics, so that would make sense. Opioids. I think it's really on the prescribing side, not the administering side in the emergency department. And anticoagulants, to the extent that you're giving out anticoagulants. Here's another insurance company. This is a doctor's insurance company. This is the largest physician-owned insurance company in the United States of America. They looked at 332 closed ER claims. Here they get real specific. Here, this is really very helpful here. Misdiagnosed, what was the list? So if you took this list and said, I'm going to study this list, I'm going to know exactly how the issues about testicular torsion, septicemia, appendicitis, fractures, subarachnoid hemorrhage. If I'm going to study this list, and I'm going to know all about CVAs, I'm going to know all about MIs. This is pretty much bulletproof for you against the likelihood for being sued. And if you are going to get sued, some of these are going to be minor. Most of these fractures that are missed are of no consequence. So it's like there's not a lot of money going to change hands. CVA, AMI, spinal epidural abscess, yes, there's going to be lots of money changing hands there. So if you were just going to say, I'll study some of these and be an expert in some of them, do the ones that relate to the most money being lost. It's one of those things where when you have a lawsuit, you have to have damages. What are the damages? What are the damages if you have a testicular torsion? I don't know what the damages are, Well, what's the testicle supposed to do? Well, make some androgens and make sperm, and basically you get people pregnant with it. So I'll give you the money if you have a testicular torsion. I'll give you the money if you can't get pregnant. Doesn't that make sense, kind of thing? Or, well, that's not all there is to it. I go to the gym and, I may be exposed to other people, and they're going to see that I don't really have one testicle here. It's going to affect me, and I'm going to feel bad because I only have one testicle. So we could fix that. We could put a chicken egg in your scrotum, and you only have the biggest testicle on the block. So where's the damages? You want a big testicle? I'll give you a big testicle. If you want to have a baby, you're going to have a baby. There's another one that's all you need. You just need one out of 18 bajillion. So it's hard to understand where are the damages in a case like this, but it is on the list all the time. So you basically have to look, and we'll talk about little babies. You have to look underneath the diaper all the time in babies who seem to be suffering. But this list is a great list. this is where I would focus my knowledge if I was going to try to become expert at something. Now, I can barely read this. This is from their patient. Well, you can read this. I like this. So this is done by the AAA. The AAA has a foundation, and that foundation does research. So they had, in this case, 6,845 drivers involved in a motor vehicle accident, and they looked at how much sleep they had in the preceding 24 hours and the likelihood of you being involved in a car accident for which you are going to be blamed. And basically they said if you had 6 hours sleep, it was compared to a normal amount of sleep, you were 1.3 times likely to be involved in this. You can see the numbers, but look what happens at less than 4 hours sleep. The ratio goes up from 1.3 to 15 to 1. It means that basically when you have so little sleep, you did the night shift and you were up all day and you get into a car accident and it's your fault, it's because you were sleep deprived. And you were sleep deprived because you chose to be sleep deprived. And so it has the potential to be very, very unpleasant for you if you get involved in one of these accidents. Here's another study that they did. 2 hours or less of sleep in the preceding 24 hours means that you are not fit to operate an automobile. 2 hours sleep in the preceding 24, you are not fit to operate an automobile. 21 hours of continuous wakefulness was equivalent to a blood alcohol of 0.8%. 21 hours of wakefulness says you are equivalent to being drunk. Driving sleep deprived, obviously, can be very costly for high net worth individuals like you. You're called high net worth. That means that they found a wonderful target. Look at Maggie's Law. In the state of New Jersey, driving without sleep for more than 24 hours is a criminal offense. Criminal offense. How many of you drive without sleep for 24 hours? You just turn yourself into the state of New Jersey every day, please. But you can see here, I'm trying to present the case that this data is known. It's a fact that if you're driving with less than reasonable amount of sleep, certainly less than 4 hours, less than 2 hours, you don't want this kind of study but used against you. Ladies and gentlemen, this doctor is not capable of driving an automobile based on a very large study. I rest my case because he hit little Maggie. And that was the source of Maggie's Law, because she was hit by a person who has not had any sleep. So I think it's a great law, actually, because you should have a sleep room where you are. If you're going to be riding 40 minutes home after your 24-hour shift, you need to go to the sleep room and get a little nap, before you go home. Yeah, I know you don't want to do that. I know I'd rather go home. Well, call Uber to take you home or something like that. But you shouldn't be driving, because if you get in a car accident, when you've been driving and you find out how little sleep you had, Lucy, you got some explaining to do. I love this one too. This is a large study. They looked at 51,000 closed claims. And what were they looking at? The effect of automatic speech recognition and its involvement in those claims. They determined that in 9 cases out of 5,180 cases, that speech dictation, automatically through a computer, was not a direct cause of harm in any case. Speech dictation was not a cause of harm in any case of 51,000 cases. Therefore, the authors conclude that authors are advised that the records be proofread, even though what they showed was just the opposite. They showed that it was not involved in 51,800 cases. And there were 8 that were maybe some question. So the author says, okay, fine, proofread all your charts. Well, proofreading your charts is a waste of time. I have a friend who's a ER physician and a lawyer. He doesn't proofread his charts. It's his policy to not proofread his charts, and he'll tell the judge that if he gets into trouble, because the law of averages say you're not going to get into any trouble when you dictate your charts. It's not going to say right leg when you meant to say left leg. It's, and we're not going to remove the wrong leg because of what you said in this machine. So this is basically where your charting in the future is going. Basically, you're going to have this Kurzweil kind of thing where voice dictation gets better and better and better. It gets familiar with your voice, and basically now you're doing a history and physical as you want to do, as you feel appropriate. So that's not going to go along with these boxes anymore. It's like somebody's going to have to get rid of those boxes when you get back to your shift. And you're just going to be talking into this machine. History and physical, interval progress note, interval progress note, interval progress note, medical decision making at the end, diagnosis, disposition, gone. Here's a way to make $500,000 quickly. This is a nurse who was asked in Salt Lake City to draw blood from a truck driver who was hit by a drunk driver. So the drunk driver was killed. The truck driver was fine in terms of there was no compromise. And yet the policeman said, I want you to draw blood alcohol on that guy. She refused. This was what the video showed. They grabbed her, out the door they took her, stick her in the police car. Now, whether she went to the station or not is not clear, but they basically, she sued the police department of Salt Lake City and got $500,000. I thought that was really well spent time here. I mean, how long did this take? A couple of minutes? At that rate, a couple of minutes for $500,000? The police have no authority to tell you to do anything, frankly. This is really important that you understand this. Your obligation is to the patient solely. You are not agent of the state. You cannot be commanded to do anything by the state. If a patient refuses a test or to look for drug packets or anything like that, you are the agent of the patient. And if the police department says, we want you to look for drug packs, we're looking for evidence, only if the patient says, okay, I agree with that. Now, you obviously would say, listen, if you have these drug packets in you and they break, you could die. So you ought to know what the consequences are here if this doesn't work out right. There was a case where some policemen went to a judge's house, got him to sign a warrant for the exploration of a person for drugs. It turns out that the cops really filled out the form in advance for the judge because the judge was asleep anyway, and they basically, there was a scrawl on there otherwise by the judge. And they showed this warrant to the doctor and said, the judge mandates that you do look for drugs in this patient. If you run into a situation like that, remember, you are a private citizen. You cannot be warranted to do anything. Warrants allow the police to do something. So the warrants have the police have a warrant for your arrest. It means the police are going to arrest you. Warrants allow you have a warrant to search somebody's house. That's got nothing to do with you. It's basically it says the police, you can go in there and search that house. So don't get confused about this stuff. And if somebody's telling you to do something, just say, I'm sorry, my patient is my concern. And if they give you a hard time, go in the police car and sue for $500,000. But there's so much confusion about this. But the key thing here is, and I can tell you that there have been cases where patients were given IV propofol, sedated, have tube looking up their butt, looking for packets. And the courts have viewed this as an egregious offense against a person's rights. The First, Fourth, and 15th Amendments of the Constitution were involved in these cases. And it doesn't sound right when you go to a jury and said that this person was forced to do this. You get in trouble if you do that. Here's a few interesting situations in terms of medical legal, like, the idea of you got to tell people about their blood pressure when they leave. You don't want to have it, you don't want to tell them that it's, there have been these cases where people go out with high blood pressure. Nobody told them about the high blood pressure. The next visit they had was 8 years ago, 8 years later, and next thing you know, their kidney function is down, and they say, did they ever tell you about your blood pressure? Oh, yeah, I remember, I think they said something about it in the ER a while back. They go pull that record. There's the 170/100. There's anything written about follow-up or anything like that, or elevated blood pressure in the diagnosis? Anything written like that? No. There was a study done a long time ago where they looked at the people who had elevated blood pressure. And the higher the blood pressure was, the least likely it was to be put down as something to follow up on in the discharge. What else? Oh, here's one. I like this third one. So this lady has a problem with her ankle. She's elderly. She goes to the emergency department, and they give her some crutches. This lady's elderly. So they get her into a cab, and they send her home. She lives alone. In the cab, she's got these crutches, and you can envision what this looks like. The crutches are all over the place. She's trying to get these crutches out the door of the cab, and then there's the curb, and the crutches go down in the curb, and she falls over, and she sustained a worse injury. It goes back to the hospital where she was given the crutches after she had been given some narcotics in the emergency room for her pain, by the way, and she was awarded $850,000. The crutches case. So you got to be careful about, you give out those crutches. You need to know that the person is capable of using them, and you need to know, you need to know that they haven't had their mind altered by some kind of drugs that you've given them, because that's a setup for them falling, but they're going to be older, and you don't want to do that. Consent for TPA, this is the horse is out of the barn on this stuff. You just basically follow the protocol. Here's a case where a patient came into the hospital and wanted a refill of their psychiatric meds. It turns out that this patient was taking a huge amount of psychiatric meds to stabilize them. That's basically what it took. And so the doctor felt very uncomfortable giving them such a huge dose, went to the PDR and said, well, here's the normal dose. And he said, well, that's no good. I need a high dose that's got me stabilized. The doctor gave the PDR dose of the patient. The patient went home, had a decompensated schizophrenic episode kind of thing, and basically I thought there was some kind of bad outcome, but the patient wound up suing the doctor or the family for $1 million and got it, because the doctor made no effort to contact the psychiatrist to see what about this dose, and gave a dose that was suboptimal to what the patient needed and used was on a chronic basis. It's kind of like it's a shame that this happened, but you can see how the doctor got into a corner here by not being willing to prescribe a high dose, which the patient basically, even if they showed him the bottle, here's what I'm taking, doc. I don't feel comfortable doing that. Co-signing the charts of patients you've never seen. I have no idea why anybody would co-sign the chart of a patient that they've never seen. What does that mean when you co-sign a chart of somebody you've never seen? Is it like it's covering your butt or something like that? They know, the world knows, that if you are in an emergency department and there's a PA working there, that doctor is responsible for the PA's care. That PA does not have autonomous practice rights at all, zero. So the fact is that you don't have to claim on each chart with a stamp that you were there. I was able to be consulted at any time, but I didn't see this patient. I had no part of the care of this patient, et cetera, this cover your ass note. Now, it's a little different if you're an independent practitioner that has, autonomous practice rights, like a lot of the nurse practitioners do, depending on the state in which you live. But there is this idea of the captain of the ship that this ER doctor needs to be responsible for every soul who comes in that department, every soul. How's it going to go down if you say, well, the ER doc was standing right there. Why didn't you talk to the ER doc about it? Now look what happened, kind of thing. So I would have a low threshold for consulting, and I don't think it's even consulting. I think that there should be a team effort. I don't like the idea of, well, you see all the minor cases, and I'll see all the more serious cases, and those are your cases, and try not to talk to me about them if you could, because I don't want to get involved in a case that I haven't seen. That is bad. PAs and MPs ought to be able to see everybody in the department, and in the process, they're helping the doctors with the really sick patients. They're helping the doctors with the minor cases. Doctor can go in and see look at the ankle. Yeah, I agree that's probably all we need to do for this case. Patients, frankly, may be happier that they saw the doctor. How many times do I hear, I went there and didn't even see a doctor, and I waited 4 hours. Patients assuming the care. This is a California nurse practitioner who called herself Dr. Sarah got a $20,000 fine for that. And some states basically make it very clear that you can't use the phraseology doctor if you're a DNP, that's fine, but you have to make it clear that you're not confusing the patient by letting them think you're a physician. Audio recording, we talked about that. The last thing, well, I'm over time, so I don't want to go there. National Practitioner Data Bank. There's a whole list of stuff that will get you into the data bank. And there's only one thing that will prevent you from being put in the data bank. That when you lose your lawsuit, you pay the money yourself. So if you pay the money yourself, you won't be put in the data bank. It's a good thing to know, you know? So if you pay the $500,000, you won't be in the data bank. All of these little pearls was from a service that my friend and I do called Risk Management Monthly. We've been doing it for about 13 years. And this is just a kind of like a little summary of the stuff that we've done more recently. So, Jan?
Good morning.
Hi.
Hi.
Thank you all.
Thank you, Rick. All right. Okay, we are going to talk about headaches. Now, maybe some of you had a little too much to drink last night, have a little bit of a headache this morning, so let's talk a little bit about your headache and other people's headaches. And this is, I want you to think a little bit about when you pick up a chart of a patient with a chief complaint of headache, what are the kind of differential diagnoses that are coming through your mind? What are you thinking about? What questions do you typically ask patients who have headaches? What are those questions intended to try to discern between? And then what kind of therapeutic options do you go for? I'm kind of hoping to address some of those things. Headache is one of those really common complaints. Lots of people have headaches, but for those who actually work their way into an emergency department, it's not your average headache. So overrepresented in an emergency department population of headaches are going to be some of the more serious causes of headaches compared to just like all comers of headaches. Now, we certainly see benign headaches, and we'll talk a little about those, but I'm going to spend most of the time talking about the emergency diagnoses that we really can't miss, that it's our job in the ER not to miss. It's not the most common headache, but it's the most life-threatening headache, and that's really what we're there for, is to make sure we don't miss those. So our goal, number one, obviously, is to relieve the pain. So people come there because they want the headache to be gone. Sometimes they're also very curious as to what's causing it. Sometimes they know what's causing it. If they have migraines normally and this is a migraine, they know what's causing it. They just want you to make them feel better. In other cases, they've never had a headache like this before, and the diagnosis is really important. So we want to relieve the pain and discomfort for sure, but we also don't want to miss the emergent, life-threatening causes of headache. Now, when you classify headaches, technically there are primary headaches, and there are types of headaches that are secondary to something else. So primary headaches are things like migraine, tension headache, cluster headache. Those are all really kind of benign headaches. Secondary headaches are headaches that come from trauma, for example, or a vascular cause, or infectious headaches. The headache pain itself is coming from something else that's causing the headache, and the serious ones kind of lie in that bucket, in the secondary headache bucket. One important thing to know is that, especially with headaches, response to your analgesic actions will not help you differentiate between these types of headaches. So if someone walks through the door with a headache and I give them my migraine cocktail or my headache cocktail, whatever my drug of choice is, and they feel better, that should not reassure you that it's not a bad headache, that it's not a subarachnoid, that it's not something bad. Those headaches will respond to analgesia. So the response to analgesia should not talk you out of one of the bad causes of headache. And I think that's a really important pitfall that we all step into often early, because we think, oh, they feel better, they look better. Often the patient wants to go home, but make sure you've thought through what the serious causes are, because that response to analgesia does not guarantee that that's not an emergent cause of headache. Now, I'm going to spend a moment on this particular slide because it highlights a point with headaches. So if you look in that second column under the word concern and scan down, these are a lot of the emergent causes of headache that we are really there to pick up on. So subarachnoid hemorrhage is one that we're going to spend some time talking about. Then we see meningitis and encephalitis, mass lesions or space-occupying lesions. We've got dissections of the major arteries, cervical artery, carotid, vertebral arteries. Those can present with headache. They will often present with neck pain as well. We've got patients who have idiopathic intracranial hypertension, which used to be called pseudotumor cerebri. That's that condition. Acute angle closure glaucoma, which is a problem with the eye pressure, but can present with headache. And then we've got giant cell arteritis, which is an inflammatory vascular condition. All of these are not the most common causes of headaches, but they are things that lead to life, sight, threatening types of conditions that we have to consider. So if you move into the column to the left of that, the characteristics, these are the kinds of questions and curiosities you want to have to try to document that you've asked, you've thought about, to differentiate between these different types of headaches. So for example, the story with a subarachnoid hemorrhage, I want to ask about how the headache started. What were the characteristics of how your headache started? And many of us, when we learn about subarachnoid hemorrhage, we learn about it's the worst headache of their life. And one goal of mine today is to sort of talk you out of that being any kind of question that actually helps you discern between something like a subarachnoid hemorrhage and a regular headache. Everyone who comes to the ER has a pretty bad headache. You can even get a headache from sitting in the waiting room of the ER for too long and enduring our triage processes. So asking someone, is this the worst headache of your life, is not going to help you discern between a really serious headache and a benign headache, because a lot of people will answer yes to that question. Doesn't mean that it's a subarachnoid. It doesn't really actually increase or decrease your probability, quite frankly. What's more discerning is to ask about how the headache started. Was this a gradual onset headache? Or when it started, was it maximal at onset right away? That's a much more discerning question to differentiate between that type of headache. So asking exactly how that headache started, and I like to see in the charts, I want to see gradual onset. That's a reassuring word to me. If it doesn't say gradual onset, then I want to know how it started. If we're talking about meningitis and encephalitis infections, obviously fever is an important fact, and that's not perfect either, right? We talked about yesterday about how meningitis may or may not have a fever, but have they had a fever at home? Is that part of the picture? Plus or minus altered mental status, that will help me differentiate between encephalitis a little bit. If we're talking about mass lesions or space-occupying lesions, I also want to know about the characteristics of the headache. Is this a headache that's been getting progressively worse, that it's constant? Is it worse in the morning? That's sort of a feature of those types of headaches. Or when you bend over or valsalva, that's indicative of possible increased intracranial pressure. If we're talking about dissections of arteries, I want to know about this. Is this new onset? Is it accompanied by some kind of neck pain or facial pain? That might make me think of an arterial or a dissection type of cause. For idiopathic intracranial hypertension, I want to ask about vision loss. I want to think about papilledema. I want to focus in on that. This is usually in females who have increased BMI or tend to be on the more obese side, tends to be the population that this condition happens in. Acute angle closure glaucoma means in my headache patients, I got to look at the eyes. I got to document what they look like, and I might even do a tonopen and check an intracranial pressure if they look red injected and they don't look normal. I want to think about that as well. And then giant cell arteritis is a condition that really happens in people in the later half of their life. They often also have jaw claudication or pain with mastication. So when you chewed, you also have pain, and they may also have visual loss. So these are the kinds of things I want to see documented in the HPI that tell me that you've thought about the emergent conditions of headache, causes of headache. Now, in the next column, all the way on the far right, you see down the imaging. You know, is a head CT going to help me here? Do I need a CT? And do I need an LP? And you can see in some of the cases, it's yes, no, yes, no, yes, no. So they don't all need a CT. They don't all need an LP, but some of them do. And so these questions will help you work down these different diagnostic pathways. So let's start with subarachnoid hemorrhage. And subarachnoid hemorrhage is one of the conditions that really is quintessential emergency medicine. Especially the warning leak, which we'll talk about in a moment. But subarachnoid hemorrhages come in a spectrum of varieties. If you blow an aneurysm and you have a large subarachnoid bleed, that is someone who's coming in by paramedics who may or may not even be conscious, who's got usually a pretty depressed level of consciousness, a pretty bad headache if they're able to tell you that they had one before all of this started. And they may have vomiting, their blood pressure will typically be quite high, they may have a stiff neck, and they're usually very, very sick. If you're talking about a large subarachnoid, when you scan and you see blood filling the whole circle of Willis, this is a really sick patient and usually a fatal event that is very difficult to deal with once it gets to this point. And the point of this is that a lot of these patients who end up having this may have had a warning headache or a sentinel leak that we're going to talk about in a minute, because that's the headache we don't want to miss. Because if they get to this point, there's not a lot that we can do. Most of these are due to ruptured aneurysms. The CT, when you do it, it's devastating. You look at it, there's white everywhere, there's blood everywhere. You know that this is a devastating bleed. And often these patients get intubated. What you do with their blood pressure is a little bit controversial, and there's a 50% mortality if you get this kind of a bleed. And if you survive, you're going to have neurodeficits most of the time. So we want to try to prevent these if we can. There are going to be those that happen that we can't prevent. Some of these are people who code in the field and we don't save in the first place. So this may be unsurvivable from the start. So if it gets to this point, there's not a lot that we can do in the ER except for basically supportive care at that point and consult a neurosurgeon. But many of those cases that end up like that may have had a warning leak or a sentinel leak, a sentinel headache, where the aneurysm that they had a small leak and they had a headache from it, and they may be presenting to you. That is the needle in the haystack that we're really looking for. Often the headache is what's called a thunderclap headache, which means that it was sudden onset, maximum onset at the beginning, usually even in the first 10 minutes, but sometimes it can be described as in that first hour it was the worst, and then it started to maybe get a little bit better. They may or may not had some vomiting that are associated with it. This may completely relieve with pain medication, so that's important to know. We still need to worry about it if the story is concerning. And often, sometimes they come in and by the time they've sat through your waiting process and gotten to you, they're actually feeling kind of better. And they sort of tell you the story of this really bad headache and, my partner wanted me to come and so I'm here, but I'm actually kind of feeling better. That should still really concern you. There are other causes of that type of headache pattern where the headache is maximum at onset. It can happen with sexual orgasm, it can happen with exertion, it can happen with things like carotid or vertebral dissection. So it's not pathognomonic for subarachnoid headache, but it should concern you for it. So there's other causes of that same pattern of headache. And this is why it's such a quagmire making sure you're trying to look for this needle in the haystack. We'll talk about how to proceed if you're worried about it. But the key here is that if the story sounds right to you and as you're concerned about it, don't let go of that concern. Now, some of these patients who have a warning leak from one of these aneurysms will actually have a pretty normal looking brain CT because the level of blood, the amount of blood that's come out of that little warning leak is not enough to really trigger your head CT to show that white blood. This is especially true if it's been more than 6 hours after the onset of the headache. By this time, basically the blood that's been released into the CSF starts to degrade. It starts to be metabolized into its heme molecule, which will eventually turn into bilirubin, which causes the xanthochromia in the CSF that we'll also talk about, which is part of the diagnosis. Now that CT scanners have evolved and they've gotten a lot better with time, we are better at picking up smaller and smaller bleeds, but still not to the point where it's perfect. These are CTs that look very abnormal. It's not hard to see the white in these CTs that show you the blood in the subarachnoid space. That's really what you'll see in subarachnoid hemorrhage. And sometimes there'll be just a little bit of a blush, and you're really counting on your radiologist to look for it, but get used to looking at CT scans yourself. When you're suspicious for it, you're the one that's seen the patient. You always have more sensitivity than a radiologist. You're not as trained in reading them, but you know what you're looking for as well. It's one of the real important reasons that it's important to tell the radiologist really what you're concerned about in your request for a radiology study so that they can focus in on what it is you want to know. So these are pretty massive subarachnoid hemorrhages. So let's say we have that patient who's coming with an acute sudden headache, you're suspicious for subarachnoid, you order the CT head. Where we are in 2022 is that if you have gotten that CT scan and you have a modern CT scanner and it's been less than 6 hours since the onset of that headache, the CT at this point is considered to be basically as close to 100% sensitive as you can get. This is now supported by ACEP in their 2019 guidelines on how to evaluate patients with headache. They cite the evidence that this is really now the case. There's been several studies looking at this, but the conditions, the asterisk to that is that you have a modern CT scanner that does enough cuts and has enough resolution to get to this point. But most of us in pretty modern emergency departments have that type of CT scanner so that if you get that CT within 6 hours of the headache, you can actually say that there's no subarachnoid there because that heme molecule, the blood is fresh enough that it should show up and you have a decent enough radiologist reading your study, which is another part of it. But that is supported by studies at this point. Now, we want to diagnose this, obviously, because as we've mentioned, this could be a harbinger of a big leak, and there are a certain percentage of these patients that will go on to blow that aneurysm and have the devastating picture that we talked about first. So we really want to make sure that we find it, because if we can find that aneurysm and it can be clipped or coiled, we can prevent that ultimate devastating outcome. So, what do I do if my CT is negative or I'm further out than that 6-hour time point? What do I do next? And this is a bit of a controversial area, to be quite honest with you. It's a little bit controversial. You could do a panel up here and we could argue about the numbers and what our approaches are, and you'll see that there's a variety of approaches. So some people would recommend that if your CT is negative, what you go to next is a lumbar puncture, looking for red blood cells in that CSF, looking for xanthochromia. What is the problem with that approach? LPs are not the easiest procedure. We often get a traumatic tap just by the nature of putting a needle in there, and now all of a sudden you've got blood coming out and you're looking for blood, and so having a traumatic tap could make the picture even fuzzier. So that's one problem. LPs are not perfect procedures. We know that if we do an LP and we're looking for subarachnoid, what we do is that we measure our 4 tubes and we're looking for a change in red blood cell count really between the tubes. That will help us differentiate between a traumatic tap and a subarachnoid, because what I mean by that is that if it's a traumatic tap and as the blood's dripping out, as the fluid's dripping out, the blood is clearing, I might have a lot of RBCs in tube number 1 because it's traumatic. But by the time I get to tube number 4 and it's been dripping for a while, that blood should clear. And if it's a subarachnoid hemorrhage and the RBCs are actually in the CSF, then that number will stay pretty constant if that's really where the RBCs are coming from. So that tube progression will help you. The CSF, if the bleed's been there for a little while and those RBCs have been sort of laying in that CSF because it's been some time since the warning leak, that's where we get into the issue of xanthochromia, that those red blood cells have now been metabolized in that CSF, they've changed into bilirubin, which has caused that yellow color, that yellow tinge of CSF, and we're looking for xanthochromia as evidence that there were red blood cells there before. So this is all very complicated, and you can see how this is very tricky. So the other option that people will say is these days, because we have such good access to CT scans for most of us these days, and not everybody does, so you may be stuck with the LP, is to order a CT angiogram. Why would I do that? Because if the CT angiogram, if I perform that, it'll tell me whether or not this patient has an aneurysm or not. It'll actually, tell me if they don't have an aneurysm, then it's probably not a subarachnoid hemorrhage, and I can kind of be done with the whole thing, avoid the LP. What's the problem with that approach? Well, the problem with that approach is that Just because they have an aneurysm doesn't necessarily mean that that aneurysm was the cause of their headache, that it bled and caused the headache. And so if you find the aneurysm, people would advocate you still have to do the LP to see if there's actually blood in the CSF, and that was the cause of the headache. And you're going to find aneurysms in people, incidental aneurysms that have nothing to do with the headache that they're there for. And once you find that aneurysm, what are you going to do with that patient? You're going to just send them home? Now you have to tell them they have an aneurysm. They're going to send them to a neurosurgeon who's likely going to put them through a procedure that they may or may not need. And for this patient, for the rest of their life, every time they have a headache, they're going to be thinking, is this my aneurysm, right? So you can create more problems that way. So this is why it leads to a debate about which way is the best way to go. What do the guidelines say? So in the 2019 ACEP guidelines, they actually tell you that between these two options at this point, given the evidence we have, is that we have equipoise, meaning that it's okay to go both ways. You can even do shared decision making with a patient as to what way they would prefer to go. This is a pretty complicated discussion to have with a lot of patients, and they may not want to get into all these details, but you know the details, so you can go down that path to explain. And there's lots of patients who don't want to undergo an LP. And so knowing that you have this alternative way to go is something to also explain. So this is sort of the quagmire where we are with diagnosing subarachnoid hemorrhage. This is what xanthochromia and bloody CSF really look like. You see the xanthochromia versus clear CSF, which looks essentially like water. That xanthochromia, if you hold it up against a white piece of paper, you'll see that sort of yellow coloring. Technically, the lab should do spectrophotometry to look for that yellowing of the CSF. Often they do a visual test just like this to see if it looks yellow and report that out as xanthochromia. Bloody CSF will look like kind of fruit punch. That's like truly bloody CSF. But if somebody's had sort of a small sentinel bleed, it won't always look like fruit punch like that. That's a pretty significant bleed in those tubes. That could also be a traumatic tap where you didn't really let the fluid kind of come out for a while and clear. So anyway, that's what bloody CSF might look like. So really, again, just to summarize kind of where we are at this point, we have a lot of evidence. There's been a lot of study of this particular area, thank goodness, because I can tell you, 10 years ago, 20 years ago, it was even messier than we are now. With the evidence, has it cleared it up completely? No, but it's given us some more guidance, and now with CT scanners as they are, and as available as they are, we do have some extra options. So I've offered to you here sort of the key papers if you want to read more about what does the evidence say. These are some of the key papers that led to ACEP's recommendations and to the things that I'm telling you here, which is about having a third-generation CT scan. If you get that CT within 6 hours and it's read by a qualified radiologist, that you've essentially ruled out subarachnoid in those conditions. And there's also, so that you know, a helpful clinical decision rule. Of course, it comes from Ottawa, as many of our helpful clinical decision rules do. The subarachnoid rule that will help you determine, if you could go through this list, that you really don't need to pursue this diagnosis. And so here are the questions that you may want to use in your chart as well. Do they have any symptoms of neck pain or neck stiffness? Any yes to any of these questions means that you still have to consider subarachnoid. So this is one of those rules that if it's no, 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 you can say, I don't need to pursue this diagnosis. But if any of them are yes, then you're basically in the quagmire of having to consider it. So you go down the list. How old are they? Did they have a witnessed LOC? Was it onset during some kind of exertion? Did they have the right story of thunderclap headache, being peak pain instantly? And on your exam, do they actually have some limited neck flexion? All of those things, if it's no, 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 you don't need to pursue the diagnosis. But any yes, then it's not off the table. And ACEP clinical policy endorses the use of this clinical decision rule as you're talking yourself through this diagnosis. Okay, we're going to move on from subarachnoid, and we're going to talk about idiopathic intracranial hypertension, formerly known as pseudotumor cerebri. This is typically your younger, on the heavier side female who often has a regular menstruation because there's an association with polycystic ovaries. They may have had some ongoing headaches, maybe a little bit of vomiting because they've got increased intracranial pressure. And the reason that this is an urgent/emergent diagnosis to make is that intracranial pressure being elevated will cause pressure on the optic nerve and cause visual loss eventually. And often when they're first presenting, they may already have a subtle visual field cut and not even really recognize it. So even if they have any visual complaints, very concerning as well. So they don't have good CSF absorption. There's a lot of theories as to why this condition evolves. There's a link to cerebral venous thrombosis also in this particular condition, and they have elevated CSF pressure. And so the reason that we want to make this diagnosis is because of of the impending blindness, because of the visual loss that is often irreversible and often starts peripherally with a way that they don't even recognize it. So if you are good at fundoscopy, this is a case where you want to do papilledema and you want to consider having an ophthalmologist involved to help you if you're not good at doing that. If you do your CT scan, it will often show you the signs of intracranial pressure, meaning that the ventricles are kind of slit-like, but it can also look normal. So that's important to know that your CT is not the diagnosis end-all be-all. So LP is really where you have to go here, and you're looking for that opening pressure. Opening pressures are important to do in LPs. This is one of the reasons, but there's lots of other reasons too. But a high opening pressure, and when I say high opening pressure, I mean this fluid will squirt out at you and land on your pants in this particular condition. It's pretty impressive. When it happens, you know it. You're like, okay, man, this is increased intracranial pressure. This is what's going on here. And one of the treatments for this condition can be serial LPs to basically relieve the pressure. So you're going to get a neurologist involved. They may need repeat LPs. Often they go on a drug called acetazolamide, and they may even need a shunt placed to divert some of that pressure. We see a lot of patients with post-concussive headache, patients who've had some level of trauma and then recent past, and we're not talking in this talk about, the acute evaluation of blunt head trauma, but what about that patient who said, I had a head trauma a few days ago and I'm coming in with this persistent headache? We know that after a concussion, people can have post-concussive headache. So first, this is a patient who has a normal physical exam. They may or may not have had a normal CT. A CT may or may not be indicated at this point. But to know that people do have headaches after concussions, we need to be sure that we give good post-concussive discharge instructions in terms of no chance of repeat trauma. We know how serious that is. And we know that also this can be accompanied by problems concentrating, some of the psychobehavioral symptoms that may also continue for months. So yes, if you have a normal head CT, they may have had a CT originally. You don't want to repeat that head CT if they've had one. You want to know that this is a diagnosis that you will often make, and you want to make sure that everything is otherwise, again, neuronormal, but that is the case that you will see some headaches like this as well. What about people who've had an LP and now have a headache? That's another type of headache that we see. Know that my teaching point here is that if you do LPs, there are things you can do to decrease the incidence of post-LP headache. One thing is to use a smaller needle if you have those available to you. When you put your LP needle in, to have the bevel of the needle parallel with the spinal column, because that way the hole that you make in the dura will seal a little more easily. There are needles that have these special types of points that are called pencil points that often anesthesiologists will use when they're doing epidurals and things that have been in the literature linked to decreased incidence of post-LP headache. That can also help. These needles are harder to use. They're less rigid, they're a little bit more flexible, so they can make for a more difficult procedure, but they also are linked to better outcomes for patients. You don't want to take off too much fluid. That's one thing that's also linked to LP headaches. And know that although many of us learned that giving fluids and having people lie flat after an LP is helpful, it's actually not helpful. None of those things work. There have been studies looking at randomizing people to lying flat, not lying flat. It doesn't seem to decrease the incidence of post-LP headache. So although we often say that, it actually doesn't matter. So that's important to know too. If you do have a patient who comes in with post-LP headache, and these are nasty headaches, very, very severe, obviously you're going to treat with analgesics, but the definitive treatment is usually a blood patch that often anesthesiology will do for you. You can also learn how to do it. They're not too hard to do, but typically if you have an anesthesiologist available, they do them a lot, so they're pretty used to doing it. Another type of headache you might see is the person who has a VP shunt or a ventricular shunt. And know that these VP shunts are put in often when people have chronic conditions that lead to hydrocephalus, etc. They put a little shunt into the ventricles of the brain. They run it down through the side of the skull, through the neck, into the peritoneum, and it basically dumps the excess fluid there. And obviously that type of a system can have problems. It's a one-way system. It's got a valve that only allows one-way movement of fluid, but things can become kinked. They can get infections, and so those are the kind of emergent things you're thinking of when a patient has this type of headache. Obviously, they've got underlying pathology, so you usually start with a CT, and your neurosurgeon may or may not want you to also get an X-ray shunt series, which will take pictures of the shunt to see if it's in the right position. So there's ways to evaluate this. Often you can tap these shunts yourself to look for infection, but usually the neurosurgeon will do it for you. It has to be done very sterilely, etc., but that will be the ultimate diagnosis of whether or not there's a VP shunt infection or there needs needs to be a VP shunt revision if there's a problem with the actual shunt itself. So this is just a diagram of kind of where the shunt goes in terms of being placed in the ventricle, kind of going down the side, going into the peritoneum. And so you'll see patients who have a VP shunt. And so those things should also be on your differential for those guys with a headache, which is it infected? Is it a problem with the VP shunt itself? Is it not draining, for example? Space-occupying lesions like brain tumors are things that patients worry about a lot. One thing just to reassure yourself is that, these aren't things that, if I don't diagnose it today, it's really going to make a huge difference. This is something that could be diagnosed in a week or two or even a month. It's probably not going to make the biggest difference. And for some of these lesions, CT is not the perfect test. MRI is actually more sensitive to look for space-occupying lesions. Doesn't mean you should be doing MRIs in the ER for this. They're not emergent, but that may be a study that they need. When I do ask questions to try to differentiate whether there might be a space-occupying lesion there, I want to ask about, is this a new or different headache? Has it been increasing in frequency or duration? Is it worse in the morning or is it worse at night? That might help you. How about Valsalva? If they say, every time I lean over, it gets worse. I lean down to tie my shoes and it's terrible. That should make you think about increased intracranial pressure, any kind of vomiting, and then obviously do a good detailed neuro exam. But space-occupying lesions aren't all malignant tumors. Some of them could be benign tumors, and they could be things like brain abscess, or if you have an immunocompromised patient, it could be something like toxoplasmosis. Something like that is also considered a space-occupying lesion. Again, this picture here is a CT with contrast showing you a ring lesion of toxoplasmosis, but typically we don't do CTs with contrast in the ED. Probably an MRI would be preferable, but that is one option if that's all you have. Finally, we'll finish with a couple comments on benign headaches. These are kind of the really common benign headaches that we see, and they also have different, pain patterns. A sinus headache is a little different in terms of its description and location than a cluster headache, which is usually behind one orbit. They often have tearing of one eye. That's a cluster headache. Tension headache is worse in the evening and night, and it's like a band squeezing both sides of my head. Migraine obviously comes with some visual changes. Sometimes they may or may not have an aura. They may have some nausea. That's what kind of a migraine looks like. So also asking questions about where they feel their pain can be helpful. Migraines are often unilateral. Again, they can be accompanied by these things. They can be pretty severe. They often, have some photophobia and want to keep their sunglasses on or keep the lights off. They may or may not have aura. They can even have some focal neuroscience, like migraines can come with hemiplegia. It's one of those stroke mimics that we also have to consider. They do technically, in a population base, have a higher rate of subarachnoids, but I'm not thinking about subarachnoid in all of my migraine patients. It's just something to know that just because they have a history of migraine doesn't mean you don't have to think about subarachnoid and ask some discerning questions. What do I use for migraines? First-line therapy in all of the guidelines is NSAIDs. Acetaminophen is also first line. Often they've tried those at home. Triptans are in the guidelines as first line, but triptans have some caveats with them. Often people who use triptans will get a rebound headache. That's one of the reasons that they're not so great. And they can also cause some flushing and some other side effects. So sometimes people don't lean towards triptans. But if a patient tells me that that works for them, I'm happy to try any of those things. Probably most commonly that we use in the ED are the dopamine antagonists. This is your things like prochlorperazine, which is compazine, or metoclopramide, which is Reglan, even Haldol or droperidol. All of these dopamine antagonists work quite well. They are really studied given IV. So sometimes I see people like giving compazine PO in triage. That's not how compazine is studied in migraines. It's studied given parenterally. And if you're giving it for nausea, fine. But if you're expecting it to perform in the way that it should for a migraine, it really is studied IV. So that's the way to give it. We talked about triptans, and then there's a bunch of new drugs out there for migraines. I'll tell you, there's no evidence base to use any of those expensive drugs that you see advertised on TV at this point. They've not been studied in emergency department populations. They've mostly been studied as prophylactic medications for migraines or treatment at home. The drug companies want you to take those every day prophylactically. They don't want you to take it every once in a while. They want you to take it all the time. So it's not marketed or studied in acute headaches in the emergency department at this point. So they're very expensive, not being used in an ED setting. And that's it for headaches. Thank you very much. Diane's up next.
Hello. There we go. All right. Hi, everybody. We are going to talk about endocrine and acid base. So as somebody who did both internal medicine residency and emergency medicine residency, I get these sort of electrolyte and endocrine acid basey kind of talks. So hopefully what I can do is distill down what internal medicine people round for hours and hours about and talk about and drink 10 cups of coffee into something that you need to know at the bedside quickly. So let's talk about endocrine and acid base. The idea of doing all of this in a half an hour is hilarious, but let's do it. Let's talk about diabetes. Now, diabetes is an unbelievable problem in the United States. It is unbelievable. It's estimated that 20 to 25% of babies born today will be diabetic by their 20s. And COVID looks like it may predispose people to developing diabetes after having a COVID infection. And I think everybody on the planet has had one of those. So diabetes is around, and it's around in full force. And it's a huge part of what we see in the emergency department, both acute things that happen with diabetes and things that happen long-term in people that have diabetes for decades and decades and lose bits and pieces of themselves. One of the sort of standard things that we have to get really good at in the emergency department is recognizing, diagnosing, and treating DKA. We see it a lot. We are the people that actually take care of those people, not the endocrinologists. We're the ones that do it because they come to us with their emergency. So knowing sort of DKA, and honestly, the pathophysiology, although interesting, isn't really, if you want to know that, that's all well and good. And I like knowing stuff, but if you really just say, like, give me what I need to know at the bedside, let's talk about that. Because people who have DKA, it's usually type 1 diabetics, insulin-dependent diabetics. In fact, it's really that is the population that gets this thing. And what happens is something triggers their balance of calorie intake, calorie use, and insulin. And there's a list of things that will trigger that will upset that balance that are super important for us to look into. But what happens in the patient is their sugar starts to rise because they're using, they have insulin lack. They actually have lost their insulin lack. They end up with, or too much stuff to metabolize. They end up shifting over to fats as a source, so they end up with ketones in their system, and the sugar's not getting chewed up at all because the insulin is lacking, and they end up with too much sugar as well. So the too much sugar makes them PPP. They get dehydrated, they get lots of sort of osmotic diuresis, so they'll come in and say they're peeing a lot. And then the ketones, think about it, if you skip a meal, or if you end up sick with COVID in bed and you don't eat for 3 days, you have a headache. You feel crappy. If you just skip a bunch of meals, you just don't feel good. That's the ketosis part of that. And the acidosis part is what kills you. The acidosis part is what makes you really sick. So they come in dehydrated, they come in with headaches, they come in feeling just kind of pukey and gross and awful, and they're acidotic. And remember, what your body does to get rid of acidosis is it helps you. It's like, whoa, we do not like to be this acid. So your body tries to blow it off. We'll talk about acid base at the end of this, but your body says, too much acid. The way I get rid of that fast is to breathe faster. Blow it out. Get rid of that with CO2. Get rid of that acid by blowing it off. So they'll come in with, if we go back to our vital sign talk from yesterday, breathing either too fast or too deeply to blow off CO2. This is why watch a DK, next 10 DKAers you see, watch them breathe. They are frequently, they're talking to you with a respiratory rate of 16 going, huge, big breaths, because every one of those is blowing off CO2, which is trying to balance that acid that they're producing in their body. Really key. So you're going to see increased respiratory rate or Kussmaul breathing, deep respirations. You're going to see people who are dry, people who are tachycardic. That's how they feel gross. They have often been triggered by something. People don't go into DKA just because. There is something that's changed in their selves or their environment that gives them that. And it's a list of I's. And if you want, I like this list of I's as what I remember, but the two that are hugest on this list are infection. Look for it, find it. It can be anything from viral, nothing, just a viral cold, that's all that takes, to mucormycosis or a perineal abscess, or it is something. Infection is super common as the trigger here. So look for it. In every single DKA case, go through and just ask them questions and do a really thorough exam so you don't miss it. And then the other big one is infraction, where they just don't take their insulin, or they have, it's Christmas time, those Christmas cookies I couldn't resist. I ate 16 Christmas cookies and threw my sugar out of whack. So it's usually infraction. But everything else on this list can also cause somebody to go into DKA. Having a heart attack can do it. Having a stroke can do it. Getting pregnant can do it. All of these, using illicit drugs. It turns out people who use illicit drugs, their diabetes is much more fragile for lots of reasons, anything from intake to forgetting their insulin or whatever. And iatrogenic is another one that we need to focus on, is sometimes we do it. So steroids, we know throw people's sugars out of whack. And one of the problems with that is that we end up with somebody that we are treating for one thing over here and we make a problem over here. Anytime you prescribe a steroid, make sure it truly is indicated. And if it's somebody with diabetes, make absolutely sure it's truly indicated, because that can throw their sugar out of whack. So we know we can cause people's sugars to go up as well. And sometimes it's just new onset. It's the first time, kids in particular, first time you see somebody with new onset diabetes, they often present in DKA, children do. So how do we diagnose it? Well, we know that you have your clinical sort of scenario, you're suspicious. You have an elevated blood sugar. Okay, you can either do a finger stick to see it's critically high usually, or get the number back from the lab. You'll need the number at some point. They have metabolic acidosis. This is an anion gap metabolic acidosis, so you need to get your anion gap done there. And their BUN may be up as well because they're dry. So that's sort of what they do. And I will tell you, the lab, frankly, that is most important on all of those labs in somebody DKA is not the sugar. It is not the sugar, it's the potassium. Because the potassium is going to dictate when and how you use your insulin, and whether you don't use it at all in the beginning. So really, really important, okay, absolutely vitally important to check that potassium. Now, if say you're someplace, you're in an office or a clinic that has no labs, can you figure out if that diabetic sitting in front of you has DKA? Yep, you absolutely can. If you have a urine dipstick and a finger stick sugar, that's all you need. Somebody who comes in saying, I'm feeling kind of queasy, I've been, peeing a lot, and, I forgot my insulin, or I ate a bunch of stuff, or I've just been feeling sick, your spidey sense says DKA. You get a finger stick, it's critically high, you dip a urine in there or ketones, you send them to the emergency department. Because that is 97% predictive of that person being in DKA. So it is a really great, quick sort of scan. If that's all you have around, go ahead and do that. Now, other tests do you need to get? So you need your metabolic panel, because you have to calculate your anion gap. You have to know the potassium. If you might want to consider liver function tests if there is something that puts you there in your differential diagnosis. So you think they have hepatitis. You think they have gallstones and they have gallstone hepatitis. If you are there for some reason, go ahead and order it. But if it's not on your radar, don't, because they may have abnormal labs a little bit just from the DKA itself. So don't go there unless you have to. But do remember that there are infections that are a super common cause of this. So consider a CBC. I have very little respect for the CBC. We'll talk about that some other time. But if their white count is up, it just warns you a little bit that maybe there's an infection going on. But do look at the urine. It's a common cause of infection. Check that. If you have pulmonary symptoms at all, check a chest x-ray. Check your EKG and a trope if you think it's a heart attack. Let's tip them over into DKA. Be a clinician. Don't do a check every box checkbox. Be an educated clinician. Just do the ones that you need to know about. And serum ketones, if you want to, and serum lactate might help you if you don't know if this is DKA or not, and you're worried about other causes of metabolic acidosis. One of the things I do want to mention, calculations drive us all kind of crazy, and this is why MD Calc is magical. And there's a thing called the corrected serum sodium. I'm going to mention it here, but it ends up more important in a different entity we're going to talk about in a second. But if you think about somebody's blood sugar going up, so say their blood sugar is 600. Okay, your normal blood sugar is sitting there at 90. It's 600. Well, your blood is saying, your circulation is saying, wow, it's kind of thick and sticky in here. Let's dilute this down a little bit. And it sucks water out of your cells into your bloodstream. In doing so, it causes a dilution of your serum sodium. You actually have total body sodium what it was before. It's just shifted everything around. But the end organs that see that blood see a low serum sodium blood, and your lab test sees a low serum sodium blood. So, and there's a calculation for this, and you can pull up MD Calc for this. So basically, it's the sugar minus 100, take that, divide that by 100, and then multiply that times 1.6. Some people use 2.4, but either one is fine. Multiply it. On that. What you're going to find is that this is, I will tell you, when somebody calls from the lab and says, we have a critical value from the lab, you have a sodium up here in the lab of 122 and the patient in bed, 12B, Mr. Gonzalez. Well, that's going to get your attention, except if Mr. Gonzalez also has a sugar of 1,200, and you do the calculation to correct that, you're going to find that his sodium is actually normal. His sodium is fine. That's all the fluid that's been pulled out into his system. We'll come back to why that's important in a minute, because it makes a difference what fluid you use to replace. Not a huge problem in DKA, but a big problem in hyperosmolar state. So our treatment first. So if you have that person, finger stick says critical high, urine dip is ketone positive, yay for you, you diagnose DKA. The first and foremost thing you do is fluids. Okay, that is the first step for all. They're all dry. They're down usually 2 to 5 liters. They're not down 10 liters. They're down 2 to 5 liters. So you give them initial bolus of a liter is fine, as long as there's no other reason not to. Go ahead and give them a liter. You see, and it can either be normal saline or a balanced solution, like lactated ringers is fine too. But give that. And they will start to pee out that sugar, and they'll start to actually fix their DKA just by the extra fluids. Really important to do. And your aggressiveness on giving fluids really depends on their fluid status. If they look like a little raisin, go ahead and dump in some fluids. But most of the time they don't. They got sick first. Ketosis makes them feel gross. They come in to see you when they feel sick. So fluid replacement, and this is the first thing to do. Fluid replacement in kids is a little dicey. Okay, there's this issue of whether their brains will swell or not. We can talk about that on the panel because it's kind of a separate topic. But if a kid looks like a little raisin, give them fluids. Do not let them stay a little raisin. We can talk about that later. Insulin, please do not ever start insulin until you know the potassium. Never, ever, ever. Because most of the time the potassium in people who have DKA is either normal or a little bit high. Every once in a while, it's going to be low. If you give somebody with a low potassium insulin, you drive that potassium down even further, and you can end up with a clean kill. So don't do it. And there's no need. There is no hurry to bring down that sugar. There is plenty of time to get to that, get that lab back, and you can even do a bedside point of care if you want to, but never start the insulin until you know that potassium first. And once you, I'll show you the sort of algorithm for this, but there are numbers where you have cutoffs of where you start giving the insulin, and actually, frankly, where you start replacing potassium, because often they need it replaced at some point in their treatment. The infusion usually is 0.1 per kilo of the infusion. You don't need to bolus insulin infusion. Don't need to do that. There's no magic to that at all. And you're going to check labs frequently to sort of see how things are going. This is the algorithm that the American Diabetes Association has. If you use UpToDate, if you use apps on your phone, this is what they're going to take you to. And it has 4 categories. The left category is what IV fluids and how to give them. Basically they start with normal saline. It's fine to start with lactated ringers and dumping in a little bit and then reassessing. That's fine. The middle there is insulin, and the big thing there should be like a big warning sign on that says, go to for the potassium first, look at that, and then consider the insulin. Because you're gonna basically need to wait on the insulin until you check the potassium first. If potassium's less than 3.3, you do not start insulin. You don't, you wait. You replace the potassium, and there's a whole sort of how to do it on there, but you will replace the potassium first. Once it's up, then you can go ahead and start the insulin. That is absolutely vital, absolutely vital. There's a whole column over here for bicarb as well. I will tell you, I cannot remember the last time I used bicarb in DKA. Really, truly cannot remember. Turns out it's not particularly helpful, except buffing numbers, not the patient. So DKA is the big thing we see in diabetes the most, but hyperosmolar state, that is basically the human rock candy. These are usually type 2 diabetics. And what happens here is something triggers this. Either they just don't take their meds right, they eat wrong, they just aren't feeling so well, their sugar starts to creep up. And the thing is, it doesn't give them ketosis. They have plenty of insulin. They're metabolizing it fine. They just don't have enough insulin to metabolize the sugar that's actually creeping up over time. They never shift over to using fats as a source of sugar. They have plenty of sugar and enough insulin to try to use it. It's just things are out of balance. So their sugar creeps higher and higher and higher, and they don't really get ketotic because they're not needing to go over to fats to use that. They can use their sugar. There's just too much. And so this creeps up over days to even weeks. And the sugars here, the highest one I've seen is 1,600. I'm sure somebody in this room has one higher. But the highest sugar I ever saw in anybody was 1,600. They came in talking to me. But they were so sugary. I mean, that's insane. They come in with a headache. They come in with diuresis. They will say, I'm having polyuria. Okay, these sugars are making my body stink. I need to get rid of it. They have polyuria. They can get some belly pain. They can get some nausea. They can come in sometimes looking like something that's wrong here in the belly, where it's really just that their sugar is critically high and really critically high. And the thing about this is because it's taken so long to get there, they are dry, dry, dry. These people tend to be 8 to 10 liters down. not 2 to 5 in DKA, because remember, the DKA people get sick early. They don't feel so good. Ketosis makes you feel gross. These people don't get ketotic, so they just get dry, dry, dry. So be prepared in hyperosmolar state patients to have to give them lots of volume, and we'll talk about why this is where the choice of fluid is very, very important. Very rarely are they ketotic. This volume replacement, so I'll give you another sort of trick here. So I'm going to take you back to DKA for a second. If you decide to use normal saline in DKA, which you can, totally fine, you're not wrong to, and you dump in 3 or 4 liters of normal saline into somebody who's DKA, you're going to take their anion gap, and you're going to make that anion gap go away and not treat the DKA at all. The reason that you're doing that, because you're giving them sodium chloride. The chloride is part of your anion gap calculation, right? I'm replacing all this chloride. I'm taking my anion gap and falsely narrowing it. Well, it's narrower, but the patient's not better. Their bicarb will still be low in DKA. In this instance, I don't have any kind of anion gap at all. What I'm giving now is a whole bunch of sodium chloride, and I'm giving 8 to 10 liters of that. If I do that, I can cause what's called a hyperchloremic acidosis. I can make them sicker. The patients where it really, really matters to consider using lactated ringers instead of something like normal saline are people who need vast volumes of fluid. This is one state, burns are another, where you're going to be giving liters and liters of fluid. I can make them acidotic by using normal saline. So I'm going to start with something like lactated ringers at first. I'm not going to give them that much chloride. And I'm going to need over time, remember it took them weeks to get here, days to get here, not in the next minutes, 10 minutes. I'm going to take a day maybe even, or hours and hours to hydrate them back up. And it's going to be liters of fluid to get them hydrated back up. It will help them pee out that sugar. You will need some insulin to get rid of that extra sugar. So you're going to watch the K. So if you look at the algorithm here, it's basically the same algorithm we had for DKA without the bicarb because they're not acidotic. I can make them acidotic if I give them the wrong kind of fluid, too much of it, but they don't come in acidotic. So I don't need to give them bicarb. So in these patients, it's the same idea as far as when you use insulin and the potassium sort of interaction. So always make that a habit. Anytime you're going to start an insulin drip, no matter who the patient is, check the potassium first, whether it's DKA or hyperosmolar state, hyperglycemic state. And all those same things apply. Here, though, it ends up being where you will want to switch to half normal saline at one point. This is where that corrected serum sodium comes in. If you look at that left side column down there, as you're going down that left side, what you see the first thing is go ahead and hydrate. Start with fluids. They start with normal saline here. I would recommend lactated ringers first. But as you get down to where your corrected serum sodium, as your sugar starts to come down and everything shifts back to normal, your corrected serum sodium approaches normal, you're going to actually want to drop to half normal saline. And just these algorithms are 100% worth pulling up, putting in your phone, taking a look at, and just do a mental exercise, a what-if walkthrough on these particular sort of algorithms. It is absolutely super easy to do. It just are certain steps that are important not to forget. So, sugar on the low end, we know can be a problem as well. I mean, this is altered mental status. This is anybody who's seizing, anybody with altered mental status, anybody with confusion, please check a sugar, because hypoglycemia causes that. Your brain uses sugar as its food. If it doesn't have sugar, it doesn't function. So it needs sugar. So and you get diaphoretic and you get nauseated, and anybody who's ever been hypoglycemic knows you feel pretty awful. In type 1 diabetes, it's usually either too much insulin or not enough food. Usually not enough food. Sometimes it's too much exercise. Somebody's starting to exercise. We see hypoglycemic events quite a bit in the sort of January, the sort of New Year's resolution, I'm going to go to the gym, and the person that's exercising more than they used to, they're basically metabolizing like crazy, they can end up basically getting hypoglycemic. So anything that causes you to have increased metabolism, either because you do it on purpose or because you're sick, infection can make people hypoglycemic. Anybody who comes in with a hypoglycemic event, you've got to get at least a history on whether they've been sick lately, any kind of infection that might have caused this thing. Or intake, often as I skipped a meal, I know I shouldn't, or I just took too much insulin today. I can't read the little thing, I got new reading glasses, I did it wrong, I gave myself too much insulin. That's the insulin-dependent type. The treatment for those is easy. Give them some sugar, figure out what insulin they have, and watch them for a little while. Make sure they don't have an infection, right? You always do that. Then push that aside. If that's not happening, good to go. Give them some sugar, make sure they can eat and drink, and then figure out what insulin they're on. Because you'll know the half-life of that insulin. If it's something that the half-life is only 3 hours, you're good to go. Watch them, keep an eye on them, boot them out. If it's a really long-lasting thing, make sure they have somebody with them, but those people can still go home. Just make sure that they're stable a little while in your ER. I'll tell you the harder ones are the type 2 diabetics, because this is an insulin overload problem. This is basically somebody, these people tend to have too much insulin in their system, and it drives their sugar down. And the drugs they take to release insulin, these oral hypoglycemic agents, drive their sugar down, but they last a long time. They have a half-life that's a really long time. So our treatment of these is the same thing initially, give them something that's sweet. But if they're on something like a sulfonylurea, something that lasts a really long time, what you'll find, and this happens all the time, you give them a bolus of D50, they look like a rose, 45 minutes later the nurse comes up and says, they're altered again, and I checked a finger stick and it's 20. It's like, what? Okay, fine. Give them another D50 bolus. Go ahead and give it that. And that happens over and over again. Well, it's because they've got the insulin sitting around because that drug is sitting there with a really long half-life. The magic medicine for that, if you're having recurrent hypoglycemic episodes in a sulfonylurea patient, is to give them octreotide. It blocks insulin release. It's like magic. Octreotide is magic in that. And I will tell you, most people who are sulfonylurea takers who get hypoglycemic need to be obsed for a while. Those drugs last as long as 24 hours as far as a half-life, which means it's really not gone for a matter of a couple of days. So at least keeping them around for obs usually is the way to go. Now, thyroid disease, uncommon, but we see them. When I talked about that elevated temperature group, we talked about in the mnemonic time, the M metabolic of a febrile person includes thyroid storm. Thyroid itself, your thyroid is an awesome organ. It's pretty amazing, actually. And the way we in the ER know if somebody's symptoms are from their thyroid is by checking a TSH. I will tell you, it took me the first 15 years of my career at Harbor for us to get a rapid TSH. We can get a TSH now done during a patient's ER stay, which is fabulous because it makes a big difference what we do. If you can't, that's fine. Just use your sort of spidey sense and consider referring for their TSH. But if you get one, a high TSH basically means that the thyroid gland is not paying any attention. So that's hypothyroid. A low TSH says the thyroid gland has gone rogue, it's doing its own thing, and the TSH, the pituitary says, I don't need to do anything, I'm done. It's low. So low TSH, hyperthyroidism, high TSH, hypothyroidism. It's reversed. Here, this is like Yvonne yesterday on the bipolar slide from Jan. Apparently Yvonne also has thyroid disease. So here's your two sides of thyroid disease. Hyperthyroidism, so there are two things to hyperthyroidism. One is truly just hyperthyroidism. That's end organ things which are getting affected. So I'm tachycardic, I'm sweaty, I'm hot in a room all the time with people, I may have just gone into AFib, and that's hyperthyroidism. They're getting end organ findings. Thyroid storm is another story. Thyroid storm is now, it's basically like anarchy. Now I am altered because I have too much thyroid. I will tell you that is an emergency. All of those organs can't handle that very well. And if you stay in thyroid storm for any length of time, you go into cardiovascular collapse and you die. So this is something where our job, if they are altered and they come in with bug eyes like that, I had a patient came in with, I asked her family, I said, have you noticed her eyes are kind of protuberant, they're kind of prominent? And they said, oh yeah, it's been happening for a year or two. And she came in completely altered and febrile. It was like, boom, done. Got that answer. That's an easy diagnosis. So put these pieces together, with it being, and again, not a common thing, but you're going to be the all-star. They're often febrile. They can be as high as 104 with this when they really go into thyroid storm. You're going to be the all-star to pick it up. Don't expect them all to have bulgy eyes. Some do. But all the rest of the picture will fit. Talk to the family. Get some more information. And tachycardia is also part of this. Treating thyroid storm, I think of this, you have to do it in the right order. And I think of this as out to in. So in thyroid storm, first of all, they are often volume deplete. So IV fluids are important, and add sugar because they're hypermetabolism, right? That's thyroid, they're like metabolizing like crazy. So give them some sugar. Take care of that fever. So consider acetaminophen. Consider cooling measures if you need to, because often they can be pretty hot. And then work your way from the outside in. Give them a beta blocker. That takes care of the tachycardia, the tremors, all of that. Give them a beta blocker. Really easy to do for most people. Propranolol is what we use, but anyone, frankly, works, to be honest. They all work just fine. And that also decreases the conversion of the thyroid hormone from one to the other out in the periphery. So you're getting kind of a bang for your buck. But start out to in. Then finally go to the thyroid. Okay, now I'm going to go to the thyroid, and I'm going to shut it down. I'm going to tell it to just quit for a while. And so I'm going to use something like methimazole. PTU and methimazole are our two choices. Methimazole is the go-to because PTU has been black boxed, except in pregnant women. In first trimester pregnant women, that is the go-to drug. So our job is recognizing it, treating out to in. as far as treating this, recognizing that it's a true emergency, you need to do something. Hypothyroidism is different. I will tell you, hypothyroidism, truly emergent level, mixed edema in particular, is extremely rare. I'll tell you, the patients who get that in the United States are people who've had thyroid something done. They've either had ablation because they had thyroid cancer and now they have no thyroid left, or they've had some sort of surgical removal of the thyroid. So if you see somebody you think is hypothyroid, please look here first. You may see the thyroid scar, which will then tell you that that brittle hair and that slow heart rate and that low temperature and that thick tongue and that thick skin on their shins that they can get is all tied in with the fact that this scar says that they have their thyroid gone, and this may be hypothyroidism. It's a clinical picture. It's often tipped by weather like this. So if it's cold outside, that often tips people into myxedema. They go from just lethargic and kind of bleh to true myxedema, where they're hard to arouse or they're altered. Altered mental status is true myxedema in these. Amiodarone is a drug that can tip these people over as well. And your labs here, your TSH will be sky high because your thyroid isn't doing anything. It's just not doing anything. The other thing to know is somebody can stop taking their thyroid medicine today. I know I have no thyroid. I'm taking thyroid medicine, but I ran out of money and I stopped today. You will not develop symptoms of hypothyroidism for weeks. Thyroid hormone has an extraordinarily long half-life. So if somebody stops taking their meds and they show up 6 months later, now truly altered and frankly myxedematous, that actually fits. That can actually happen. So stopping your meds itself yesterday won't do it, last week won't do it, but months ago may. Treating this, so remember that it has a trigger. Usually cold does it, meds will do it, or infection. Infection's a trigger for all of this stuff. So it's recommended flat out in mixed edema to pan-culture people, everybody, and to empirically give them antibiotics until we figure out what's what. If they're low temperature, and they can get pretty low, passively rewarm them, put them on a bear hugger, get them all nice and toasty. Now you need to replace their hormones. Now I will tell you, there's really no downside to giving thyroid hormone. We hesitate because it's like, thyroid hormone. The downside to giving thyroid hormone actually is to not give hydrocortisone first. Think about it. That person's been kind of hypothyroid for a while. And when things aren't perking along, being really active, your adrenal glands go, oh, I'm bored. I don't need to work so hard. And your cortisol levels drop. You actually, your adrenal gland is just kind of Well, now I blast you with a bunch of thyroid hormone that makes you revved up, but you don't have enough cortisone around to take care of you. You end up in adrenal crisis. Now you end up hypotensive and in adrenal crisis. So what you want to do is give hydrocortisone first. So now I've got that base covered, and then you can go ahead and give IV thyroid hormone. Now, if you're uncomfortable with that, the IV thyroid hormone isn't an emergent thing. The hydrocortisone is, the fluids may be, the warming somebody, the pan-culturing is, antibiotics. The thyroid hormone itself, it's not like blocking somebody who's hyperthyroid. They will die if you let them sit that way using thyroid storm. This is not so much. This you can actually kind of take a little slower. So get your endocrine person on board. They can help you. All right, this is like what you look before and after. Let's talk about acid-base disorders, quick and dirty. So literally this is, people do whole specialties on this, right? They go into nephrology, they do whole specialties. Let's just summarize quickly the things that you at the bedside need to know. And I'm going to give you an algorithm that's my favorite algorithm for making it as clean and simple as possible. A couple basic things though. The emia, acidemia, alkalemia is the blood measurement. The osis, alkalosis, acidosis is the process that's causing it. So if you're a terminology person, that's sort of how that works. So if I have a respiratory acidosis, that's because my PCO2 has basically ended up increasing. This little table tells you the osis is the process, the emia is what the blood says. For compensating for things, my quick compensation is my lungs. That DKA person who's acidotic is trying to compensate by taking big old breaths, okay, big gigantic breaths. That's my quick, and we can do that on purpose. If you have somebody who's intubated who's acidotic, you can hyperventilate them if you really need to. So we can actually take care of that. That's fine. Your kidneys, though, take longer to adjust. So metabolic, the changes there take hours to frankly days. So the metabolic stuff, it takes longer to happen as far as somebody getting to a steady state of whatever osis they have. Our blood gas, by the way, venous is fine for virtually everything we care about. A venous blood gas is fine for the pH, absolutely fine. A venous blood gas is fine for we actually have pulse ox for PO2, so we don't really, that's fine for that. And if you really, really, really care about the PCO2, where it really makes a difference, the arterial is a little bit better, but not much. So venous gives you everything you need to know. I'm not going to mention base excess because that's kind of a little, you can read that for your information. But to figure out what's wrong with somebody's acid-base status, you basically need 4 pieces of information. From the blood gas, you need the pH and PCO2. And from the chem panel, you need the bicarb, and then calculate the anion gap, see what the anion gap is. Those are the 4 things you need. And that's all you need to figure out what's what. And there's your anion gap. By the way, we used to calculate this all the time. You don't have to now. It's usually printed out or on your labs that you can see up on your screen. So here's the algorithm that I have created because I really like this algorithm. Makes it super easy. And what we're going to do is start up at the pH. So the first thing you're going to look at is the pH. And you're going to see, is it actually technically emia? Is it acidemia or alkalemia? Is my blood pH either high or low? That's the first thing you're going to do. If it's high, the next thing I'm going to look at is the PCO2. If my PCO2 is high, that's a metabolic alkalosis. If my PCO2 is low, that's a respiratory alkalosis. Easy, easy peasy. If I do my pH, though, and I go over and it's an acidosis. By the way, the alkaloses are rarely truly an emergency for us. They're usually a sign that we need to find out why, but they're not something we need to address crazy right this minute. Very different in the acidosis ballpark. So acidosis, because your body doesn't like to be acid, again, PCO2 first. If the PCO2 is high, that's somebody who's retaining CO2. That is a respiratory acidosis. I know my problem is something I have to do with their breathing. Either help them breathe better because I need to wake them up, help them breathe better because their lungs aren't working. I need to address their lungs first. If their PCO2 is low, though, that's a metabolic acidosis. And now we're into the life threats. Now we're into something where I really need to know that anion gap. If that anion gap is high, those are the killers. High anion gap metabolic acidosis is where the killers live when it comes to acid-base disorders. If you're interested in all the other more nuanced stuff, there are other parts of these algorithms you can go to, but frankly, everything in the top is everything you need to know to be able to do something as far as an emergency at the bedside. The killers are on the left side of this. The elevated anion gap things are the things like the person who ingests salicylate as an overdose, the DKAs, people who have lactic acidosis. The killers are over there, carbon monoxide poisoning. The non-killer, though, the non-anion gap metabolic acidoses are things that basically give you volume depletion. So diarrhea, people have RTAs, they can end up with this as well. But that's not life threats. We just hydrate those people. There's a couple charts here for your information. When it comes to metabolic alkalosis, this is basically also things that basically have volume depletion. I have basically a contraction alkalosis. Diuretics do it, gastric losses do it, diarrhea and vomiting do it. So those are, and again, not life threats. None of those are life threats. We can fix that quickly, or fix that over time, not crazy. So these 2 tables are for your information, but the bottom line, frankly, is the killers of the acidoses. Metabolic, go to that elevated anion gap, find where the problem is for that patient and address it specifically, like DKA. No elevated anion gap, usually it's just an RTA or they need some fluids, all good to go. Respiratory acidosis, fix it. Help them breathe better. Either wake them up where they are breathing or take care of whatever's problem with their respiratory status. So, I went a little overtime. Let's take a 10-minute break. Let's get back at 10:20. Thank you very much. We'll see you after the break.
Hip, hip in every way. I'm in Vegas. It's supposed to be like the Elvis show. All right, I like to start on time. So we had a countdown clock going over there. I know Dr. Birnbaumer said until 20 after, but I always like to make the people who are just wandering in feel like they've missed something really important. It's like, oh, what did I miss? Did Ken say something really important? All I'm going to say is, hey, I get to do hip and pelvis now, and I'm dressed like I normally am instead of in a flight suit. So this lecture is about the hip and pelvis disorders, and there's some subtle things that we don't want to miss. And so there's some pearls in there to try to focus in on. Just like before, we're going to start with a little of the anatomy. Most people come in saying, I have pain in my hip, and they put their hand here. I've got pain in my hip. Sometimes they go, I got pain in my hip. And that's your greater trochanter or your iliotibial band. Some people say, I got pain in my hip. That's a pain in the ass. Okay? And that might be piriformis syndrome or something like that. But the actual hip joint is right here in the groin. And often, this is what they mean when they say they have pain, and it's not their knee, it's their hip. So, pediatric hip disorders. Oh, yes, pediatric hip disorders. That's what we're going to start with. There's a whole list of things. I'm not a big fan of bullet point slides because I'd be shooting at you with all the bullet points. Can you read? Yes, you can. So you don't need me to read all these bullet points to you. But those are the things that we're going to cover in the pediatric section of the hip disorders. So, start with a little anatomy of the hip. In a child's hip, an infant's hip, they haven't had a lot of time and gravity to make a deep acetabulum like you and I. We've been standing upright, some of you sooner than others, but by the age of 1, most of us are weight-bearing and walking. And so that femoral head gets pushed into the acetabulum, and you get a nice cup. Not with children. With infants, they have a very flat acetabulum and an ill-formed femoral head, and they can dislocate quite often. And so you'll see the ossification centers there. If you've looked at pediatric hip x-rays, you go, do they even have a ball and socket joint? Because there's not much to ossify there in the femoral head. They don't have a lot of muscle mass around the hip to keep it stable, right? We talked earlier about the knee that's so vulnerable to getting impacts. The hip is pretty protected. It takes a lot to dislocate an adult hip. Who here has seen dislocated shoulders? Oh, I have. Because this is the most vulnerable point for your shoulder to be in. High five. That's the most vulnerable point. We see way more shoulder dislocations than we do hip dislocations. And that's because as we grow up and that acetabulum forms and all those muscles come around and that capsule gets stuck right there and it's super protected. Not so much with children. And the vascular continuity, this is a pearl, the vascular continuity goes through that femoral head and you can get hematological spread of infection. So you can get an infection in the bone, but you can also get an infection in the joint when you've got little ones. So osteomyelitis and a septic hip. So neonatal congenital hip dysplasia. We should be screening at birth. I am primary care certified, and so this is part of the primary care exam when we get these newborns in up until about the age of 3 months, and we're just taking their hips and going, right? Pop them out, pop them in, pop them out, pop them in like that. And that has 2 names. One is ortolanis. Oh, that's how I remember it. Oh, I'm a simple guy. Oh, did I tell you I'm a rural doctor? I spent 27 years working in rural communities, and what I mean by rural, just to define that, is a 5-bed emerge and no CT scanner. So I think you guys call those critical care access hospitals or critical access hospitals, but I think most of those have CT scanners. We don't. The only scan we can get that's a CAT scan has 4 legs. It's like, right? And so I do rural medicine. It is 0.4%, so 1 in 250 births. Now, some of the risk factors make sense to me. a first birth. You can see that pelvis on the woman, obviously being narrower if she hasn't had 3 or 4 or 5 children, right? That first birth, that might be a very narrow canal and dislocate the hips. I get it. I don't get why girls are more likely to dislocate than boys, or females than males, and then the left hip more than the right hip. Again, I'm not really sure why that is, but I understand oligohydramnios. You do not have enough amniotic fluid in the swimming pool, right? And so it's compressed, and those hips can dislocate. So Barlow and Ortolani's, those are the ones that you do. So Ortolani's, you take the hips and the knees up like this, and you push down, and you make an O out of it. And you should feel that hip pop back in. And if the hip doesn't pop back in, it sits upright where the other one drops. So the one that still stays up and won't AB duct go out to the outside is the dislocated hip. So you do that. And then the Barlow's is when you do the opposite. You take them from the AB ducted position and you put them up and you push posterior down and you try to dislocate the hip and feel it pop out. And usually we just do these at the same time. You go 1, out, in, out, and feel if you can feel clicking or locking in that hip. Up to 3 months of age. All right, here is a chart that you need to memorize. No, I'm just kidding. So this is like trying to age categorize the child that comes in that's limping. And you can have 1 or 2 or 3-year-olds, you get the 5 to 10-year-olds, you get the teenagers. And different age ranges can mean different things. But I want to caution you, this is just a general way to organize your information. Just because you go, oh wait, you're 11, you can't possibly have that hip disorder. It only goes up to age 10. Right? So that's not how I want you to think about this information. This is just a nice way to put it into some age ranges. So the first age range is Legg-Calvé-Perthes disease. This is the 4 to 10-year-olds. This is the children that are going to school. Right? This is not the preschool and the kindergarten children. This is off to school, but before you guys have junior high here, right? Or middle school or something like that. So middle school. This is earlier than that, before they hit their teenage years. It's usually unilateral. You don't often see it on both sides. And it's a lack of blood flow to the femoral head. So you get avascular necrosis of the femoral head. It crumbles and falls apart. There can be genetic risk factors for that. One of them can be sickle cell disease, because when the cells sickle, they clog up, and the blood flow doesn't follow through to the femoral head, and the femoral head dies. Steroids. I love this. A history of trauma. Which 6-year-old have you ever said, hey, did you fall today? Like, I mean, if you're between the ages of 4 and 10 and you have recess, right, there's always going to be a fall history. So I don't know if that helps you. It's sort of like seeing a kid and saying, well, it's often preceded by a viral illness. My kids are in daycare. It's always a viral illness while they're in daycare. So I don't think the history of trauma is very helpful. But what is helpful is when the child comes in and they says, my knee hurts. If you get a child saying, my knee hurts, and they're rubbing the inner aspect of their thigh, their medial thigh, think hip. It is so important because they get referred pain. And they say, my knee hurts, and it's their hip. Now, they blew up that one image. The image on the one side, so that is the left side of the screen, that's a normal hip. The image on the right side, they say, oh, it's all degenerative stuff. When I see hips like this, I go, it's so fluffy, but I don't love it, right? I love the fact that I've made the diagnosis, that I see this fluffiness in that hip, but that's that hip degenerating and falling apart. This is a sign of badness. This is Legg-Calvé-Perthes disease. This is the child you don't want to miss. All right, slipped capital femoral epiphysis, easier said as a SCFI. So this is a SCFI, a SCFI. You see it in the older children, the tweens, the teenage children, when they're going through a growth spurt, often bilateral. Now, this crowd isn't old enough to know, but please, if anybody is old enough or just knows, who is that famous actor down in the bottom of the screen? No, scream it out. Thank you. Charlie Chaplin used to walk like a duck, right? And if you have a slipped capital femoral epiphysis, Your quad muscle is really strong. You've all seen dislocated or fractured hips. What do they come in as? Shortened and externally rotated because the iliopsoas muscle is so strong, it pulls up and out. So they come in like this. I had a case recently in this age group, 12, 13-year-old, and they felt a pop on the stairway going up at school. They felt something pop, and they came in saying, I hurt my knee. And they kept saying, I hurt my knee. And they were sent home, right, with rest and said, you probably sprained your knee. I saw them on the next visit. My knee's sore. They had an x-ray. The x-ray was normal, but they were getting worse. And Mom said the foot was turning out. We get the x-ray of the hip, and what do you see? The skiffy. And that's what was happening. They say that it's like the ice cream melting off the ice cream cone. So if you think of the femoral head as ice cream, and it slowly melts and falls off, that may help you. I think the biggest help is the large arrow sign. If it has a large arrow sign, I think there's something wrong with this x-ray. I'm not quite sure what it is, but I'm sure there's a problem here. So this did come with a positive arrow sign. And it's nice. This is bongo. Buy one, get one. When you get the hip x-rays, you get the pelvis, right? So you get a normal one, but they can both be abnormal, so be careful. But you do get one to compare to. And I hope you can see that that ice cream is falling off, where that growth plate is falling off the femoral head. There is something called Klein lines. So Klein lines go up the neck of the femur. That's the line that you draw, obviously probably named after Dr. Klein. And it should transect or go through the femoral head. And if the ice cream has slipped off, then that line goes up and it doesn't go through part of the femoral head. And so they've got a normal one on the right and an abnormal one on the left. And I think we've got to zoom in on that one to see that it's, the abnormal one, is on the left and the normal one is on the right. So that's your skiffy. Teenager, middle schooler, comes in saying, I hurt my knee hurts. Think about the joint above. Think about the hip. Think about a skiffy. Get the x-ray, get the hip x-rays, and look for that ice cream falling off. A septic hip. So, a septic hip is somewhat difficult to diagnose if they don't have the textbook case. If the child comes in and they've got a fever of greater than 38 degrees Celsius, by the way, that's metric. Do you guys do metric here? Oh no, that's wrong. You don't do metric, right? The only thing you guys do in metrics is grams of Coke. So I don't know what that is in Fahrenheit, but that's a fever, just to let you know. Also, the white blood cell count is usually up. Inflammatory markers are usually up, CRP, ECR, or ESR, those types of things. Prior hip surgery, certainly in adults, but we don't see a lot of hip surgeries in children. Blood cultures are often negative, but if you've got it's a child that's not going to ambulate, they've got a fever, and they're complaining about hip pain, and they're not walking, and their inflammatory markers are up, you'd be thinking septic hip. And an ultrasound can look at that and find a joint effusion, so that it could be a good imaging modality to be looking for. All right, septic hip etiology. In pediatrics, it's usually spread through the blood, staph or strep. In the adults, it's usually, and it says IV drug use, IVDU. I think I'm going to change this slide to substance use disorder, so it's a less pejorative, but it's not IV drug use, it's substance use disorder, and post-surgical causes. The IV drug use or the substance use disorder is usually gram negative. And remember, you get bugs in the joint, it's not good for the joint. And there's things that can mimic it. This can make it hard. I mean, people with appendicitis come in saying, I've got pain here. And they're sort of referring to the hip, right? The pain is referred to the hip, but it's right lower quadrant pain. I can tell the difference here. I'm missing that too. But right lower quadrant pain. But you could have an iliopsoas abscess, right? You could have SI joint pain referring in there. All sorts of different things along there can give you hip pain, like septic hip. Toxic synovitis, this is a bit of a misnomer, isn't it? Because the child will not look toxic. They don't have a fever. They don't have elevated inflammatory markers. This is an inflammatory disease that just requires a little time, a little rest, maybe a little NSAIDs, and that's it. It's in the younger children, preschool age, get these irritable hips. Pediatricians see this all the time, send them home. There's not a whole bunch of children with septic hips being missed. But they can come to the emergency department and toxic synovitis, right? You're telling the parent, oh, your child has toxic synovitis. You just have to reassure them. They've just got an irritable hip. They've just got a little inflammation going on in there. NSAIDs and rest. Avulsion fractures. So children do a lot of sports and activities, and they will get push-off injuries or injuries that have pulled off a little piece of bone, a little avulsion off the hip girdle somewhere along the hip or the pelvis, and you can get all these little flecks of bone. And you see these x-rays and you go, oh, is that a fracture? Do I need to be worried about that? What should I do about that? They do say it's a 2-to-1 male to female ratio. I think that ratio is coming down. I think it's pretty much 1-to-1 now. And I keep this picture on my cell phone, so it's a nice picture to have. And then when I get a pelvic x-ray, I go, oh, is this little funny thing? Is this one of these little things that's been pulled off and stuff like that? Do I need to really worry about it? So this has got lots of not just arrows, but lightning bolts. All right, now into the adult hip anatomy. So like I said, when the adults stand up and start walking, they start forming that really good femoral head and that deep acetabulum. All the ligaments form around there, all that musculature around that core, and that hip is pretty protected. And so we don't get into as many injuries unless they're high force injuries or the person is quite frail. And then we see the fractured hips, right? So hip dislocations, the vast majority of these are posterior. The vast majority. Obviously, it takes a tremendous force in a young, healthy person to put that hip out of the joint. It's usually a knee into a driving console, into the dashboard kind of injury, and it pops out back. So if you've got a posterior dislocation, remember, when they break the hip, it comes up and externally rotate because the iliopsoas. When it's posterior dislocated, it's shortened and internal rotation. Shortened and internal rotation. So they come in with their knees knocking, not out like this. So you know how we watch these paramedics bring the people in on ambulance? And it's fun to watch and you go, oh, look at that. She broke her hip. Right? Or sort of like that. Right? They come in like this. The opposite. Ooh, you look good. Oh, I think that's a posterior dislocation. You didn't need no x-ray. All right, need to get these back in quickly. There's a lot of vasculature in there, and you could end up with avascular necrosis of the femoral head. So time dependent. Need to get that hip back in sooner rather than later. Procedural sedation will often be necessary. So this is how they come in. Internally rotated, knocking the knees, shortened internal rotation. And there's that positive arrow sign. I mean, I think most of us could say, hey, that doesn't look symmetrical. Right, on either side. Ooh, I think that's right. I may not have needed the arrow, is what I'm trying to say, on this x-ray. But that's a posterior dislocation. So this is how you can relocate them. So the one in the color photography there, that is called the Whistler technique. And if anybody wants me to show them how to do the Whistler technique, I'm happy to do that at a break or something like that. We'll just get a volunteer to lie down and I'll show them. It's so easy. I did this the other day with one of the residents. They were quite concerned. Oh, it's a hip. How am I going to put it back in? They weren't the biggest person. Orthopedics isn't about brawn. It's about brain. It's about appropriate sedation. And then the application of force using fulcrums and things like this. So this Whistler technique, you just put the one hand underneath and up and over on the other kneecap, put the hand like that, and you're squatting down, and then you stand, you use your legs, and you pop it back in. So before, what we had to do is we would get two other people in the department, and they would put, in that black and white photo, put their hands on the pelvis. Each person would have one hand on one side and one hand on the other pelvis to stop it from popping up as you try to pull this leg back in. With this other technique, it only takes one person. You just go over, on top, hand, you're squatting like this, save your back, keep it straight, and it pops back in. It's really really satisfying. Okay, now, so I told you I started off in orthopedics. That picture there on the right, that was very similar to one of my first attempts to put in. It's called the Alice technique. Please don't do that. I stood up on the bed. There was a big 350-pound guy, motorcycle, popped out his hip posterior. So I got onto the bed like this, squared shoulders, big guy, put my arm under like this, kept my back straight, and just did this dead squat, right? Trying to pull the hip back in. Well, I lifted 2 nurses up, and what did I do? I flipped the gurney. Okay? And then there's just a lot of paperwork now. Like the patient fell, all right? There's 2 workers' comp injuries involved in this. I'm a junior resident, so I'm sort of in HR again, explaining myself. So don't use the Alice technique, please. I'm happy to show you the Whistler technique. It's so slick. You will be a Jedi master. All right, anterior hip dislocations are rare. Again, they're going into the dashboard kind of thing. But they come in externally rotated because they popped out this way into the front, and the iliopsoas muscle pulls it up and out. So it looks like a fractured hip. It looks like a fractured hip. It can be inferior or superior to the acetabulum. You still just need to get this back in. This is sedate the patient and put it back in. So there it is there. Something doesn't look right. Something doesn't look right. Asymmetrical is what I would say. See, they didn't even put an arrow on this one. Like everybody can see that, right? Dislocated prosthetic hips. So they usually go about back. It's somebody bending over after they've had their total hip done. They bend out back and it pops out and they come in like this, right? Posterior, internally rotated, knees are knocking, right? You can't really screw up the vasculature, right? Okay, so we just want to get that hip back in. And I would just say out of professionalism and courtesy, call the orthopedic surgery team, whoever's on call, whether it's your local orthopedic surgeon or whoever's on call for ortho, and say that you've got this total hip, it's dislocated. Would you like me to make an attempt to put it back in? In 27 years, I've never heard them say, no, I'm coming in. No, you don't touch that. No, I'm so glad you called me at 2 o'clock in the morning. I'll be right there. No, but just call them and say, hey, do you remember anything about the surgery? If they were the surgeon or something like that, would you like me to attempt to put that back in first? They usually say yes, at least in my experience. Hip fractures. All right, so you get your subcapital fractures, your intertrochs, and your subtrochs. So subcapital are just under the femoral head, and then you get them through the trochanter, the greater trochanter and the lesser trochanter, and then below it. Pain management, these are usually older, frailer individuals that have these types of fractures. These wonderful people that have served their community for decades and decades and very kind and slipped and fell, and they broke their hip. Pain control is important, but they might be also sensitive to opioids. And so learning how to do femoral blocks, if your department allows you to do femoral blocks, very great way to spare some opioids and keep the person not getting sort of totally lulu while you're trying to control their pain. Because they broke their femur. This is painful. Now, I have to say that most of the people that I see who are, again, these wonderful people in their 8th decade of life, just wonderful community members, when I see them and I ask them for something for pain, they go, dear, you look busy. I didn't want to bother you. Right? And they broke their femur. And yet I'm allowed to make fun of my in-group, usually some young man going, oh my God, oh my God, oh my God. And it's a paronychia. Now, we have a code stroke team so we can get faster care, and we have a code STEMI team and a code sepsis team, just so patient satisfaction is higher, time to antibiotics is sooner, all those metrics improve. We are currently looking at a code paronychia team because we know we can improve all the metrics and your Press-Ganey scores. So, they usually are very stoic and say, no, I'm fine. They broke their femur, right? And so you can spare them the opioids and do a femoral block, and they're usually very appreciative. Chest x-ray, ECGs, Foleys, whatever your institution requires. If you're going to do a femoral block or one of those plain blocks, you can do it ultrasound guided. I just go for the thump, thump, thump and go beside that. But you can do it ultrasound guided. Just let them know, because, like the orthopedic surgeon, because they'll go, yeah, they've got no sensation in that leg. You put in a block, okay? All right, elderly hip fractures, minimal trauma, yes, they're frail and elderly. Films, yeah, films can be difficult to interpret. I have missed a couple of hip fractures in my day. I still remember the very first, you always remember your first mistake, right? And this was, I was a young, hot shot, brand new grad. And I looked at the plain films. No, I can't see a broken bone. Radiology read it as -2, okay? So what did I do? Discharged her home, despite the nurse coming up and saying, it's broken, right? She can't walk. It's broken. And I'm like, nurse, I've changed, okay? I have had my ass saved so many times that I'm like, yeah, I sent her home, and then, obviously it went thunk and fell off, and then they came back. And so don't make that mistake, right? If they can't walk on that, right? And the plain films can be normal. They can be normal. It's like the scaphoid. It can be an occult clinical fracture. Get the CT. Or do what I didn't. Listen to your teammates. Anyways, so there are the different types of fractures. Subcapital, intertroch goes through the trochanters, subtroch. Occult fractures, yes, that's my whole story about occult fractures and missing them. So have a low threshold. If you think they fell and they have hip pain and they can't walk, and you can't really see anything on x-ray, be pretty low resistant to pulling that trigger for getting a CT of the hip. Missed fractures have worse outcomes. And there's an occult hip fracture algorithm to try to figure that out, so you can go through that algorithm on your own. And there's some, the picture on the left there has the black arrow sign, so you know something must be wrong there. And the hint is that you see the density of, like you've got the trabecula lines, and they should all line up. But when they get this minimally or non-displaced fracture, it just has that double density that goes 90 degrees to the trabecular line. It's a little white line that looks a little bit out of place, right? Little thicker, stuff like that. That's where that is crunched and cracked. But you can see it on the MRIs. Greater trochanteric bursitis. We have a whole bunch of bursa all around our hips, and we can get into trouble with those bursa. Just like in the knee, it is some rest, some NSAIDs, and some time. Please do not do incision and drainages of bursa. Please, if you're going to do something, do a tap. Do it with a needle. Don't create a sinus, and don't create more problems. And that is it. 3 minutes ahead. Getting you back on schedule, 10:45. Woo! And clearly you're capping for this guy. Gooch. The gooch.
Sir?
Thank you, sir.
All right, well, good morning, everyone. Welcome back for day 2. So, talked a little bit about orthopedic already. You're actually going to talk about some more this afternoon. So, the elbow and the forearm. And those are sometimes frequent things we see. For the most, these luckily are not life-threatening and tend not to have complications. So here's the elbow, there's the forearm. Any questions? But nah, it's a little bit more detailed than that. One thing that you're probably going to hear several times is anytime that we have this paired bone, so here my radius and my ulna, then we talk about lower leg stuff with the tibia and the fibula, is they have some inner membranes that connect them. And these ligaments here are really important for function and for stability. So here, the ulnar collateral ligament, that is really important for stability of the elbow. So if I have severe fractures there, I have dislocations there, I definitely have to be concerned they may actually have a ligamental injury. So if you're able to get a good assessment of the stability of that joint. Do they have good range of motion? Is it limited? Maybe it's due to pain. But definitely if you're worried about that avulsion fracture or they had that displaced fracture, have a higher nexus suspicion this patient may also have a ligamental injury, and that definitely can affect future use and recovery of that joint. Same thing down the distal forearm there at the wrist. I think right after lunch, Ken's going to talk about wrist and hands, and these are all connected, but definitely that's really important for stability. And here, more the elbow, the forearm, not as big of a deal, but are they right-hand dominant or left-hand dominant? And definitely which side is involved, because I definitely want to make sure this patient gets follow-up care, definitely if they have risk for further problems from that. Think about your soft tissue there. There's multiple compartments. Not very common to see a compartment syndrome in the forearm, but it does happen because I've got all these fascial planes. So remember that your ulnar nerves deal with your flexion and your radial nerve deals with your extension. And you'll talk about this definitely more about hand assessment, but get a good assessment of those. Are they able to have flexion or extension intact there? This also plays a role here, especially if I have some of those mid-shaft fractures. We'll talk about those special ones here in a few moments, but get that good distal assessment. And that's something to talk with ortho if you had to talk with them. And hey, I see this, I've got this, I'm concerned about this, because this definitely can be a problem even all the way up to the elbow with some of those injuries. You're gonna hear this over and over again, but basic orthopedic things. Make sure you get a good assessment of that joint above and below, because definitely, especially if we have significant energy transfer from blunt trauma, that definitely may cause further injuries than just what the patient complains of. See that a lot with the lower leg. They have that ankle injury, but it's the proximal fibula that sometimes gets injured. Same thing here. So what do you feel? What do you see? How are they able to function? Always get a good assessment of that neurovascular status. How's their movement, their sensation, and their perfusion? Ideally on initial assessment, and definitely anytime before and after I do any manipulation. And again, also prior to discharge. Hey, they had great cap refill. If there's a pulse I can check, let's assess that, document that. Because definitely if I have to manipulate this, maybe doing a closed reduction, I want to make sure I knew what the perfusion was before versus after. And definitely if we've immobilized that, it can make kind of pulse assessment difficult. But in most people, cap refill is still a really good assessment, especially if they're in that warm environment. Hey, how does it just feel? And document those things. And what does the patient feel like? Do they feel like it feels normal to them? But look for those things and document that. At least those 3 times, initial, manipulation, and discharge, sometimes even more. So who needs that elbow x-ray? Patients come in, they may have had that blunt trauma, maybe they had that Fuchs injury, and they've got pain there in their elbow. Typically, if they're able to lock that forearm in full extension without significant pain, that decreases the likelihood they probably have a fracture there. Definitely look to see if they have point tenderness. Where is it? Is it right there on the olecranon, or is it maybe in the soft tissues or over the radial head? But definitely if they're able to do this without significant pain, they have good range of motion, less likely that person has a fracture. So it's something that may help limit your x-ray use there. Our fat pads. These we talk about a lot with kids, and you're going to hear this even more, but definitely even sometimes when adults, these may be very helpful. And definitely sometimes, especially if I'm worried about there might be a fracture there that I can't see real well, that occult fracture, this is when the fat pads can really help us. So anterior fat pads might be normal in some kids, these little small ones, but just keep in mind that posterior fat pads are almost always abnormal. So look for those. You know, back in the days, we had to hold up to the hot light and get a better view. Now with most of our electronic, it's much easier. I can inverse the image, I can blow it up, I can really get a better idea. But look for those fat pads and even document the presence and absence if you're still worried about this person might have that occult injury. So as you can just kind of see here on that picture on the left, anterior fat pads sometimes can be normal, but it's usually very small. It's not bulging out. It doesn't kind of have that sail appearance we'll look at in just a moment. We're here, and I'm like, Ken, I love when the x-rays come with arrows. This makes it so much easier for us. But that posterior fat pad, that's obviously abnormal. And look how that anterior one's kind of got that sail sign coming out. It's like the sail off a boat. That's abnormal. And this patient does have a very subtle radial head fracture there that sometimes might be missed. Sometimes that's just due to the positioning of the patient. They weren't able to get that exactly right view. And definitely, if you have that suspicion, they're really tender, look at those fat pads. And especially in kids, sometimes it can be difficult. So even think about the importance of comparison views, but always look at your films. I luckily work where I almost have 24/7 radiology overreads. I'm spoiled, I love it. But occasionally they miss things. And so I've had to call a couple times and go, hey, what is this that I'm looking at? And they're like, oh, I'll fix that. They miss stuff, we can miss stuff as well, so it's great if you have that resource. So my radial head fractures, those are my most common adult injuries here at the elbow. These can be very simple and be non-displaced, and sometimes they can be pretty significant. These are most often seen with Fuchs-type injuries, so that patient fell in an outstretched hand, and they've got that energy transfer up towards their elbow, and sometimes they may even see some dislocations here with that. So where are they tender at? How's their range of motion? If I've got a non-displaced fracture, most of those patients, it's splint immobilization for a week or so, they do great. But if there's definitely any displaced fracture there, there's any angulation, that's when I want to get ortho involved sooner versus later, because I want to make sure they get proper healing and they don't have any limitations of range of motion later. So as you can see here, some of these are really subtle, but definitely those fat pads can really help us out. Even in the adults, you may still see some of those, but definitely in kids, this can be really helpful. If in doubt, they're tender, you don't see anything, it's never wrong to immobilize them and have them follow back up. We love being able to do our two-sided splints now compared to we used to do all those circumferential casts years ago. But it's going to give them some comfort. Usually that's going to help limit movement and gives them support, and then have them follow back up, maybe coming back to see us or hopefully in to see ortho. My supracondylar humeral fractures, those are my most common we see in kids. This is often a type of Fuchs type injury as well. We see this a lot with playground equipment. They're on the monkey bars, they're doing their stuff, and they fall and they hit, and that energy transfer causes this injury as well. One thing that may help us here, as we call, is the capitellum test, or that anterior humeral line test. We'll look at it on a different slide, but that can sometimes kind of help us look for these, because sometimes these can also be kind of subtle, and it might cause displacement of that capitellum that can be easy to overlook, but that humeral line test can help us. So if I took this picture here, see that typically in most kids, that middle line there goes right through the middle of the capitellum, if I were to divide that into 3 sections. That's proper normal anatomy. And so even if you don't see a fracture, look to see where that line is on that front of that humerus, and if it goes to the middle third, I probably don't have a fracture. But if there is some displacement, then definitely there might be an occult fracture there that I can't see very well on that initial film. So as you can see here, nice, normal, I've got good alignment. Looks like I've got a little bit of an anterior fat pad, but nothing posterior, and that line goes right through the middle third. Looks pretty normal. I don't see anything there. If they've got some limited range of motion, they got point tenderness, hey, let's do a period of immobilization, have them follow back up. But if I look and I see something like this, and I've got this big, obvious, huge fat pad here too, but this can definitely help me look to go, ooh, I've got to look closer. There is a little occult fracture in there that may be difficult to see, especially if you're not used to looking at these a whole lot. So do your anterior humeral line test. If it's not going to the middle third in most kids, there's probably something there causing some displacement. So this table here just kind of gives us a summary we just talked about, looking at those occult elbow things. Remember that in peds, it's mostly the supracondylar. In adults, it's the proximal radius. But do your straightening test. If they can hold it straight out, pretty good. But if in doubt, immobilize for a brief period of time, have them follow back up. But get that good distal perfusion and assessment. So epicondylar fractures, also a common thing that we see in kids. They may use the Gartling classification system here if you want to get really nerdy with your radiologist or with your orthopedist. But these can have significant problems because of displacement. Maybe can cause some impingement up on the nerves or even the vasculature. These usually don't give us any fat pad signs, which can make it really difficult. And this is when my comparison views may come into play a lot. If you've got radiology, sometimes we don't have to do those, but definitely if I don't have that quick overread, then probably getting an x-ray of the opposite arm just to compare can really help me go, ooh, that is their normal variance, because not everybody read the textbook, or actually that looks nothing like their other side, so maybe there is something there. If it's non-displaced, usually it's just splint and immobilization, but definitely if it is displaced, talk to ortho. They may want to go ahead and see this kid sooner versus later. Maybe it's tomorrow, but I definitely want to make sure this kid gets follow-up care, because it may even need sooner operative intervention than just a couple of days later. The growth plates. Great things, but definitely could be challenging for some of us, especially if we don't look a lot of pediatric films. So Crito is my mnemonic here for the elbow, kind of the typical order in which they heal at. Sometimes they're going to be mistaken for fractures, but look at them really closely. These growth plates tend to be very smooth, very uniform, where your typical fracture is going to have some irregularity to it, maybe some jaggedness. Then again, your comparison view may be helpful here to go, oh, that looks exactly like it does on the other side. They're almost mirrors of that. But definitely if they're tender, just think about a brief period of brief immobilization, have them follow back up. So elbow dislocations. Typically with most of these are also your Fuchs injuries, and these are almost always posterior. So P's is a mnemonic here that may help you. Posterior is your elbows, anterior is your shoulders. I think we're talking about those later today as well. But typically it's your posterior. And it's that Fuchs injury, they fail, they've got limited range of motion. Usually you can feel some deformity back there, and they don't want to move it. And it does hurt a good bit. These are usually some of the easier ones to reduce. Maybe you'll do this with limited sedation, maybe just a local regional, like Ken talked about earlier. But definitely with just a little bit of traction, these usually go back in place pretty easily. but it is a dislocation, so I've got to worry about underlying soft tissue injuries. These do have a high incidence of having some injury there to one of the nerves or the vasculature. Kind of debated back and forth often, do I get an x-ray before or just only after? But if I'm really worried there's a fracture there too, that'd be the reason I might want to go ahead and image first and then talk to ortho and like, hey, it looks like there's a fracture there, so may want to do a little different method than our typical just reduction in these patients. But no fracture, I can easily reduce it. Usually probably a brief period of immobilization with a sling or maybe a shoulder immobilizer, and they're good to go, but definitely follow-up may be warranted if they're having more problems. But definitely there's a fracture, get ortho involved sooner. So olecranon bursitis. Kim was talking about this a while ago with the bursa. These get inflamed. We see this a lot with people that do a lot of floor work, like carpet layers, tile workers, but even students. They're down studying, they got the elbows up, they're reading, and this is just irritation of that sac, just from repetitive friction, repetitive movement, and usually it's just inflammatory. But sometimes it can become infectious, and that definitely makes it very red, very angry looking, where this one here looks just like it's just inflamed, but not really infected. But do ask about things like maybe this could be a foreign body. Just if they're out doing a lot of work, laying carpet, do they get a carpet tack or something there? But usually this is just inflammatory, so it doesn't need imaging unless I'm worried about a foreign body. If I've got a little hole there, it looks like a puncture wound, then yeah, let's image that. A lot of these, and we'll look at this on a picture in a moment, that sometimes you'll see a little calcium deposit there just from the chronic inflammation, and don't mistake that for a fracture. It's going to have a very smooth appearance, just like the growth plates we talked about a while ago. You can also see this sometimes with gout or even RA, but usually it's inflammatory. But definitely if it's very red, it's very angry looking, I've got localized erythema, I'm worried about this being infectious, then this is definitely a patient I might want to tap it. Go ahead and numb it up, aspirate back some fluid, see what it looks like. If it looks very mucopurulent, it looks very cloudy, then I definitely want to send it off for a culture, send it off for a cell count. But if it's clear, it doesn't look inflamed, this probably is just an inflammatory process, not really infection. But if I'm worried about infection, this is typically going to be your skin flora, so staph or strep. So go ahead and cover those typical things. 15, 20 years ago, it was mostly just regular staph and strep. But nowadays, we see a lot of MRSA here as well. So think about those organisms and what's going to cover those. Clinda might be a good option, TMP SMX. If I really just think this is typical staph or strep, then maybe just cephalexin is a good option there as well. If it's not infected, it's just inflamed, then probably doing a local injection with maybe a anti-inflammatory corticosteroid like triamcinolone, maybe with a little local anesthetic like lidocaine or bupivacaine, usually gives them some pretty good relief if they're okay with you putting a needle in that area. Ultrasound can make this even really easy, but it's just usually pretty easy to do. You can find it pretty easy by just palpating, when that probably has some better efficacy and better resolution than NSAIDs. But definitely if you don't want to do that, you're not comfortable doing that, then a short course of NSAIDs are probably okay as well. So just some pictures here. There in that bottom left, that's your truly inflamed looking. It's red, it's angry. That's the patient I probably am going to consider tapping, whether I'm doing a local anesthetic or maybe a topical, and aspirate back some of that fluid and see what it looks like, and even send it off. Where on the far right, that's your non-inflamed, that's just chronic irritation, inflammation. And as you can see there in that center x-ray, that little calcium fleck there, that's just the chronic inflammation, so don't mistake that for a fracture. You could see an avulsion fracture here as well, but what does their history tell you about? And that's why typically, unless you're worried about true injury or foreign body, don't even get the imaging, just go through your clinical assessment. So our subluxations, typically our radial head subluxation is our most common sublux. This is your nursemaids. This can be a really gratifying kid to see. Mom, dad, whoever, bring them in. Usually the kid's not complaining of pain a whole lot, but they're definitely neglecting that arm. They're not using it. And this typically happened because somebody grabbed their arm and pulled them, and that radial head slipped out of place just a little bit, but enough that it makes them not want to use it. Sometimes this is going to be, you can kind of palpate the area, and they are usually tender right there over the radial head, but this is something that's really easy to fix. And some people will go ahead and teach parents how to reduce it. Typically by age 4, by age 5, the incidence has dramatically decreased, but some kids, if they have once, they're likely to have it more again until they get older. So if you're comfortable with that, teach them how to do this. But it just slips out of that place there. That ligament's a little lax as we're younger. It has more mobility. By age 4, definitely by age 5, it's normal laxity and tends to decrease the occurrence. Don't need imaging here. This is clearly a clinical diagnosis. Couple techniques out there for years. Most of us probably did that one on the far left. Probably the right, that hyperpronation probably works a little easier. So I want to get mom or dad to hold that kid, hold that good arm out of the way, because they probably don't want you to touch it. I'm going to take my hand, as you see, encompass that elbow, and probably try to find their radial head with your thumb, and then grab their hand and wrist and start to hyperpronate that. And as you hyperpronate that, you're going to feel a little click, and you're going to kind of feel the radial head pop back in place. And you'll feel that, and then probably within a couple of minutes, that kid's active, playful, doing great. If they haven't resumed utilization within 5 minutes, then I might want to reassess them. Maybe I didn't get it fully back in. But most of these kids, they're going to scream or shout a little bit, and they're done, and then they're happy and back to normal. But if it didn't go back in, doesn't feel just right, then maybe you try that again. That may be when I consider imaging. But most of these, they're going to be back to normal within a couple of minutes. Do great, maybe give them some ibuprofen, some acetaminophen, and then go home. And then just educate the parents on how to reduce this risk. Hey, let's try not to grab them too hard by that. Or, hey, even here's how you fix this if you need to. So a couple of our forearm fractures we have to be aware of. This is our Montagia fracture and a Galeazzi fracture. These are fractures that tend to have more complications because you see a fracture and a dislocation. So I want to make sure I get a good view of that full extremity. Again, looking at that joint above and below. So with this Montagia fracture, I've got that ulnar fracture, and I've also got a dislocation below that, where with the Galeazzi, I've got the radial fracture with a dislocation. These almost require operative intervention. These have a higher incidence of having some of their neurovascular compromise. These are usually blunt trauma. They've had significant force there, but look for both of those, and definitely this is the patient I want to talk to ortho sooner versus later. This may not be the patient I can just immobilize and send home. Definitely get a good neurovascular assessment and get ortho involved or get them transferred over to ortho, because I would hate for this patient not to be seen in a timely manner and then have a vascular problem or have a nervous injury. Our Colles fracture, definitely ones we see a lot of. Your typical distal forearm injury. See this a lot with a Fuchs injury. May have that deformity we see with that classic fork type deformity or that swan neck deformity. These are pretty simple, non-displaced fractures. Sometimes they are a little displaced, but these are typically ones that we probably can do a closure reduction there in the ED or maybe urgent care and immobilize and have them follow back up. But get that good distal assessment. If there's a lot of separation there, I'm going to go ahead and talk to ortho. And most of the time they're like, just reduce it and I'll see them tomorrow. But get them on board to make sure they have follow-up care. We also have our Smiths, and Smiths is just the opposite to reverse Colles. So instead of falling on that outstretched hand, they may fall on that flexed hand. And that may have more problems as well because of the way the impact is and fractures there. But again, get your good distal neurovascular assessment, get your imaging. These are usually pretty easy to see, but make sure you get a good assessment up top at the elbow as well. Because if they've had that energy transfer at the wrist, it definitely may have got translated up to the elbow, and sometimes you'll see a fracture there or even a dislocation. If they're minimally displaced, split and immobilized, maybe a little bit of displacement, we probably can go ahead and reduce those. If you're able to do those, this might be a procedural sedation. This is when a hematoma block is a good option if you're able to do those. Get there, inject some lidocaine in that area, and then you can manipulate all you want to, and they don't feel a thing. And then this is your typical sugar tongue splint. Whoever's immobilizing them, whether it's you or your nursing staff or your techs, go back and look at it and make sure they did it right. Because sometimes people forget about that anatomical position, and that's not this. I need a little bit of flexion there, and just make sure it's been well padded, that we've prevent skin breakdown, and I've got them in that true anatomical position. And then make sure that patient gets really good discharge education about what they can and cannot do with that splint and why they still need to follow it with ortho, because this is only a temporary device. Definitely in some of our kids, we can have more severe injuries. We talk about our Salter-Harris things, which is here. So there's a couple of mnemonics out there. One of those is that slip straight above, lower through, or ram. But definitely we see some of these, like those ram fractures where I've got significant impact. I can have those impacted fractures. Usually ortho's pretty good at go, it's this, and radiology says, they love to label these things. But most time now it's much easier because radiology can look at them. We can get ortho to look at them pretty quickly. Sometimes you kind of get, you just send me a picture of that. And if your hospital policy allows that, sure, watch out for the HIPAA stuff. But some of these can be problematic, so I definitely want to make sure they get follow-up care. So some more pictures here if you like. Definitely see what that above that epiphyseal fracture looks like. As you can see, it goes straight through the epiphysis. So definitely I want to make sure this heals properly so they actually have continued bone growth. Because if it doesn't get proper follow-up, it doesn't get watched, then this definitely could lead to impaired growth and have some limitation in use later. And then definitely that severe one like your 5, it's impacted together. So that definitely needs to be followed up, or even your lower epiphyseal fracture there. And then lastly are overuse syndromes. We see these commonly people that do a lot of manual labor, but sometimes also just sporting activities. And it's just for that continual use, flexion, extension of those structures. So things like epicondylitis. That's my tennis elbow if it's lateral, it's my golfers if it's medial. But they usually have pain right there over that structure, and usually certain activities tend to make it worse. Probably for most people initially, we're just going to do supportive care. So rest, NSAIDs, and then give them a couple of days to rest, and then start gradual back into it. Rehab's important there. Probably if they're having continued problems, then maybe we consider doing some interarticular injections there at the structure itself, just to kind of reduce some inflammation, but those may not have any better long-term or short-term benefits than just doing rest and NSAIDs as well. And then lastly, we have de Quervain's tenosynovitis. So inflammation of that sheath right there above the radius, usually right through here. We can sometimes see this just from overuse. Also, this is a lot in pregnancy, definitely due to some fluid retention. Sometimes females may get this as well. And one thing we can look for here is the Finkelstein test, but they're usually going to have pain right there over that area, and you may even feel some crepiness. So if we're looking at this picture here, having them do some ulnar deviation, that's my Finkelstein test, and that usually increases their pain. And while you're having them do that, go ahead and palpate over that area, and you might feel some crepiness. And that's just, this probably is this. It's just an overuse syndrome, or in the case of pregnancy, it's just inflammation. Rest, NSAIDs, as you saw in that previous picture, sometimes some devices like this will kind of help hold it in the right place, but just gives us some comfort. But usually about a week or so, it's feeling better, and they can slowly work back into what they've been doing that caused that inflammation. But rest, NSAIDs usually is the best here. Many need benefit from long-term use of injecting some steroids there. All right, that's it. Thank you so much. Looks like we've got one more, Rick, and then we'll be ready for Q&A. Thank y'all so much.
Okay, this is the first of two pediatric talks. Today we'll talk about the core of pediatrics, and tomorrow we'll talk about some of the infections that kids get themselves into and other medical problems. Kids are fun, but I think also there's a certain fear of kids because they often they're small, their organs are small, they don't necessarily give us a history. The history's coming from the parent. We don't really know exactly what's going on in the kids. But starting out as a baseline, the aunt brings a child, the teacher brings a child to the emergency department because they fell and hurt themselves in the monkey bars. That kid needs a medical screening examination. EMTALA never said, well, you needed to have the parents' permission or anything like that. And if that kid fell off the monkey bars and literally backed his head pretty good, you'll need to do a CAT scan probably in that kid without the parents' permission. That's okay because you made a medical judgment that the CAT scan, the benefits exceed the risks in doing it for this little kid because the clock's running. So you need to do medical screening examination and don't be too concerned about, see if you can get a hold of the parents, but bottom line, you need to do it. There's this group of people who are kids, yet don't need their parents' permission to be seen, like they're talking about the pregnancy, the child abuse, obviously, substance abuse, mental health conditions, depending on the state. So there are STDs as well. They can be seen without their parents' permission. There's this issue about child abuse and failure to report child abuse, and we talked about the consequences of that. So if you don't report child abuse, you're breaking a law of the state of wherever you are in. But sometimes it's not obvious that it's child abuse, and sometimes it's very subtle. But the problem is that once there's evidence of abuse, the concern is what happens the next time. The child goes ahead. One of the things that I saw a case, only the frenulum was torn. Why was the frenulum torn in this little kid? And you know, it's like, how do you tear a frenulum? But that's kind of known as a cold sign of abuse, and that you should think of that. In any case, this case, the kid was sent home and basically came back, fractured skull, all these other things, broken ribs, because the abuse continued. That was a $45 million lawsuit. The nurse's notes noted that their child had bleeding in the mouth. The doctor wasn't really impressed. By the time the doctor saw the kid wasn't bleeding, and so there wasn't an appreciation of the nurse's notes. Here's a good example of where the nurse's notes could have saved this person, but unfortunately they didn't. So failure to report child abuse is, your malpractice insurance may not cover you. You may go to get arrested for this crime. So you may have a civil lawsuit against you from the parents or relatives, and then there's a criminal one. So you have to absolutely have a low threshold. If you're not sure, report it. Let them figure it out. This is the idea of emancipated minors. These are young kids, basically, in some cases, who don't need their parents' permission. Like if you're in the military, you don't need your parents' permission. If you're married, you don't need your parents' permission. If you're a minor but out on your own, supporting yourself. So there are a number of kids that became emancipated minors. Macaulay Culkin, you know, the guy who's on all those movies about Christmas and all that stuff. He was an emancipated minor. Drew Barrymore was an emancipated minor. They were basically allowed to kind of get around some of the education type rules because the court allowed them to become emancipated minors. Otherwise, they were allowed to have the tutors come to teach them at school while they were making the movies, etc., as emancipated minors. Obviously, when the kid's being examined, don't even bother examining the kid till the parents are in the room. This is a show, and the show requires the audience, and the parents are the audience. The kid's this big, and so the idea is to examine the whole thing. If it's a fever, okay, we're going to examine the whole thing. We're going to look in the ears. Mom, I'm looking in the ears. There's a little wax here, but I don't see anything else. There's no drainage. Mom, let's see the mouth. Oh, the mouth is clear. I don't see any pus or anything back there. It doesn't look like he has a sore throat. His mouth is nice and wet. It doesn't look like he's dehydrated. He's crying and he has tears. I don't see any skin rash at all. Let's see how his neck is. His neck is fine, Mom. There's no clinical evidence of meningitis. Chest, I'm listening. Good breath sounds on both sides. Heart, sounds good, Mom. Belly, let me see here. I don't feel any enlargement of the liver or the spleen, and it doesn't seem to be tender. Let's look under the diaper. No diaper rash, Ma. The child moves all the extremities well. Good strength. Doesn't seem to hurt him anywhere. How long did that take? Was that a minute? Was that 2 minutes? Was that 3 minutes? And then you get the doctor. Do you have a private practice? Because that's the medical equivalent of hitting a home run, knocking it out of the park. And what you just did is you verbalized as you examined, so that the audience, the parents or whoever there brought the child there, can hear what you're looking for. And so it's easy to do, and it's a nice trick for you to learn to kind of get clear to the people that you are doing a thorough job. How thorough? They want hands-on touching. And whether it was important to look in the ears or not is largely irrelevant. Obviously, you have to have the equipment. You don't want to have a big sign out there that says emergency, and then a little kid comes in and you don't have the essential equipment. You don't have the intubation equipment the life-saving type of equipment for a kid. So that's clear. You know, the Braslow tapes and its competitors are all basically allowing you to try to figure out how much dose of drug should I give this little kid. And they even have a thing now where you can scan the bottle of the medicine, and the barcode of the bottle of medicine tells the concentration of the medicine that's in there, and it calculates the weight and says, here's the dose for the kids. So there's no calculations on the part of the nurses. Intestinal, this is the inconsolably crying child. You know, the child just will not stop crying, and they bring them in. First of all, there's this issue about colic. Colic is a diagnosis of exclusion. We put that to the end in terms of considering that, but it has a definition: 3 hours a day, 3 days a week for 3 weeks in a row. 3 hours a day, 3 days a week for 3 weeks in a row is colic. 13% of kids have colic. What is colic? Well, some people call it intestinal colic because they think it is focused in the intestine. Maybe it is, maybe it isn't. We still don't have a great idea of what it is. I mean, some kids are basically going to calm down when they're carried. Sometimes they put the kids on the washing machine or the dryer, and the vibration of the dryer basically will settle the kid down. They find things that are unique that'll settle these kids down, but it's a diagnosis of exclusion, but it does have a definition. Is there any occult trauma? Well, you have to look for the bruises, and you have to take the diaper off, and you have to move the extremities around. And sometimes the trauma could just be the child's crying because there's a nasty diaper rash. Now, when you think of that, this is an ammonia-caused burn over that area down there, and the kid's crying, and the mom doesn't know about frequently changing the kids and really doesn't know how to handle a diaper rash. And so this kid's got a really painful, skin condition that you need to find out by taking off the diaper. Strangulation of a digit. You ever see this? How many of you have seen the strangulation of a digit? Is that weird or what? Like a penis tip, finger. This is basically where the mother's hair attacks the kid because mom's not being given enough attention lately. But in any case, you have to be aware of it. Now, don't go digging under this thing with a number 11 blade, trying to cut the hair. Consider getting a depilatory, Nair being one that, is out there. Corneal abrasions. I'm not interested in finding their corneal abrasion, to tell you the truth. Have you ever tried to put fluorescein in a kid's eye? This is a little baby. The fluorescein is all over everybody. It's over you, the kid, the face, mom. It's all over. And then now try to pry that little bugger's eye open. It's physically impossible to open that eye. These things heal in 2 to 3 days. The kid might have scratched his own eye. Because they're basically in Brownian movement for a while, with the, random things, and must have poked his eye. But it's a hassle going through that. So I generally tend not to do it. And the other thing is many kids, if you are able to look at their cornea, they will have areas of corneal staining, which are not abrasions. Abrasions need to be nice, linear kind of thing is an abrasion, but there's sometimes the areas do some corneal staining that really is not an abrasion. So we did the trauma, we did the strangulation, we did the corneal abrasion. Infection, sure, that could cause some crying. You've seen kids who cry about ear infections. Their ears hurt, they cry. A 6-year-old comes in and they're crying and they're pointing to their ear. You don't need to be a rocket scientist. You look in there at bright red kind of thing, and the kid's crying and it's very painful. Well, maybe one of these kids has got something like that. Do they have meningitis? Meningitis is still around, even though there's all these herd immunity and all these immunizations. It is still out there. Surgical conditions, you have to look under the diaper. They're looking for hernias and testicular torsion and anal fissures. You have to take the diaper off. Basically, here's neonatal jaundice. The most common reason for a newborn coming back to the hospital is neonatal jaundice, and the most common reason for that is physiologic jaundice, where in fact The body's job is to take these neonatal red cells, these are the nucleated red cells, get rid of these in the spleen and replace them with the adult type red cells that don't have a nucleus in them. So the bottom line is that the spleen is basically screwing up these, taking out these red cells. There's all of this bilirubin floating around in the bloodstream. The liver's job is to take that bilirubin, conjugate it, and put it through this, the ampulla vater into the second portion of the duodenum. So that's the idea there. But the liver can get overwhelmed by this kind of thing. So that in fact the liver's trying its best, but there's a large amount of bilirubin that has not been able to be conjugated. And so we measure in this kid the bilirubin, the direct and indirect, or conjugated and unconjugated, and you have a huge number. The biggest number is the unconjugated bilirubin, and then the small part of it is the conjugated bilirubin, because this can flush back into the bloodstream. But the real issue here is you got this big batch of unconjugated bilirubin because the liver just can't keep up. And so depending on the height of the bilirubin, this may be a billy-light situation, but the bottom line is you're going to be able to call somebody. They have all kinds of guidelines about when does somebody get a billy light, when did they not get a billy light. Idea is we're trying to kind of find out why this kid has this jaundice and to see if we can ameliorate it. Sepsis is supposedly on the list, but septic kids generally don't look well, and to the point that they're septic and jaundice, they're generally going to be not appearing well. They're not going to be active, responding to those kinds of things. So the idea here is maybe this kid needs the billy light. Maybe this kid. How about this one? This is really strange. So mother's breastfeeding, and while the kids now the jaundice I just talked about, it comes on like the second, third, fourth day kind of thing. Down around 10 to 20 days into this kid starts turning jaundice, and they're breastfeeding and everything's going along just fine, but the kid turns yellow. The reason there is you need glucuronidyltransferase in your liver to conjugate the bilirubin, glucuronidyltransferase. In mother's breast milk, there is an inhibitor of glucuronidyltransferase, and so this kid's sucking this stuff in, and this inhibitor is inhibiting the ability of the liver to conjugate bilirubin, and so this is a breastfeeding-related hyperbilirubinemia. So the screening tests that we order are the total bilirubin and the fractionated, the direct and non-direct. We want to do a Coombs test. Coombs test is a test for preformed red cell antibodies. So these come out, latch onto the red cell, and destroy the red cell. So a Coombs positive basically means that you've got a hemolytic anemia going on here, not related to issues with conjugation of bilirubin from liver problem or glucuronidyltransferase inhibitors. So you put the kid under the light. What does the light do? It's kind of strange. The light does not conjugate the bilirubin. The liver conjugates the bilirubin. So the light basically at a certain wavelength takes bilirubin and transfers it to a water-soluble form. And once it's in this water-soluble form, it can go down the biliary tree and go out. And so you see these kids now, they're under the blue light, they got their eyes covered. Now they got blue light coming from the bottom. Bottom, top, the amount of surface area that you can expose is the key thing, the proximity of the blue light, the wavelength of the blue light. Those are what this is all about. What happens if you did this blood test and then you got the large amount of conjugated bilirubin in the bloodstream, and the ratio, which is normally seen of a large amount of unconjugated, small amount of conjugated, that's the normal ratio. What happens in this case if you have a large amount of conjugated bilirubin? It means that this bilirubin cannot go out through the hepatic tree, which is maybe a sign of biliary atresia. And that would be a sign we're making this stuff, but it can't drain out, so it refluxes back into the bloodstream, and that's what's going on there. Vomiting in infants, basically there's this nice differential that they tend to have they tend to vomit at just about anything. You look at them cross-eyed, they'll vomit. Infections, sure, infections. UTIs, this drives me a little nuts. What is a UTI? UTI basically is typically something in women that makes them, it's a bladder infection. They pee a lot, it hurts when they pee, they may have some microhematuria. That's a UTI. What is it when you have a flank pain and fever and you're generally ill kind of thing? That's not a UTI. Well, it is technically, but it isn't really specifically. It's pyelonephritis. Why don't we call febrile children who have an infection of their urine pyelonephritis? Why do we use sloppy language by calling it a UTI? It's not a UTI as we know UTIs, but in any case, that's what those are things. Hepatobiliary causes of vomiting. The kid's supposed to be jaundiced. We got a blockage in the liver. Something's going on. We're not processing as we had hoped to. We're coming, and so that's basically kind of one of the tip-offs of hepatobiliary causes of vomiting. Kid is jaundice. Malrotation of the gut is really kind of interesting. So in utero, in the developmental process, the small bowel goes into the amniotic fluid. And while it's out there, it makes a certain number of twists and turns that are not random, that are always the same way, and then the bowel comes back into the abdomen. Sometimes in the process of doing those twists and turns, it doesn't do it properly. And we have what's called malrotation of the gut. And that malrotation is associated with fibrous bands developing, and most frequently these bands develop across the duodenum, but distal to where the bilirubin enters the duodenum. So distal, the third part of the small bowel, or further down, there's this fibrous band that's crossing it, it is obstructing the bowel, and so the kid's vomiting. But the tip-off here is the kid's vomiting bile. Kids are not supposed to vomit bile. So when they talk about biliary emesis, that is a tip-off to the fact that you may have a structural blockage of your bowel, maybe from malrotation of the gut. This diagnosis is usually made in the first couple weeks of life. However, many people, the obstruction is only partial, or in fact, doesn't really affect the passage of anything. And so there have been adults found to have malrotation of the gut, but it just didn't cause them a big problem like it did in kiddies. Pyloric stenosis, we'll talk about that. We'll talk about incarcerated hernia. They don't call it shaken baby anymore. That's old-fashioned. Abusive head trauma is, well, yeah, you have shaken this baby and increased intracranial pressure developing, and that we know that people will become vomiting from that, and maybe they'll become obtunded as well. So these are the things that are serious causes of vomiting that you should consider in these kids, although the majority of them are generally going to be some kind of viral disorders. And there's our good friend Dancitron at the bottom. Infectious diarrhea, just summer and winter. Winter is viral, RSV. So we got these immunizations against RSV. Rotavirus. And they work. The first ones didn't work. They basically prevented you from getting the infections, but they would cause in the bowel lymphoid hyperplasia. So there was pooching up along the bowel wall of lymphoid tissue, and this lymphoid tissue served as a lead point for intussusception. So this initial immunization was associated with intussusception, so they got rid of it and made a better one, and it's very effective at preventing serious rotavirus infections. It may not do much if you're having, if it stops a really serious one, that's good, but you still may wind up getting more minor cases because it doesn't work maybe 100% of the time, but the serious ones are. Summer is Summer is preformed toxins from staph. So, you talk about we had the picnic and the mayonnaise was out there and the chicken salad kind of thing, and somebody ate that, and within a short period of time after eating that, they've got vomiting and diarrhea because they have ingested a staph-generated exotoxin. So this is a preformed exotoxin. It doesn't matter about anything growing in your body. You just ingested it, and within a short time, within an hour, 2 hours, you're not feeling so good anymore, and that's basically staph diarrhea. The invasive diarrheas that we're concerned about in the summer are Salmonella and Shigella. Both of these invade the bowel wall, rupture a few capillaries, cause basically bloody diarrhea. The distinction between Salmonella and Shigella that is important is Shigella is associated with a neurotoxin, so there is a particular propensity to have febrile seizures in kids who have Shigella. And I remember the case that I had personally that we had a little tyke who had a seizure, high fever kind of thing, and it was kind of like, oh, this is we're doing the meningitis workup here, and the EMT takes his kid and kind of makes a little donut of him, kind of to open the spinous processes. And when he did this and did that move, out came the specimen that we were looking for, and out came the bloody stool of Shigella. So that's one of the ways to get a specimen when you need one, is just like a kid like that. Blood in the stool. Usually we don't know. Just to say, something got scraped. It's not that big a deal. That's the case if the child is well, eating, happy, playful, he's got blood in the stool, but otherwise is okay, then you can watch those. You don't have to make a big project out of it and see whether it stops on its own. Other people say, well, maybe there's cow's milk intolerance. That's considered to be a significant subset of those cases. Anal fissure, well, that blood's right out. You get a streak of blood right on the stool there. That's kind of a tip-off there. I'm saying is just to put this to rest. Some say that the blood in the stool comes from the baby sucking at the mother's breast. So they've got this little vacuum pump of a kid on the mother's breast who's exsanguinating the mother through these cracks in her breast. And basically the blood, and that's the cause of red blood in the stool. Well, that's obviously not the case because you put blood in the stomach, the acid in the stomach turns blood black, and so that's an upper GI bleed if you had that. But I can't believe that really is of any consequence. Pyloric stenosis, white boys, Northern European. These are easy to diagnose usually. So this is a very hungry kid. You give them the bottle, they drink, take the bottle away, out it comes, and it doesn't have to be a projectile, but it can be. And the kid's hungry, drink, and next it throws up. So basically, you feel the abdomen. These kids are quite young, and so the abdomen is soft and easy to palpate. And there is, in the epigastrium, is an olive. And now that you know how to do ultrasound, you just diagnose this with the ultrasound, and that makes the diagnosis, and you refer them to some surgery guy, and it takes care of the olive. As you can envision, if you vomit a lot, you're losing hydrochloric acid. If you lose hydrochloric acid, then what's left is a metabolic alkalosis. And in the setting of metabolic alkalosis, you shift potassium, so the potassium is going into the cell in the setting of, you lost your chloride, hydrochloric acid, so you're losing your chloride, you're moving your potassium intracellular, you have a metabolic alkalosis. Not that you necessarily need to do anything about that. As soon as the kid gets fixed up, it'll all resolve. Intussusception, basically a pretty common cause of surgical obstruction. The idea is most of the time the small bowel invaginates into the large bowel. Well, where does the small bowel and the large bowel come together? They come together at the cecum. So normally the cecum is basically where the small bowel starts invaginating. So where is there going to be a mass? The mass is going to be on the right side because that's where the cecum is, where your appendix is. It's on the right side. So there's a tubular mass on the right side that may be able to be palpated. If you don't want to palpate it, you can take your ultrasound. And the ultrasound is so classic. When you're shooting down the barrel of a tube within a tube, even I can say that's not normal. That picture is a tube within a tube shooting down the barrel of the two bowels together. Talk about people saying, well, you know, they often have a current jelly stool. That's a late finding. You can't depend on that for sure. One of the things that's kind of unique about these kids is that they are in a lot of pain. So that when the pain is there, they're bicycling, their legs are turning all red, they're really upset, and they're crying hard. And after that, they basically kind of like calm down, and they're listless, and they're just silent. And then they go to another spell, and another spell comes, crying, legs moving. So there's this very kind of unusual pattern of pain and a relief of pain. Brief resolved, unexplained events. This really takes a little bit more than a couple of minutes to do, but this is the AAP's latest guidelines, May 2016. Involves kids who have a spell, some kind of spell that lasted less than a minute. The kid's less than a year old, and the spell is of one of four types. They can turn blue, they can turn pale, they can have irregular breathing, or they can have absent breathing. They can have muscle, they could be floppy muscle, or they could be rigid muscle, but not seizure. Or then they can have altered consciousness. Some of that basically is what we're talking about here. And generally, these kids come in by ambulance because the mothers or fathers are so upset about this, they get frightened to death. Call the ambulance, and these kids are typically, the mother is sitting on the stretcher with this happy little baby on her lap. And that's the presentation of these cases, because these are short, and when they resolve, generally the child is perfectly well. And it's like, okay. So the kid has to have a short spell of one of these things, and it has to be perfectly otherwise well. It can't have a cold, it can't have any illness going on. If it does, then it's no longer a low-risk patient. So if the kid is perfectly well in your examination, happy, playful, drinking, those kinds of things, and it's never happened before, first time, there's no family history of sudden death or other kinds of things like that, and the child is basically a term birth. No CPR was done by anybody, and then basically this patient the American Academy of Pediatrics says, don't go overboard working these kids up. And it's very specific. It doesn't say may not. There's a number of things that says, don't do it. Don't do it. There's a little shared decision making here, obviously. We're going to, the most obvious thing to do is observe the child for a while. See how they do. See if they, give them 2-3 hours in the department, how they. So pertussis, they say consider it pertussis. Pertussis can stop your breathing, but usually you're coughing like heck when you have pertussis. In EKG, you want to see I think it's perfectly reasonable to do an EKG to see if there's anything going on with regards to abnormalities there. But look at the list of don't order. Don't. This American Academy of Pediatrics say don't do this. Then there's a long list of mays that you can do. Febrile seizure. I think I'm over time here, and I don't want to take up the other people's time. So I'm going to stop here, and I'm going to pick up the rest of this on the next pediatric talk, so we don't give it short shrift, because I'm particularly interested in talking about pediatric fluids that is part of this. So let's stop here, and we'll begin with our question and answer period.
All right. Question and answer time. We're going to bring up our
There
faculty.
there were only 80 questions this morning.
You guys are hungry.
You know, it's like,
My goodness. I got carpal tunnel.
did the lecturers give any of the answers? You know, it was like, what happened here?
Some very good questions, though. And sometimes there's no exact right answer. There's some good guidelines and suggestions. Don't forget, you can watch the live stream. Remember, it's www.ccmelive.org. And we keep those videos up, like I said, for
Is Ken?
a couple days after the course, and then they come down. But feel free, share them on your social media, tell your friends.
Here he comes.
Here he comes. He was up front talking.
Paging Dr. Milne. Paging Dr. Milne.
Ken, and then Jan is not going to be here.
Oh.
So
Well,
we
we'll
actually,
just
let's
have
scooch
to-
down one, and then one chair can go off, because Jan's upstairs on a call.
I'll just put it back here.
Hello, darling.
Hello.
Hey, Kenny?
And my Christmas socks on. It's the only Christmas I can get on an outfit up here, because we're
All
supposed
right,
yeah,
let's
how
get a
festive.
jump on
Yes.
this.
I brought all my Christmas socks.
It's very
I had
nice.
to leave my Christmas stuff at home. Put Dr. Milne here.
All right, Dr. Milne. You know, when you're ready.
True. 2 minutes.
11:45. It's 11:43.
You know, damn. I
OCD.
I was looking on the clock on the right. It was in the red.
You had 2 minutes.
And Dave, we have AM Day 2 up, right? Yes, AM Day 2.
Yes. Hello.
Okay.
All right, let's do it.
Okay.
Alrighty.
What are we doing?
Answered
that?
Yes,
Okay.
we're doing this. You know, we kind of mentioned a little bit about this yesterday, but let's comment again on recommendations regarding providing refill prescriptions for chronic health conditions in the ED setting. I usually provide daily dose and recommend follow-up with primary. Question is the legal ramifications of doing this.
I think it's a reasonable thing to do. If the pills are blood pressure pills or cholesterol pills or whatever they are, hopefully they're not any kind of controlled substances.
Yeah.
But if they're blood pressure pills, why not? Why would you not fill them?
I think it helps to have confirmation, like in the record of what they've been on, and you can call the pharmacy or if they have bottles or something.
Right.
So you know the dose and confirmation.
You're going to make a
Yeah.
record, and that's a reasonable thing to do. This is all about good faith examination. Well, good faith examination doesn't mean you physically have to touch them. They can tell you, I forgot my blood pressure pills, and this is what I take. Can you help me out? And the answer is yes, I can help you out.
And I think it's reasonable not to do it. But I work in a different system where people have access to primary care. And so I'll get them through until primary care, or I'll pick up the phone and say, your patient is here and they require a prescription renewal on their antihypertensives. Thank you for taking care of that. And so it's a different system. So it depends. So I think it's reasonable to do it and it's reasonable to not do it. It depends on where you're working and the practice environment.
And I don't think the legal ramifications are a particular concern as long as you can
You can
verify that's what
verify
they're
and
on.
justify that's what
And
they're taking.
I'm
And
not
not
prescribing
controlled stuff.
a month's worth unnecessarily. Here's a couple weeks worth.
Yeah,
and
no,
that should
yeah.
give you enough time to get into
Yeah,
somebody.
sure, yeah, no, and that's, and we're coming up to holiday times and access to care might go down and we might be the only game in town, so it might be, here's a 30-day supply until the new year, until you can get in to see your clinician.
I thought that was an interesting
totally
point.
fine.
This person is just prescribing one pill. What's the point of one pill? What's that doing for anybody? One single pill of your blood pressure medication. If you're going to prescribe the medication, if you know that's the medication that they take, why not give them those couple of weeks or 30 days?
And the thing is, if it's just blood pressure pills, you know that the Framingham data was based on 10 years. So, 1 pill, 30 pills, 100 pills isn't going to make a difference with cardiac outcomes on a disease process that takes 10 years to show an effect size.
Yeah, now benzodiazepines, opioids, complex medications.
They need insulin? They need insulin, right?
Yeah.
That's different, right? So that's why it all depends answer.
Hello.
Diane's
This
mic's
is one way
not
to
great.
shut me down.
I will be her sign language interpreter now.
No, but the other thing though is more and more I'm aware of how hard it is to be a patient. I'm more and more just stunned at how hard it is to be somebody who needs medical care. And I think anything you can do, if it's not really slamming you to help, is just a nice thing to do. Our healthcare system's really slammed. If you've had any loved one who's tried to get a doctor's appointment or even get through on the phone, it's just a nightmare. So if you can do something to ease it a little bit, and it just really depends on your day and the situation, but I kind of throw that into the pot a little bit.
Yeah, absolutely. Okay, Dr. Bucata, medical legal lecture today.
You're on the hot seat.
What happened with the scenario? Oh, is that up there? Yeah. What happened with the scenario of retaining an intoxicated patient in the ED?
Oh, the word Kowalski was put up there, and there was a New York State decision that said under certain circumstances, intoxicated patients could leave the department. So, but my point of view is I'm not letting anybody who has got mental incapacity leave the department, and I'm not really going to care about anybody's law because it's the right thing to do. You can't let them go out. They may get hurt. They may trip on one of those things in the parking lot, for crying out loud, and everybody's going to say, what'd you do that for? And I'm going to say, well, there's a law that says I have to let them go. I'll worry about that later, but the fact of the matter is that most of the people in the family will be appreciative that you help cause them to stay. You're not going to be too aggressive about it. You're not going to be hog tying them down. We basically have lots of drugs that can basically take the wind out of their sails if we need to keep people around.
Take their clothes away.
So
good point.
I don't worry about it. I wouldn't even think twice about it. If you think that they are incapable of making good decisions about themselves, they're yours.
That's great advice. Okay, next question. What's on the differential for thunderclap sudden onset headache besides subarachnoid diameter?
Yeah. So the one to always put in your bag of tricks, the things to think about. So say you do your whole workup for subarachnoid, it's not a subarachnoid. Please go back and ask about anything that might have caused a dissection. A vertebral-basilar dissection or a carotid artery dissection. And that tends to be suddenly, so it's kind of interesting. We think about it as the sort of the chiropractors. We diss the chiropractors because they jerk your head around. But the reality is these can be seen in people that are doing something on sports or have a minor whiplash injury or even sometimes turn their head abruptly or even sneeze.
The dental chair.
Right. A violent sneeze can do this. So
Getting
go back and
The hints technique?
yeah.
No cases of the hints?
Maybe
Yes.
we don't do hints because we can cause these, but
Not
it presents identically. It presents identically. Sudden onset severe headache and it may not have in fact it usually doesn't have neurologic findings until anywhere as long as a week to 10 days later. So I think the thing there, and all you do differently is just get an angio with it, a CT angio. Just look at the vessels. You'll find one of these, I guarantee it, in your career. As you kind of go through your career over time, you will find the one that you will save from a locked-in syndrome or a stroke-out problem. So that's a thing that I add always on my subarachnoid differential.
You know, Diane gives a really great talk called A Wolf in Sheep's Clothing at our advanced course that talks about a subarachnoid case that is really awesome. If you'd like a preview of it, we do have it up on the CCME YouTube website right now, so you can take a listen to that.
It's a fun talk. It's called A Wolf in Sheep's Clothing because it's benign complaints that hide serious conditions. The things that you would see in an urgent care that you might just say, no big deal, that turn out, if you have a few little things you check for, are a big deal.
All right, this is a long story, this next one, so hang in there with me.
It's
I'll
too
read
small
it.
to read. You got to read it.
Yes. A 70-year-old came to the ED, known acute shortness of breath, agitated, blood pressure 180/100, heart rate 130, respirations 40, 78% on room air. EKG shows new left bundle branch block. Nearest cath lab is 3 hours. Crepitation all over the chest. ED resident initially, I guess, was ordered high flow O2. The patient removed the mask. Lasix 2 times 40 milligrams. Cardiology was informed immediately about an MI. The patient died immediately after 30 minutes. Cardiology blamed the ED. I guess we're looking to see who's at fault here. I mean, is this a consult issue? Is the person who asked this question here?
It's complicated.
It is complicated.
Are they here?
Doesn't look like they are.
If they're not here, let's move on.
Is that?
Because there are too many unknowns in that.
complicated.
Too many unknowns?
To answer a question
Too
there.
complicated.
Oh, I'm sorry, everyone. Okay. Okay, would you get a CT in a post-concussive patient who did not get a CT at time of injury and is now complaining of a headache?
So we talked about the clinical decision tools yesterday, and of course, they're after the 24-hour rule. Now we can't use those tools, so that's not what they were studied in. But I think if you've had a patient who had head trauma, now has a headache, and especially if they have an abnormal neurological exam, you're suspicious about something else, that it might be validated. But definitely, I think it's got to go in your clinical decision making and what you see clinically.
Of what ifs in that, right?
Yeah,
if it's
there's a
an
lot of what ifs.
80-year-old who had a concussion,
Right.
I would feel very differently than a 20-year-old who has a concussion. So there's a few unknowns in there, and we know that post-concussive syndrome has headaches, right? That's part of its
That's the
defines it.
Yeah.
So I think, and the fact somebody survived 24 hours, there's certainly not an acute terrible thing going on in there. So I think you have a pretty decent, unless you have some other reason, like it's more than just their headache has gotten a little worse, they're vomiting their brains out, there's focal neuro or something. I think you don't have to.
Okay. How are we counseling patients about the risk of tendon rupture if we absolutely have to put them on a fluoroquinolone? Should they avoid certain activities during treatment and for a certain period after?
The answer is we don't know.
No, we don't.
And I would just say if you get joy playing tennis, go play tennis. And you got a 3-day course of an antibiotic for a UTI. Just if you get terrible pain, right? If you start feeling pain that's out of, your usual I'm playing tennis pain or I'm doing this pain, then obviously get seen. But, it's a good medication and they're for appropriate indications. It's just
This
fine.
is really
Rare.
important for you to tell the patient ahead of time.
Yeah.
There's this rare thing that happens. It is a rare thing that happens, but it happens. It happens enough that the FDA's put this black box on this thing, and I just want to talk to you about this because this really is the best drug for you right now. Otherwise, I think you're good to go with this medicine. It's the right thing, but just know if you really, really, really are going to worry about this, let's talk about whether there's something else we can offer. Really, this is more just telling the patient about it. This is an attorney problem. This is not so much a medical. It's really rare. It's not common.
Yeah,
But this is about neuropsychiatric issues, I think.
That's
are
real. That's
more-
different.
Big one.
Right?
Yeah,
This is
more
different.
common and
vascular dissections.
And for your UTI, there's nitrofurantoin. There's all kinds of other stuff that would be the unusual infection that says you got to use this one. There's no other choice.
Yeah, fluoroquinolone's a strange first-line agent to be using anyways.
Urologists.
Yeah.
Yeah,
So,
I posted actually a systematic review that looked at quite a few studies, and they found that age was actually one of the
Right.
biggest indicators of patients, and the age was 60. So they're at higher
Offense
risk.
at that.
John Shedden was a farmer who basically had a cough and went to his doctor and was given fluoroquinolones and steroids for the cough and ruptured both of his Achilles tendons. And it was the first lawsuit against Johnson & Johnson who was making it, and it was at the time it was like a $3 million lawsuit.
Yeah, so the take-home point of that, though, isn't that fluoroquinolones can cause that. The take-home point is do good medicine.
Yeah.
Right?
Right.
I mean, that's that was bad medicine.
Bad medicine. Well, they honestly, maybe they didn't know about it at the time.
Well, no,
you
but,
know,
but
I
if,
guess they did.
if it's a URI, what would you be giving fluoroquinolones for a URI?
why would you be giving antibiotics for a URI? It's
Right,
the most
exactly.
common indication for giving
Exactly.
antibiotics.
Well, I think and right now the temptation is high to give anything to anybody because everyone is miserable.
Well, I
Like,
thought
everybody
everybody
you see is totally miserable.
Everybody has to
but-
have a Z-Pack or a Z-Pack.
and
or
they're
whatever you
asked
call
for it, and
It is
everybody's
what they
sick right
call
now,
it,
so it's
Canada.
everywhere.
We call it a Z-Pack.
A
Yeah.
Z-Pack.
Ken, is it just me, or every time I hear the phrase bad medicine, I think of Bon Jovi?
Of course, who wouldn't?
Of course.
1980s. It's like bad medicine.
Right.
And that was my theme music for Tamiflu.
Oh, Tamiflu.
When
So,
I did my review on Tamiflu, it's just bad medicine.
actually, really good side note. Dr. Milne does an amazing, wonderful
But-
podcast.
Did you have it on your thing?
Yes, we do.
Yes.
But I'm going to make sure that we put that as another post. It's called The Skeptic's Guide to Emergency Medicine. He really does an in-depth review of papers. Fantastic stuff.
Plus,
And
it's hilarious
It's really
sometimes.
funny.
It's just stuck in the 80s.
Yeah, and he plays music. It's really
Yeah,
great.
if you're from the 80s, if that's like your music, you are all in on his podcast.
Yeah, so if you just want to Google the SGEM, SGEM, comma, Ken Milne, it'll come right up. But we can put a link here in Slido as well. Okay, next one. Oh, speaking of ruptures, there's actually several questions on this, so I'm going to try to address them all. Mainly it was about splinting and consultation, but this one is a consultation with ortho really necessary for a simple Achilles rupture injury? Wouldn't splint and non-weight bearing and follow-up be sufficient?
I would say it depends on your current practice environment, whether your orthopedic surgeons want to be called about these things or whether they want to see them in clinic. You know, like, so you know your culture. I know that our orthopedic surgeons don't want to see them acutely, they want to see them in clinic. But other places may want, how come you didn't call me? So fine.
I mean, it's reasonable to do a phone consultation. That
Yeah,
way it's
no.
also on their radar because they now know their name. It's
That's the
logged
key.
somewhere, and now it's on their radar.
Yeah.
And then and still the patient has to follow up.
And
Yeah.
time of day, like you're not calling them at 3 o'clock in the morning, by the way. you
It's
know?
worth
So-
generating for yourself a list of the actually relatively few things that you need an orthopedist right now for.
Yeah.
Because otherwise most things are splint and refer or splint and get an appointment. And really the list is relatively short for the things you really need an orthopedist to come in and take care of.
Compartment syndrome?
Yeah, pretty much. I mean,
Yeah, I had one.
Open
I
fractures.
had one recently, and they didn't have a fracture. And I said, yeah, I know. But they have compartment syndrome, and they go, no, I've never seen, a patient with, and I'm like, well,
Let
now
me
you
be the first.
Well,
now you have, and they're like,
That you
now,
know of.
to grant, I was speaking to the resident.
Right?
I was speaking to the resident and referring them out, and
The residents that I've never seen. It's like,
and then it can't possibly be, and those you know that phone call, right? And then I said, well, just mention it to the attending, okay? And then the attending called me back and said, yeah, I can send them over. And sure enough, they're in the OR that night, right?
Yeah.
So, yeah, compartment syndrome is one of them.
The other question that's a little farther down the line that I don't have up on the screen right now is about the splinting. There was someone that had mentioned something about dorsiflexion. That is not correct. It's always plantar, okay? You're pointing the toes down, not up to the sky, and it's usually a graduated splint,
In
right?
an equine position.
Yeah,
Right, like a horse.
Exactly.
But think about what you're doing, right? You want the two pieces of the tendon
touch.
closest together you possibly can. You're going to point the
Point
toe
your toes.
down.
Now,
Ooh, nice socks.
There is a
My-
nice
these are my Christmas
substitute.
socks.
Nice Christmas cat socks.
I know, truly.
Sorry,
There-
I'm distracted easily.
Squirrel.
He's a sock guy. So.
Someone said an animal, horse, squirrel. Okay, so when you're splinting these people, if you really truly, I'm not going to say that there's one better than the other. I prefer splinting patients myself, always.
It's fun.
I know the injury. I know how to do it. I know exactly what's going on. I've looked at the X-ray, whatever. I've talked to ortho. Fine, I can splint them, unless of course ortho's there. They can help. You can get a graduated splint in a boot as long as you have the heel, the special heel converter. So you can ask your hospital about that if you want to get fancy.
In a boot?
In a boot.
Thanks for translating
A
that.
boot.
Okay? All right. Oh, this one's interesting.
Is it?
If you have a patient who got in an accident due to falling asleep at the wheel, and you're seeing them in the ED for an MVA-related injury, by the way, it's MVC, we don't call them MVAs anymore, do you absolutely have a report do you actually have to report them to the DMV?
I'm not aware of any DMV that would view that as a mandatory report. I mean, you don't have a disorder characterized by lapse of consciousness. You just didn't sleep last night.
The DMV?
So it'd be like
Of all the
seizures
places.
and stuff like that.
I'd call their mother first. No, wait,
Diabetic
you can't do that.
episodes and seizures and stuff. Okay.
Yeah, you don't need to call the DMV.
But don't put yourself in that position where you could be criticized
Yeah.
when somebody gets hit.
Okay. More legal implications, Rick, or
Wow,
ramifications.
a lot of legal questions.
Yes, yeah,
Scary
people are
stuff.
worried. For an MD, if a patient, I like this one though. This is the one, if Rick and I were discussing this outside. If a patient left without being seen due to a long wait time, any legal pitfalls in terms of documentation, et cetera, for the doctor? Or NP.
Actually,
Well, I think that
anybody,
some
right?
people leave without being seen, or it's their prerogative. And if you can assess basically that their capacity was not compromised in terms of, well, they came in because they bumped their knee and their knee was swollen. Well, if they left without being seen, I basically call them at home and saying, I'm very sorry that you had to leave, or have the nurse do that. We would be happy to see you. Do you have a doctor that you can go to tomorrow, or something to that effect? If the person does not have capacity, I think that you have to call the hospital security, have them look around the property, and in the stairwells in particular, and I would call their phone number, but if there's no answer, don't assume that it's their correct phone number, and have them call the police, and then you have done everything a reasonable person would have done to find a person who you think is compromised.
So this is a problem we see all the time, right? And we're seeing it more and more these days. I mean, left without being seen numbers are skyrocketing right now, and I don't blame people one tiny little bit for leaving.
Right.
I think the thing for you at your institution is to find out what your policies and procedures say to do, and make sure you're doing that. And I don't know, each institution is different, but frequently it will include at least a note that you have reviewed what is in the chart at the time, so that the patient doesn't disappear. It's like, reviewed the chart, saw the triage note, labs look appropriate, chest X-ray is negative, so that at least someone has closed that loop. But best is to try to get a hold of the patient, just make sure they're okay. And tell them that the door is open if they want to come back, and they'll say, yeah, sure, because I'm going to wait again. But this is really a huge problem now, and there's a lot of people falling through the cracks. We've had several cases every day of trying to track down somebody with some horrific finding on a film or a lab, and trying to find them.
Yep. It's not easy. Okay, I kind of like this next one too. Could you perform a Tonopen test for idiopathic intracranial hypertension?
So there have been studies on this, kind of fun study. I will tell you where it's not the Tonopen, it's sort of like the Tonopen on steroids, which is an ultrasound. Mm-hmm. So people are using ultrasound to basically, you can measure intracranial pressure-ish. And actually the studies are decent on this. I'm not sure it's a replacement for anything, but it is you can certainly increase your oh dear kind of sense of somebody, a young woman with a headache.
Is that a, oh dear?
Oh dear.
It sounds like, oh my.
Well, it is. I mean, these things are like, I'm working somebody up, it's like an ultrasound.
Like an odds ratio.
Yes.
Oh my.
But that's, so Tonopen I've seen a little dribs and drabs studies kind of like, wow, we did this, it was cool.
Yeah.
But not anything really that's studied to any degree of predictability or usability. But ultrasound, which is taking over the world, is also being used to measure intracranial pressure.
If you want to get into this ultrasound world, and let's say you don't even have time to go to a course, why don't you just tag along with someone who's really good at it and be like, for the next 3 weeks, the next 9 shifts that I have, I only want to ultrasound the eye. Like, I want to see every eye patient. Will you let me know? And then you'll learn. You'll be able to do some of these valuable tests. And that's how I learned. Then I went to a formal class and solidified my skills, and then I could use them more confidently. But Tonopen, there are some interesting studies. Ultrasound is the best. But quite frankly, I mean, if you're concerned about intracranial hypertension, there's some other things that you're going to see in the patient, you're going to hear from the patient.
Or you'll do a TAP.
Mm-hmm. Right? Okay.
Which also speaks to the idea of doing an LP and making sure you measure opening pressures as a habit, rather than like don't take those little tubey things and just throw them away. Put them together and actually measure. And in most LP trays, there's also that little piece of what looks like IV tubing. It's like, what the hell is that thing there for? Yeah. Well, what that's there for is the needle's in the patient's back. The male end of that IV tubing goes into the needle. The rest of that needle goes on the three-way stopcock. The rest of that piece of tubing goes on the three-way stopcock. So you actually now we all get nervous, like taking that weird stacked up thing and you stick it into the needle, and it's like, it feels like it's all wonky. Well, it gives you distance. Mm-hmm. Now you actually have a little piece of tubing, and you can lift the thing up and down if you want to, and the needle just sits there in the patient. That's what that thing is for.
Practice that. That's another thing. Practice that. It looks so cool when you do it well, and then you have such a great wealth of information, right? All right, next one. Oh, here's a DKA. Oh, wait, no, sorry, that one went away. We'll get to that in a second. Love these questions. I love and hate migraines, so I can't wait to hear what everybody has to say about this. What headache cocktail is your choice for patient, basically? I've been told no NSAIDs due to risk of bleed, which is a separate question.
Yeah.
So maybe answer that second part first about NSAIDs.
I don't know.
Bleeds?
You've seen bleeds with NSAID? I have yet to see
Is that a single dose?
Yeah.
So where this came up,
was it subarachnoid?
I believe was with the mesencephalic, potential mesencephalic people with the
Yes.
Yeah.
And we talked about this Monday in the farm course, and everybody has their cocktails, and most people probably have already insetted out before they get to us, so probably there's no utility in giving them another dose if they had one 2 hours ago. But if they haven't had a dose, go ahead and give them one. And then different people, I think triptans are now considered first line. The dopamine antagonists are still what a lot of us use, metoclopramide, clopidogrel, and they work great. Some people still like to give diphenhydramine with them. Most of the studies have shown that probably if they're given properly, you don't need the diphenhydramine. It does make them sleepy, which if they haven't been sleeping, then maybe that's a utility, but it's actually educating your staff on how to properly give Reglan or Compazine. Don't have them go in there and just slam it in. Now you're going to have a new allergy on the patient's list. I order them as piggybacks if I can get them that way from pharmacy, so they can't just slam it in and give them that 10 of Reglan, that 10 of Compazine.
Actually, you might want to reiterate that. This technique is something most people aren't, I think a lot of people aren't aware of.
Right.
It's like you just order it, the nurse just gives it, but that actually turns out to not be particularly the best. Well, it's not the best way for sure.
You know, and if they haven't had NSAIDs, then I may give them some ketorolac or some IV ibuprofen if I have it available. But then do your triptan or your dopamine antagonist, maybe the diphenhydramine if you're worried. Most of the cases have shown that, hey, if it's given properly, there's low risk of dystonias. It's just when they get it given very rapidly. And if you're not, think about also following up with some dexamethasone if there's no contraindications. It's been shown to reduce the reoccurrence and even the severity of that reoccurrence in the next 2 days after treatment.
Yeah, the number needed to treat is 9 for that.
So not bad.
Gooch, you took the words right out of my mouth.
Oh dear, here we go.
It must have been like
Oh no.
So yes, we
2
actually
out of 3 ain't bad.
We talk 2 out of 3 ain't bad for sure. So we actually talk about this on the 2View. We're doing our episode live tonight at 5:15 p.m. If you want to stay and listen,
With
right
an
here.
audience?
With an audience right here.
Whoever wants to stay.
In Las Vegas, whoever wants to stay. But we talk a lot about migraines, mostly because I love talking about migraines. I have gotten them for years. As Mike said here, there are only 3 drugs, the antidopaminergics, the NSAIDs, and the triptans that have been proven to be efficacious, and the steroid dose, reiterate, very useful for reoccurrence.
And no opioids.
And no opioids. It'll do anything for headaches.
And you rebound.
And if they're allergic to all the other stuff, think about your antipsychotics, haloperidol, droperidol, trazodone. Those are all off-label use,
conversation.
You're talking my
but
language
it's going to
now.
help their pain because they're both dopamine antagonists, but also makes them sleep and they go to sleep and they feel better when they wake up.
I would say Compazine is my favorite drug of all time. Compazine, antidopaminergic, great drug. It treats nausea. It treats migraines. It calms the voices in my head. It's a wonderful drug.
I'm thinking ketamine.
That explains a lot.
Yeah, I know. Okay.
Those
I
Caspian
digress.
ketamine clinics you go to.
Okay, I'm unsure what the reason would be for looking for neonatal congenital hip dysplasia in the ED. What would that be? Does anyone have a case where this is related to the chief complaint or was relevant to an EM infant workup?
So if the child is fussy, if the parent says they're just not acting normal and stuff like that, some of the biggest mistakes we make in this type of medicine is omission, not commission. We didn't look. And it's done as a screening exam in primary care. But if somebody's bringing in a child and they're saying they're just not acting themselves, they're just not right, I'm concerned about them, or whenever I change their diaper, they're upset or they cry, that's the time to just go, oh, okay, that's not it. You know, so it's not like, a 3-month-old isn't going to come in and say, yeah, I'm having a lot of trouble going up and down stairs. That's my chief concern, right? It's just a screening exam, which screening exam means asymptomatic usually. But it's more for that, if that irritable child or that fussy child, you're looking for hair tourniquet, you're looking for corneal abrasions, check the hips. It's just on the list.
I love Rick's approach to evaluating a kid.
Undress them.
Yes, I mean, and as you go, Rick, you're saying, okay, mom, the chest, everything looks good, lungs sound clear, mom, dad, whatever.
Hips are good,
you're
ears
giving
look
them
good.
confidence.
Yeah.
Right?
And there's not a lot to them. They're like this big.
Yeah.
So
Why
undress
not
them.
do it?
They don't have a long past
And
medical
they're cute.
history. These are quick.
And
I love these exams. I love seeing kids.
It's one test. It's one test. What's the big deal? We find incidental findings all the time in the ER. How is this any different? And you could really make a difference in this kid's existence. So it's a big deal. It's not like we're ordering CAT scans and MRIs on him. So just saying. Okay. Ooh. So I saw an 8-month-old with no past medical history with a bruit. Mother reported child was cyanotic at home for approximately 45 seconds. The child looked great when I saw them. I called on Call Peds resident who evaluated the patient in the ED. They discussed the case with their attending and scheduled follow-up in 2 days. Part 2.
There's the part 2. I was like, where's part 1? Oh.
I discharged the patient. The patient came back 1 day later, cyanotic and required intubation. Who's legally responsible? Who is legally responsible?
Well, everybody will get
Everybody.
named,
Right.
Everybody will get sued.
and then they'll try to.
Then they'll narrow it.
They may apportion it. You're 40% responsible. You're 60% responsible.
Well, and I have to tell you, so I'm not quite sure all of the details of this, but anytime you, so first of all, a consultant doesn't necessarily dictate what you do. Sometimes it's hard because you really feel something needs to be done. They are the only ones that can do that, and you can't get them to do it. If you really feel strongly enough that they're not correct and you've had a reasonable discussion, you can escalate that up to the head of their, the chair of their department, or even the CMO of the hospital if you need to. That's one extreme. But the other thing is that a consultant, when it comes to something like a brew, and as long as you're all on the same page and it's documented why you did what you did, things go bad, shit happens. It doesn't mean anyone is at fault. So part of all of this is clear documentation on why it was felt it was safe to send home this 8-month-old with a brew. What criteria was used, how so shit does happen, and it makes everybody feel terrible. But the key is to, in the moment, make the most educated, thoughtful decisions that you can, informed decisions that you can, work with your consultants if there are consultants involved, where it's amicable and you come to an agreement, and then just that's what happens in life. So I'm not sure the exact circumstances of this,
but you
and
can
if
do
any error
everything.
was
You
made.
can do everything correctly, and people will have bad outcomes. That's medicine.
Absolutely.
You're in the wrong game if you think, oh, I'll just do everything right, and everybody will live, and no one will have an adverse outcome. That doesn't happen. And what you say is, you're just on good faith. You're doing the right things, and you're communicating well with your team, and you send the patient home. That happens.
Yeah.
Because the flip side of that is everybody going to get like every brew going to get a complete workup and an LP and a CT head,
right?
and that's going to just cause a lot of a swath of harm.
Well, and we have a really good, at least when they came out with the brew guideline, they finally said areas where it said, they say do nothing. They say, frankly, really, in black and white, do nothing in this particular instance. So I'm glad they finally did that, because it's nerve-wracking to hear that a kid turned blue at home or whatever, and it gives you a nice guideline. I like it.
Okay, this next question about cocaine. How young can you use cocaine for nasal work?
How young can you use cocaine? Is that the question?
Yeah. So I actually did quite a deep dive on this.
Good. Really?
I did, because I like to do that. No pun intended. So the position statement from the American Academy of Otolaryngology, Head and Neck Surgery Foundation says specifically that cocaine is a great drug. They like using it for all kinds of things, but they do not specify how young or in pediatrics. I can't find anything.
And likely it's never been studied.
Yeah.
There hasn't been a reason to. It's so low utility.
And why use cocaine?
Yeah.
There's so many better things, But it is a great drug to use for, our certain problems.
It's great for nose because it's vasoconstrictive and anesthetic.
Anesthetic, right.
But I don't know. This is going to bug me. I'm not going to sleep tonight.
So is lidocaine.
I don't have this answer. I might have.
There may not be an answer. You may have to just
Unfortunately,
let
a lot of
it go.
places
I'm
also
really
stop
bothered by it.
carrying.
I can't find an answer. So if anyone can find the answer, I'd love for you to tell me.
Bring it back after lunch,
Yeah, bring it back. Bring it back.
because it's 12:15.
Oh, shoot. Are we done?
We are done.
We're done.
Oh, can I just end with a dental block? Because I love procedures.
Go for it.
25 gauge or 27 gauge needle to do dental blocks is nice. And the tip trick clinical pearl is an 1.5-inch needle. Don't be using little short needles in that mouth. Use an 1.5-inch needle so you can get back there or down there or up there. Doesn't mean you have to insert the whole needle, but use a longer needle because it will help you get to the space more appropriately. Ultrasound guided is always best.
And I love 30 gauge. They're hard to find, but they restrict you, so you can't push it too fast, so you get less of that stuff. A 30 gauge 1.5-inch is awesome, but usually it's a 27 or a 25.
All right. Have a good lunch. We'll see you back.
See you back soon.
1:30.
Bye for now.
Bye-bye.
Bye-bye.
Life. Oh, I'm live now. Here I'm telling stories how I had to repeat grade 1. Longest 2 years of my life, grade 1. Just wasn't finger painting with the rest of them. Can I finish my mint? No, it's okay, I'm good. How many more seconds do I have? 1:29. Like to start on time. It's like that OCD, except I have CDO. Same thing as OCD, except the letters are in alphabetical order like they should be. All right. So, like I said this morning, I'm doing all sort of the joints and stuff like that, and we're working our way up the body, it appears, because now we've got hand and wrist problems. And I know people get kind of, there's a lot of bones in there, right? And they do a lot of different things. How am I possibly going to know the motor function, the sensory function, the dermatomes, the injury patterns? By the end of this lecture, you will. And if you want to step it up one notch, at Advanced Boot Camp, I give the lecture on how to do all the interesting nerve blocks. So there's only a couple of nerve blocks in here, but if you go to the Advanced Boot Camp, I show all the interesting extra advanced blocks, which is a lot of fun. All right, so hands and wrist injuries. Common. I mean, look, most of us have 2 of them, and we put them in everything, right? And we do everything with these things. Some people talk with them, right? And so our hands often get injured, and there's a lot of complex anatomy to have this sort of universal joint to be able to do everything. We're going to focus in on maybe some unfamiliar injuries that you haven't thought of or heard of before. Always remember that alcohol, Julianne, alcohol can delay the diagnosis. Oh, she's turning beet red. I love it. Can delay the diagnosis, and some people don't feel that they can get a faithful exam, a really high fidelity exam if somebody is under the influence. And sometimes you actually have to go in there and explore the wound to find out the injury. So you need to know about the hand. So the bony anatomy of the hand and wrist. Here's what I'm going to say. Name the digits. Don't number the digits. What's number 1 here in the U.S.? Right? You guys are number 1. We're number 1. But if you're in Europe, what's number 1? Right, sir. Thumbs up for you. This is number 1. How about if you're in Asia? This is number 1. So instead of putting 1, 2, 3, 4, 5, or 1, 2, 3, 4, and thumb, name them. Index, middle, ring, pinky, or baby finger. And I always remember this from the movie in the Inglourious Bastards. And even though that's outside of my common movie viewing range, which is 1980s, I always remember that scene in the French cafe. And here we are at the Paris. And they're at the French cafe. And we've got some Americans who are pretending to be Germans. And they are ordering some more drinks. Do you guys remember that scene? How many more glasses? And the American says, 3 more glasses. And the German knows he's a spy, because this is how you'd ask for 3 more glasses. Radial, thumb side. Ulna, okay, pinky side. DIP, distal interphalangeal joint, proximal phalangeal joint. Your MCPs, dorsal, volar, that kind of stuff. Name them properly so anybody else reading your note wouldn't be confused. Sensory innervations of the hand. This is pretty easy. Everybody knows this on the palmar surface is the median nerve, right? The back side of that is the radial nerve. And over on this side, on the ulnar side, is the ulnar nerve. So the sensory part of the hand is pretty easy that way. Once we get into the dermatomes, like what does C5 do? C6, C7, C8? I thought there was only 7. Yes, there's a C8, T1, T2, T3. What are the dermatomes of the upper extremity? I'm going to give you a really easy way to remember that. All right, for the motor innervation of the hand, the median nerve is British. There, now you know the motor innervation. What does the motor nerve do? What does the median do for motor function? It is British. Pretend you have a teacup. Pick it up. No, do it. No, like this is muscle memory. Thank you. Pick it up. Apposition of the digits is median nerve. Flex at the wrist. The hand here is optional. Flex at the wrist. Flex at the elbow and pronate. Oh yes, it is British. Okay, so the median nerve is British. You know all the motor function of the median nerve now. You pick up your teacup, you flex at the wrist, you flex at the elbow, you pronate. The pinky is also optional. Okay, so all of this stuff, apposition, flexing at the wrist, flexing at the elbows, pronation, not supination, pronation, is all median nerve. And then I go really easy. Radial nerve is this. Stop. Extension of these fingers here, the first thumb, index, middle. Extension of the fingers and extension of the wrist. That's radial. And then ulna is, bye-bye. Interosseous muscles. Okay, you could, do, I hope I remember this. And when you do this, these fingers go down. That's also ulnar nerve, extension of these fingers. So I remember it because of the Pope. And it's thought that the very first Pope, Peter, help me here, people, on this church, I shall establish my church. The usual, when rabbis used to speak to the temple, they would hold their hands up like this, like a Vulcan symbol, and that's where Mr. Spock got that Vulcan symbol, going like that. Used to do a blessing of the temple like that. Well, when Catholicism came in, they made the sign of the cross, but the sign of the cross is made like this, because it's thought that the first pope had an ulnar nerve injury and couldn't extend his ring finger and pinky. So, median nerve, British. Pick up the teacup, flex at the wrist, flex at the elbow, pronate. Stop! Or I'll say stop again. Radial nerve, ulnar nerve. All the motor functions. Easy breezy. Finger flexion and tendon anatomy. So what you really need to know for finger flexion is there's flexor digitorum superficialis and flexor digitorum profundus. Which does which? Here's how you know. Flexor digitorum profundus is very profound. It goes please come in. You haven't missed anything. It goes all the way to the tip of the finger. It's very profound. So flexor digitorum profundus flexes your distal interphalangeal joint right there. Flexor digitorum superficialis, it doesn't go very far. It flexes here at the proximal interphalangeal joint. So the profound flexor goes all the way to the tip, and the superficial one doesn't go very far. It's easy to remember this stuff. And there's how you do the examination, because you want to make sure both flexors are intact. Flexor digitorum profundus and flexor digitorum superficialis. And there are the basic nerve functions. Isn't it easier to learn it this way? That the median nerve is British, the ulnar nerve says stop, or the radial nerve says stop, or I'll say stop again, and the ulnar nerve is interosseous, crossing your fingers and being a pope. Done. That's what it says there. Now, there is some slight nuance. There is one pure motor branch in the upper extremity, and that is the recurrent branch of the median nerve. So the median nerve comes down through the carpal tunnel, right? Median nerve, you know what it does. But one of the things that it does is it has a recurrent branch that loops back and innervates the thenar muscle, and that allows you to do this. And if that nerve is cut through a carpal tunnel release surgery, then you lose the thenar muscle and you lose apposition. People will hold a paper not like this. If you ask them to hold a piece of paper, they'll use their ulnar nerve and hold it like this because they can't oppose. So it's called the $1 million nerve because traditionally it was $1 million payout if you could no longer do this from a medical legal standpoint. There's one pure sensory branch in the upper extremity. That is the dorsal, the back branch of the radial nerve. It bifurcates midway through the forearm. Radial nerve does this, extension of the wrist and extension of these fingers. It does this. But that dorsal branch gives sensation to the dorsal aspect of the hand. And so if you're doing a good hand exam and you go, oh yeah, the radial nerve's intact, if they're numb there, they may have cut the dorsal branch. So you see this in knife injuries, plate glass window injuries, something coming down, a crush injury here. The motor can be intact, but the sensory can be down. All right. Oh, I was going to teach you one more thing, wasn't I? Yeah, let's do the dermatomes of the upper extremity. Okay, so here's my cheerleading days. Not that I ever did cheerleading. Cheerleading days. This is C5, right, where the sergeant patch is. C5 on the deltoid. That's your sensory C5 dermatome. C6 Can you see that? Makes the number 6. This sensation is 6. Sensation along this finger, the middle finger, is C7. C8 is along this ulnar aspect of the hand, along the 5th finger, or the pinky. T1 goes along the forearm. T2 goes along the inner aspect of the bicep. T3 is the axilla. And so you can do this. 5, 6, 7, 8, T1, T2, T3. I don't know why people find this hard. It is so easy. 5, 6, 7, 8, T1, T2, T3. You usually have to go up an octave for the T3. But now you know the sensory, you know the motor, you know the complete function of the upper extremity. Easy. Who wants a list like that? Tough fractures. Okay, they're tough. Who here hasn't crushed their finger in a door or the car door or a screen door or some kind of pinching object? And you get a tuft, a break off of the tip of the finger, dropping heavy objects. It can be associated with a hematoma under the nail. If it's open, if it's an open tuft fracture, there is debate on whether or not you should start antibiotics. Okay, the evidence isn't great, but we do start antibiotics for lots of things. This is an open fracture, especially if it's on the dominant hand of somebody who uses their hand for a living, and on the thumb and index finger. You don't want those getting osteomyelitis. Less concern maybe on the non-dominant, on the pinky finger, but again, it's debatable. We don't have great evidence that it prevents infection. If it is interarticular, so it's along the articular surface into the joint, refer. Splint to protect it, and of course pain management. It hurts. We've got a lot of nerve endings in the end of our fingers. A mallet finger, an injury to the distal extensor tendon insertion. So at the top of the DIP, it pops off and you get this kind of swan neck deformity. If you get that swan neck deformity it's usually seen in a volleyball or a basketball injury where you take the ball here and it pops the distal interphalangeal joint, and you pop that extensor tendon, you just splint it in extension. Splint it in extension. They usually heal. Subungual hematomas, aren't they fun? Oh, I love going in there. Now that we have this like little pen thing that heats up and you can trephinate, and it's like, woo, and you get the puff of smoke, and they're like, I feel so wonderful. You're the best practitioner ever, right? In the old days, what did we use? Hey, you got a light? We heated up a paper clip, held it with a clamp, heated up, pushed, get it white hot, push, and finally we got that puff. So draining them. You don't need to remove the nail bed. If there's a fracture below that, plus or minus antibiotics. Nail bed repair. I don't do a lot of nail bed repairs. I don't see it having great utility. I mean, you have to take the nail off, sew it up, and then do you put the nail back on? Do you suture the nail back on? It seems like a lot of busy work. It's controversial whether you should be doing nail bed repairs, splinting, and antibiotic. Just warn the patient that they're going to have a funky nail, and it's going to be a funky nail for a long time as it grows out. And they may always have that one finger that has a funny ridge in the nail or something. Trigger fingers. Okay, so you get these trigger fingers, right? And you sometimes can palpate that little lump right there, and the finger gets stuck, and then you pop it out, and the finger gets stuck in flexion, and you pop it out. It's right there. X-rays are usually not helpful, but X-rays are done of the hand to see if there's any other kind of mechanical impediment, i.e. something bony related as opposed to a soft tissue impediment. I'm not doing steroid injections on these patients. I'm sending them off to their plastic surgeon or their hand surgeon or their orthopedic surgeon, somebody who does hands and will be doing steroid injections. The risk is infection, but you'll be clean in your technique. But the other risk is if you're injecting steroids, you can have a tendon rupture. And then they'll come back, and I know you had the medical legal talk earlier. So, how many injections have you done? Including this one? Right? And that's the one that ruptures, so it's just not something. And it's not emergent. These things have usually been triggering for a while. A felon and a paronychia, very similar types of infections. In a felon, it's the pulp space that's infected, and so you do a digital block, and then you can do an IND and antibiotics. The paronychia, you can usually just push that cuticle back with a little instrument, and you get that little pearl of pus coming out, soaking it in some salt water, taking some NSAIDs, and putting them on some antibiotics. But here's one that you may not be familiar with. Anybody familiar with a herpetic whitlow? That's herpes in your finger. I'm only knowing herpes 1, herpes 2, even though that really doesn't, you can get herpes 1, herpes type 2, both genital and oral. But this is a herpes infection of the finger, the distal tip of the finger. And how do they get this? It's usually with moms wiping little kids' faces who have a cold sore, and then they get it. Or it's people that tend bar and that are cleaning glasses. And there's a whole bunch of young people socializing, getting drunk, and have a big cold sore. And then they're washing the glasses, and they have a little nail injury there, a little minor thing. And the herpes virus gets in there, and they come in, and they're tending bar because they've got this herpetic whitlow. The thing with this is you'll see the vesicular lesions. Don't IND these. Don't release all that herpes. That's the key for this. Put them on some anticyclovir or some other Vir, so if you don't want to be on something 5 times a day, Famvir, Valcyclovir, some kind of Vir, an antiviral for this. Flexor tenosynovitis. This is something that we'll see from time to time. Usually I see it in laborers, people that have had an injury along the flexor aspect of their dominant hand usually, and it looks like a minor injury, but they get an infection in the tendon and it comes up the tendon sheath, and it can come up fast. And we call it the Evel Knievel sign. Evel Knievel, because I grew up in the 70s and 80s, if you remember Evel Knievel, and I know many of you won't. In fact, so many of the residents that train with me don't get my jokes anymore, that when they start a 1-month rotation with me in the community, I give them a USB key with 5 core content 80s movies to watch, so they get my jokes. And so if I'm running a code and I'll be doing CPR, and I'll look up and say, they're only mostly dead. And the look on their faces are like, oh my God, you're so dark, Dr. Milne. And I'm like, no, they're still mostly alive too. Like Princess Bride, inconceivable. But they don't get my joke, so I give them a USB key with 5 core content 80s movies to watch so they understand. But you can get Evel Knievel sign. This is a serious infection. This requires antibiotics, but it requires surgery. This is when you call out. I had a case the other day, and I had to call plastics, and I had to, and then, they want to see pictures, and I'm like, every time I straighten the guy's finger, he hits the ceiling. I mean, this is a lot of pain. He's in a lot of pain. Plain films look fine, right? But it's infected. He's got a Knievel sign. Of course, they ended up seeing him and took him to the OR, right, for a washout. Boxer's fractures. Okay, common injury usually associated with a nose fracture, not on the same person. All right, now, I don't know, but there is a very common history to boxer's fractures. Are you familiar with it? What is the number 1 risk factor for a boxer's fracture? Standing on the corner minding my own business. These 2 guys just jumped me, right? That's the nose injury, that's the boxer. I was just helping this little old lady across the street, and these 2 guys just out of nowhere jumped me. I was enjoying a nice Chardonnay with friends. These 2 guys just jumped me. I was minding my own business. So if you are going out in Las Vegas tonight, I encourage you to get in everybody's business. Because I have yet to see any individual come into the emergency department, yeah, I was out last night, I got in all this guy's business, I was all in his face, and then he popped me. No, everybody who comes in says, I was minding my own business. So please, if you're going out tonight, get in people's faces, get in their business. It's the safest thing to do. What do? You splint it, ulnar gutter. There's one small study in this position. There's one small study out of Australia. As long as there's no rotation, right? So when they close their fingers, they scissor because that's a rotational defect in a boxer's fracture. As long as it's in the plane of motion and you can wave goodbye. In this Australian study, they showed waving goodbye was just as effective as splinting them. Bye-bye. Now, I'm not doing that yet, but I'm entertaining it with patients saying, hey, we could just put a splint on, it's down 30 degrees, or you could just get by with a tensor. What would you like to do? But that's getting a bit ahead of the curve. The standard is to put them in an ulnar gutter, splinting like that, usually the wrist back 60 degrees and the fingers down here at 90 degrees. Ortho referral. Metacarpal fractures, yeah, people break their fingers all the time, splint them. Okay, boutonniere's deformity. This is where it slips on the extensor tendon, and it slips, so you get this funny-looking finger that looks like this. It's hard to do that with my finger, right? But it slips down the side, and you get that PIP knuckle pointing up. This needs to be splinted in an extension if you can, and an orthopedic or hand surgeon referral for the boutonniere's deformity. Proximal thumb fractures, there's two different subtypes really, Ronaldo's and Bennett's. One's more serious because it's intra-articular, but if you see a fracture in the thumb, these people need to be seen by a surgeon, they need to be immobilized. Your thumb is the most important digit you have, right? It allows all this apposition and grip, and so you need to have that repaired properly. So these are high-risk injuries. Skiers' thumbs, those are the people skiing down and they get that ulnar collateral ligament popped, right? Because the ski pole pops that thumb back. The chronic version of that is gameskeeper's thumb, because in the UK they used to keep wild game, and you know how they killed them? I'm just saying. And that would be a repetitive strain injury, and they would pop their ulnar collateral ligament eventually from breaking the necks off their game. But ski pole thumbs is more sudden, needs usually operative repair. Thumb spica is the treatment of choice to begin with, thumb spica. Carpal tunnel syndrome, you should be familiar with this. That's the sensation here, pain here, pain at night with the hand, tingling. You can do Fallon's sign where you sit there and go like this, or you can do a Tennell's test. Thank you. Yes, tapping in the back, tap, 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 tap and jazz. But a Tennell's sign is anywhere you tap. So you can have a Tennell's at your ulna. You can have a Tennell here, right? The Tennell is the tapping. But this is the classic version of tapping on the wrist and mimicking, or reproducing the symptoms that they were having. Splinting, NSAIDs, rest, refer. Okay, some subtle wrist injuries. The fouche, I don't think the fouche or fallen outstretched hand is very subtle, but the subtle injury is that occult fracture of the scaphoid that can be missed. And so you can get plain films, and plain films on a fouche injury. So somebody fouches, fall on outstretched hand, has pain on the radial aspect. 17% of fractures are picked up on plain film. That means 83% aren't. That's a lot of misses, right? So this is one of those occult injuries. So you need to have sort of a high degree of suspicion, and you don't want to miss. The scaphoid has a lot of articular surface, and it's foundational for your function of your wrist. So you don't want to miss that. They've done history taking. The history is usually fallen outstretched hand, but you can have a sudden hyperextension injury, thinking of holding your steering wheel and going, holy crap, and having a front end collision. And that can mimic a fouche injury or reproduce a fouche injury. So just be very specific. The wrist didn't get put in a hyperextended position under great force. So history, there's not enough good information to rule it in or rule out. Well, of course not. That's why we examine them. Okay, snuff box tenderness, does that rule it in? No. If they don't have snuff box tenderness, can you rule it out? No. Oh, that's why we do x-rays. Okay, we do x-rays. Can that rule it in? Yes. If you see a fracture, can it rule it out? No. And that's the error that can be made. Yep, nope, checked it out, history, x-rays. Even the x-rays are read as normal by the radiologist. These people splint. The more concerned, the more distal to the thumb you go, but splinting, immobilization, some kind of immobilization, whether it's just a back slab or a volar slab, or a commercial splint, right, to put on there, and then have them come back anywhere between 1 to 2 weeks and reassess them. Or you can get a CT scan. CT scans can miss scaphoid fractures. An MRI is the only test that has a good enough negative likelihood ratio to rule out a scaphoid fracture. But the MRI may be difficult to obtain depending on your practice location. The snuff box right here, where people used to put snuff and snuff up their nose, right here. You can just do a thumbs up on yourself and see it. Or you can do a scaphoid tubercle on the palmar side. Imaging options, yes, we went through those. Plain film, CT, MRIs are the best. Oh, yes. Does anybody notice anything odd about the one photo? Yes, it has a positive arrow sign. That's a scaphoid fracture, if they all came like that. The one on the other side is normal. No scaphoid fracture. The one with the arrow has a scaphoid fracture. There's scaphoid lunate dislocations. And so often these are missed. So 25% of the time there's a delay to diagnosing where the scaphoid and the lunate sit side by side. If you have a particular injury, that can separate them and give them a gap. Who's the gentleman on the top? You got to have to yell it because I can't hear you. Letterman, right? So it wasn't called the Letterman sign, but I called it the Letterman sign because I trained in the early 90s. Who's the guy in the bottom? Thomas. Yeah, this was the Thomas sign, right? Is that what? Yes? Terry Thomas sign, yeah. So that is a big gap in the tooth. So on x-ray, you go, hey, that doesn't look quite right. There seems to be a gaposa. It didn't come with an arrow, but there's a gaposa there. And so that was the Terry Thomas sign. I called it the David Letterman sign. Ligamentous injury. And there, it comes with a big red arrow. But it's just a gap of greater than 3 millimeters. That's a tiny amount for you inches people. Okay, 3 millimeters. All right, and you can find that. If you feel on your own wrist, right now, take your own wrist, start on the radial aspect, that's your thumb, and go towards the ulnar aspect. You should feel a ridge. Do you feel a ridge? That's called Lister's tubercle. Do you feel that? Drop forward into your hand and there should be a little hole. That's your scaphoid lunate joint. That's where you would do a wrist injection. That's how you feel for a scaphoid lunate dislocation, right there. Lister's tubercle, boom. If you feel comfortable, if 2 days is enough, reach across and feel it on your partner sitting beside you, even if you don't know them. If not, wait until day 3 to do that, okay? All right, perilunate and lunate dislocations. So perilunate is a little bit misnomed because it's really a capitate dislocation. Can you see on that image on the left-hand side of your screen, there's a half moon. That's your lunate. It's still in contact with the rest of the wrist. It's the capitate that's dislocated. I wish that they just called it a capitate dislocation, but they call it a perilunate dislocation because in relationship to the capitate, it looks dislocated, but it's actually in a normal position, the lunate. Now the one in the middle, the picture in the middle, that's the lunate dislocation. Can you see the half moon turn on its side? That's dislocated. That's how you recognize that. So look at these wrist x-rays carefully. Okay, we did the Lister's tubercle there, so you should be able to find it on yourself. I don't know if anybody's met anybody and is working on holding hands. No? Not really. Okay. You are. You've had a little liquid courage, though. Yeah. Okay, so splinting the hand in a position of comfort. You know, all these angles, whatever. It doesn't really matter. Just have it in a nice, relaxed position. Digital nerve blocks. Okay, so the sensory nerves run down either side. I teach the residents you can either go straight into the finger this way and then go up and then pull the needle back and go down. But that's a little bit of a sawing motion. And so I just go straight in from dorsal and inject and withdraw. Straight in, inject and withdraw, and I've only made one poke as opposed to going like this because there's structures in there that you don't want to sort of saw in half. Anyways, and is epinephrine safe in the tips of things? Yes. It will not fall off. None of those things will fall off if you use epinephrine. I know people are like, oh, it's not true. Transthecal, going into the palm of the hand and injecting at 45 degrees, I'm not doing this. I'm usually just able to do a digital block. It's much easier. People get really freaked out when you start putting needles into the palms of their hands. You know, so, but it can be done with a little lidocaine. And then the web space, yeah, that's a little bit easier just going in the web space. People are much more tolerant than going into the palm of their hand that way. Same sort of thing. And yeah, don't go through infected skin, okay, because you could basically have a cord instrument and inject that infection deeper. Avoid hematomas, avoid the sawing injury. Just put it in, put your bleb in, inject slowly and withdraw. Usually works really well. And that's it. I finished on time. Who's up? Who's up? Who's next? Is it me? Am I speaking again? Okay, next. If you want to take this, because I finished 2 minutes early, if you want to take this time and reach across to your neighbor and feel their Lister's tubercle right there, go radial into their Lister's tubercle and drop down. If you want to stand up and go 5, 6, 7, 8, T1, T2, T3, I will laugh at you, and Martha will take a video of you doing it. Okay, if anybody wants to do a video with me, I know that table does. You want to do it. After another one of those, there's pretty much nothing Nothing, right? We'll do another one. Yes? Will we do a video together? Okay. Are you going to come up? Okay, good. Come on up. Are you going to come up? Give her some courage, people. Come on, she's coming up. Come on, we're going to do this together. Her name's Julianne, right? Julianne, and she's from CT. That's Connecticut, I learned. The alphabet in the emergency department alphabet is A, B, C, T. You ready? Did you ever do cheerleading? Like, do you have like a background in this area?
No, unfortunately not.
So we're on equal footing here. Now, do you remember it? Okay. 5, 6, 6, 7, 6. This hand. 6.
Okay, got it.
7, 8, T1, T2, and
T3.
T3. A little higher, yeah, a little higher there. Okay, ready?
Okay, wait, no, one more time. 6.
So it's 5,
got it.
6, the number 6,
All right.
7, 8, T1, T2, T3. Okay, ready? Will you give us a 5, 6, 7, 8? C5, C6, 7, 8, T1, T2, T3. Now, she's going to videotape this next one. Are you coming out front, Martha? Here we go. Ready?
Okay, we got it.
So now this time,
5, 6, 7, 8.
now we're just going to go 5, 6, 7, 8, T1. Okay, ready? Face Martha. Ready? Here we go. Ready?
Yes.
5, 6, 7, 8, T1, T2, T3. Give her a big round. Now I owe her a drink.
So I expect you all to do that tonight,
Yeah.
especially after a couple
out
a couple of drinks, and it'll be all good. All right, so we're going to switch the schedule up a smidgen here. We're going to switch down to electrolytes. I think I have the wonky microphone here. Okay, so electrolyte disorders. Let's talk about sort of the main stuff that comes to us. Now remember, a lot of the details of this, the really truly nuanced bits and pieces of this, people literally spend entire internal medicine residencies and then nephrology fellowships to learn about. Our job is to do the fun part of basically all this stuff. We got the fun part of endocrine, we now get to do the fun part of electrolyte disorders. But these are really important to have some basic concepts about that are just crucial. So, these are the electrolytes. We know that it's basically sodium and potassium, calcium are the ones we deal with the most. We also have magnesium we need to talk about. We talked a little bit about chloride earlier today, but these are the ones that we get back that we have to figure out what to do with in the emergency department. I'm going to start with the salt stuff. So we're going to start with the salty issues, the natremias, the ones that go up and the ones that go down. So I'm going to start first with a concept, though, that is really, really important, and that is to do no harm. It is vitally important not to ever treat a number. You treat the patient first. And that is really crucial. Sometimes the numbers are wrong. Sometimes it's an error in the lab. Sometimes there's just something that's wonky that isn't the patient. You guys, is this mic? Okay, sorry. I don't know what's up with this microphone. But anyway, the key here is to basically treat the patient, not the number. So that is absolutely vital. So if somebody calls back with a sodium of 120, and there's just no reason to think the person has a sodium, maybe it was the blood was drawn above a line that's actually diluting the blood. So just know, treat the patient, not the number. Really important. The other thing to know about electrolyte problems is that fast versus slow matters. So someone who develops an abnormal sort of a sodium level, for instance, over a matter of days to weeks, it's very different than somebody who develops that abnormality over a matter of hours. For instance, hyponatremia in a baby that's given free water as a fluid replacement versus somebody who develops this over days and days and days from something like a diuretic. So remember, it's really important. Don't treat the number, treat the patient, and fast versus slow matters. So let's start with the high salt stuff. Let's start with hypernatremia, so the high salt stuff. Too much salt. It's defined as a number of basically 145 or higher. Oh, by the way, in your handouts are these picture slides, because I got kind of bored with all those word slides. The word slides are in there. They're the last two in hypernatremia to summarize it all on the last two. But I think these are more fun to teach with, so that's why these picture slides. You guys, is there any way to fix this? Sorry, hang on. Okay, got it. We'll keep going. So a sodium over 145 is hypernatremia. That's what defines this. But I'll tell you, the way you get there, to get to a sodium over 145, is too little water, not too much salt. You cannot eat enough soy sauce on the planet to get yourself hypernatremic. You will end up drinking fluids. I mean, think about it. You have soy sauce for lunch and you're thirsty by 1:30 and you're drinking lots of water. You hardly ever can get super high from taking in too much salt. It's almost always because you are too dry. There is a condition, though, where you end up with diabetes insipidus, which is basically too much, basically too much water out of your body, so too much salt in your body. Hang on a sec. Full swap? Okay, sorry. I have to take my clothes off to do this. All right, here we go. I'm going to see if I can just throw this behind me, not completely ruin my clothing, or strip up here. All right, let's go back to high sodium, salty people. So diabetes insipidus is one of the things where you pee out too much water, you can end up too much salt that way. But the reality is most people who come into the emergency department who are hypernatremic are there because they got too dry. Okay, and so think about the kinds of people who would get too dry, and I'll explain the kinds of patients that you see with hypernatremia. It is also almost always chronic. So know that hypernatremia is really hard to get acutely. It's really hard to have this happen just all of a sudden. So it's hard to get the thing acutely. So it takes a while to get there, meaning fast versus slow matters. You don't necessarily need to reverse hypernatremia quickly, fix it quickly, because you can cause some harm with that. Important. So you think about the fact if it's not enough water, people haven't had enough to drink, if that's why they're getting hypernatremia, it tends to be the very old and the very young that have trouble with hypernatremia. So that's the group of people that will come in. You see this is the nursing home patient that for some reason just didn't get enough water over time and ended up super hypernatremic. So no, that's the groups that present, and the way they present is with an altered mental status usually. So the person from the nursing home who comes in looking really dry, like just a little raisin kind of person, really super dry and altered, but I will tell you that they didn't get there today. They tipped over into altered mental status today. But they didn't get to this number all by themselves today. It didn't happen all of a sudden, which is important because you do not want to reverse this thing too quickly. So this idea of acute hypernatremia is almost impossible. It's almost always chronic. And just keep that in mind, even if somebody tipped over their mental status today. This morning they were a little confused. This afternoon they're hard to arouse. That's just the fact they finally crossed the threshold where their brain couldn't stand that much salt anymore. So this idea of acute renal failure or acute hypernatremia is uncommon. Just know that. It's uncommon. And if the person is awake and alert and hypernatremic, always start with drinking fluid if they can. So have them start with drinking fluids if that's possible. So if they're awake and alert enough, have them drink fluid. That will dilute them down. And your body knows when it's thirsty. It knows when it needs water. So know that hypernatremia is something that people can drink to treat if they're awake and alert on their own. If it is truly acute, if you think it's acute, I'm sorry, this thing is like brushing on my lip. Hang on a sec. Okay, if you think this thing is acute, make sure it's really acute. Go back and find out for sure. Go back and find out if this really was something that there's some reason they went into diabetes insipidus suddenly. It's just not common. Because I'll tell you the treatment if you need to do this is that make sure if it's really acute and that the patient is really sick. Warrants something that's going to be relatively uncommon to do, in fact, very uncommon to do, which is to treat them with a significant amount of D5W, water, free water. We fix hypernatremia with free water. So, and this, I will tell you, I don't think I have ever in my life done this in 30 plus years of treatment, done this particular treatment, given this much D5W, because frankly, hypernatremia is very rare that it is ever acute that needs that aggressive of therapy. The reason, by the way, we even worry about this, why not just give them water? What the heck? Your body over time gets used to having a really salty plasma. It's get used to having high sodium, and your brain adjusts to this, to not having lots of fluids around. You now give extra fluid. Your brain is now also hypernatremic. Everything is. It gets all kind of dry. Well, now it's like having a sponge that you add water to, and it expands. Your brain can get edematous if you give too much water too fast. It's used to having this kind of super salty environment. So you run the risk of people getting cerebral edema, which is why we don't go super crazy with correcting people. We are very careful with correcting people. Usually it is a chronic problem. So if the patient is, basically is sick enough to warrant something, that's fine, go ahead and treat them. But most of the time they're not super sick. Even if they're altered, they're not super sick. And you can go slower. This is not going wacko with D5W. What you want to do, your goal here is to basically get that sodium altered by a predictable amount, about 10 milliequivalents per liter over a 24-hour time period. So you don't want to go crazy making their numbers normal. You don't want them to go from 165 down to 140 in a 24-hour time period. You run the risk of getting the brain edematous there. You go slowly. You can do this with D5W. This is the recommended sort of dosing that you do, and get MD Calc out for this. Don't calculate it on the back of a piece of paper. Get out MD Calc, put in all the sort of the numbers that they need in there, and they'll tell you how much to give per hour to get somebody basically their hypernatremia treated with D5W. Now, I'm going to take a little step aside with this as well, because you can use, if you use normal saline is 154 milliequivalents per liter. If your patient is 165 milliequivalents per liter, if you treat them with just normal saline, you're already giving them a little bit of hyponatremic fluid as it is compared to them. So frequently what we'll end up doing is somebody looks super, super dry. They come in hypernatremic. They need to be tanked up some because they're dry as a bone. You can give some normal saline. That's actually fine. The key is to know, though, that once you hit 154, you're not going to be fixing anything at all. So this is well worth taking the time to get away from our usual just bolus a dry person and get a little more sophisticated with hypernatremia and go look at MD Calc and calculate the D5W amount that you might need to give to get them down to something in a normaler range, slowly and carefully. And what you're going to follow with this, by the way, you can send urine electrolytes and serum electrolytes to follow, but the thing you're going to follow most is mental status. If somebody's mental status, they go from confused or altered when they get there, and now within 2 or 3 hours of tanking up a little bit with IV fluids and maybe giving them a little bit of D5W, they wake up. Now you chill. There is no hurry to getting them back to normal. Just be careful. Treat the patient, not the number. You're not going to go completely nuts getting somebody down to a normal number. You're going to take it slow to get them there. And there's really, frankly, with hypernatremia, rarely is it acute and enough that you need to give lots of D5W. You don't. It's very carefully done. Titrated, done. Absolutely fine. Dispoing somebody who's hypernatremic. Basically, if they're hypernatremic, you usually admit and observe them because, again, they took a while to get there. You need to, as you get them down to a normal sodium level, you need to watch them to make sure that we have an overshot and get their brain edematous. So we just watch them carefully. So we just watch them, it's fine. So the summary of this is it's almost always chronic. I will tell you, it is so rare for this thing to be acute. Rarely, if ever, do you need to aggressively reverse this. You don't. You basically treat to mental status improvement. Oral first if they can. They will drink what they need. So go ahead and give them oral to start and do your calculations kind of in the background. Calculate that free water deficit so you know kind of how much we're aiming for. And the fluid is D5W if you really need to get them really corrected over time. And you're going to do that carefully and slowly. And the summary slides of these are these last two if you just want it in 2 slides alone. I'll tell you, we don't see this that much that requires us to do anything significant about, but what we do spend a lot of time on is hyponatremia, and we should. It is really, really common, and it's actually a little bit complicated, at least if you're a nephrologist or an internist. But for what we need to know, it's actually not that complicated. It's actually, there's like the hypovolemic, hypervolemic, is it pseudo, it's like, oh my gosh, it is actually not that complicated. So let's start with this. Let's start with a low sodium. So we have the lab that calls us with a low sodium. So now we know for sure somebody's sodium is, say, 120. The very first thing you always do, and I mentioned this earlier today in the endocrine talk, step one is always to look for this, whether it's a pseudo-hyponatremia or not. Is there something in there that's making it look like the sodium's 120, but it's not? And the most common thing here is sugar. Check the sugar. We talked this morning about how to correct for somebody who has a high sugar, how to correct the sodium. You correct the sodium by using the formula that is actually in your MD Calc, easy to remember though, but this is, just look it up. This is, so you get that sodium of 120, your eyeballs instantly go to the glucose. Step number one, instantly eyeballs to glucose. If that glucose is normal, oh well, that sodium is really real. If that glucose is high, calculate out what that contribution of that high glucose is to this. Correct it. And see, correct it. Is it still really hyponatremic? You may find it's not. Somebody comes down with a sodium of 129, but their sugar is 660. You correct that. That actually is a sodium that's normal when it's corrected. You don't have to do anything about that. You just address the sugar problem there. That's what we're going to focus on. So first thing always with a low sodium is to check the sugar. There are other things that can also drop it kind of falsely with this, by the way, which are things like elevated lipids. People have super high triglyceride, for instance. People have some things like the multiple myelomas and kind of things can do it. But in general, it is the majority of the time, it's a high glucose. So that's step number one. See if it's pseudo. See if there's something else that's causing this, and actually it really isn't once it's corrected. It isn't hyponatremia. If it's still low, though, you've done that. It's still low. You've already calculated that. It's already still low. Now you go back to the patient, and you see what their symptoms are. So again, remember, the patient is always the most important thing, not the number. So you're going to go back to the patient. If you see the patient, and they're seizing or comatose, like this is, okay, this is a sick person. Remember, it may not be from the sodium. Check and see if there's another cause. Are they seizing because they're off their Keppra? They're seizing because they have a head injury. Is there some other reason that they're seizing? And if there is, fix that. But if you've looked for the other cause, you've either thought about it and just done it through history and physical, or you've actually done a workup in an altered person. They're getting their scan while their labs are drawn. The lab calls with the sodium of 116. The patient's in the scanner looking for that head bonk problem. Well, if the scanner is negative and that 116 is all that's left, now you need to treat that. So now we're going to go back. If there are no other causes, now that sodium is the answer. That sodium is the reason that they're so sick. If someone is really sick from hyponatremia, this is the comatose seizing person, do not hesitate to grab 3% normal sodium chloride. 3%, it's not normal, it's 3%. That's 513 milliequivalents per liter. So that's a lot. And you're going to give them a treatment of this. And what you're going to give, you're going to start with 100 milligrams, or 100 milliliters, 100 cc bolus. Start with that. So seizing comatose, low sodium, no other reason for it. Grab the 3%, ask for 100 cc's to be delivered as a bolus. Now, while that's happening, you're going to go back for a second. And you're going to find out if this seizing stuff is something that came on. Did somebody get this sort of hyponatremia over a matter of just 48 hours or 24 hours? And I'll tell you the group of that's those babies. That's the babies who are febrile and who are getting their fluid replacement with pure water. Or where I work, it's dilute tea. It's just something that our local community sort of culture is to use dilute tea to rehydrate their babies. Well, the problem is that's pure water. So these kids got hyponatremic really fast. So I know that this baby was fine yesterday. They're getting free water now at home. They're seizing. I can fix that completely right now. So I can go ahead and fully treat them with 3 doses. If not, though, if this has been coming on over a while, start with just that single 300 cc bolus and then kind of hang out and see. What will happen is you're going to watch their mental status. And what you're aiming for is their mental status to improve. If they stop seizing after that 100 cc's, now you just take a deep breath and you step back and you say, okay, now we can think about this. Let's figure out why they're there. What's the reason they're hyponatremic? You can slow it down a little bit. So if it comes on slower, you just watch their mental status and back yourself off once they start to improve. So rules of thumb here, the reason here you're going to do this, and this is actually really important. Your temptation may be, I'm just going to fix, my gosh, they're seizing because their sodium is low. I'm just going to fix it and put it all back to normal, which would be lovely, except if you do that, it's not going to cause problems with the patient today. It's going to cause problems upstairs tomorrow when they get a condition called central pontine myelinolysis, which if you have ever seen a patient who has this, it's devastating. It causes a locked-in syndrome. They end up awake and alert, and they basically get myelinolysis, and they frequently end up locked in. Can't move, can't talk, can't do anything, but they are in there and they're thinking. You don't want that to happen tomorrow. You won't know that. It's happening upstairs tomorrow because you've corrected them too quickly. So certainly stop the seizure, but don't go to correcting them to completely normal quickly. Just get their neurostatus better. That's your goal, is to get your neurostatus better. Your maximum amount of correction should be 8 to 12 in that first 24 hours, 8 to 12 milliequivalents improvement. And you actually you rarely need to go even that much. What you really want is them to, often it's just a matter of 4, 5, 6 milliequivalents up, and then their seizures stop, or their mental status improves, and you slow it down, and then take your time to bring it all the way up. Your goal is either symptom improvement or a sodium of about 120 to 122. Why that? Because someone's mental status should be improved, if not normal, with a sodium of 120. If they're not, you need to step back and reassess the situation. Are you missing something completely? Think about it. You've seen people with sodiums in the low 120s that are basically at home on the hydrochlorothiazide, and they've gotten there over time. They should have their mental status improve at that point. And if they are not improving at sort of the 120 to 122 range, rethink it. Rethink what's going on with that person. Now, if you're in internal medicine and you have somebody who's hyponatremic, they sit down and spend hours and hours and hours of time, God bless them, but it's fun, it's interesting, talking about, well, what's the FeNA? And what's the urine sodium? And they ask you what the FeNA is, and have you calculated the FeNA? And frankly, as an internist back in the day, it was fun. I loved calculating, it was fun. As an emergency person, it's like, are you kidding me? I don't really care. I don't need to know those numbers to know why they have hyponatremia, because as an emergency person, what I do is I look at the patient's clinical history and I have them right in front of me and I can examine them. So if I know if somebody has too much volume on board because they're edematous all over the place, I know that. I can see that. I know if somebody's dehydrated because I'm looking at that. I don't need a FeNA to tell me that. I can do that clinically. So I know that there are people who have hypovolemic hyponatremia. And the way they get there is they either have extrarenal losses, like they're vomiting a lot or they have diarrhea, or they have renal losses, like diuretics that we give people, right? That's that, and they're dry. So they have hyponatremia and they're dry. Or I know people that clinically look euvolemic. Their volume status looks just fine, but they're hyponatremic. That group tends to be the group that's SIADH, or somebody who has polydipsia. They dilute themselves down by drinking too much fluid, like that baby, right? That baby would have a normal fluid status. I also know the ones that basically have too much fluid on board, the CHFers, the cirrhotics, the people who have renal failure. So you can clinically, we spend so much time, it's like, what's the FeNA, and what's the urine sodium, and what's the ratio, and this and that. The reality is, you clinically put them in the right box 99.9% of the time. So use your clinical judgment. You already know. You don't have to do all that fancy schmancy calc. It's fun, but you don't have to. So if somebody isn't seizing or comatose, so if you're looking at their symptoms and they're not seizing or comatose, they're basically otherwise fine. In fact, they maybe just an incidental lab finding if they find it's low. Now your job is to put them in one of those three categories. Are they too much, too little, or just right water in their bodies? So we know they're hyponatremic. Just use your clinical judgment for volume status, and then it's logical what you do after that. If somebody has too much fluid in their body and they're hyponatremic, restrict their fluid. So you restrict their fluid intake. You might give loop diuretics to help get rid of some of the fluid status as well, but fluid restriction is the treatment for that. Same thing for somebody who basically has if somebody has too little blood volume, or not blood volume, too little fluid volume, so they're hypovolemic. That's the person who's dehydrated because we've given them diuretics forever, or we've diuresed them like crazy. You go ahead and tank that person up with some isotonic saline. It's fine. Be careful. Don't overshoot. Fill their tank a little bit because they're dry, and then give them potassium if they need to, and just watch them. They're fine. The person whose body fluids are fine, so they're euvolemic, that's the person who has lung cancer and SIADH. That's the person who is surreptitiously drinking too much water, or the person who read somewhere that drinking 64 glasses of water a day was good for them instead of at 64 ounces of water a day, which I've seen one of those. They read it as 64 glasses instead of 64 ounces and got themselves hyponatremic really quickly. So it's logical. So don't let anybody get you freaked out about this idea of hyponatremia. It is very straightforward. You have clinical judgment to get there. It's super easy. Now, dispoing these folks, what do you do with dispoing somebody who's hyponatremic? If they're sick on presentation, they stay. If their sodium's less than 120, they stay. It just takes too long to safely get it up. Okay, and any other indication, of course, they stay. If you're going to admit them, then go ahead and send all those things like the urine sodium and get the urine osms and all the serum osms and all the stuff that helps them determine what's wrong with the patient more nuanced than we might and what to do long term. So that's all cool. You don't need it, though, to make your decisions. And then if somebody has a sodium of less than 125 but more than 120, you can usually OBS that person. Usually that person is somebody who's either a CHFer that's gotten a little bit out of control and there's too much fluid on board, or somebody who's taking too much diuretic, and you just need to kind of tweak it a little bit. And usually an OBS stay is plenty for that one. Everybody else can go home. Your sodium of 130, they can go home. That's fine. It's like, figure out why you think they're there so they don't go home and get worse, but that's fine. So here's 2 slides that summarize that as well, if you want it in the 2-slide version, but I think that's the easiest approach to this. Now, potassium. Potassium is the other thing we see a ton of, and this is something that we must know how to treat, and this is bread and butter emergency medicine. The thing about hyperkalemia is that people may not know they're hyperkalemic and frequently don't know until something goes really wrong. The symptoms they get are vague. They have fatigue, they have weakness, they just don't feel very good, and then all of a sudden their heart says, really don't like all this potassium, not at all, I'm gonna do something. One of the things, they can have sudden dysrhythmias, they can have progressive dysrhythmias, and that initial EKG is really important. The minute that you think somebody has hyperkalemia, or you get a phone call from the lab that they're hyperkalemic, order that EKG, order it. You care about what that potassium is doing to the heart. That is what is going to guide your therapy. We use potassium in putting down your dog. You know, they use potassium boluses. Your heart does not like a bolus of potassium. It doesn't like it around high levels either. So your heart gets really irritable. Your EKG is what we use to determine what we're going to do about this. Now, the other thing to know is there is a progression of what we think about on the EKG, and we'll talk about that. I'll show a picture next, but there's this progression of things that happens. Anywhere in that progression of things, someone can develop sinus brady, just bradycardia. So I'll tell you, you will be an all-star when they send in somebody who's feeling lightheaded and syncopal at the dialysis center, who is found to have a heart rate of 40 or 30, and they're going to send the patient to you. Because you are going to know that the very first test you're going to do is to check a potassium in that dialysis patient and see if it's high to treat that dysrhythmia, that bradycardia. Isolated bradycardia may be the only rhythm you see in somebody who is hyperkalemic, really important. And the most common causes we see of this hyperkalemia is renal failure, flat out most common. But the second most common are the drugs that we use, like ACE inhibitors. ACE inhibitors, I tell you, the prills are big causes of people being hyperkalemic. So look at their meds list, see if, I had a patient that was taking both, got the generic version and the trade name version of the same drug, so I had a double dose of a drug, didn't know that, so ended up taking twice as much, ended up hyperkalemic. Just know these are the drugs that can cause them to be high, and renal failure is the most common cause. So we think of what happens to that EKG is, I think of it as taking a string. So if I take a string and I squish it, so an EKG, and make it a string, so it's my EKG thing, it's like a string. If I first squish it together, as my potassium's going up, I'm going to push the ends together, and what will happen is my T wave will pop up. Push it together, my T wave pops up. Okay, well, that's the first thing that changes. I get this peak T, and it's peaked. It's actually it's way more peaked even than that usually. It's one of those things where it's like, oh, that looks like hyperkalemia. Then what will happen is you start to pull that string apart. You take the ends of that EKG strip, and you start to pull them apart. That T wave will now come down. It's not so peaked anymore. Your PR will increase. That gets bigger. Your P wave eventually gets pulled flat, and then as you pull further, you get the sine wave. Your QRS widens, and eventually you get a sine wave. So I think of it that way to remember, and remember anywhere in there, from peak T wave to pre-sine wave, you can end up having a bradycardia. So that may be all you, in fact, may be all you get. You may not get any of the other changes at all. So remember that, and you'll be an all-star. Treating it is really important. So again, remember, again, this is where you're treating the patient, not the number, because you're treating the EKG for that patient, not the number. So remember that this can be falsely elevated too with hemolysis. So if the EKG looks absolutely stone cold normal and somebody has a potassium of 7, go back and look and see how that specimen was collected. Did it sit around for a while where it ended up the cells broke down and they ended up with a high K on that reason? So be careful with that. If it's not making sense, trust the EKG and trust the patient in front of you much more than the number itself. Trust that EKG. Because your EKG should change when your potassium hits about 6.5. And at about 6.5, your P wave goes away. Your PR will increase a little bit before that. Your peak T can be peak T at a potassium of 5.5 or higher. We really worry when that P wave gets involved. The PR lengthens and that P wave disappears. So any bradycardia, Disappearing P wave, widened QRS, and absolutely, of course, sine wave, we absolutely treat. Those are the indications. Just a peak T wave alone doesn't necessarily mean you need to treat it. You need to address why their T is up, why their K is up, but you don't have to treat that necessarily. So the EKG will guide your treatment. And the treatment of choice is to give the heart something it prefers to use rather than being irritated by that potassium. And what you're going to give them is calcium. The calcium actually uses a backdoor way of getting into the heart when the potassium is high, where the heart will say, thank goodness, I'm so glad I have this. You can use either kind of calcium. Just know that calcium gluconate has only 1/3 the amount of calcium in it than calcium chloride. So if you are in a panic moment, the patient's heart rate is 20, their blood pressure is down, they've got their dialysis shunt, you do a point of care test and their potassium is 8.5, turn to the crash cart, grab the calcium chloride, and give that. Absolutely fine. Just make sure your line is good. If it extravasates, it can cause necrosis of the skin. Make sure your line is good. But any degree of calcium is fine. And what is so cool about this, and you've all been there, you watch the EKG, their P wave is gone, or their bradycardic is like, oh my gosh, you push that calcium and literally watch on the monitor the heart get back to normal. Literally watch it happen. So exciting to watch. Works like a charm. Absolutely works like a charm. That is the treatment of choice. You can use shifters as well. So that's basically fixing the heart. Now we go out to the fact there's too much potassium out there. So we use shifters. We use glucose and insulin. Okay, that's what we do. And remember, insulin we talked about with DKA. You give somebody insulin, you drive potassium into cells. We do that on purpose. If their sugar's already high, you don't need to give glucose. If their sugar's normal, give glucose because you're giving them some insulin. But be careful with older people. Use a half dose of the insulin with especially thin little older people because 10 units of insulin may drop their sugar through the floor. So just be a little bit careful with those. Watch for hypoglycemia. Bicarb, that was used to be part of the knee jerk, give the cocktail. Part of the cocktail was bicarb, but it only works if you're acidotic. So it will work to bring your potassium down if you're already acidotic. If you're not, it doesn't do a thing. It doesn't do a thing. So don't expect bicarb to be the answer here. Don't expect that. But what can work beautifully are inhaled adrenergics. So get somebody on an albuterol nebs. That also drives potassium into cells. So I'm doing it by inhaling. I'm doing it by giving them something in their IV. I've taken care of their heart by helping with calcium. I've got something in their IV to help kind of shift that potassium into cells. I'm having them breathe something to shift that potassium into cells. Those last things are temporary. They last half an hour, maybe an hour max, an hour tops. I need to get that potassium out of their system. Now, there are ways to do that that are very effective and ways to do that are less effective. We used to use Kexlate all the time. That is no longer used. It is actually not recommended, and there are other things to consider. The reason it's not recommended is it doesn't work very well, and it can actually, particularly in people who have renal failure, renal transplants in particular, it can cause them to have necrosis of the bowel. It's just bad. It's just bad. So that turns out not to work very well. The other two things on here, the Valtessa and Lokelma, I'm not supposed to use trade names, but they're easier. We often will order that in the ER, but I will tell you, it's buying you nothing. What that's buying is the nephrologist feeling like they're feeling better for coming in the next day. They take a long time to work. They don't work right now. In the meantime, you may have to retreat that potassium as it comes back out of the cells. This takes a while to work and they're expensive. If somebody really has hypernatremia and or hyperkalemia and there's no other way to get it out of their system, dialysis is the way to go. And if it's a dialysis patient who is hyperkalemic, they absolutely need dialysis. That's what they're getting their dialysis for in the first place. So hyperkalemia treatment, it is bread and butter stuff. The main thing that I'd like you to take home is remember that bradycardia isolated may be your only cardiac indication that they have hyperkalemia. Now, hypokalemia is usually something we do to people. We give them diuretics, and so they end up peeing out potassium, and if we haven't replaced that or watched it, they pee it out. And these people come in weak. You need potassium for normal muscle function. So they come in weak. So they come in feeling, and they may be constipated. They may feel palpitations, because you can get PVCs from somebody who has hyponatremia. They may have polyuria. They just don't feel good. They just don't feel good. They feel weak. And these are the people where the potassium comes back at like 2.2, and it's like, oh, that's why you're not feeling so good. In cases that are basically diuretic induced, that we cause these things, you need to replace that potassium. But I will tell you, the only way it's going to stay in there is to also give them magnesium. Potassium and magnesium live together. So this synapse I want you to leave this conference with is low potassium, I need to fix it, give potassium. I also need to give magnesium. They have to go together. Otherwise, you'll find you have cases like this where you've given, it's like, gosh, I've just given them oral potassium 3 doses. I give them a dose IV. It's not budging their potassium. Why is that? Well, it's because they need to have the magnesium on board as well. So get them magnesium as well. So treat the cause if you can. Take them off the diuretic if they're diuretic, if they've got a lot of diarrhea, get them slowed down, etc. And know that total body deficits of potassium when it's low their deficits are usually 300 milliequivalents. That's a lot. 300 is the mean. They may end up with higher or lower, so it could be even more than that. But 300 milliequivalents is kind of where they need to get back to a normal body repletion of this thing. So go ahead and oral replacement is fine. It's beautifully absorbed orally. It just is a little corrosive. So go ahead and give it to them orally. That's absolutely fine. And then if you really need to give IV, you can. Just be careful giving it peripherally. It hurts like a son of a gun. You can go as high as 20 milliequivalents, but be careful as far as giving this peripherally. It's fine to do, but just be careful giving more than 20 milliequivalents an hour. And remember, give MAG. You can either give it IV or orally. It doesn't have to be. It's very well absorbed. You can give it orally as well. Here's some EKGs just for sort of review's sake. Calcium, I'm going to spend the last 2 electrolytes in about 2 minutes or so. We're going to talk about calcium. Hypercalcemia, we tend to see in cancer patients. So this is a cancer problem. We see this in cancer patients. Hyperparathyroidism is lovely if people have it. It's a fixable thing, but usually it's cancer. It's breast, lung, prostate, myeloma are the big ones, because the thyroid as well. They're the big ones that cause people to have hypercalcemia. And the thing about this, people don't usually get symptomatic until their calcium is pretty high, about 14. And the symptoms they get are very kind of nonspecific. They're constipated. They have lethargy. They're vomiting. They may be a little bit confused. They're super dry. They have, decreased reflexes. They're thirsty. Think about it. People with cancer, especially if they're on an opioid, those kinds of symptoms are often things they have that we blow off to their cancer or to their cancer sort of treatments. This may be calcium. So look at somebody's calcium if they're a cancer patient coming in with these vague kinds of symptoms. This is that sort of bones, stones, groans, and what are toxic moans kinds of things. This is the remembering the end organs of these. The other thing that they do is they get a short QT. So if somebody hands you a rhythm strip or an EKG and the QT is like, whoa, that is really short. What is happening? That T wave is right after the QRS. Worry that person has a high calcium. Go back and check out and see what's going on with that person. We treat this, by the way, with IV fluids. So you basically give them, they're dry, treat them with IV fluids. They will start to pee out the calcium, and often will drop it enough to make it not an emergency kind of situation at all that can get dealt with upstairs. It can get dealt with by their primary care doc or their oncologist that can deal with this thing. So rehydration is first and foremost. Rehydration is key. After they're fully rehydrated, then things like loop diuretics can be used. But frankly, your first thing to think about is to just get them hydrated up. And they're dry already. You would have already thought about it, just clinically. Give them some fluids for this. There are other things to do that, frankly, in the emergency department, they're here for your interest, but we hardly ever do. Really, hydration is the main thing that we do with hypercalcemia. Hypocalcemia, though, is a renal failure problem. This is something we see in people with renal failure. They get hypo-K, hyperphos. That's what they are, hypocalcium, hyperphos. They get this all the time, that combination. Renal failure is the biggest reason people are hypocalcemic. They present with symptoms that are, the mnemonic is cats go numb. They can seize, but they often don't get full seizures. They often get myotonic jerking. Or when you tap, this is that Chvostek sign, or the signs where the Trousseau sign, where the muscle ends up getting tetanic because you have decreased perfusion to the area by using a blood pressure cuff. These symptoms are the things that they will come in with that will clue you to what they have. The way we fix this, by the way, most of these are mild. You don't need to do anything for them, but you also need to know if this is acute or chronic. Most of the time, we don't have to do anything except back off, get the nephrologist involved, because it's usually renal failure, and leave them alone. We hardly ever have to, if they truly are having full-on seizures, then you can go ahead and treat it with calcium, usually gluconate in this situation. But if they're not full-on seizing, then just leave it alone, because they'll fiddle with their dialysis settings. That's what they usually fix this with, and you don't need to make it worse. The magnesium is the last thing, and I'm just going to spend 2 or 3 quick slides on this, because magnesium is kind of, nobody gives it respect. It's sitting in your tissues. It's not sitting in your blood. You usually have plenty of magnesium in your body. The problem is, for your body to use it well for shifting electrolytes, is it needs to be in your periphery some. So hypomagnesemia, which is, we see it in certain people, that's what we measure as hypomagnesemia, is really important, mainly if you have to worry about somebody who has hypokalemia as well. These don't really assess whether somebody has magnesium deplete total body because they have it all over the place in their body. We rarely, if anything, need to do anything with this. Just watch it. Rarely do you need to do anything. Treatment, if you need to, can be oral. Hypermagnesemia we see in renal failure. That's really the only time we see this. It's really, your body gets rid of magnesium just fine. It's renal failure where we have the problem here. So we rarely do anything with magnesium. Leave magnesium alone. Potassium you have to get absolutely flatly good at. No hyperkalemia cold. Hypokalemia, remember if you need to replace it, you need magnesium with it. Hypercalcemia, think about it in cancer patients that are coming with vague symptoms. Look at that lab on purpose just so you'll pick it up, otherwise you'll miss it. Hypocalcemia is something that the nephrologists tend to take care of. We don't need to do anything. And the natremia is just remember, treat the patient, not the number. Really key to do. And you can figure out hyponatremia on your own, clinically, no problem. All right, we have buzzed through all of that. So I'm gonna bring Jan up. Thanks a lot.
All right. Hi, everybody. I love that electrolyte stuff. Diane, you're such a pro at explaining it. Takes a while to get it, but I agree with your statements about hyper-K is definitely something we do all the time. Okay, so we're going to flip back in your book to 251, and we're going to do a flyover of a bunch of different environmental disorders. So we're going to talk about things like hypothermia and hyperthermia and electrical injuries and bites and stings and things like that. This is a real potpourri. And what's interesting about this sort of area of medicine is that before, emergency medicine is one of the newest specialties, relatively speaking, to the big specialties of medicine and surgery and the house of medicine. We're relatively new. And when we kind of came along, we sort of took over a lot of these topics. Who really owned hypothermia, hyperthermia, bites, stings? Nobody really owned it, and we kind of took it on and owned it. And so now a lot of the research and interest in these areas really falls underneath the umbrella of emergency medicine, because these are the kind of things that we see all the time in the ED. Now, some of you might live in places where you deal with high altitude illness a lot, or you live places where hypothermia is super common, and so you may be local real experts at this and know a lot more about it than what we're going to present here. But this is sort of a general overview of a lot of these environmental conditions. So we'll start with altitude illness. Altitude illness is really interesting. If you think about why people get sick as they go up to altitude, clearly it's due to the relative hypoxia that you experience as you ascend from, your mountain sea level to going up into the mountains there. And what that does as the O2 concentration in your body drops, and it's relatively hypoxic, is it increases your sympathetic drive, and that can lead to a little bit of leakage over time, specifically in terms of what's most important in your brain and in your lungs. Interestingly, being in good shape is not protective from altitude illness. So that is not something that's going to necessarily protect you from having these syndromes. It can really happen in anyone. And as you look up the scale, you can see that on our planet we've got some pretty high places that people go. And you can acclimate to this for sure, but as you travel to these places, you certainly are at risk for getting sick. Now, acute mountain sickness kind of starts around 8,000 feet. That's not like a hard number. It's a little bit variable from person to person, but around there, you get up to altitude, you get off the plane and you're up high, and some people, interestingly enough, really don't experience much in the way of symptoms, but other people start not feeling well. And acute mountain sickness feels kind of like a hangover. You got a little bit of a headache, you're kind of like a little nauseous, you're like a little tired, you can't sleep very well because your breathing's a little changed from this relative hypoxia. And if you drink while you're at altitude or take any kind of sedatives, it can make it a little bit worse. But it's certainly not life-threatening. It's just you don't feel so good, and it will go away if you give it time and give your body the chance to acclimate. You can actually prevent acute mountain sickness by taking acetazolamide, which is a diuretic, and it happens to shift things around. It causes a metabolic acidosis, which then generates this compensatory respiratory alkalosis, which means you breathe a little faster, and that helps offset the relative hypoxia. So if you know you're someone who gets acute mountain sickness pretty reliably as you go up to altitude, this is something you can do to kind of prophylax against those symptoms. Now, if you've ever taken acetazolamide, and I'm someone who actually gets this, so I've taken it before, and it's Diamox is the trade name. It does some weird things. It makes your extremities a little tingly because it's got this carbonic it's a carbonic anhydrase. It makes carbonated beverages taste completely flat and weird. It does some weird things, so there's some side effects to beware of, but it really can help. You don't need these things. This will just go away if you spend a couple days at altitude. You can also take a little NSAID, even a little dose of steroids would help. If you were to give yourself some extra oxygen, that can make people definitely feel better. Ultimately, the answer to all of these altitude illnesses is to descend. Obviously, if you descend in altitude and bring up that oxygen concentration, you will feel better. That's just often impractical when you're at one of these altitudes. The end of the spectrum here in terms of where altitude illness can go really bad is when that capillary leakage happens in places where you don't want to have extra edema around, specifically the brain and the lungs. These are the two really life-threatening forms of altitude illness. So high altitude cerebral edema, if your brain starts to get, your brain is a pretty confined space. You start to get any edema there, it can really be problematic. And imagine being at high altitude, you're up climbing one of these mountains and you start to get confused and ataxic. That is not the place that you want to have these symptoms. So this is very life-threatening. It's increased intracranial pressure. It can manifest with hard signs and symptoms. It's not just I don't feel well, it's I now can't walk. I'm confused. People all of a sudden are altered at altitude, even seizures, and go so far as to say coma. And really the answer is someone like that who's in this life-threatening situation, we really need to get them down. In the temporary form, we can do steroids, you can do portable hyperbaric bags, things like that to try to increase the amount of oxygen, deal with it temporarily, but really descent is the answer. High altitude pulmonary edema is where people start to cough at altitude. Pretty soon they're getting pink frothy sputum. They're really having pulmonary edema at altitude because of this capillary leak in the lungs. This usually happens after you've kind of been up there for a little bit. It starts to set in. All of a sudden you're a little short of breath, which you first attribute to being at altitude. Pretty soon, actually, it's more like, no, I'm actually coughing up stuff kind of thing. And this is one of the pulmonary edemas that if you do a chest x-ray, the heart size will be normal. So as opposed to CHF, where you have cardiomegaly, in this case, your heart is just fine. It's edema that's happening in the lungs. So it is a normal heart size on that chest x-ray, which may help you figure out the diagnosis ultimately. But that's one of the interesting things about it. Again, descent is really the ultimate treatment. Some people will use things like, albuterol inhalers and steroids, and all these things are temporizing to try until we can get somebody down. Often people did have some mild altitude illness before these things set in, but really this is on a bit of an unpredictable spectrum, and these things can happen at altitude. Now, along with being in the mountains comes hypothermia, but that's not where we always see hypothermia, is it? I work in Los Angeles, and we see a lot of urban hypothermia when people are out and they're exposed. So technically, hypothermia is when your core temp is below 35 degrees Celsius. It can, as I said, not happen in non-freezing temperatures. If you have altered sensorium, you're intoxicated, you're exposed, you're not responding to what your body is telling you. In addition, we can see hypothermia in people who have sepsis, who are really hypothyroidism. There's a lot of other medical conditions that can also lead you down a path of hypothermia. Patients who have had trauma, burns, are also at risk for hypothermia. Patients can get altered, their heart starts to slow down when they get hypothermic, some interesting things. This is an EKG of a patient with hypothermia. One of the interesting little findings you'll see on EKG as their heart starts to slow down is you can get these prominent J waves just there at the end of the QRS, which are called Osborn waves. These are not pathognomonic for hypothermia. You will not always see them, but they're one of those little interesting things that you can look for on your EKG as this very slow heart is going along. You can also see things like AFib. The heart is very, very irritable at low temperatures. So we want to warm them up. Not a surprise to know that the therapy for hypothermia is to rewarm people. And there's the easy way to go, and there's the hard way to go. And you pick as aggressive as you need to get depending on the clinical condition of the person in front of you. Certainly, someone who's in wet clothes that just got pulled out of some freezing lake, we're going to get the wet clothes off, warm blankets, all those obvious things. But we can get more invasive as well. Many of us in our departments have something like what we call the trade name as a bear hugger. It's basically one of these blankets that puts forced warm air kind of circulating over the body. That's one of the quick ways to get things warm. You could even go as far as to put a Foley in and do warm water lavages of the bladder. Even in severe cases, you could put chest tubes in and do warm water lavages of the chest. That's going really on the end of the spectrum, but there are softer things you can do than that. One of the things about taking care of a patient with hypothermia is that you need to have ongoing temperature monitoring of that patient. This is most commonly these days done with bladder temperature monitors, where you basically put in a Foley that has a temperature monitor and you can see basically their core temp on the monitor for as you're treating somebody. The old days we used to put rectal thermometers in people and then follow what their temperature is, because you want to make sure that you're following as you're going along. One common thing that happens as you start to warm people up is you get this paradoxical afterdrop where they're starting to warm, and then as their circulation starts to kind of open up, they can get cold again because that cold blood is now recirculating, and then you got to kind of keep going. So that's one thing to know about that. So warm lavages, warm fluids, etc. Certainly one other thing that can happen at altitude and hypothermic conditions is frostbite. And really I think of frostbite as burns of tissue that's caused by the cold exposure. And it's the corollary to burns is sort of the depth of how deep it goes. You can have superficial frostbite, it can get all the way down 4th degree to bone. So depending on how low in your dermis you've burned through can be the level of frostbite that you're dealing with. The thing about frostbite and warming people up who've had frostbite is what you don't want to do is warm them up and then have any chance that that tissue is now going to refreeze, because the damage that can be done in that second refreezing is really bad. So you want to rapidly rewarm them with pretty hot water, warm water, and you want to do it at a time where there's no risk of them refreezing. So that's one thing that's off the list. Often if you have blisters, like these kind of hemorrhagic blisters, often we kind of leave these intact because it's a nice biological dressing, and we'll talk a little bit about that when we talk about burns as well. So now let's move from the cold to the hot and talk about the patients who are hyperthermic and what that looks like, what we do for them. There's kind of two sort of stories of hyperthermia, right? There's the epidemic heat wave in some town, and all the people who are stuck in their apartments and don't have air conditioning. There's sort of like epidemic heat wave, and so there's those types of patients who have hyperthermia. And then there's like the young, active military recruit that was working way too hard in hot conditions, and they're having hyperthermia as well. And those are really two different types of hypothermia. So we also have patients who are intoxicated on drugs, et cetera, who get overexerted as well. So there's heat waves and there's ambient changes, but there's also overexertion and hyperthermia from that. Heat illness, just like in terms of hypothermia, has a spectrum as well. There are people who have very mild heat illness, people who have a little bit of swelling, they have heat edema, which we do not treat with diuretics. It's because they're hot and they're getting a little bit puffy. People can also get heat cramps if they've been sort of exerting themselves. And these are early signs that you are starting down this pathway of hyperthermia that you need to pay attention to and deal with. People need to cool it, sit down, cool down, etc. People can have heat syncope from sort of the pooling of blood in their extremities and getting syncope from that place. We lie people down, cool them down a bit. And then people who have heat exhaustion, which is, now I'm sort of like maybe I'm vomiting, I'm feeling not so well. This is due to dehydration, cool them down, PO, electrolyte repletion, etc. All of those things are separate from heat stroke. And heat stroke, that term, should really be reserved for these true emergencies. And really the clinical symptom that we want to pay attention to here is altered mental status. As soon as someone is hot and confused, now we're talking about heat stroke. That's what heat stroke means. Everything before that, before they started to actually have major end organ damage to the organ that I really care about, is pre-heat stroke. This is heat stroke. And when I think of that and I see someone who's very hot and now is altered, I also start to think, okay, things are starting to melt inside of you. And it's your liver enzymes will be elevated. Now your brain's not working so well. You can go into multi-organ failure from that hyperthermia. So that is really an emergency, clearly. And often the core temperature will be quite high, often over 40 degrees. And that altered mental status is really the harbinger of true heat stroke. Their vital signs can be all over the place, but often they're kind of trying to compensate, and they can be tachycardic and tachypnic, but they can also drop their blood pressure as well. So obviously we're going to send labs, and the things that we will often see are acidosis. We can send a creatinine kinase, a CK, and see some rhabdo going on. They can go into ARDS, have full-on renal failure, including the hyperkalemia that may come as a result of that. So these are things that we look for in heat stroke. There, as mentioned with these heat illnesses, there's kind of the classic epidemic form, and then there's the exertional form. And these occur in sort of different types of populations and have a little bit in the way of different outcomes. So the person who's stuck in their apartment with no air conditioning, who's just sort of heating up over time, that is not an exertional type of heat illness. And that's often elderly who may have, chronic disease, et cetera. It could also be very young people, people who can't respond to that environment around them and may have comorbidities as well. Often when they're brought to the hospital, they have sort of dry skin, and they often do okay as long as we can get to them in time. They don't usually go into florid, renal failure, et cetera. The ones on the other side, the ones who way overdo it and totally exert themselves and get way overheated, and yes, they're the healthy and active ones, but they're often the ones who actually go into renal failure and rhabdo because they've really pushed their body to a point of stress that just can't be tolerated. And so we really see these kind of different forms of heat illness. So we want to cool people down, right? We want to change our ABCs to really thinking about putting cooling really up front. And we want to resuscitate them, rehydrate them, and also cool them simultaneously. So how can we cool people down really quickly? Well, certainly we can get fans, we can spray them with spray bottles, but one of the more aggressive ways to do it, actually these days, is to get a body bag, right? Put a bunch of ice in it, icy slurry water, and put somebody in that sort of little contained bathtub that you can make to cool people down really rapidly. And this is another circumstance where knowing a patient's core temperature is really important. So I need either a bladder temp or a rectal temp to follow exactly what their temperature is. This is really important in cooling someone down because we don't want to drop them too low. We don't want to go too far with it, which you can certainly do. So you want to stop at around 101.3-ish, 101. You want to kind of stop there because it's going to continue to go down from your measures that you've employed. So you want to actually stop at around that sort of mild hyperthermia, and you don't want to overshoot in terms of treating someone with heat stroke. Now let's talk a little bit about burns, and I work at a burn center, so we get a lot of burn patients transferred to us and trauma patients who have a lot of burns. So I've seen a lot of bad burns. And I'll tell you that when, people, they'll always ask you if you work in an emergency department, what are the things that you see? What are the crazy cases? What's the stuff that really you don't want to see? And for me, it's burns. Burns are, so devastating to people, major burns. They're, that their recovery period and the surgeries and the cosmetic implications are going to be so severe that they are just one of those injuries that I just hate to see, for sure. And so when you're looking at burns, there's obviously different levels of burns, and we still kind of throw around first degree, second degree, third degree, but really, if you're talking to burn surgeons, what they want to know from you is in terms of the depth of the burn. How much is superficial? When we're talking about partial thickness, superficial partial thickness, deep partial thickness, and full thickness burns, really the depth of the burn tells a lot more about their outcome and the kind of interventions that they might need. So we want to really characterize our burns that way, and we'll walk through what each of those levels really looks like clinically in front of you. Everybody knows what superficial or first degree burns look like. That's a sunburn, really a bad sunburn, which is just your epidermis. It hasn't penetrated anywhere below that. It's a very painful burn. It's going to get better. There's no scarring that's implied there. We can give some NSAIDs, give it some time, and they're going to be okay. Every once in a while, as you start to move down, that's when you might start to see a little bit of a blister, a little thin-walled blister, as we move down into the superficial partial thickness burn. So now we're talking about red skin, we're talking about getting a little bit of blistering there, and that's also still very painful, and typically it's going to still heal pretty well within the next week or two without a lot of scarring if we're talking about superficial layers. Then we start moving into the really serious burns, the deep partial thickness and really the full thickness burn. So a deep partial thickness burn, it's not red anymore, it doesn't really have these little thin-walled little baby blisters. We're talking about pretty thick-walled, serious blisters. We're talking about people whose skin starts to look kind of mottled, doesn't look so healthy anymore. They may even have a decrease in sensation, and it's not as painful because you're starting to get down into those nerve endings and actually burning through the nerve that cause the pain. These are burns that may heal more in the weeks to months category and often will have major scarring, may need skin grafts, and may have pigment changes over time. And when we're talking about full thickness burns, and we've really dug all the way down to the neurovascular bundle of that skin, we're talking about painless, sort of white, brown, charred-looking skin that doesn't have much in the way of sensation and will never come back. And that's going to have to be grafted for sure. So as you're describing burns, you really want to keep in mind these levels of burns. And nobody really cares about the superficial burn. We're talking about as we start to get down into deeper burns. So if you're talking about quantifying somebody's body surface area burned, we're not talking about all the burns that we see. We're talking about really the second degree or the partial thickness burns on down. And that's really what you're quantifying for someone in terms of body surface area that's been burned. You have to estimate body surface area burned when you're talking about someone who has a pretty serious burn. This can be done in several ways. We have here just telling you about the rule of nines, which is sort of dividing the body up into different quadrants and estimating how much surface area has been burned. You can also use kind of the quick way is to take their palm and equate that. That's about 1% of their body surface area, and then quantify what percent is sort of burned in that serious way. For children, it's a little bit different. Their proportions are different. There's what's called the Lund-Browder chart, which can help you also quantify how much is burned. This is what the Lund-Browder chart looks like. You'll never memorize it, but just know that there is a system to know how much BSA, body surface area burns are in kids, and you can always look it up, and it helps break down those same kind of rule of nines, but the numbers are a little bit different because they have sort of different size proportions than we do as adults, of course. Okay, we're going to talk a little about minor burns. That's really what we see a lot day in and day out in most of our practices. We see people who don't have one of those major burns that we're talking about. We're talking about minor burns. What can I do for those? So what do? We cool them down. We're going to treat their pain. These can be quite painful for sure. Even opiates can be indicated in these minor burns sometimes. Certainly in the major burns, very much indicated. Blisters, what to do with them is always a little bit of a controversy, but for the most part, the recommendations are to leave blisters intact. Again, it's a nice biologic dressing to keep that sort of exposed skin covered. However, if the blister is already broken, you can debride it, make things cleaned up. If it's over a joint and things are kind of tense, you may decide to debride that blister in that particular case. So there are some conditions where you might debride the blisters. You definitely want to update their tetanus. That's something that we want to make sure they're not at risk for. And then you can manage it in a few different ways. I have a picture of Silvadene here just to remind myself to talk about it, because it's always a question like, can you still use Silvadene? Silvadene's fallen a little out of fashion because the silver pigment in it can cause some pigment changes that can have some cosmetic implications, but Silvadene's really cheap. It's still used. There's no formal contraindication, so you're not wrong to use Silvadene. It's just not really favored anymore because there's a lot of other types of dressings that you can use. There's a lot of fancy colloid dressings out there that you can use that have things impregnated in them to keep things moist and clean. You can use one of those, but you don't have to use one of those. The real key is to use loose dressings to make sure they're non-adherent, that you have something, whether it's Vaseline, it doesn't have to be antibiotic ointment, but you can use antibiotic ointment as well to make sure that the dressing isn't sticking to the wound and that these dressings will get changed. So you can use sort of a closed occlusive dressing. You could manage a little small burns openly with some kind of just an ointment to protect the skin. There's a lot of different ways to go here, but that's, we do these kind of things day in and day out. In terms of how we treat major burns, if you work in a place where you see one of these, certainly you want to watch for that hypothermia. You want to make sure that you get you also want to think about the toxicology, were they in any kind of a closed space fire where they may have been exposed to something like carbon monoxide or cyanide, remembering those types of exposures as well. And then we have to assess their airway. And often if you work in a place where you might be considering transferring someone to a burn center, this airway question is a really important one. You want to make sure that their airway is intact as you're transferring someone. And as you have a major burn patient and you're doing a lot of fluid resuscitation, patients can get pretty edematous. And so that thought about the airway is an important one. Certainly if they have any kind of respiratory distress, if there's any sign that they may have inhaled or had an inhalational injury, their voice is different, things look swollen, they're sort of charring there. You want to be conservative with the airway and take it if you're going to have to transfer someone or if there's any question. Fluid resuscitation is very critical here. There are a bunch of different formulas. I've provided one here for you, which is the Parkland formula, which basically is a body weight calculation that you're going to give, and you're going to give half of that volume that they're going to need in the first 8 hours, and you're really looking for a urine output that you want to be shooting for, because these patients are at risk for renal failure from all the myoglobin from the muscles that it's going to be released. You have to continue to flush that out. What do we do with these burns? Who do I need to transfer? Who don't I need to transfer? Most of the time, if it's a less than 10% body surface area burn, these can be treated as outpatients. But certainly if it's a major burn, it looks pretty obvious that needs to go to a burn center. There are some other specific categories of burns that you may want to refer to a burn center. Circumferential burns are kind of a big deal because as the swelling happens, you can get ischemia, and that may be something that a burn center wants to take care of. Things that are really cosmetically important and don't heal well, which is really genitals, facial burns, eye burns, ear burns, hand burns of really functional areas. Those are things that burn centers are more than happy to help with. Inhalational injuries, of course, electrical injuries, and then basically how much is burned. And there's some formal criteria for this. Burn centers are also happy to talk to you over the phone and give you some phone advice if you're kind of wondering or you're on the fence to see if that might be something that they want to see, whether it's something to be directly transferred in the moment or something to refer as an outpatient. So electrical injuries are something that we also commonly see. Why are electrical injuries kind of a big deal? Because clearly as electricity passes through our body, it can cause tissue injury, it can also cause damage to our heart as well. One of the things about electrical injuries is they're often combined with trauma. The person who's up on a ladder and has an electrical injury happen then falls off the ladder, and the patient who's presenting to us is a trauma patient and also someone who's had an electrical injury. So we don't want to lose sight of the trauma that often goes with it. Alternating current turns out to be not that great, and one of the reasons is because alternating current, which is a lot of household current, because of its alternating nature, it often lends the victim to have some kind of tetany where they can't release from the current and get away from it, versus direct current, which is like one big blow, right? So the degree of injury really depends on the length of the contact, the duration of the contact, and what the tissue was in the path of the current. The biggest risk of actual death is the trauma that happens along with the electrical injury or a cardiac arrhythmia that can't be dealt with in time. But either way, we want to think of them as a trauma patient as they roll through the door so we don't lose sight of those traumatic injuries that may be more life-threatening to them than the actual electrical injury that they suffered. One of the little caveats to think about is kids who go around and bite on an electrical cord. If they come in with one of these burns on the side of their mouth, just keep in mind that the anterior labial artery runs right along there, and so this is a pretty big artery, and this is not an uncommon thing for kids to do. And that anterior labial artery, while it may clot off initially, as that burn starts to heal and that clot starts to retract, they are at risk for a rebleed, a pretty significant arterial rebleed. That's someone you want to refer to plastic surgery, for example. So as you're assessing the patient with electrical injuries, you want to look for that entrance and exit wound. We're obviously resuscitating them, doing our regular ABC assessment, and we want to think about what kind of exposure they actually had. Household current exposures that people have with regular household voltage is usually not a big deal. It doesn't need a bunch of labs. It doesn't need monitoring overnight in the hospital. You kind of take a look at the patient. If they're doing okay, they're not at risk for having like an arrhythmia down the line. It's really not that big a deal. These patients can be discharged. But if it's more than that, then consider sending a CBC and a CMP and looking at electrolytes and thinking about a rhabdomyolysis picture, thinking about coagulation, getting that EKG, and admitting them to a monitored bed to make sure that nothing develops over time, specifically any kind of renal dysfunction as their CK may start to elevate. Mammalian bites. Let's talk a little about bites and stings. So bites are a big deal. Human bites is probably the worst mammalian bite that someone could have because human mouths are so contaminated with bacteria. People who come in with fight bites, they have basically injuries over their knuckles and they say they punched a wall. We always want to think about, could they have punched someone in the mouth and have a contaminated injury? That would need washout. That's a high-risk injury. Dog bites actually have a lower infection rate, but they have more of a crush injury. So we want to think about that tissue damage that may have occurred. Cat bites are often puncture wounds, and they can be really at high risk of pretty deep-seated infection. So those are pretty nasty. But all of these, if antibiotics is indicated, you can use amoxicillin clavulanate, and that's Augmentin. And I always remember this one as Dogmentin. I want to use Dogmentin for animal bites. That's the kind of go-to antibiotic, first-line antibiotic to use if antibiotics are indicated. Rabies is often a consideration as well. People present all the time with a concern of rabies, and rightfully so. Rabies is pretty much a fatal disease if it happens to develop, so we do want to be careful with rabies. This is why we have these prophylaxis regimens. Really, the kinds of bites that are at risk for rabies, in terms of what you'll see day in and day out, are people who have any kind of a skunk bite, raccoon bite. Bats are really the highest risk in terms of rabies transmission. Even if they were in a room and there was a bat found there, even if there's no obvious bite mark, that would be a high enough risk room to prophylax for rabies. Things that are not at risk for rabies are like, I got bit by a rat. That's not at risk for rabies. Rabbit bites, not rabies risk. So those people do not need rabies prophylaxis. And we want to give the prophylaxis in the form of the vaccine as well as immunoglobulin. CDC, Public Health all have really good resources to look this stuff up if you don't see it all that commonly. Bites and stings we also see quite a bit. Bee stings, wasps, ants, obviously. Usually these are just local symptoms. Anaphylaxis is a whole different topic. But if you do see bites and these kind of things, really what you do for them is just ice and over-the-counter pain medication. Every once in a while, someone will come in with a really big reaction to one of these bites or stings, and you'll think, oh, it looks like they might have cellulitis around the bite, but just know that there's a good little chunk here, 10 to 15% of people that will have a local hypersensitivity response, and they'll have this big area of swelling and redness that can last even up to a week. Doesn't mean that it's cellulitis. It could just be a hypersensitivity to the actual sting that they had. We do see people who come in with spider bites a lot, and often when they say spider bite, what are they actually talking about? They're talking about an MRSA abscess, right? So, you know, a lot of spider bites are not actually spider bites, but spider bites actually do happen, and people can get bit by things like black widows and brown recluses. It can happen. Black widows are that black spider with the hourglass on their body. They usually have pain right away. They even can develop sort of systemic symptoms like nausea. It's on the list of things that can be a mimic for appendicitis. They can actually have like a lot of abdominal pain and cramping with a true black widow bite. And really we treat these symptomatically. There's really no role for antivenom. Antivenom is something that has a lot of side effects in the case of black widows, and black widow bites are not life-threatening, so there's really a risk-benefit there that's not worth it. But always you can talk to a toxicologist if you're considering it. Brown recluse is not as common as black widows. This is a pain that usually happens in a delayed fashion, and they get a lot of skin findings that go along with it. And again, analgesics and often dealing with that wound are what's indicated there. And then finally, you could talk about snake bites for a whole conference. So really just to mention that snake bites happen. Often people live in places where they know exactly what to do. These are usually, in terms of there's crotalids, there are lapidids, there are different types of snakes with different types of toxins. Really the most common ones, especially as we sit here in the western US, are the crotalids or the pit vipers, the rattlesnake bites. There is antivenom for those. It's really, really important to use it early and at generous doses for people who have true bites, and that is something that you can always look up and transfer to places that treat snake bites frequently. And don't forget to call your local poison center or toxicologist to help you manage these if you don't do it all that frequently. Thanks very much for environmental, and I think Rick's up next.
Well, I have seemed to have screwed up the schedule. My eyes just kind of closed, and next thing I knew, there was phone calls and texts coming in and anything. But anyway, let's talk about heart failure. This is a big deal disorder, commonly seen in the emergency department. It is Medicare's most expensive diagnosis. It is and one of the reasons is because of readmission, 3 or 4 days at a clip. Here's a healthy heart. You can see the septum. Look at the difference in the septums on the two. Look at this thickness of the left ventricle compared to the sick heart. The thickness of the right ventricle compared to the sick heart. And you can see that the sick heart is the profile of it is larger. So when we take a chest x-ray of somebody who has heart failure, we say that they have a big heart. Yes, they do, only because everything's gotten flabby, and the fact is that it is more full with blood, but not necessarily pumping out very well. The mortality of congestive heart failure is about 10% per year. So this is a disorder that has a mortality that is higher than that of some cancers at 10% per year. And so our job basically is to try to identify these people, treat them effectively, and maybe try to even keep them out of the hospital. Because there is a move to keep people out of the hospital who have a mild episode of failure that you're able to reverse. They're feeling better. It's a couple hours later. And you may just make a decision to send them home. Before, everybody who had an episode of exacerbation of heart failure came into the hospital, but that is changing now with time. Systolic dysfunction, diastolic dysfunction. When I was younger, there was heart failure. It was they didn't make any distinction between systolic and diastolic. It was just basically you had a weak heart and it wasn't pumping out blood to the extent it ought to be. But now we've kind of separated that a little bit. The first one is systolic failure, pumping failure, squeezing failure, and that's kind of easy enough to understand that basically the pumping is becomes weaker and weaker over time, and as a result, the heart is not pushing out blood as much as it should, and basically it backs up into the lungs, and from there it backs up to the right side, and next thing you know, you get neck vein distension and the like. Low ejection fraction is a characteristic of systolic heart failure. Now, the normal ejection fraction is between like 55 and 70%, so nobody's pumping out 100% of what goes into the left ventricle. There's always some residual that is there. You can determine somebody's ejection fraction by, a Doppler ultrasound, where in fact you were able to see in and out and measure. So that's a pretty easy diagnosis to make, especially if you are able to use an ultrasound and rather quickly make this diagnosis. But fundamentally, this low cardiac output is the final common pathway here. As you may envision, the causes are ischemic problems where the muscle is not getting enough blood. The heart does only two things. It pumps and it has a beat. It pumps and it has a beat. It has the strength of pumping and the regularity of its beat are the only two things that the heart does. Does it for 60, 70, 80 years, which is pretty remarkable. And there's the list of the things that may be the cause of the heart just wearing out prematurely on the list there. Diastolic dysfunction is kind of interesting. This was the newer understanding of at least some people's congestive heart failure. And this is about, think of it as a muscle-bound heart, where the muscles of the walls are thicker, stronger, but they aren't stronger, they're stiffer, and they therefore basically can't squeeze as they would if they were more of their natural thickness. Now these are hypertrophied. Hey, I've heard of that before, hypertrophied. Now that's one of the problems with left ventricular hypertrophy. When you have high blood pressure, left ventricular hypertrophy gradually can progress until the point where there's little room in the chamber of the left ventricle because the walls have become so thick. Those people have ejection fractions which are probably normal, but the problem with those people is that there's so little blood that can fit into the left ventricle, that it may pump out 55% of it, but it's pumping out 55% of a very small number. The final common pathway, however, is that they've got backup of blood into the lungs, and in the lungs, basically, there is a starting to leak, increased hydrostatic pressure, increasing leakage of fluid from the capillaries into the interstitial space. Here's the alveolus. Maybe that space is getting a little bit full of interstitial fluid. The lungs are getting heavier. There's leakage of this fluid into the alveoli. Now we can hear rales. Lungs are heavier, rales. The work of breathing goes increased because you got these heavy, wet lungs that you have to try to ventilate. And so there's this vicious pathway of that is common to both types of heart failure. This is kind of basically the schematic of it, and I think it's really kind of nice because the first one, the vertical, is the normal heart, and you get some sense of the relative percentages of what the walls are doing during systole. So in the regular heart, you can see that as things squeeze down, there's still some reasonable amount of space in the left ventricle. The right ventricle walls are not paper thin as they are in the middle heart. The middle heart is systolic failure. This is a heart where the walls are thinned out, whether they be from ischemia or the like. And then the right heart, that's the hypertrophied heart. Basically, the walls become stiff, thick, big, and you can see that the chamber on the left ventricle is much smaller than it should be. And when it squeezes down, there's just not much blood being pumped out. The percentage of blood that is being pumped out is normal, but the absolute amount of blood that is being pumped out is not normal. There is some variations in what they call this stuff now, but for us, it's easier to think of systolic and diastolic failure. These initials, they're basically talking about left ventricle, it's basically heart failure with preserved ejection fraction, heart failure with decreased, reduced ejection fraction. Who would want to use those when you could just say systolic and diastolic? I mean, it's really more cumbersome than this systolic diastolic failure. When things get kind of nasty and blood's backed up into the right side of the, from the left side into the lungs back up into the right ventricle becomes distended, blood goes up, the neck veins become more prominent, the liver becomes more full of blood, so there's a hepatojugular reflux. There's peripheral edema. Those are all right-sided heart failure signs. The most common cause of right heart failure is left heart failure. So when we see somebody in the emergency department and we see these neck veins distended, this basically means that we've got a problem from the left all the way around to the right and out on the right side. So here's the list of things that we kind of consider as the precipitants of what brought this person into the emergency department. We're supposed to look for intercurrent illnesses like particularly pneumonia, and they may also have some degree of COPD thrown in there as well. Myocardial infarction, obviously, and I like the fact that there's NSAIDs listed here because NSAIDs are generally not a great idea for older people to be taking because you remember Vioxx? Vioxx was taken off the market a bunch of years ago. It was first in this class of NSAIDs that was involved with what ultimately was thought to be 60,000 myocardial infarctions due to Vioxx. So that was pulled off. But there were other relatives of Vioxx, like celecoxib is a relative of it. And so is Motrin, and so is Aleve. And all of those, this is a family all having various degrees of problems. Vioxx may have been at the top of the list, but Aleve, naproxen is basically involved in this too. So you'd like to ask people who are older to see if they can deal with acetaminophen first for whatever their pain issues are, not dealing with NSAIDs and the renal blood flow effect and the fact that they cause the retention of sodium water, basically increasing the risk of elevation of blood pressure, and they have this underlying business where they can be associated with myocardial infarctions. Arrhythmias, sure, if you basically go into an arrhythmia that is not a particularly good arrhythmia, like atrial fibrillation. Some people who are atrial fibrillation, basically because you've lost your atrial kick, that atrial are supposed to be doing something there, so that they're supposed to be helping push this blood around the heart. If the atria are not kicking in their contribution, then basically you may have a manifestation of that atrial fibrillation as congestive heart failure. Uncontrolled hypertension, right, that's for sure. You can envision it, left ventricular hypertrophy. Now we have increased likelihood of diastolic dysfunction. Excess fluid, that's kind of the thought of most people who are coming in. They're not necessarily sick. Maybe that over time they've been kind of generous with the salt shaker, and the idea is they've accumulated more and more and more fluid. Their feet are more and more edematous, And basically, as the vascular volume increases, this precipitates the manifestations of a failure. Anemia, you don't have enough red cells, so what do you do when you don't have enough red cells? You have to basically push the blood that you have around faster. And to do that, the heart rate will go up. Basically, an increased heart rate in a predisposed person is basically going to cause a failure in that environment too. Like you've heard of hyperthyroid congestive heart failure, because basically the heart just cannot keep up with the fact that the demand for oxygenation is such that it has to pump blood a lot faster, a lot harder than it did before. Valvular disorders, absolutely, that's for sure. Carditis, myocarditis is, we're going to talk about that. That's a hidden killer that we really ought to all be aware of. So we got the NSAIDs, the amlodipines, and this diabetes drug are basically also been associated with increased risk of heart failure in those who already are predisposed. I mean, amlodipine is not going to cause heart failure, but if you're otherwise predisposed, it will make it come on you. I like this picture because it explains all the pathophysiology that we see when somebody comes in with heart failure. As an example, we see somebody coming in, yeah, they're huffing and puffing, we got that, we got the rails, we get the maybe some intercostal retraction, we got the increased respiratory rate. The heart does only two things, speed and force of pumping, speed and force of pumping. So in this case, because the things are backing up, the heart rate goes up. How does the heart rate go up? It goes up through the release of adrenaline. Adrenaline, we know, makes the heart rate go faster, but we also know that adrenaline can cause peripheral vasoconstriction, which will be a problem here because we don't want that. Peripheral vasoconstriction, you look pale now. The person's pale. And when they're pale and they're peripherally constricted, they can't dissipate their heat. If you can't dissipate your heat through your skin, then how else can you dissipate it? You start sweating. So the sweating and pale, those are the signs of excess adrenaline. They've got tachycardia, they've got elevated blood pressure, then they have all of the other kinds of the peripheral edema. They may have some nausea because of some filling edema of the liver, the bowel, those kinds of things. But we can understand now, pale, sweaty, elevated heart rate, elevated blood pressure. And if you have that group of disorders at once, you can probably treat this person and within an hour they'll be obviously better. If you don't have one of these, what if the blood pressure is low in a case like this? If the blood pressure is low in a case like this, you have cardiogenic shock. Cardiogenic shock, you know the outcome for cardiogenic shock. In response to this failure stress, basically the heart is supposed to be having an elevated blood pressure and elevated heart rate. If you don't have an elevated blood pressure, you don't have much to work with, because our treatment for this is to drop the blood pressure. By dropping the blood pressure, it'll be easier for the heart to pump from the left ventricle, pump it out into the vascular tree, basically unloading the left side, and then the right side, and everybody's feeling better. Generally, in about like an hour, there's noticeable difference. Some of the testing that we do in congestive failure, most of the time we know the diagnosis. Sometimes we don't, and sometimes we have to measure BNP to help us. But most of the time we measure BNP to help us, it's in the mid-zone where it's not particularly helpful. The idea here is, as the right ventricle is full of blood and expands to accommodate this load of blood, the wall tension is such that it releases BNP, which is, we measure it as it's a vasodilator. The idea here is supposed to be helpful, but for us it's a marker of what's going on with the right ventricular wall tension. However, as an example, there's another thing that will raise your BNP. What if you have a nice big saddle embolus blocking the obstruction of the outflow of the right ventricle down into the pulmonary vasculature? So now the right ventricle suddenly is distended because it can't push out, and then so in this big PE we also have an elevation of BNP. So it's not specific for congestive heart failure necessarily, but usually is. Here's an example where you have an EKG where you've lost your atrial kick. You've got atrial fibrillation. You have tachycardia here associated with atrial fibrillation. This may be a compensatory tachycardia or the tachycardia associated with uncontrolled atrial fibrillation. A lot of patients have quote-unquote controlled atrial fibrillation, but all of them don't have their atrial kick. So their heart rate may be down to 90 because of this drug or that drug, but the fact of the matter is they've lost their atrial kick in this process. Troponins may be elevated if in fact the heart is also ischemic. There are other reasons for troponins to be elevated, which you'll talk about. I don't want to give it away just yet. But we're going to certainly look and do an EKG in these cases. We're certainly going to look into a troponin in these cases to find out if this mechanical dysfunction of the heart is due to a ischemic process whereby you can't get blood through the coronary arteries because of obstruction, and therefore basically the pumping power. It only does two things: pumps and has a rhythm. Pumps and has a rhythm. So you can only ask it to do two things: change the pumping and change the rhythm. So here's a typical X-ray, and over time, basically, the X-ray clears. But oddly enough, the X-ray does not clear at the same rate that the patient improves. So you have somebody with obvious pulmonary edema on the left side, and over time, the heart seems to get smaller. The vascular shadows seem to dissipate. But look at the date on that X-ray in terms of when it occurred. This person's better in an hour. They're substantially better in an hour, but there's this disconnect between how long it takes for the chest X-ray to clear versus how long it takes them for them to feel symptomatically improved. We now know that the best way to diagnose congestive heart failure, unless you're perfectly confident that you've made the diagnosis, is to do an ultrasound. An ultrasound basically, finds these B lines, which are these light beams through the lung fields, and look at compared to a chest X-ray. Everybody gets a chest X-ray. That's what we use to diagnose congestive heart failure in terms of imaging. But look at this: 96% sensitivity with the point-of-care ultrasound versus 65% sensitivity with a chest X-ray. So basically, you could have congestive heart failure, and you'll miss a third of the cases on a chest X-ray because the sensitivity is only about 65%. Specificity of both techniques is good. If it says it's failure, it's failure. But the fact is, we're looking to pick it up. And if you don't pick it up in a third of the cases because you got a chest X-ray, then it's kind of disheartening. Because it's interesting, we keep on doing chest X-rays, but there's a much better way to visualize the lungs. It's called a CAT scan. And CAT scans are using less and less and less and less radiation now. They use about 3 to 5 times the amount of radiation for a chest X-ray. But the radiation for a chest X-ray is nothing. An abdominal CAT scan, looking chest, appendicitis, that kind of thing, is 500 chest X-rays. So if you have 500 chest X-rays for an abdominal CT, and you have 5 chest X-rays for a chest CT, it's like, well, that's hardly anything. And so the answer is, it picks up pneumonia much better, picks up failure much better, picks up everything much better than. So it's kind of like, well, we have a much better test, but let's get a chest X-ray kind of thing. I think that there's going to be a move, so there's more and more stuff, and obviously here, this is not a difficult thing to master. For those of you who took that class over there, and Teresa was showing you about how you make this diagnosis through just by putting within minutes of the patient's arrival, you have the diagnosis. Other things that you might want to consider is comprehensive metabolic panel, looking for all of these people are on diuretics. All the diuretics decrease your potassium. In the process of decreasing your potassium, you decrease your magnesium. Potassium and magnesium are both needed for, the strength of contraction. So if you have low mag, your strength of contraction may be decreased. We don't measure magnesium routinely, but we measure potassium, and basically we're looking at that. Well, there's a relationship, low potassium, low mag, in these cases. It's kind of interesting. This comprehensive metabolic panel, it's got like stuff in there like a chloride. What the heck would you care about a chloride? I vote that we remove the chloride from the comprehensive panel and stick in the magnesium. Thank you very much. Because measuring the chloride is it's like measuring the sodium twice. It's called sodium chloride, you know. But in any case. But that's just my own opinion, obviously. So is the potassium low? We can expect it to be low in these cases. Is there evidence of anemia? If there is evidence of anemia, maybe this is the cause of precipitated failure, because we're looking for the precipitants of it. Anemia didn't cause failure, but anemia just worsened the failure. White count, maybe that goes along with an infection. Treatment is pretty straightforward, honestly. The idea is to give them supplemental oxygen if they need it. Don't go overboard. You know, we're looking for 92, 93, 94. That's fine. We're not looking for 105% kind of thing, because it is believed by some that hyperoxemia causes vasoconstriction. It can cause coronary vasoconstriction. May cause some pulmonary vasoconstriction as well, which is the last thing that you want to have happen. And that's one of the reasons why now when somebody has a myocardial infarction, the idea is to don't go nuts about the oxygen, because you have a person who's got compromised coronary arteries, and the idea if you use hyperoxygenation, say, well, the more oxygen we can dissolve in their serum, the better. Basically, it's thought that there may be some downside to that, and that there's not an increased benefit by going overboard. So it's all about reduction of the afterload. Think of afterload as what's after the heart. What's after the heart is the aorta and all the blood vessels. And what we'd like to do, because they're all relatively constricted now, and the blood pressure is elevated as a result of that, we like to dilate it. And so we're basically going to use some high-dose nitroglycerin. It's nice because it's titratable. We can turn it on, turn it off, has a quick on, quick off kind of thing. We titrate it to basically dilate the blood vessels. Dilating the blood vessels it creates a place for all of this extra fluid to go. And if these people are chronically in failure, and they have the manifestations of fluid overload, they got peripheral edema kind of thing, that it would be appropriate in those cases to use some Lasix. You know, before I go to that, the nitro basically also is not limited to the arterial side. It does cause some effect on the venous side in terms of vasodilatation as well. IV diuretics. I don't know that most people know this, but IV diuretics, when they're initially given, cause vasoconstriction. That's the last thing that we want in a person who has heart failure. So if you want to do a heart failure in a person who is dementis, you nitrate first, then you give the IV furosemide to take out the excess fluid. And when you do it, these people start pouring out urine like nobody's business. But that's generally considered a reasonable thing to do. Although the literature on this, we all do it, but the literature on this is kind of like so-so. Not because it doesn't work, but because the literature really hasn't taken a lot of time to address it. And yes, not all patients who are in failure have fluid overload. As an example, what if you have a myocardial infarction, bam, like that? All of a sudden, the heart's not working mechanically because of the ischemia. So in that situation, they're not overloaded. They were fine, 5 minutes ago, but now they have a heart that's not working. The heart size is normal. When you take the chest X-ray, you may see some evidence of the failure, but they're not overloaded. So these patients are not necessarily great candidates to decrease their fluid volume by giving them a diuretic, because they're not overloaded in the first place, and you do need a certain amount of volume in your vascular tree for it to perfuse organs. So that's one thing to consider. Flash pulmonary edema, so it comes from something else. Jan was talking about the idea of as you go up in elevation, you start leaking out of your capillaries, and as you leak out of your capillaries, you get pulmonary edema in your chest, and you can get cerebral edema, so you have a headache and you're getting short of breath. Well, there are other reasons to be short of breath and as a result of she said a lot of that was due to adrenaline. Well, think of it, if you have a hemorrhage in your head. Subarachnoid hemorrhage, have you ever heard of the idea of those people having pulmonary edema? This is a huge surge of adrenaline that comes out from this catastrophic injury. And basically, they have a pulmonary edema that can develop where, in fact, they have normal volume in their vasculature. So that's another cause of flash pulmonary edema. Other things that can be used, but are, if you're in the pre-hospital setting and there's no time for an IV, you can give them sublingual captopril, which does a number of nice things here. And that has been something that some of my friends have used routinely before the IV started, before they could just come in off the street. Here's a sublingual captopril while we're getting these other things started in somebody where the diagnosis is pretty straightforward. Myocarditis. The key here is disproportionate tachycardia. Disproportionate. Somebody had a viral type illness, and they may have had a low-grade fever and myalgia and a kind of flu-like kind of thing. But they come to you, and it's an adult male, and they're not really having much of a fever, if at all, and their heart rate's 110. And they just say, I just don't feel good. And, I feel maybe a little short of breath. And they're running 110. And why are they running 110 when they should be running, 80 or something like that? The fact of the matter is that in this country, the most common cause of myocarditis is a virus, viral myocarditis. Yes, there are other causes. Chagas disease is the biggest cause of. This is a protozoa that basically gets into your system and causes weakness of the heart, and it's the largest cause of heart failure in the world. But in this country, it's viral myocarditis. And so the issue here is somebody comes in with a flu-like illness. They don't have a fever, and they could have a fever, but the heart rate is disproportionate to what the fever is, or the resting heart rate's 110. Whenever you see that, you have to think, is this heart infected by a virus? Because the fact of the matter is that if it's infected by a virus, and we get that little Chagas guy up there. If it's infected by a virus, then the heart cells are, just like when you get an infection of a respiratory virus, the virus goes in and destroys your cells. Well, the same thing happens here. The virus goes in, destroys your cells. You get an inflammatory process. You get some white cells interspersed within the muscle, and the muscle's cells are damaged. And what do they leak? They leak troponin. So that you can leak troponin because you're ischemic. You can leak troponin because your heart cells are being attacked by some virus. There are other causes of it as well, but for you, the syndrome of myocarditis in terms of it's disproportionate tachycardia, and because this heart is involved with this, whether it be a toxic myocarditis, alcohols are probably the most common toxin that cause myocarditis, alcoholic cardiomyopathy. There are other things, but as long as you understand, I got a tachycardia here, and I listen to the chest, and actually I hear a few rails in there, which ought not be there in this 40-year-old person, because myocarditis doesn't care how old you are. You can get this virus at any age, and particularly in little kiddies. So the idea here is you have a little kid who comes in with tachycardia, and the idea is this kid have myocarditis, disproportionate tachycardia? You listen to the lungs, it's a little shorter breath. Why is he a little shorter breath? We take the x-ray, there's a little, hey, this kid's in failure. What's the story? So that's something to consider. Myocarditis is caused by all of these weird diseases, but all you care about is the manifestations, and you know about it. So here's the white blood cells interspersed between the cardiac muscles. Out of proportion, congestive heart failure, maybe a dysrhythmia, yes, absolutely, sudden death. In fact, one of the real problems with missed myocarditis is sudden death. So this kid comes in with a flu, you think it is the flu, it's not really the flu, it's got myocarditis in it on top of it, kid goes home, drops dead. Drops dead a week from now, a month from now, basically as a result of the residual of this virus or an active virus. And so it's believed like 20% of young people who drop dead they have undiagnosed myocarditis. Anything here? Yeah, EKG. Because this is a diffuse disorder of the heart, you're not going to find any uniquely anterior, uniquely posterior, uniquely left ventricular. The whole heart is involved in this viral infection. So basically, the idea is that the whole heart will have evidence of abnormalities in terms of you've got the tachycardia, of ST abnormalities. These change over time, so you don't really need to know anything specifically about them. Here's the heart. Look at the T waves are inverted. All the leads have abnormalities. There's a sinus tachycardia along with it too. The treatment basically of myocarditis is, first of all, to try to identify it, and basically the idea is to avoid. They're treated basically as if they have failure. Basically, you have to try to treat them in the same way as if they otherwise have a cause of failure. But you want to be careful with the rate. You want to be careful with the blood pressure. It's not as easy because the entire heart is compromised, and so we have to be a little gingerly about it. Pericarditis is usually caused by myocarditis, but although we know of other things that specifically cause pericarditis, symptoms of this are pain when they when they cough, when they twist, when they turn. It's anterior and lean forward, it's worse. But when they lean forward, actually it's lean forward that's better. But when you lean forward and you listen to your stethoscope, the majority of them will have a rub, which is most well heard when they lean forward. So it begins relatively suddenly. Diagnosis is by ultrasound, which shows fluid between the pericardium and the heart. And as it gets worse and worse, basically the heart gets trapped in this bag, pericardium. The heart is generally squeezed by the fluid in this bag. So the heart sounds are muffled when you listen because it's got all this insulation. EKG, low amplitude waves, because it's got all this insulation around it now. And ultimately, you have difficulty filling the heart because the pericardium basically constricts the superior and inferior vena cava, so there's difficulty filling the heart. And next thing you know, basically, you've got what we call, wait a minute, I'm going to go back to this one. This is just here for your edification, trying to distinguish the two. But I think pericarditis is not usually that difficult to make clinically. You know, somebody could have had a heart attack about a month ago. Now they have symptoms of pericarditis. Remember, that's called Dressler syndrome. Why that occurs exactly, I'm personally not sure, but it probably has something to do with a little immunology. This is basically what to expect in these cases, pericarditis. Physical exam, as I mentioned, the response to the heart is faster, harder, faster, harder. Well, this heart cannot beat any harder because it's being compromised by being compressed, so it beats faster. So there's generally it's faster. Diffuse, because it's involving the entire pericardial sac, basically all the leads are abnormal. There's an evolution over time. Here's a typical case where, in fact, most of the leads are abnormal. They are. So there's no localization to an artery, or the location of an artery's distribution at all, and there's this tachycardia that goes along with it. Echo makes the diagnosis without doubt, and basically the idea here is to find the underlying cause if it's an infection and try to treat it, Chagas disease or whatever. And basically anti-inflammatories are given to try to kind of calm this inflammatory process down. This is cardiac tamponade. This is what the heart looks like, but it's not really the heart. The heart's probably a little bag in there with the pericardium all full. And the last thing is this idea about pericardial tamponade, where in fact you have when you take a systolic blood pressure, normally when you take the blood pressure, and if you take a deep breath, you suck blood into the lungs. When you take a deep breath, you're creating a vacuum. You suck blood into the lungs. When you suck blood into your lungs, your systolic blood pressure goes down. When you exhale, that blood that was in the lungs comes into your vascular tree, and the blood pressure goes up. It goes up and down in association with taking a breath. When you have an exaggeration of this normal up and down, which is usually about 10 millimeters of mercury, when you have an exaggeration of that, that's kind of a tip-off to pericarditis. It's also seen in advanced cases of congestive, COPD. And I think that is basically what we have here. There's the ultrasound kind of thing. Those of you who are learning how to do ultrasound or know how to do ultrasound, basically this is very straightforward diagnosis. Thank you very much. That is heart failure in still 6 minutes over. I just got to go faster. I got to go faster. I'm having trouble. I got to go faster. Break time. So I just took 9 minutes of 6 minutes of your break. No, break time.
All right, 4:01. My anxiety's kicking in. Now, technically, it says I have 42 seconds on the other countdown clock. Do I have 42 seconds? I have 42 seconds. The answer to life, 42. Somebody was asking what my 5 favorite movies are. I do tailor them to the student and to their educational needs. So, but typically it's Breakfast Club. Love Breakfast Club. Princess Bride. Who doesn't love Princess Bride? Top Gun. Oh, I love Top Gun. Terminator 2. And I am a huge Star Trek fan. A huge, like you have no idea how big of a Star Trek fan I am. I am such a big Star Trek fan that last year during lockdown, you're not recording this right now, right? During lockdown, in the Canada, up north, the big pink part on the map, we couldn't cross your border by ground. We had to fly. A new lockdown came. I had secured a 3-day weekend with Captain James Tiberius Kirk, otherwise known as William Shatner, for his 90th birthday. And I was going to spend a long weekend with him in upstate New York. And then the lockdown came and they put the restrictions on that you couldn't drive. And it was like a 6-hour drive to upstate New York from where I was. And I was going to go with a good friend of mine who runs a CBC radio program. And we were going to make a road trip, guy trip out of it. And it was just this epic thing. 2 days before, they closed the border. I don't believe in a no-win scenario. This was my Kobayashi Maru. And so what I did, through the help of my wife, because she knows everybody, she knew an airline pilot who had a float plane. I put on a red shirt for my away mission. We jumped on a float plane. You're not recording this, right? We flew over Lake Ontario on the float plane and dropped us on the American side, walked into a rental car agency, and drove. We get to this party, which was for 24 people, plus William Shatner, and they're like, how the hell did you Canadians get here? And I'm like, oh, I will get here. It's my childhood hero. I had to be there. Anyways, so Wrath of Khan, Star Trek II, The Wrath of Khan has to be on it as well. So, but there are so many 80s movies I could pick from. But now we're going to be talking, you may commence. Now we are going to be talking, nobody knows what just happened in the room, that's what I love, shoulder disorders. And I was talking to a group of people earlier, showing them how to do some shoulder reductions and some hip reductions and stuff like that. If you want to know more, come to the advanced boot camp, because we get into a much more detail than we do in these lectures. It's an advanced course. We're looking at, I do all the interesting dislocations and reductions and all the interesting and different blocks. And so that's what I take this to at the advanced boot camp. So shoulder anatomy. When you look at shoulder anatomy, you go, wow, what a joint. It isn't like the knee that just swings in one direction, right? One plane of motion. This is a universal joint. And it's a universal joint so we could get this important thing we have to what we need to do as tool makers, right? Evolution and coming out of the trees and swinging from the trees and all that kind of stuff to get the hand to be able to do things with it. But that means with all of that mobility comes instability. And it's very easy to dislocate it because it's a very shallow, bony joint, right? With a lot of soft tissues from ligaments to tendons and muscles surrounding that joint so the shoulder can have that universal motion. And so knowing some of the anatomy will be important, and we'll go through some of the important tendons and bursa. And that just shows you some more of the shoulder anatomy. But like I said, we'll get into it because there's an impingement system. And if you see where the ligaments are and where the tendon would have to come up and slide underneath that, you can see how if it was inflamed or damaged, it would create a painful arc or a difficult inability to move the shoulder. So when you examine the shoulder, so these are the key concepts, sorry. Incredibly mobile, bursas are important, low bony stability, combination of injury patterns. We're going to be talking about the rotator cuff muscles, the supraspinatus, infraspinatus, teres minor, and subscapularis, commonly known as SITS, and the AC joint. So when you go to examine a shoulder, you inspect, you palpate along the bones. and along the AC joint. Oh, that feels weird. Oh, that's right. I've got an AC separation on this side. Let me check this side. Oh, yeah, I'm Canadian. I played hockey. I've got an AC separation on this side. I don't dent the bubble, but I do have 2 big bumps on either side of my shoulders from shoulder separations from AC joint disruptions. Forward flexion, extension. abduction goes out this way. Adduction is you're adding together. So this is adduction together. Abduction goes this way, and this is where you get the painful arc right through here. And then you have external rotation. See, it's an X, external rotation, internal rotation this way. There's your motions. You're going to examine the shoulder. There's some specialty exams you can do, a Hawkins test, various other maneuvers. We won't get into that right now. So the AC separation, usually a direct blow. So you see this in contact sports like hockey going into the boards, football going into the ground, rugby. But any direct blow over the deltoid can cause the AC joint to rupture. And you can get a rupture of your AC joint. They grade these from 1 to 3, where 1 is the mildest and 3 is the worst. And usually you have pain. It's almost like the Vulcan nerve pinch. You pinch right there over the AC joint, and big guys like me go, ah! It hurts right there if you've done your AC joint. And then you'll get a bump. You'll get a lump. There'll be something there that you can feel and palpate. The x-rays may be negative. What I mean by negative is you can't see a grade 1 separation necessarily, a grade 1 separation of the AC joint, because the joint isn't separated. It's lined up. The fibrous band, that ligament, is disrupted, but the joint still lines up. So you see the joint line up. A grade 2 separation is where that is popped up slightly, but if I pushed my 2 fingers together, which represent the acromion and the clavicle, they would still touch. They would overlap. That's a grade 2. A grade 3 is where if it's disrupted and you push those 2 bones together and they would no longer touch. They would no longer interact. That's a grade 3 separation. It's pretty simple management though. Rest. Tylenol, Advil, I should say ibuprofen and acetaminophen, and some time, maybe some physio. I could still feel it 6 months out when I did my shoulder on the one side if I got my arm just in the right position. And so there it shows the separation, right? It lines up. That's a grade 1 if you've disrupted it. A grade 2 is it's overlapping when you push them together, and a grade 3 is complete disruption. Shoulder impingement syndrome. So if the soft tissue gets irritated from repetitive strain, from direct trauma, friction, anything like that, it's going to interfere with the gliding and the lifting up or the abduction of the shoulder. So down here it's okay. So you got this pulley system running through my shoulder, and it pulls up to the point where it's going to be impinged. So from here to here it's okay, the first 30 degrees. But then the next 30 degrees it's like, ah, and then you get beyond that and it's pulled through that impinged area, and there's no pain up there, or it's minimized. So you get this painful arc where you go fine, ow, and then fine again. Treat it with oral anti-inflammatories, medication, stretching exercises, rest, time. Time is a great treatment. And so this just zooms in a bit and shows you on that pulley system, and you've got a bursa in there, maybe you got a bursitis in there, and you pull that pulley, and as soon as it hits that bursa, or as soon as the tendon that's been disrupted hits where the bursa is, you can see where it could flare up and get impinged and hurt. And then we talked earlier today about calcification, right? When we were talking about pseudogout in the knee. Well, have you ever taken an x-ray and gone, ooh, it looks like they broke off a piece of their humerus right at the top there? And that's a calcified area. And can you imagine that little piece of bone, and then you pull on the pulley, and it gets jammed up as it's trying to slide through? You can see why they'd have a painful arc there. You know, rest and NSAIDs, but that's calcified. Steroids sometimes, right? Steroids sometimes with some injections going on can help. Bicep tendon rupture, this is the Popeye arm, boom. The gun show, which way to the beach? There's gum in my shoe. But this is the big bicep that all of a sudden pops right up. And you see this on when you get these isometric contractions, and isometric means you're contracting your muscle, but you're not moving the elbow joint, or you're not moving the joint itself. So isometric contraction, so you're pulling like this, so it's heavy lifting. So if you're doing lifting like this, you can pop the bicep tendon. And we've seen those guys in the gym. It's like, bro, do you even lift? Right? And so they'll be down doing their curls, right? And they've got these massive bars on there, and what do? They go, right? And their elbows aren't moving, but they're just arching their back up and down, and they're doing core work, I think. But they'll pop their bicep because it'll be sitting there like this, not moving, right? It's just fixed position, doing these kind of maneuvers, and pop, and they come in with this pop tendon. Fluoroquinolones, we mentioned that earlier today, right? So a fluoroquinolone can put people at risk for this. Having steroid injections can put you at risk. Rheumatoid arthritis can put this at risk. All right, thoracic outlet syndrome. So you have this thoracic outlet where you get this neurovascular bundle heading through and bordered by the scalene muscles in your shoulder and the first rib and the clavicle. So there's an area where you can get impingement, and it's called the thoracic outlet syndrome, and you get compression of that neurovascular bundle. So you can imagine if you get pressure on a artery, you can get some pain. On a nerve, you get some tingling, right? So you get discomfort in your arm. And so it can cause compression of just the artery, just the nerve, or both. There are two different tests that you can do for this. One's called the Adson test. It's a little difficult, and I've never actually picked up a case, but there's 300 people in this room. You may pick up a case doing the Adson test, looking for a thoracic outlet of an arterial impingement. And that's when you take the person's arm, you put your fingers on the bumpity-bump thing. That's the radial pulse, the thumpity-thump thing right there. You put it on there, you feel that. You have them put their head to the side that's affected, over to the side, twist, and back. And that'll pinch off there, and you lose their pulse. That would be cool. I have yet to see that, yet to experience that. But I think that'd be pretty cool if you did the Adson test and figured that out. Now, the other test is called the EAST test. That's where you elevate your arm stress test. EAST test. I'll demonstrate because it's fun. So I showed you the Adson test. The EAST test is you put your arms in the air and you wave them like you just don't care. But actually what you do is you do this for 3 minutes. And this will do arterial and nerve. And you sit there and do that for 3 minutes, and you start getting pain, numbness, tingling, discomfort, heaviness in the affected thoracic outlet side. That's a positive EAST test. Doing that, looking for a thoracic outlet syndrome. You can see why I like doing that. All right, clavicle fractures. This is one of the bones that you can break at any stage in life. So you can break this bone from the day you were born, right? If you had a vaginal birth and you were pulling and you had your clavicle broken, and if you get that Erb's palsy injury or whatever like that, but you can break the clavicle when you're born and to the day you die. You could fall and break your clavicle. So this bone can be broken throughout your whole lifespan. And for my whole lifespan, most of the time, it was just put them in actually it was a figure eight, but now we're not doing figure eight so much anymore, just a sling. But I've noticed over the last 5 years that things are headed towards, if it's a distal third, if there's tenting, if it's really displaced a lot, they're putting plates along these now, plates and screws. And so this will be, just immobilization with a regular sling, adequate pain control, and refer to an orthopedic surgeon. And I prep the patient. I used to say, oh yeah, these don't get fixed. Now they do. Now some of them do. But that, I'm always saying, I'm the physician. I'm not a surgeon. So that's a discussion between you and your surgeon. And you'll have that discussion about whether your injury pattern of your clavicle, and it's usually the distal third, and it's separated, and it's tenting and stuff like that, is a good candidate for surgery. And so they used to do this lift and separate, right? This sort of thing. We don't use those anymore. That caused axillary nerve problems, right? You'd pinch off the nerve, and the axillary nerve gives sensation to the deltoid over here on C number. Thank you. Oh, see how good she is? Julia, I think you deserve a free course. I'm just saying. We'll see what I can do for you. Okay, but holy smokes, you're at C5, yeah. Axillary nerve, right? So now we're just doing this, so we're not getting that lift and separate sort of thing going on. Rotator cuff. This is what a lot of people come in with, right? Tearing of the rotator cuff. One of those four muscles, supraspinatus, infraspinatus, teres minor, subscapularis, right? And it's pain, right, with abduction, moving the arm out, not in, out over 90 degrees, and external rotation and internal rotation. Both of those movements can cause pain to the rotator cuff. Now, there's lots of causes, direct trauma, of course, tendinitis, overuse injury, those types of things. Lots of people get tears in their rotator cuff. So the mechanism, well, these four muscles, I usually put my hand on the person's shoulder with my thumb being up front on that shoulder, and I say that's teres minor, and then you have these three on the back, one that goes above the spine of the scapula, supraspinatus, one that goes below the spine, infra, below, and then one that's underneath, like a submarine, that's subscapularis. And patients love it when you explain that while you're examining them. And so you show how that will hold the shoulder, those four ligaments, those four tendons will hold the shoulder into the shoulder girdle. And if you disrupt it, you get a dislocation. And you know these people, they come in, they're usually young men, and they come in holding the arm like this, and they've got that boxed off squared shoulder. It's sort of like, yeah, that's dislocated, right? It's sort of like the fractured hip, right? Externally rotated and shortened. I see this person holding their arm, and they've got that squared off shoulder, and they're like, ah. Yeah, that's usually an anterior dislocation, and most are anterior. There are some posterior. Usually you see those in lightning strikes, so they don't happen that often, and seizures. And the problem or difficulty or challenge with seizures is you can get bilateral dislocated posterior shoulders. So when you look at the x-ray, they look symmetrical. And so that can be a difficult problem, especially if it is somebody who has had status epilepticus and you have sedated them and you've intubated them and then you've got the post-intubation film, right? And you're checking to make sure your tube placement is correct. And you get that chest x-ray and it looks great and you're looking at the tube and you're not looking at the shoulders. And it's bilateral dislocations. And it's not until they wake up in the ICU going, I can't move my arms, that somebody goes, uh-oh, could this be bilateral posterior shoulder dislocations? So just watch for that when you have someone who's had a seizure, make sure you check their shoulders. And then you've got the luxatio erecta, and that sounds like a cool hotel on the Vegas Strip. But that, doesn't it? It's a little blue pill. Some people got that joke. But that is a very rare one. And the people come in with their arm up like this. How's it going? High five, man. Dude. Right? And they got their arm up. They can't put their arm down. You go put your arm down. They can't. Okay? They can't. It's an anterior-inferior shoulder dislocation. So it's anterior, but it's a subset of the anterior, and it's very rare. I've only seen one so far. Anterior, and they'll come in with their hand up, and you're like, high five, high five. Okay, so shoulder dislocations. Check their neurovascular status. Yes, you've got a job. C5, checking that axillary nerve. And then relocation often requires pain control, but you don't necessarily need to do it. You don't necessarily need to sedate the patient. You can relax the patient, you can talk to the patient, and you can do something called the Cunningham technique. Happy to show people. There are YouTube videos on it, and they do it without analgesia or sedation necessarily, and you can get a reduction from that. There are different techniques for preparing, though. You can do procedural sedation. So you can sedate the person. You can give them some analgesia or just an oral benzo or something like that. You can do an interarticular injection. You can do a nerve block as well. There was a systematic review meta-analysis just recently published looking at those three different techniques, whether you do a procedural sedation, an interarticular injection, or a nerve block, and there was no difference in outcome. So, pre-reduction films. Do you always need pre-reduction films? If I use that term always, the answer is no, pretty much always. Because sometimes we have people that are repeat dislocators. And if there wasn't trauma involved, let's say it's a young athlete who has dislocated playing volleyball multiple times. They've been x-rayed, and they come in saying, yeah, I dislocated it again. I was up spiking the ball. Did they fracture something? No. Is it probably going to be easy to put back in? Yes. right? And so you don't always need an x-ray. But sometimes, oh, he's waving at me at the back. Hi, hello, how's it going? So sometimes you do, and that's when you have trauma. You have an older individual, they fall, and you're worried about a fracture dislocation. You're trying to relocate an arm, and you're pulling across a fracture. You're not going to get that humeral head back into the glenohumeral fossa because you're opening up the fracture because it's not connected anymore. Does that make sense? So trying to put back in something that's a fracture dislocation, it's much different than just a dislocated joint. So that's why x-rays are important. So pre-reduction films, the older person, pathological fractures, something doesn't sound right. But if it's the repeat person that's always coming in and they've dislocated it multiple times, you don't need to wait and send them off and delay, because that's just going to make it harder and harder to relocate the longer it's out. All right, so I mentioned to somebody earlier the Peter Simon, or Paul Simon song, 50 Ways to Leave Your Lover? Well, there's got to be at least 50 ways to put in a shoulder. I mean, there's so many different techniques, and everybody has a named technique. Just get good at a couple, 2, maybe 3 techniques that you're really familiar with, and use the safe ones. And so there's a whole bunch listed there. There's YouTube videos on all of these different techniques, and the technique you use will depend on your resources, how many people that need to be there. The Whistler technique is not on there, and the Whistler technique, like the Whistler hip technique, is very simple. People dislocate their shoulder when they're out skiing or snowboarding, and it is a large ski hill on the west coast of British Columbia called Whistler. And what people do is the ski patrol would have the person put their hand around their knee like this. They'd push their knee forward, and they'd lean back into the snow or up the hill. And that way they would just do gentle distraction and pull their own shoulder back in. No analgesia, no procedural sedation. Called the Whistler technique. And so the person can know how fast or slow to go. They're personally controlling it. But there are all these different ways to do it. Here's an example of the Stimson technique, where you get the person to have a weight and they lie prone on the bed and it pulls down, and then usually they come out saying, okay, it's back in. There's that technique. There's the scapular rotator technique. I've tried it a few times. I haven't had great success with it, but that doesn't mean other people can't have great success with it. But you sit at the back and you try to rotate that scapula around. The Ferris technique, that's where the person holds this side of the bed, so they give you the counter traction and you pull out on the other side. Or you can have them lying down and pull them off the bed. That's another technique. I tend to have some gentle counter traction with a drape, and then I just gently distract and externally rotate and elevate. Yeah, and it's a modified Hennepin Milch technique where I'm externally rotating and lifting, but to prevent the person from doing this, I get a sheet. They're sedated sometimes, and then somebody will just be leaning back like this, holding the sheet so that I don't pull the body off the gurney. It's a lot of paperwork. Okay, other anterior shoulder reductions. Okay, so there are some methods that increase the risk. It's like the hip, any dislocation. It's about using the forces. You don't have to be big and strong. You just have to be smart about it and have the person relaxed. And that relaxation can come from pharmaceuticals, or it can come from the Cunningham technique, where you're just looking deeply into their eyes, massaging their trapezius, and relocating their shoulder. You can do it. But you wouldn't want to be using the Hippocratic method. And that's where they would put the sandaled foot into the axilla and pull up, right, on the floor. Okay, that's the Hippocratic method. Please don't do that. There's a modified Canadian version of that called the Eskimo, and I think that's probably culturally insensitive now. It's probably called the Inuit technique. But if you're out hunting for seal, and they usually do it in twos, you'd be out there with your kayak. This is the most dangerous position, the arm like this. A wave hits here on this paddle, and boom, the shoulder's out. You're lying on the ice floe, hunting polar bear or seal or something. So instead of putting the foot in the axilla, you put the foot on the chest and pull up, just to get out of there. Please don't do that. All right, so there are some dangerous techniques. Posterior shoulder dislocations. These can be easily missed. Now this one isn't, because it's obvious there's an arrow. So you know, well, there's something wrong. I just don't know what it is yet. But look at that. Look at that head. Look at that humeral head. Are any light bulbs going off? Because they should, because that's the light bulb sign. Because it looks like an incandescent light bulb, right? Normally the shoulder doesn't look like that because you've got an AP view, right? But when the shoulder posterior dislocates, you get the rounded head coming and you get this sort of light bulb. It's also called the drumstick. So it looks like a drumstick. So if you're hungry on shift, think drumstick. If not, if you're like, ooh, I had a bright idea, I think that's dislocated. It's the light bulb. If you live down here, it's also called the gun barrel. No laughs from the Americans. None. Okay, yes, it can also be called the gun barrel sign, or the drum, because it looks like the end of a rifle, I guess. This is the luxatio erecta, with the hand up like that, and literally they come in with their hand like this, forearm to forehead, locked in that position, can't move it. Same thing, inline traction, sedation, externally rotate, pop it in. These things have like major rotator cuff injuries. All right, adhesive capsulitis, a shoulder injury, and if you don't get rehab, and this is the thing we talk about, like you could get a frozen shoulder, you don't get out there and move it. Like, when was complete rest good for almost anything? Like, we don't lie people down, ooh, I threw my back out, great, stay in bed for 2 weeks, see how you're doing. Oh, I hurt my ankle, stay off of it completely for 2 weeks. No, we have progression, right? We have progression, or activity is tolerated. And so the same thing with the shoulders. They can get into adhesive capsulitis if you immobilize the shoulder for too long, and it doesn't take that long for it to stiffen up and you lose that mobility in the shoulder. And so you see it more in the older individual. And then you can prescribe Codman exercises, and you can print off sheets, you can refer them to different websites, and it's basically hanging over and doing small circles or writing the alphabet or something like that with your arm. So there's an example of somebody bent over and doing their Codman exercises like that, just to keep it limber, just to keep it moving so it doesn't freeze and lock up on you. Proximal humerus fractures. These are usually due to falls, and we see them all the time, these surgical neck fractures. There's usually a frailer, older individual who's taken a fall, and they break it here, and it's sort of like, that's why you get the x-rays. It's like, you'll see a deformity, and you go, I think that's dislocated. If it's the young, healthy individual with no trauma that comes in like this, but they were just spiking a volleyball, that's a dislocation. If it's an older individual going, oh, don't bother, dear, I'm sure it'll be fine in a day or two, right? And it looks sort of off, I would think that's a fracture of the humerus, and get an x-ray on that. And they've got all these different fracture patterns. Do I know them? No. I mean, if it's in multiple, I just, it's smashed. It's broken lots. It needs fix, right? So I don't get into the details. And it's usually just a hanging sling for that, and a referral to your orthopedic surgeon. Proximal humeral fractures, there's one, but this is fracture dislocation. If you've got a fracture dislocation, this is a consult to this. I'm not attempting to put those back in. Those need orthopedic procedures to put that in, and adequate pain control. And look for other injuries, because fracture dislocation took a lot of force. Midshift fractures of the humerus, so if you break your arm up here, but mid-shaft, so not up near the shoulder, but mid-shaft, the radial nerve runs down there. I'm going to rely on my expert, Julianne. What does, hey, can you tell me what the radial nerve does? That's right, yeah, thanks. Yeah, so extension of the wrist. So you may lose extension of the wrist. If you have a humeral fracture, you can get a radial nerve injury, and you can't do this. And everybody remember what the median nerve is, right? British? Pick up your T, flex at the wrist, flex at the elbow, pronate. All right? Told you it was easy. And refer them to ortho. That's it. Thank you. You got Jan now. Yay! We're not worthy. We're not worthy. Questions, concerns, comments, Jan? Yesterday we dressed the same. I had a blue top. You had a blue top. We tried to match. Today we don't. She's like, "Arr."
We are running a little bit late. It's not your fault.
Am I?
Yeah, no, you're not. I mean, you did it on time. We're just running behind in general.
Oh, okay.
So
all right.
this is the last talk of the day. We're running a little bit late, but that's okay. We're just cramming in more and more knowledge, Okay, so we're going to talk about abdominal pain. This is actually, we have 2 lectures on abdominal pain. We have this one, which is really about lower abdominal pain, and then tomorrow you'll get a lecture on upper abdominal pain from Mike Sharma, who's outstanding. So this is kind of a 2-parter, half today, half tomorrow, and we're going to talk about the lower half today. So, the patient who comes in with lower abdominal pain, there is a huge differential on the table here. And the purpose of this list with all of these different possible diagnoses is not that you have to memorize all of them, but to recognize that there could be a lot of things going on in that lower abdominal pain. It's really easy to make mistakes here. And so where do we step into it? Where are the pitfalls here? One of the pitfalls is when you find yourself writing gastroenteritis as the diagnosis, to just stop and think twice about that. It's possible. People certainly get gastroenteritis, but you have to have gastro and enteritis to really get to gastroenteritis. And you just want to make sure you're not missing something in that patient. So that's one of the diagnoses that's often linked to mistakes, that kind of generalization. But there are patients that we want to be especially careful with. Certainly in our elderly patients, these are cases where we want to test liberally, we want to consult liberally, because there are some disasters that can happen in that population. So let's start with some of the common stuff. Often we want to call people constipated. Are there people who have constipation as the etiology of their lower abdominal pain? Maybe, but remember that constipation is really a symptom more than a diagnosis. And it is really a diagnosis of exclusion. Before you reach for constipation and they tell you how they haven't pooped in this many days, etc., just make sure that you're not missing something there, because often people who have something serious going on can also have constipation. A lot of people want to reach for plain x-rays to look for whether someone's constipated or not. It is really not a good test for answering that question. Yes, can you see someone filled with stool on a CT or a plain film? You can, but does that mean that that's exactly what's causing their symptoms? Not necessarily. So don't over-rely on plain films to reassure you, oh yeah, they're constipated, that's what's going on. Not a great test. And so just think of constipation like nausea or vomiting as a symptom, not necessarily a diagnosis. What are the common things when people do report constipation and you do think that might be what's going on? They're otherwise not focally tender, they don't have a fever, there's not much else going on. Think about what could be causing it. One common thing that causes constipation is medications, and narcotics in particular. We send lots of people home on narcotics, not as much as we used to, but there are a lot of people who are taking narcotics for different reasons, and narcotics are famous for causing constipation. The other thing to think about is whether someone could have a fecal impaction. Are they actually impacted there? We do see debilitated people who've been in bed, they can't get the poop out, our nursing home patients, for example, and undertaking fecal disimpaction can be a major undertaking. I have done lots of fecal disimpactions. Sometimes they require procedural sedation if it's really going to be uncomfortable, but you think that's what they need. So, consider whether or not you want to undertake that and think about it in a way that, yes, that may be what they need, but, it is kind of a big deal in some cases, but that may be really what you need to do to get things taken care of. Think about, being liberal with your labs is okay. You may end up with constipation, but ruling out other things, you're going to need more information sometimes to get there. And it could be that you end up CT scanning that patient, especially if it's an elderly patient who's a little bit tender and you're not sure what's going on. There's lots of things to do for constipation. I wrote the chapter in Rosen's, the emergency medicine textbook on constipation. It was one of the first chapters I got assigned. I was a junior faculty person, very ambitious, give me an academic project, and my boss at the time was one of the editors of the Rosen's textbook, and he said, Jan, do you want to write a chapter for a textbook? And I was like, yes, I would love to write a chapter for a textbook. I can't wait. And I'm thinking to myself, oh, I hope it's like Airway or it's something like, procedural. That'd be awesome. Everyone will think that I know a lot about it. And so I was like, all right, what's the chapter? He's like, constipation. I'm like, oh, great. That's going to be I'm going to be famous for all my knowledge on constipation. But I did learn a lot writing that chapter. And I did learn that there's lots of ways to treat it, that's for sure. And so, having your favorite go-tos are certainly, something that you want to have in your back pocket. All right, the other end of the spectrum is certainly diarrhea. We see a lot of people come in for complaints of diarrhea. It's most commonly viral if we're talking about infectious diarrhea. What does viral diarrhea look like? Well, if you were to do testing of the stool, which you don't need to do in all cases of diarrhea, but if you were to look for fecal leukocytes or blood in the stool, they wouldn't be there. This isn't an invasive type of diarrhea, and often people just don't present to the ED with this type of diarrhea because it's very self-limiting and mild. But we do have people who are sick with diarrhea, and there can be invasive organisms that can cause a lot of cramping and a lot of pain and even bloody stools. Campylobacter, Shigella, Salmonella, all of these things are more invasive and can cause more serious forms of diarrhea. Another form is people who've been traveling, and that should be one of the questions we ask people who present with diarrhea. Have you been somewhere? Have you been to Mexico or somewhere else where you've acquired E. coli and you have traveler's diarrhea? That is, a bacterial type of diarrhea as well. There's also staph diarrhea, which is particularly awful if you're vomiting and, pooping at the same time. That could be pretty bad. But, diarrhea is all over the place. There's a whole laundry list of causes of diarrhea that we're not going to get into here, but let's just talk about the approach to the patient. So we take a good history, we ask about travel, we ask about immunocompromise, how many days, and really what we should be thinking about also is this patient dehydrated from this diarrhea? That's really often where we can make a difference. Sending stool cultures and doing, stool studies is not indicated in most cases of diarrhea. It really kind of depends on the patient in front of you and what you think is going on or how long it's been going on for. Certainly you could have sick people who are presenting with diarrhea that may be a symptom of something else going on, and in those cases maybe you do want to send some specialized testing, but think about what you're looking for before you reflexively do it. Diarrhea in kids, for the most part, is going to be self-limited as well. If there's really not bloody diarrhea and they look pretty good, just focus on the rehydration of the kid in front of you. Should I give antibiotics or should I not give antibiotics? And this is a little bit of a controversial question, and I always like to think about what would I do for myself in that particular circumstance. Often, a few days of antibiotics and some loperamide is usually okay for something like a routine traveler's diarrhea. Is it absolutely necessary? No. But if they're particularly suffering, that's okay to do. It's not an unreasonable thing to do. Just don't use this, overuse antibiotics in this particular case, because antibiotics can cause diarrhea themselves. So it's not always the answer. One thing to do that you should think about in patients with diarrhea is Clostridium difficile. So C. diff is certainly a problem that we have to consider, and that's what we want to, we always want to run through those emergent things in our mind, and this is one of them. So we are seeing more and more surges of cases. We learned often that C. difficile is something you get from using antibiotics, but there are a lot of cases that are not associated with antibiotic use, but we should ask about recent use of antibiotics. If they have a lot of diarrhea going on, if it's bloody, if they look pretty sick, this is definitely something to think about. And if they've recently been in the hospital, definitely something to think about. Most of us now have access to a PCR C. diff test. This is a test that's very sensitive for this organism, so we want to send it when it's indicated. Some people can be colonized with this organism, so we want to send it when they really have significant abdominal pain and real diarrhea, and we really want to know the answer to this question. We don't want to get a lot of false positives. So think about, really what they have going on before reflexively sending this test on people that don't look so bad. If I do need to treat C. diff, what if they do come back positive for C. diff, or I really have a high suspicion? Know that the guidelines did change just a few years ago. It used to be that metronidazole was our first kind of go-to antibiotic to treat C. diff. That was changed by the Infectious Disease Society guidelines a few years ago. So now the current recommendations, our first line is oral vancomycin, not IV vancomycin, oral vancomycin, 4 times a day, or a drug called fidaxomicin is also kind of considered first line now. These are expensive drugs, but these are the first lines that are recommended. And then metronidazole is more of a second line drug as well. People can be very sick from C. diff. They may even need surgical consults if they're quite toxic, so keep that in mind. Vancomycin is on the list there for patients who are really, really sick, in addition to IV metronidazole as well. If they have recurrent C. diff, there are some recommendations for that. You could look that up if you find yourself in that circumstance. If you do think someone has C. diff, as soon as you walk out of that room and you're thinking this could be C. diff, put up a contact precaution sign. It's better to be safe than sorry. One of the ways that this thing gets spread is from healthcare workers spreading it around. So we want to make sure also that you're not gelling in and gelling out of that room. You have to wash your hands to really make sure you're dealing with the C. diff spores. So contact precautions important, and be washing your hands and gowning up and all that kind of stuff. All right, let's move into some other diagnoses for the patients who present with lower abdominal pain and spend a moment talking about appendicitis. And the reason that we spend a lot of time talking about appendicitis is that, yes, it's common, people get it, and it can be a really tricky diagnosis. Turns out patients don't read the textbooks, and they don't always come in with all the right lower quadrant pain and fever, and I'm not eating anything, and all the classic signs and symptoms. So this can be a pretty high-risk diagnosis. Certainly infection, inflammation from an appendicolith is often the cause. They don't always have an appendicolith. How long they've been obstructed can relate to when they will actually perforate. And so, about a fifth of the time, they actually don't even have a physical obstruction there. The classic history for appendicitis, if the patient reads the textbook, is, yes, I kind of had pain around my umbilicus, and then it migrated down to my lower quadrant, and I'm tender right when you touch me there, but we know that they often don't present that way. The ones that often don't are our elderly patients and our kids that can't always tell us exactly the story or manifesting it in different ways. People can be constipated. Some people may or may not tell you that they've had a fever. Some people are feeling hungry. Some people are anorexic. It's really all over the place. And time to perf really varies, so it's hard to know for sure how much time do I have from when they present with symptoms to when they might perf. And actually, sometimes if people do perf, they feel better when that pressure is relieved. The only thing you can really count on is they should be tender on your exam. That tenderness on exam is something that you can rely on. Otherwise, this would be, an open question all the time. So an exam is really important here, and you should find some objective form of tenderness. Everything else is all over the place. I have seen appendicitis with a normal white blood cell count. Don't let surgeons tell you that the white blood cell count isn't right for appendicitis. There is no right. It can't be too high or too low. It can be all over the place with this particular disorder. And some people can have diarrhea. So it can be a really tricky diagnosis. And the less your patient can tell you about what's going on, the more you want to keep this kind of up at the top of your list. This is also a really common surgical disease in kids, of course, and so we need to consider that. And often they can't tell us, again, that kind of classic history that we might be looking for. They can have, again, diarrhea, constipation. They can even have dysuria as a chief complaint. Always make sure you press on that McBurney's point, press looking for that abdominal tenderness. It turns out when you look at lawsuits for when we do miss appendicitis in kids, and you look at those charts, what did we think it was when it turned out later to be appendicitis? The initial things that we've written on charts when we miss it are gastroenteritis at the top of the list. URI is number 2. And isn't that interesting? How could I confuse a URI for appendicitis? Well, most kids are running around with snotty nose. And imagine the kid comes in with a snotty nose and a fever, which is very quickly ascribed to URI, but did you push on that belly? Did you actually do an abdominal exam in the snotty nose kid? Just take a quick push on their belly. That's my word of advice. There's no harm in doing it. It's very quick, and maybe you find they're actually a little more surprisingly tender there, and now all of a sudden your calculation changes. So that is one of the things to think about. Pneumonia, sepsis, UTI, also all on the list. Let's talk about imaging for appendicitis. Imaging, technically, if you had a classic case, young male, the differential diagnosis list is pretty small. They're tender right there. The story's really good. Maybe you have a surgeon that won't require imaging. And there are those surgeons out there that will take that case to the OR. But there are a lot of surgeons these days that want the imaging. They want to know whether or not it really is this. And it's true that you can be fooled. There are a long list of API mimics. Ultrasound is really kind of our first go-to, especially in the younger folks that we don't want to radiate to their abdomen with a CT. So ultrasound is becoming more and more a first-line choice, especially in young patients. CT or MRI is where you would go if that ultrasound is inconclusive. Now, many people will say, I don't have access to ultrasound 24 hours a day. Totally get it. You're going to have to use what's available to you, and it may just be that CT scan is what you got. Often people also say, well, ultrasound, I always get back a reading that they can't see the appendix. And, if we don't order them, our technicians won't get good at doing them. So ultrasound is a good place to start. And the more your techs get used to doing it, the better they'll get at finding it. Because CT radiation to the abdomen is significant, especially to young patients. What about contrast? Well, oral contrast is not necessary. If you look at the radiology literature, their own literature, it is certainly not necessary to make this diagnosis. IV contrast is a good idea and recommended, but even if you had to do a non-con CT, you can find appendicitis. So your radiologist will probably want you to use an IV contrast. They may also require you to do oral contrast, but just so you know, the literature is out there that doesn't necessarily support that, but you can only do what your radiologist wants wants you to do. MRI protocols are out there also for kids, pregnant women that you don't want to radiate, and that is a totally reasonable option to look for this condition. The management of appendicitis is still the cornerstone, is go to the OR and take it out. But let me tell you that the landscape of this is changing. There are more papers coming out to support the use of antibiotics only instead of a straight to the OR strategy. But regardless of what you hear about that, know that those papers exist. Your surgeon isn't crazy to recommend it, but you're still calling a surgeon for appendicitis. This is not something that we're doing in the emergency department, just deciding to put someone on antibiotics and send them home without consulting a surgeon. But there are patients who are not good surgical candidates. Maybe they don't want to go to the OR. There might be reasons that the surgeon could choose to try antibiotics, and it's not unsupported by the literature. Some people go for IR drainage if they've perfed and have an abscess. So there are a variety of approaches, but still the standard of care is going to the operating room. But really, you call a surgeon and put the ball in their court to decide what to do next based on your findings. Often they'll ask you for pre-op antibiotics, and that's a common thing for us to do. Let's move on to diverticulitis, another common thing that we see all the time. You know, I learned in school that diverticulitis was sort of a disease of older people, but boy, now don't you see diverticulitis in like 30-year-olds and younger people, which is always kind of a surprise. So it really can be at any age at this point. These are those little tiny pouches in the colon that get obstructed and get inflamed. It's usually on the left side. Sometimes people tell you that, yes, they've had it before, it's recurrent. Most of these are now, at least for the first time, diagnosed by CT scan. That's where you find it, you know, plus or minus contrast depending on how your institution's protocols look. At this point, you know, it used to be that all diverticulitis got admitted, and now it's, you know, we've started to move towards outpatient management of diverticulitis for patients that have their pain under control, can tolerate PO antibiotics, and they look pretty good. Outpatient is not unreasonable with a good follow-up plan, because there will be outpatient failures of oral antibiotics. So if they look pretty good, the labs look okay, they can go home with oral antibiotics and a good follow-up plan. Usually in terms of antibiotics that you can choose the combo of ciprofloxacin and metronidazole. You can also use a quinolone. You could use Augmentin is another choice. So there's a variety of options there. CT scan is not always required in diverticulitis. If they have a history of known diverticulitis, they're presenting with that left-sided pain. Again, they look really good. Sometimes they've come in earlier because they've been through this before. It is reasonable to start them on antibiotics and not CT scan them every single time. Okay, another emergent cause of lower abdominal pain that we have to be aware of is sigmoid volvulus. This is basically where the intestine twists upon itself and can lead to some pretty bad ischemic complications. Now, in the sigmoid colon, when this happens, this is usually in patients who have limited mobility, they've been chronically constipated, and basically this is a disease of that, where things twist upon themselves. Very different from cecal volvulus that we'll talk about in a moment. If you do a plain film, there's some classic findings that you can see, but most of the time, because the differential's unclear in this elderly patient with abdominal symptoms, you're doing a CT scan and that's how you're finding it. These don't always have to go to the OR. These can be treated, actually preferentially often, with decompression, sigmoidoscopy and decompression of these rather than operating on them. This is that classic plain film. If that's what your first line imaging and that's what you have, you can do a plain film, and this is what you would classically see. You'd see this sort of kidney bead thing pointing up to the upper quadrant, and this is what a sigmoid volvulus would look like on a plain film. Cecal volvulus is different in almost every other way. It's on the other side, it's on the right side. It happens in younger people. It happens because of a congenital difference that they have. They have a congenital mobility of their cecum, and so the cecum flips over and twists upon itself. This is usually, again, something that you diagnose on CT. You could never distinguish this just clinically from a lot of other things. So you get the CT, you find this, you're often surprised. It turns out this is one of the most common causes of bowel obstruction in pregnancy, which is very interesting. And this one only gets treated surgically. There's no decompression kind of procedure for this. They go to the OR and get this thing fixed because they're often young and it's pretty acute. And we're talking about something that's potentially ischemic. So they go to the OR. This is what their plain film, their kind of classic plain film looks like. It's even more like a kidney shape here. And you see that really what you're talking about is an ischemic part of bowel that may have to be resected if we can't get to it in time. So often, again, the differential diagnosis would be pretty broad, and the CT scan will get you there. Okay, let's talk a little bit about some of the inflammatory bowel disease, Crohn's disease. Now, we're not making the diagnosis of Crohn's disease in the emergency department. This is a diagnosis that's made usually on a colonoscopy with a biopsy, that kind of thing. But we have people walk in with this diagnosis, and we may suspect it in some patients when we hear their story and kind of take a look at things. But this is an inflammatory disease that can involve the entire GI tract, from mouth to anus, the entire thing. And again, it's not something that we're necessarily making that diagnosis. They often have diarrhea, they have bloody stools, they can have a lot of abdominal pain, and really surgeons are reluctant to intervene surgically in these patients because this is an inflammatory disease of the entire tract. Just because I'm dealing with this complication means that it can still happen anywhere else. So surgery is really reserved for like the bad complications. If they are coming in with a flare of Crohn's disease, for example, often they get admitted for hydration, maybe some antibiotics, some more immunosuppression to see if we can kind of cool things down before anything has to go anything further. Know that they have a lifetime increased risk of cancer. CT will often show you the enteritis that they're suffering from, and they can get a variety of other extra gastrointestinal manifestations like kidney stones and arthritis and rashes and a lot of autoimmune type things. The course in their life has changed for the better with the introduction of a lot of the monoclonal antibodies that are available now. You know, the trade names of Remicade, et cetera. People's quality of life that have these diseases has really changed for the better with these newer medications. We don't see quite as much of the terrible complications anymore, and they don't have to live on lifetime steroids, which is fantastic. Ulcerative colitis is another inflammatory disease of the bowel, but this one actually is limited to the colon. So if you were to take out the colon, you are done with ulcerative colitis, and it is limited to that part of the bowel. Not that you'd want to do that, but just so you know, that would be technically curative for them. They also have an increased risk of cancer. This is only in the colon and the rectum. It can bleed, it can hurt, it can obstruct, and they also will get supportive care. They're often on immunotherapy, and they may also be on one of these monoclonal antibodies, and they could have extra gastrointestinal manifestations as well. I think one of the pitfalls here is when patients carry this diagnosis with them and they present to you in the ED with pain, to not forget that these patients can still have appendicitis, kidney stones, other things. It's not always a flare of their Crohn's or their UC disease, but to make yourself not anchor on that and bias yourself towards that diagnosis, but to step back and think, what else could this be? Am I sure that that's what's going on? And to talk yourself into that rather than, the other way around. So make sure that you're not missing other things in these patients. If it's a female with one of these conditions, they can have gynecologic problems. They can have other things going on that you need to consider. We see a lot of patients with bowel obstructions, and these can be pretty dramatic. There's really the two most common causes for people to have a small bowel obstruction are they've had some kind of abdominal surgery in the past and they have adhesions, or they can have an incarcerated hernia. So I always ask people about their past abdominal surgeries, and that gives me an idea of how at risk they may be for small bowel obstruction. Malignancy is lower, lower, lower on the list for small bowel obstruction. It's higher, higher, higher on the list for large bowel obstruction. Patients come in with a lot of vomiting, they feel terrible, they can have a belly pain as well, and you're going to need imaging to kind of get to this diagnosis. And also your surgeon will often want to know where the transition point is. What is the anatomy of this bowel obstruction? So CT is really replacing plain films for this, although plain films, if that's what you got, you're going to start with that, and you can see those classic air fluid levels in most cases. It's not a perfect test for this. CT is much more specific. These days, these aren't all getting rushed to the OR, are they? A lot of them are getting watched, having supportive care, and being followed often with gastrographin. They're taking oral contrast, a serial fashion, and seeing if at some point it will pass. So they get IV fluids, analgesia, plus minus on the NG tube. Often your surgeon will want you to put in an NG tube. That's not always required. You can have a discussion about it. NG tubes are one of the worst things we do to people. They are so uncomfortable, and it's not always absolutely indicated. For someone who, though, is obstructed and vomiting a lot and very, refractory to your antiemetics, it can be really useful to decompress someone with an NG tube, but it's also just not something to just reflexively do in everyone. So electrolyte imbalances can also be there. So these are plain film pictures of those air fluid levels that you can see, but let me tell you that CT scan is a lot more sensitive. Large bowel obstructions are not as common. Malignancy is much higher on the list, but you want to think also about things like intussusception and diverticular disease and volvulus would all be on your differential diagnosis. There are specific plain film findings as well for large bowel obstructions, but often, again, you're going to CT that's going to give you this diagnosis. They often have pain. They have a lot of constipation. They may have even feculent-smelling emesis, which is pretty unpleasant for them and for you. And these ones do require an NG tube and IVs, and they're all getting admitted, and most of them are going to surgery for sure. So these imaging here, some pictures of what large bowel obstruction looks like. You can see the haustra in terms of the large bowel pattern, and the CT will give you a lot more information. Mesenteric ischemia is one to put an asterisk by. This is one of those emergency diagnoses that we really need to not miss. It can carry terrific, terrible mortality and morbidity for patients, and we definitely don't want to miss this. And this is ischemic bowel. It can be fatal. It often happens in older patients who really don't do well with ischemic bowel. So what is this? This is decreased blood flow to your mesenteric, to the gut, basically. It can happen because they've thrown a clot there, or they can have thrombosis, or be in some kind of a low flow state. That might be a patient who's in the ICU with sepsis, low blood pressure, and they get ischemic gut from the hypoperfusion that may go with that. So your older folks, those who have AFib, maybe digoxin or something's on their medication list, they're a vasculopath, diabetic, they're really sick, think about mesenteric ischemia. And often the clinical story, when you hear an older person that has a risk factor, they're telling you about this terrible pain they're getting, and you examine them and you're kind of like, not really localizing this to anywhere, but they're telling you about this excruciating pain. Think about mesenteric ischemia. If you think about it, this is one you want to call a surgeon on, and you want to be kind of on top of it if everything's sort of pointing in that direction. They've got bad AFib, they're a vasculopath, it sounds like it. This is something you want to involve the surgeon early because outcomes could be pretty poor. They usually will have a pretty significant leukocytosis because of what's going on, and I would send a lactate to take a look at that number as well. Is it 100%? No, but it can also help you talk you in or out of this diagnosis. CT with IV contrast is the way to go here. They're often going to go to surgery. They could even go to IR for some kind of interventional procedure, but often we're behind the 8 ball on this one, so we want to always think about it early at least and kind of have that on our differential and then talk ourselves out of it rather than discovering it later and thinking, oh God, I should have been thinking about this earlier. Hernias, we see a lot of patients with hernias, some good, some bad. Some of them are really straightforward. Remember that the terms that we want to use when it comes to hernias, incarcerated hernia means that it's kind of stuck, I can't reduce it, but when I use the word strangulated, I mean that I think that blood flow is impaired to it. And if I do think something's strangulated and it's ischemic, that's not bowel that I want to put back. So I want to think about what I'm really dealing with. The two most common types of inguinal hernias are the direct inguinal hernia and the indirect inguinal hernia. But there's a lot of other types of hernias. There are femoral hernias, there are Spigelian hernias, there are umbilical hernias, incisional hernias, lots of different types of hernias. Femoral hernias in particular are likely to incarcerate and get stuck, particularly in women. And we will close out in talking about perforated bowel, another thing that's on our differential for the patient that comes in with lower abdominal pain. This is often not that dramatic. It can be the elderly person who's perfed, for example, and things are like not as dramatic as you might think, versus the person who also can look totally peritonitic and be very, very sick. So it can be a little bit all over the place. One of the cases of perf bowel that I remember very well was an older lady who had fallen. She had a Colles fracture. Someone had put her on some opiates, just oral opiates for a little while. It didn't really tell her about the constipation. She got constipated, and she ended up perfing because of the sequence of events that took her down. So, it could be just a consequence of lots of things. Usually if it's proximal, you're going to have free air, they're very painful, but distals can be a little bit sneakier. CT is the way to go here in terms of defining what's going on. It's way more sensitive for free air than plain films are, but if you want to start with a plain film, that's fine. Make sure it's an upright plain film. You've let the patient sit up for a while, give that air a chance to ride under that diaphragm and give you that positive x-ray. Prompt surgical consult, giving antibiotics, those are the things that we can do, and supportive care for sure. This is what free air looks like on a chest x-ray. Don't confuse it with a stomach bubble. Stomach bubbles can also sometimes fool people. Free air is that, you see that diaphragm, it's really thin and you've got like that black air underneath it. That looks very different than a stomach bubble. So that's what you're looking for when you're looking for free air, is that thin diaphragm with black free air underneath it. CT scan will show you all kinds of air, little bubbles, big bubbles. It'll just give you a much, much more detailed picture. And that is it for lower abdominal pain. Thank you very much. And this is my last lecture here at the boot camp, so thank you for coming, and I appreciate you. And we're going to go into our optional Q&A if you want to stay.
Yet. Hang on a second.
If you want some more interesting information, let's do it.
Couple of things. So first of all, Bill, the PA, is looking for some people to go ziplining with him. If you're interested in going with Bill, it's $33.50, and he'll meet you right over here. Okay?
What
Second
if you're just
announcement.
interested in Bill?
What's that?
What if you're just interested in Bill?
That too.
How much is that? It's Vegas, baby.
I don't know. I got to check his rate. So the next announcement is, again, we will have the live stream tomorrow for you that, you want to get a little crazy tonight and you don't want to get up right at 8. Come on down.
Martha, is the live stream only available live? Is there any recording of it people can watch?
Yes, we keep it saved, but we don't guarantee that everything will be there. It might be a little spotty also for a couple days, so if you want to watch it in the airport, you can. So it'll be there. A couple of other things about the advanced course. It is available for purchase, our prior recording. We don't have scheduled dates for it yet. No scheduled dates for the live course.
Working on it.
It's so much fun.
It is. It's so much
live.
If you think this is fun,
Yeah.
wait till you see us.
We take it to a whole new level.
I mean, wow. And then additionally, we are doing a live broadcast podcast tonight of the two of you. For those of you that have been listening, I know a couple of you I've talked to. You've heard the show. Mike Sharmer's going to be here. It's really going to be a lot of fun. We're talking about boobs, butts, and fingers, respectfully. And we'd really love for you to stay. We'll have a trivia question at the end where you can win a free digital copy of this course.
Ooh,
Rick.
Nice.
well, there you go.
Okay.
Look at all these peeps. Hi, you guys.
Cool.
Oh, look what I did.
Yeah, now
I
they're
scared
leaving.
you all away.
Cool.
It's okay, we don't mind. Go ahead.
Yeah,
Now
that's
look
okay.
what you did.
There's
fine.
lots of things to do here. It's been a long day.
I'm taking a video of all the people that are leaving.
We're taking names.
There goes their
It's
discount.
No CME for
Have
you.
fun.
What the hell?
Wow, okay.
That's
Shoulda
good.
showered.
Okay, come
We-
on. It's good.
We
You know how
won't
long
take,
this day has
take
been
this
for them?
personally.
It's a long day, we know.
It's a long day.
It's a really long day.
All right, let's go.
All right, here we go. Oh boy, Ken, you're going to be all over this one.
Oh boy.
You already
You're
were.
definitely going to put a finger on this one. I was told before that you have to have all 5 Canaveral signs to diagnose flexor tenosynovitis. Is this true?
Is this true, Ken?
Is that true, Ken?
Whoever is making the claim has the burden of proof to suggest that it is true that you have to have 5. But diseases happen on a spectrum, and not all 5 things show up at the same time. And so if I have an index of suspicion of a Canaveral sign, I'm concerned about that person that they've got tenosynovitis. They're getting antibiotics and referred. And I'm not going, oh, they only had 4. Sorry.
That's like the same with
Treat the
compartment
patient.
syndrome,
Yeah,
right?
like,
Compartment syndrome
the
starts with
pain, pulselessness, pallor, all that kind of stuff.
Eventually, yeah.
Eventually you'll have all 5, and then eventually you'll have only 4.
Right.
So yeah, whoever taught you that, okay.
And what's the definition of sausage, right? Do we actually have a measurement for how, like, my
Stop it.
sausage might be smaller or bigger than your sausage. So this is too
You
much.
know-
Actually,
Okay.
and
Now they're really leaving.
well, and actually, one of the things on that, one of the subtexts on that in the replies on this was that this person was told that by kind of an educator, a teacher.
Yeah.
To them.
But I
and
mean,
that is hard, right? Go ahead.
No, I was going to say, but we still hear the no epi in the tips of things. People are taught that still.
Right. So I think the thing on the receiving end of teaching where you're like, not so sure, is to be respectful, say, wow, and I like the answer of saying, wow, I just read this thing of X, Rather than saying, well, did you see the article on such and such, which instantly makes somebody defensive. It's like, wow, I just read a thing. Could that be possible? And then eventually, if you're not going to, just let it go.
Or just where did that information come from?
Yeah.
Where can I learn more about that? Where can I read more about that?
Gently.
Those five signs.
Mike Sharma.
Right?
Oh my gosh,
Paging
Michael Sharma's here.
Mike Sharma.
He's here.
Mike Sharma.
Sharma's in the
Oh
house.
my god, do I look all right? He's here.
Sharma's in the
He's got
house.
his
Oh my
jacket
gosh,
even.
so happy.
No jacket up here, buddy.
No jacket. Okay, so I think that covers that.
Yeah, it's just sort of like anything. These are clinical signs that you're trying to put together. When do we make any decision based on one data point?
Right. Well put. We're going to skip your list of 80s music favorites, but you can.
Movies.
Yeah, but they're pretty great.
I
Yes,
gave them
movies.
a list. I
Movies,
wanted
excuse
to,
me.
like,
My
yeah.
favorite movie's on there.
Yeah, is it? Which one's
Yes,
that?
When Harry Met Sally.
Oh, we
My
could sit up here and
favorite.
talk
What a
about
great-
that all
I'm
day.
such a sap.
I do the
Great
white man
movie.
overbite. See, I know 80s movies.
Yeah, of course you do.
So, Diane, you drove this point home.
I did, and there were lots of questions, though.
Legit on magnesium. I know you did, but
Yeah,
there's still some questions. Can you?
Of course there are.
Okay.
So I'm going to clear this up. If your K is low, and you need to replace somebody's K, there's somebody else's K is low. Yours may be separate, but when you need to replace somebody's K, you need to also give them magnesium. Period. Your magnesium level is not a very good indicator of enough of it to be available to help your body retain the potassium that you're giving them. You need it basically at a cellular level to keep the potassium in your system. It's kind of just a cell membrane exchangey thing, but the reality is just give it. So your knee-jerk should be, and it doesn't have to be IV. I know Martha put in the responses to this thing a whole fancy schmancy sort of trauma way to give people back their stuff. You can do it orally. It doesn't have to be IV. You can do both of the medications orally. But you need to, no medication, the electrolytes, but you need to give MAG with.
Yeah.
Doesn't make any difference with, in fact, don't even measure the MAG level, just do it.
Your kidneys are super smart, and if they, if
They
they
are
don't
really
need
smart.
it, they'll just pee it out. So it's, they'll figure it out. But usually you're also.
But they'll also say,
We won't, but they
ha,
will.
ha, if you don't give me magnesium, I'm going to just pee out this potassium. You need to give me MAG. And,
Yeah.
Although, there is more potassium intracellular than in the bloodstream. It's like the ratio is 30 to 1.
Magnesium.
No, potassium.
Potassium.
Okay.
And so if that's the case, it's like, well, why should we measure K? Likewise, because it's not particularly reliable reflecting intracellular K. So that I think we can make a case for measuring it. I mean, it's not as
Measuring okay.
magnesium.
Magnesium, right.
Because
So I want to make sure, we do really care about what the K is in the bloodstream, right? That's really important. But the magnesium is the one that doesn't get measured very well.
Yeah.
Because most of it's intracellular.
Yeah, most
Yes.
of it's
But most
tied up.
potassium is intracellular.
Yeah.
That's all the point.
Except that it's the membrane. Membrane doesn't like having the potassium out in the bloodstream when it's high.
No, I ain't going.
Yeah.
Okay.
Mr. Sharma.
Glad we cleared that up.
Yes.
Come
This is
over
Mike
here, buddy.
Sharma. Mike is joining us from Texas. He was a major in the Army and was in the Afghanistan conflict where he was a frontline trauma team kind of guy where they fixed him up as best they could and then shipped him interiorly.
I actually never made it to major.
Oh, listen, you said you were a major
They
before.
fixed you up and then shipped you in?
Only amateurs get promoted to captain once, okay? So I got promoted to captain twice, okay? So I was a captain in my paper pushing job before I became a PA, and then you go to PA school, they demote you. Say, thanks for becoming a PA and wanting to give your life to medicine. Let's take away some rank and some pay. You can earn your way back up, so.
Dave's looking at you funny because you really are just that loud. So, because your mic's not on.
Yeah, his mic's not on. That's just Mike.
I heard it,
Yeah,
I heard
yeah.
it not.
This guy,
I was
this guy
isn't
does
it
not
funny?
need a microphone.
That is a
as you
non-mic'd
can
voice.
see.
Yes. Fantastic.
What a
All right, well,
There's
you joined
Mike's
us
Mike
just
plus
in
voice.
time to talk about poop.
Like
So,
Billy
what
Mann.
we would like to discuss now, Jan, there were some questions still about constipation.
Since you are the expert.
Since you wrote the chapter on it.
I'm happy to talk about it.
What are the differential diagnoses to consider liberally with constipation that Jan was talking about?
Well, often constipation comes with some abdominal discomfort. So the things that cause that abdominal discomfort are still on the list. So if I touch somebody's belly with constipation, they're tender in their right lower quadrant, I'm not necessarily just writing off, appendicitis. It could still be something like that. It could be diverticulitis. It could be all of the things. Constipation, it could just be part of their presentation. Any other pearls that you guys want to add about that?
Older people fool me.
Yes,
And
they
I get
do.
a
They
CT
love to-
scan. Oh,
They love to fool you.
98-year-old with appendicitis. Really?
Yeah.
You know, yeah. So
It's just not
be
fair.
wary
Well,
of
and
those.
constipation is more common in elderly people, and more belly badness is more
Yeah.
common in elderly people.
And so
and
they're gonna
just-
overlap.
Yeah, they're going to overlap.
They also say the serosa of the appendix in the older people is more fragile and thinner and predisposes to rupture. I don't know if that's true or not, but they say that.
Right, and they do rupture more often, and initially it was because we didn't diagnose them, but they still do it even with our diagnosing them better than we used to.
Well, a lot of people also, they fixate on their bowel movements, and they really want to believe that what they're feeling has to do with their pooping pattern rather than something serious. So they often may be wanting to believe that it's constipation when really it's probably something worse. So at least it's our job to think about the worst stuff first. If we end up with constipation, we don't find anything else, fine. But, we at least to think about the other stuff first.
This next question about how do you know when to do a disimpaction, I'd like to just tell my brief story about disimpaction. Basically,
I hope it comes out okay.
Yeah.
I knew that was coming. I knew that had to happen.
I had to beat everyone else to the punch on that one.
So I had never done one before, and I was working in an urgent care center with one of my very favorite physician colleagues, and I was trying to put a bunch of procedures on my docket, and I thought, well, he said, this patient needs a disimpaction. Would you like to do that? And I said, you know what, I really do. And he was like, go for it. I said, but I need some help. I need to know when is the time to do it. And he said, you'll know. You'll know. So went in, took a look. The rectum basically has the stool pointing out at you. It's pointing. And
crowning?
It's crowning. And that's when you know, because they can't get that hard ball out. So when you lots and lots and lots and lots of lubrication, warm water, if you have gone to this disimpaction route. I've tried other things before that because less invasive the better. And a warm water dripping on there, gosh, this sounds awful. Dripping on there while you get the lubed finger in to go around the ball. When you can get that out and pull it out,
then the flow happens.
Yeah.
Get out of the way.
You won't know unless you do a rectal exam, so you have to go looking for it. And do you go looking for it in everyone? No. But there are people who are at risk for this, people who are debilitated, they don't have the strength to push the poop out. There's the people in wheelchairs. It could be people who are, very debilitated from cancer, lots of different reasons that people just can't push the poop out, and they've gotten quite constipated to the point that it's just that nothing's working. So, those are really tough situations, but boy, when you relieve them of that, it's just magical. They just feel so much better, and a lot of all their troubles just go away. So it really is worth doing in the right patients.
My brother's mother-in-law had severe osteoporosis, was in chronic pain, and she was put on opiates, and ultimately she became so constipated and couldn't go that she had a rupture of the bowel, and she died of a bowel rupture.
I've seen that.
Yeah.
It's terrible.
Yep, no, for sure. I think, the other key is to prophylax for it, right?
Yeah.
So putting people on bowel regimens that are in these conditions and are on opiates is really, really, really important. A combination of Senna and Colace is probably a good first step, and then you can step it up to other things. But, prophylaxis is the way to go.
If I had a tip to offer for disimpaction, it would be, there is this device called a lidocaine Eurojet, and perhaps this was in the talk already, so forgive me if it was, but it's meant to numb the male genitals before you do a catheterization here. It also works really good to numb the male and female rectums before you do disimpaction. Okay, so I'll squirt that in there, and I'll come back in, the nurse will or whoever, I'll come back in 15 minutes, and there's at least some degree of decreased discomfort. Okay, it's always going to be uncomfortable, but at least you've done all you can do to make it more comfortable.
Yeah.
Excellent. Okay, antibiotics are no longer indicated for uncomplicated diverticulitis per UpToDate.
Yeah, I didn't talk about this because this is out there. This is a real thing, but to me, it's like on the leading edge still. I think for emergency department
it's
care.
Over in Europe.
Yeah, it's like it's out there. It's happening.
It's UpToDate.
Yeah.
I didn't double check that, but wow.
But I don't think that that's really how emergency physicians are practicing yet. We're kind of aware of it, but it's not practice changing yet for sure. Would you guys agree?
I
Yeah,
agree.
yeah.
I
I
agree.
think that's
Although
like-
there's more and more data, and I think the main thing is to find where it really is safe. And being somebody who's been practicing a really long time, back in the day before we scanned everybody with diverticulitis, people would come in with basically left lower quadrant discomfort. They would be a little tender to palpation. They would be afebrile. White count would be normal. We would call that painful diverticular disease and send them on their way. That is probably what the cases are that are filtering out to be they don't need antibiotics, diverticulitis cases now. We know that there's actually some inflammation, but they're otherwise doing great. So I think what's happening is the pendulum is swinging back with more data, and we're finding the niche that we did before, but now we are looking at it on a CT scan and saying this is probably fine because of X, Y, and Z, but I'm still not all in yet as far as this being anything that's standard practice, at least here. I don't know about Canada.
Yeah, it's not been embraced, but the evidence is mounting that there are people that could be treated this way, and so I think it opens up in these minor cases, mild cases, for shared decision making, because you won't be out on a limb if this person has 7 different allergies to antibiotics, or every time they get antibiotics, they go, do I really have to go on antibiotics? I get such terrible yeast infections, or it just makes me miserable. I'll go, well, actually, there is some good data coming out that says in mild cases, you can forego it. What would you like to do? So it opens the door, but I don't think it's a routine thing that, oh, it's mild, you don't need them.
Be careful now. I think we're in that transition
Yeah.
zone.
Yes.
I'd err on the side of being more careful at this point.
That's why it's sort of like, okay, I can justify it by saying we have some evidence, and the patient really doesn't want the antibiotics. So even if you prescribe them, they may not take it. So
Yeah, you don't want to be too ginger about potentially blowing out the colon.
Yeah.
It's
Oh
not very-
boy,
it's not very
diverticulitis is
forgiving.
bad. When it goes down, it goes bad.
Yeah. We get this question, I think, every course in regards to any recommendation or rules of thumb for when we do CTs with or without contrast of the abdomen pelvis.
Yeah. I mean, it's a really common question.
but it's easier now, though, with the shortage.
Yeah,
We don't have any. Okay, I guess
Yeah.
we'll do it without.
Yeah. So times, basically, I mean, this easy answer is do what your radiologist wants you to do because they're the ones reading the films. That's not the best answer because the truth is that there are papers saying that you don't need oral contrast for most of this stuff. For what we used to give it for, we don't give it anymore. The only times that I'm finding myself giving oral contrast anymore are in bariatric patients.
Absolutely.
That's the case
Absolutely.
where you definitely want to give oral contrast to see the pattern, and some specific cases where you know that there's a bowel obstruction, your surgeon really wants it, but otherwise it's pretty limited. There's nothing else besides those bariatric cases that I feel like I definitely want to give it.
Right,
But
right.
there's a lot of radiologists that are still asking you to give it. I acknowledge that.
I'll give oral contrast to very petite people who I'm scanning for appendicitis. Is that the good plural for appendicitis? So like if your BMI is like under 20, and they're, especially pediatric patients under 20, at least our practice locally is to give oral contrast. And then while they're drinking the oral contrast, you can do an ultrasound. Maybe you hit pay dirt and you find that inflamed appy on the ultrasound, and if not, well, then they're ready for their IV and oral contrasted CT.
Those are the people you'll find the appy on, though. That's the right body habitus, the right age. And,
Yeah.
Oh, and when I say bariatric patients, I don't mean just bariatric. I mean people who've had bariatric
Post-surgical.
surgical
Yeah.
procedures.
Yeah,
That's what I mean.
Yeah.
Because those are really
I
hard
understand.
people
Yeah.
to interpret the imaging, and even radiologists with oral contrast have trouble interpreting the imaging on those. So you want to give everybody the best possible everything because they're really difficult to interpret, and the complications they can get are devastating.
Yeah.
Can be devastating.
Okay. Why not admit all patients with either hyper or hyponatremia, since correction must be done over time? 4 hours to disposition in most ERs. Well, there's a lot of variables here.
Right, so there are very few things where the extremes of all or never apply. And that's why we all have jobs and we're all good at what we do, right? There's a range of things. The reality is most hyponatremia is not severe, right? Most hyponatremia or hypernatremia is something we can fix pretty quickly either in the ER or it can adjust itself at home without any danger. It's where it's more profound, where they actually have gotten to a point where they're symptomatic, or they're at a range where correcting them more than what is recommended in the first 24 hours, you should take longer to do. That's a person, often they go to OBS, those people that are the little tweener zone, they just go to OBS. So admitting is actually, frankly, not the rule, it's the exception, I think, for most of the hyper and hyponatremia cases, because they're not as extreme as, most of it's a relatively narrow range of abnormal on either end. Is that other people's sort of?
Yeah, I agree. I see a lot of hyponatremia that's chronic. They've had it before, it's been going on for a while. It doesn't necessarily need to be corrected in the moment. So I think there's so many different ranges here, flavors of this stuff, that it's hard to say all or never. It really depends on the patient in front of you, why they're hypo or hypernatremic, what they clinically look like, are they actually symptomatic, is it in the context of other, abnormalities. So it's hard to say all or never, yeah.
You know who loves to talk about sodium issues? The hospitalist. He'll talk for days about electrolyte issues. Give him a call. Talk to them about the case.
Yeah.
In children who have
Hospitalist.
Hospitalist.
little diarrhea and vomiting, and they're now mildly to moderately dehydrated, the American Academy of Pediatrics say don't order electrolytes, just fix the fluids, and the body's process will fix all of that stuff. So yeah, they might be a little hypernatremic, but everything will kind of smooth out as soon as you rehydrate.
Yeah, we need to overall consider the patient's well-being and focus on them and not their lab tests. And trying to normalize every number isn't necessarily a good thing. Can I discharge someone home with a sodium of 133? Yeah.
Of course you can.
Of course you can.
Yeah.
But they're hyponatremic. Yeah, okay, stop your hydrochlorothiazide.
Yeah, there's
Okay.
a term called euboxic, which comes, I think, from the House of God, where every box is made normal. You just basically, your goal is to, it's the House of God is an interesting book. It's worth a read at some point in your life, but they have all these sort of dictums, and one is to make the patient euboxic. You don't want to make them euboxic, you want to make the patient better.
Okay, Jan, here's one about burns. And I actually would be curious what you know about this for your hospital specifically,
Yeah,
because
the
this
burn
person
center.
is saying that you do not recommend Silvadene for major burns. Do you? It is my understanding that burn centers do not want us to put anything, even saline, on major burns due to problems with residue resulting in problems with grafting.
Yeah, so if you have a patient with major burns, you don't want to slap a bunch of Silvadene or anything really goopy all over the place if you're transferring them. It's okay to cover it with a clean sheet and transfer them. So I don't lather them up with a bunch of goopy stuff.
Just cool saline, like saline dressings
Yeah,
or something?
yeah, you can just
a
do
moist dressing of
yeah,
saline.
a moist dressing, not
Yeah.
and
But
being
not
careful
with
with
goopy stuff.
hypothermia. But
Yeah.
yeah, you don't want to cover it with a bunch of goopy ointment,
Well, and
whether
actually-
it's Silvadene or anything
right.
else.
And I do think that this just mentioned this idea of residue, and I actually have read about this recently. I'm not sure exactly why, but one of the things that is concerned is whether grafts will take, or whether there will be a problem with the grafting if there's something on the skin. That's one of the reasons we don't put goopy stuff.
Yeah.
I think this issue of don't put anything at all begs the treatment part of what we need to do, at least acutely in the ER. Pain control works well, and getting burns kind of chilled out with moist, at least initially.
Moist, yeah.
At least initially. You stick your finger when you burn it under a cold faucet, right? It feels better.
Yeah.
But then transition from that, because they can get hypothermic, to opioids. I will tell you, if anybody in the world deserves opioids, it's cancer patients and burn patients. That's every nerve ending raw with the air on it right now. There's nothing protecting those nerve endings. So give them pain medication, and then what you cover them with, it depends. At our place, we have a burn dressing thing that it's dry, that once they're stabilized before we transfer to you, we put this dry thing on the top. It's just basically a sheet sort of thing.
Yeah.
All right, here's an easy one-word answer. Would sublingual nitro be okay to give initially if difficulty with IV insertion for acute CHF?
Absolutely. The first use of nitroglycerin was sublingual. They were to give 3 or 4 tablets. This was a German study where they first did this, and it worked out miraculously. But the fact of the matter is that giving an IV, you can titrate, so quick on, quick off.
But remember that, because I'll tell you, I don't know, if you're like a lot of people I know in emergency care, you're the person that is on the plane when the call goes out saying, is there a doctor or a medical person on the plane? And I've been on a plane where a patient went into florid pulmonary edema at 37,000 feet. And there were several people involved in the care, but basically got on the overhead when we ran out of nitroglycerin and said, does anybody have any nitroglycerin on the plane? And treated the patient in the air until they could get landed with sublingual sprays over and over and over again of nitroglycerin. It works, it's absorbed beautifully. The dose is 0.4 micrograms. You just go for it.
Did you get any air miles or any kind of thing?
No, and I'm glad I wasn't the only person because it was hairy. It was hairy.
Except no compensation.
Except no gifts?
Yeah, no compensation.
Otherwise, it's not good Sam law.
Good Samaritan.
Okay.
A bottle of wine, nothing.
It's not really going to jail for a bottle of wine.
Right.
That's it.
In patients with diarrhea, when would you consider parasitic diarrhea antiparasitic meds?
So when I see that, I think about people who've been traveling, drinking like river water. I was camping, thinking about Giardia, something like that. People who are immunocompromised. So, you know, you've been overseas, you've been drinking fresh water out of somewhere where parasites live, you're immunocompromised. Those are probably my top three.
And the presentation tends to be more prolonged, right? So you should put parasitic diarrhea in your differential when their diarrhea is more than 2 weeks. So don't order the O&P initially. That's like, no.
Yeah.
That you wait on the O&P until somebody's actually had diarrhea for more than 2 weeks.
Yeah.
Or they have a really clear situation where I was, drinking just down from the beaver lodge that was right up the way.
Giardia. No, that's different.
Ooh, specific. Bill the PA. Oh man, is he here? Did you go ziplining yet?
Not
Oh, Bill!
yet.
Hey, Bill!
There's Bill, yay, Bill!
Now everybody knows who Bill is.
Mr. Bill.
Yeah. Oh, I used to watch that as a kid. All right. Specifically, Bill wants to know, trigger finger slide. Should it be... Bill, do you want to ask your question? Oh,
Yeah,
he did.
it's just a slide thing.
It's just a
an
slide
error
thing.
on the slide.
It's just there on the slide.
Whoops.
Next.
Sorry.
Let's talk about that CHF question. Remember that
Yep.
one about?
Oh, yeah, great idea.
It was about Entresto.
Yes. Oh, boy. Okay.
you
It's
read those
kind of,
very
oh,
well?
man,
I
it's
find
far
it
down
not
there,
okay.
Jan.
Yeah. Well,
Okay, hang on.
Just redo it.
I was
Yeah.
just asking about Ken about you didn't talk a lot about Entresto, the new drugs out there.
I got
Any
it,
role
I got
for
it.
that?
I'm getting there.
okay.
Boom,
There.
boom, 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 boom. There it is.
The neprisilin inhibitors, which is Entresto.
Entresto.
Yeah, no, it's getting lots of attention, I can tell you that. And
So
it's,
not everybody's familiar with it,
it's- okay.
including me.
Oh,
Because so
Entresto
explain.
for CHF?
Yeah,
Yeah,
explain.
it's a new drug to treat CHF, and it's sexy and it's new and it's popular and it's all over the cardiology literature. I haven't read enough to have a good opinion on it yet.
What
I
is
recall
out
a
there?
drug that they brought up, 15 years ago that was going to be the magic medicine.
Yeah.
That
Yes.
also fell off the map really fast.
Well, this originally I thought was created to get, what did Cheney have? What did he have for his heart before he got
Did he
his
have one?
He had
Sorry.
a heart?
heart trans?
No, he had an
Yeah, 'cause he had-
LVAD.
he
Oh,
lived
sorry,
on
I'm not
An
supposed to.
LVAD.
Yeah.
Yeah,
He
yeah,
lived
yeah,
on an
yeah,
LVAD
Oh,
forever.
gosh, he had
Yeah,
an
that guy
LVAD.
walked around on an LVAD for over a year.
Yeah, so I believe, so this was supposed to supplement, so you wouldn't have to go to the LVAD status. That was originally what I read about these drugs.
Actually, I don't know.
But I don't know what those, it'd be great to read in the literature if it was more effective, less effective, help with bridging time, whatever, to transplant, if that's what something was going to occur.
So, like most expensive medications, the early studies have all been pharma supported, pharma designed. So be very skeptical about who's writing the papers, because that's where the data is coming from. And so, like Diane said, we've been through this
Yeah,
before,
we
where
have.
this new
And that's-
expensive drug comes out, and the data kind of looks good.
It follows an arc. The standard arc is, look at how wonderful it is. Yeah, it's pretty good. Oh, we got a new drug. This is crap, right? And it follows this arc. And
But
so
it comes in a teal box, and it's so pretty.
But it might be very useful. I'm not saying that
I
it's
just
not.
haven't-
We
I
just
di-
don't know yet.
I haven't done a deep enough dive into
Yeah.
it
If you
to
watch,
really opine on it.
60 Minutes on Sunday night, where the commercials are all drug
Yeah.
commercials because the age distribution of people watching
It is
60
amazing,
Minutes
actually.
is about 65 or 70.
remarkable.
They talk about Entresto in terms of not basically prolonging your life, because if we acknowledge that CHF is ultimately going to probably kill you if something else doesn't, that the idea of prolonging life is kind of like an appealing concept. And I think it's really just a combination of two drugs, that it may be an ACE inhibitor and one other, and it was like, well, why combining these very common drugs into one pill does it become
Is
so
that what
expensive?
it is?
Would somebody look up Entresto?
It's about like modulation.
I'm on it.
Yeah,
I'm on it. Yeah.
It's this inhibitor of this thing, naproxen.
Yeah.
Yeah.
There's actually a lot of stuff on here about LVADs and Entresto.
Yeah.
But don't waste these
fascinating.
people's time looking.
Yeah,
at
sorry
it.
about that.
It's certainly not like a first-line therapy.
No,
it's one of
no,
these
no,
sort
no.
of like for late-stage CHF
Yeah.
that might help with modulation. And so I don't think it's reaching the levels of like what we would do with acute pulmonary edema.
Yeah, yeah, yeah.
ED.
Yeah.
Although
no.
the next question's a good one.
Yeah, nitro paste.
Nitro
Yeah.
paste.
Okay, so let's talk about that.
Yeah.
Just
So-
a thought on IV nitro. Paste is, well, I don't want to read this because it's not accurate.
Yeah. Well, I think the thing is to know what you get from nitro paste and what you don't. What you get from nitro paste is a moisturized skin area of your body where you applied it, but we're not sure how much drug gets anywhere in somebody who gets nitro paste. There's an amount that's in what you squirt on the thing, but what actually gets absorbed into the patient is completely unpredictable. And if it's something that you're treating that you really, really care about, like I'm having an acute ischemic event and I'm having a massive heart attack, or I'm in a really florid pulmonary edema, you really want something that you know for sure is going to get in there in a way that is predictable. So sublingual nitro is absorbed beautifully. IV nitro is given right into the vein. So you want something that you actually can predict that getting the response from. So nitro paste is not as predictable, and so it's one of those things that in the choices that we have, it is probably not the best choice for congestive heart failure.
Yeah, as long as you have a nice high blood pressure in these pulmonary edema cases, when they first started giving nitro, they were giving 2 or 3 tablets of this stuff at a time because the dose of nitro to dilate your coronary arteries is not the same dose that is going to drop your blood pressure.
Right, by a lot.
Well, having worked at the bedside for many years as a nurse, I remember giving a report to a nurse once where I said, oh, I've been putting on nitro paste, and I had this little card, and I was putting on the paste, and she goes, oh, well, I'm going to replace it, we'll get the next dose. She comes out, the thing's like a giant bubble of paste, didn't look anything like what I put on earlier, yet it was the same dose. So, yeah, I'm not a big fan of the paste.
Yeah. But there was another question in the Slido about the fact that if you start IV nitro, you're confining them to an ICU bed in most institutions, and there's not that many ICU beds these days. So is there an alternative? And so the nitro paste sounds very attractive, but it's not titratable, the lack of absorption. So usually, the role for nitro paste might be that you kind of get them over the hump with your IV nitro. Yeah. They're looking a lot better,
and
maybe
they do,
and they get better. I mean, IV nitro is magic, and now they don't need that ICU bed, and you can transition them to something.
Right, and that makes sense then on the back end.
So people are talking about sending some CHF patients home now.
I don't use nitro patches.
Okay.
Yeah, I don't think we have them.
You don't have nitro patches?
No, I don't
Do you have those in Canada?
Yeah.
Canada?
Yeah, we got 0.2, 0.3, 0.4, 0.8 of nitro patches.
Huh.
So we sometimes will just
they're
slap
here.
the patch
People
on.
have them. In
Oh,
fact,
okay.
sometimes, if you ever send anybody who's like
Severe hypotension,
yeah,
roll them over.
Roll them over, and look, we had a patient of them all over. Oh, no,
Ooh, look at that.
Take
It's
them
saran
off.
wrap everywhere.
We just had like this community tube of nitro paste that like everybody used. Like, yeah,
I was
no.
brushing my teeth and then I
Cute,
just
right?
dropped.
Oh. All right. Rick, this was going back to one of your talks. Do you normally discharge patients with pericarditis on NSAIDs and follow up with cardio?
Well, I personally have no experience because if they have pericarditis, they're going to be talking to a cardiologist someplace because it's interesting to treat, not that common, and I'm not going to make that call. It's above my pay grade.
I think that it's not uncommon to send somebody home with pericarditis when you've done an
No, I think
ultrasound
that
and
might
look,
be-
yeah, and look at.
Would they have seen
yeah.
the cardiologist?
Not at our place.
No.
So
No.
I've had
No.
pericarditis
No.
5 times.
No?
I have had pericarditis 5 times, and every single time I've gone home. I don't go home with NSAIDs, though. They give me prednisone, which is the only thing that's ever really worked for my pericarditis. And I've seen a cardiologist since I was 18 years old. And every cardiologist I've talked to about it prefer prednisone. That's usually what they give anyway. Sure, you could use NSAIDs, but I've never been admitted, and it's extremely painful.
Yeah, but I'm not sure that's standard. So that may be the people that you've seen that like it, but I think the standard is make sure there's not a pericardial effusion.
Yes,
so
of
check,
course.
make sure.
Yeah.
For sure.
And then non-steroidals are kind of the go-to first. Colchicine has been brought up as well, but non-steroidals are
Yeah,
kind of the go-to.
colchicine. Yep.
Well, that's kind of weird because, you use colchicine for gout, the kind of thing they used to use it. But steroids are so easy, so effective, and
Yeah,
you're not
Diane,
dealing
what's-
with this toxic drug kind of
Yeah.
thing.
What's wrong with the steroids?
I'm not saying there's anything wrong. I just don't know that that's the most cardiologists recommend. That's the only thing I would kind of push back on.
We send them home from our rural site just because there isn't a cardiologist, and they'll see him in clinic.
Yeah.
You know, like I'll have maybe a chat with them or send them the ECG at times if there's a diagnostic dilemma and those types of things.
They can follow up.
But they follow up, yeah, and I treat them with NSAIDs, not usually steroids.
Okay, noted.
Sometimes colchicine.
Yeah.
Are we done?
I think we're over
I
time.
think
Oh, we're
we're
over.
over.
Sorry, you guys. We'll see
All
you
right,
tomorrow
thanks.
morning. Thank you.
All right, we'll stick around and we're going to start
my
the show
God,
in
I got a
about
loose screw.
4 to 5 minutes.
Oh, wow. You're going to do it right
Yeah,
here, right now?
Look at this, I got a loose screw.
Oh,
Did
well,
you-
do you
I
knew
knew
that
take-
already.
You're
Do you want us to
joining
do anything with
for
these
dinner,
chairs?
I
You want
guess.
to leave them?
No, we're going to leave them.
Nice to see you.
Good to see you.
Hello. Welcome, welcome.
I guess I'm behind the times on the
Hi,
prednisone.
Mike. How are
Rick,
you?
Rick, I mean,
Good
prednisone
to see
for
you.
pericarditis. I mean, that was a gym thing too. I mean, that's not what I've ever always been taught. But it's NSAIDs. That's
Alrighty.
our go-to.
How's it going, eh?
Alrighty, good, eh?
Well, they
Yeah,
would
nice to
be the
see you,
same
eh?
People who say,
Poser.
Stupid.
you know, for gout,
I'm sorry, but I think that's wrong.
Steroids-
Hi, Bill.
steroids for gout are like is incredibly easy.
I know.
good,
I mean, I don't get it. I
effective.
mean, I
You
think
want an
that's saying-
anti-inflammatory? It's NSAIDs versus.
It's a YouTube
steroids.
live feed.
Well, there's no comparison.
I never took
It's
it. I
YouTube,
never-
though.
You are giving away a big prize at the show here, in case that entices anybody.
I found
You guys
this
feel
piece
free
of
to
tech
move closer too if
on
you
the
want.
stage.
Hi.
Hi.
Mike's sort
How are
of
you?
trying on
Good.
Good to see you.
It's funny that I haven't seen you in person in like 6 months after all we've been talking over the past like few months.
I
Like,
know. I know.
yeah, crazy.
I know.
Listen,
Oh, Bill, please.
I've worked in CV surgery for a number of years at
Oh,
Fairfax
okay.
Hospital.
That's where I worked.
no,
I know, but Fairfax, I was there for 10 years.
Innova.
Gosh, let's see, 2006 to
You flying back now?
2016 in the ER.
How far is it?
I was
to
the
here?
sepsis nurse for 3 years too.
4
I came
hours.
to-
Oh, okay. I was thinking like 8 hours or something. That'd be crazy to drive.
Well, how did our paths not cross? I did my training starting in
What do you mean we?
2006 as a student, and I was hired full time in 2008.
Oh, I didn't know that. Oh, hi. How
What's
are
your last name? Then you must know John Amrine.
Oh, of course.
He's my
Oh,
homie.
He
He left and then he came back and I trained
And
him.
yourself?
I live in Sioux, just south of
These, these,
Okay.
Yeah.
This
Wow.
is one of my PA colleagues when I
Yep.
Oh.
So I do a lot of Northern Ontario relief
Yeah, little
shifts,
frack. Oh my gosh, did my
as
grandmother's
part
surgery.
of a government
Best
program
car-
called
oh.
Health Force Ontario. So
Yes. Oh
I'll-
my gosh.
I go to Lake of the Woods in Kenora. You know, I'll fly into Winterpeg, Manitoba, and rent a car and drive over. But I also go up to there's the Sioux, of course. I've worked in the Sioux
Yeah.
for their
Yeah.
emergency department, and I've worked in Elliott Lake.
That's phenomenal.
Iroquois
Yeah, oh my
Falls,
gosh.
Blind River,
Yeah, my grandmother, I swear,
Matheson,
he saved her life, for sure.
What's that? The
Oh,
cap?
so long
Caps
ago.
casing,
I mean, she lived to be
Kirkland Lake,
93.
all sorts of
And
stuff.
I think she had her surgery like in her 70s.
Wow.
Like,
Oh, yeah, I
it
know
was
where
ridiculous.
Aspinall
It
is.
was one of the first ones they did at Fairfax.
God's country, as they say. Lots of little lakes and beautiful place. Yeah.
She
Great.
had
So are you enjoying the course?
bypass.
Are you? Yeah.
I was with them from 91 to 99.
And what do you do?
Okay.
What-
So maybe it was the 80s. Maybe it was late 80s. But
And what
either
do you
way,
do
she
there,
lived for a
though?
really long time and he did
how do we
surgery.
do this, Dave?
What's your last name again? Bosley.
No, I
We
don't know
should
what people
move
like.
this
what
out.
Oh, gosh.
their
Yeah, we're gonna
qualifications are.
have a computer up
Oh,
here.
he knows me.
Yeah, no,
has
'cause-
kind of our
'cause-
script for
no,
the
no,
show
there's
on
just there's
here.
PAs, there's
But
NPs,
we'll
there's
also
MPs,
kind of like
there's
just
DOs. I
freewheel it
never
off
Yeah,
of the
Oh,
PowerPoint.
you're a
Glenn
nurse 'cause
Druckenbrod.
you're-
Yeah, he did a lot of my NP
So
training with me.
and you do?
Mhm.
Okay, cool.
Yeah, so where are
you're
you
a
now?
PA
Ken
then.
coming? Was that?
And you were in the
I don't
military?
think
Okay,
Ken's
I
a
worked in Mount
top
Vernon
of
for a short
this,
period of
I know
time.
but I
that
think
a
he's
lot of
coming for
PAs came
dinner.
out of the
Yeah.
military
Oh, yeah.
program,
I think.
didn't they?
Yeah,
Like
he
I know
is.
Mike
Okay.
Sharman
Alright.
did.
gosh.
I think
been-
it's
Stuff like
us
that, a lot of
three.
Red Embry,
If you're
so-
into
In
this,
Canada, we don't
and
have a lot
maybe
of
Diane was
PAs.
going to sit in
We
as
only
well.
have one
Okay.
PA school
Yes.
in Hamilton.
Be good.
Gosh,
That's something
when
that
was I there?
knows.
2014
You fit the bill pretty well for that.
2017?
No.
Maybe?
You know, I must admit.
Yeah, I worked. Oh,
I
no,
don't
but
know what
Alex,
the,
Mount
menu
Vernon,
is for
Sibley,
tonight in terms of this,
uh,
what are we
Montgomery,
This show here?
Yeah, recently.
stuff you know.
Metzgar, Olney County.
He just,
There's
no,
everywhere.
no,
We're
just in the last
different
week,
COVID
he was out
There's
saying because we're having staffing
mastitis.
shortages
The new
and
things about
crises
mastitis,
and
so it's new for everybody.
shortages and,
Oh,
so
Jesus.
that's good. We're all on the even footing
critical
there.
access hospitals. We had
Paranoia.
critical
That's
access
Well,
easy
hospitals.
bread and butter
I'm
stuff
really
there.
glad your name
And
Bill
then
Bosley
there are
now
some-
is
you'll love
completely
this, just
familiar
kind
to
of
me.
like
People said your
even-
name and I
even
know that I've
cases
been.
in March,
I had like
So,
a patient
we
bringing
definitely
a service
did.
dog. Like, what do you
Yeah.
do about that?
Well, way to
You
get
know,
into
and,
things. I'm glad that you
things
came.
like that. You know, so
I'm too
things
old
that,
for this.
weird.
Yeah.
This is
All
not
your
a-
experiences.
Oh,
not a
okay.
comfort
And
dog.
I remember when I went
Yes,
to
I
Matheson.
was. That was-
I
I
went
was
to your
absolutely there.
Buffalo. Was it
That's
your
the
Buffalo?
Yeah, I
question,
remember I
right?
wore a
48
short
hour
blouse
shift
shirt
there.
and
It's a
Diane
service
told me it was
animal.
too
And then
short. I had to go
drove
up and
the
so
change.
1
it's
hour
always,
to
as you
Matheson,
know, it's
and
like,
then started
I
a
can't
72
ask
hour
you,
shift, so I had a 1
She's
hour
very
gap.
conservative.
show me the papers. You know,
And it was
Anyway,
just
Phil,
like-
nice
I
to
can't
see you.
interrogate the dog or
72
its
hours,
owner,
I
but
saw
there are
5
things you can
people
ask and
in
stuff.
Matheson.
Okay.
It was weird.
That's tricky.
So I was bored out. I was
Yeah,
bored out of my mind.
yourself.
Wait,
That's Rick.
prednisone for pericarditis? I'm gonna lose sleep.
That,
on
no,
this.
no,
I've never heard of that before.
yeah, I
You've
brought a
never
bunch
heard of
medical
that?
legal
I've
cases
never
with
heard of
all
that.
that
Prednisone for
stuff
gout?
done, so.
Yeah.
Somebody's smiling.
I've
Somebody's
always heard
happy.
NSAIDs for pericarditis.
Oh,
but I've
good, as
never-
long
I've
as
not
there are
had it
happy
5
people in
times.
the audience.
So, I mean,
I never
you
know
have
if
5
is
times
this thing on?
experience.
Is anybody listening?
I guess infinity.
Am I making
times the
sense
experience
here?
that I do.
I'm gonna
Anybody
sleep in
getting the
middle.
jokes
Do
at
we have, I
all?
wonder if we have a little, like a lower table.
No, we don't.
You should like,
Nice to meet you
flap it.
too. I hope you
We're gonna
enjoy
do
the
that.
rest of the
How
course.
about I'll bring you, if you I can put another chair here, and you put the laptop on the chair.
No,
Oh, all right.
no, no. I appreciate that, but I'm.
All right. The chair
All right,
over
we're
there.
ready.
Is Diane joining us?
I don't know if she is. She might.
Diane? Oh, is she talking to?
She's having a combo.
Does this drive that?
Yeah.
I'll drive this, and you drive the computer. Is that okay?
Yeah. Can you can?
Yeah, I can look on.
Okay. All right.
Great.
This guy?
Yes.
It's only if you want to be.
Yes,
Well, I
he
don't
is.
want to.
Okay, then.
Get up here.
I don't want no.
Dave, you got a decent, are we in the frame?
I mean, but the live aspect. I mean, I'm gonna have to put on the
Oh,
frontal.
you'll be fine.
I have to put on the frontal lobe. Okay. I didn't wear anything sparkly.
That's all right. I think I've got everybody covered.
Sure, am I sure? Oh, yeah.
Oh, you betcha.
Jan already left.
You betcha.
The
She had-
sparkles were inside of you the
she-
whole time.
Yeah.
I'm
Yeah.
just-
She has
Teamwear.
family dinner plan things. So. All right.
I'm gonna put my phone out just so I can read off the script on my phone too.
Okay, cool.
What time is dinner then?
We're going to be quick. It's going to be less than 30 minutes.
It's around 7.
Barb's just asking me.
Oh, 7.
Okay.
Well, what time should we meet downstairs? 6:50?
I told Chips, 10 till.
When the dinner is.
Well, that is true.
Why don't we meet like at 6:30? Is that too soon?
Oh.
6:45.
6:45.
Well,
Yeah.
it is a little bit of a ride now.
Yeah, it's Chinatown. 6:45.
We don't want to be late now.
Yeah. Outside the
We'll-
check-in from
we'll
the
lose
Diamond
our-
Lounge.
We'll lose our spot.
Okay. All right, Dave, can you count us in? Oh, what? All right. Boy, okay. Okay. So, what's up? We're
go.
here.
Hey,
we're,
ready? Okay.
We're here in Las Vegas.
All right.
We're hosting an episode of The Two View, and we've been doing this podcast for almost 2 years now.
Yes.
Right? And I'm Martha Roberts. I'm a nurse practitioner.
Hi, I'm Mike Sharma. I'm an emergency medicine and urgent care PA from Dallas, Texas.
And we have Dr. Rick Bucata and Dr. Ken Milne here to help us for our topics today. Today we're going to cover a couple of things. We're going to talk about mastitis, we're going to talk about some paronychia with a really awesome video, and then we're also going to talk about some strange cases. What would you do? I'm just going to say one of the cases involves marbles and a dog.
So is this a 4-view podcast? Because you have your standard 2 views.
Okay.
Clearly, I'm an oblique, and then
Right.
we have the special views.
Sunrise, maybe?
Yeah, sunrise, sunset, but we have special
Frog
views.
leg.
Frog leg.
lateral
Ooh,
pelvis.
baby. That
Yeah,
sounds even better.
we have to have some special views on this show.
Well, if you want to tune in and listen to this podcast, we have several episodes up there. We cover a lot of really great topics. You can go to our liner notes that we're going to put in the show here for you. And we're available on Apple iTunes, on Spotify, and Fireside, which is our main site.
Yeah, you can go to our main site. It's called 2View, the number 2, view.fireside.fm.
Right.
And we've got every single show there. And this is our 22nd show, going way back. We've had Dr. Bucata, Dr. Milne. We've had Randy Danielson, who is a PA emeritus faculty from the boot camp. Diane's been on. Your father, Jim Roberts, was on
Late,
several
great
times.
Jim Roberts.
Yeah, so it's a great place. We have awesome guests here.
Yep. All right, well, so the first thing is we're going to, if you want to advance the
I
slide.
have slides to
please.
click, okay? Yeah, so, we wish COVID had started in Vegas, because as we all know, what starts in Vegas happens in Vegas. Ideally, it stays in Vegas here. Certain STDs, maybe not. But otherwise, yeah, they stay in Vegas here. let's talk about some of these hot topics. So COVID will make it quick. We're all going to be on the same footing here in terms of these new mastitis treatments, paronychia, a little bit of a deeper dive into paronychia, more than you might think. It sounds like a simple topic, but there are some kind of wrinkles we're going to go into. And then the ER is kind of like that friend that you know you shouldn't hang out with, but when you do, there's always like great stories to come out of it, okay? And so that's what we're going to do for our final segment here is kind of like weird cases Martha's seen recently and kind of how would we all handle these cases.
Yeah. So I first just want to give a couple of updates about COVID, that the monoclonal antibodies are no longer effective against the newer variants, specifically against this BQ1 and the BQ1.1. Yeah, we are, I don't know, how are we doing on COVID in Canada, Ken? I'm curious.
Were the monoclonal antibodies very effective?
To begin with?
Previously?
Yeah.
Yeah, like the evidence behind that.
Very effective?
Yeah.
Now we can say they're not effective.
Okay, they're clearly not effective and not recommended. The reason actually that I found out about this at first was because I got this really cool alert from the state of Vermont. And they send me little text messages and video and audio recordings. So I was getting this message, and I'm like listening to it, and I'm like, yeah, but they weren't really ever useful. So, but thanks for letting me know.
Well, I just don't know how useful they were, and I can understand it was a great idea to start with because we had people that we didn't have anything really much outside of symptomatic management to offer these individuals. We didn't have vaccination at the time. We didn't know about dexamethasone for admitted patients, and so people who had COVID, some of them wanted to donate their monoclonal antibodies and stuff like that, and so. So from a hypothesis standpoint and from a we want to help society standpoint, I get it. I just don't know how effective it really was, and certainly now that we have these new variants, it's really not proving to be effective.
Would you have given me yours, though?
If you ask.
Okay, all right, well, sure.
Anecdotally, they worked well, and we all know the strength of evidence for antidote, but I mentioned I'm an urgent care PA, and so where I work in urgent care, we've kind of made a name for ourselves as being kind of a COVID specialty clinic. So we were we have Evusheld in our fridge. We had all the different monoclonal antibodies, and people will get sent in by their PCPs from all different neighboring areas to come for antibodies. And, we did not hear of any cases where, hey, so-and-so got the antibodies, they were in the hospital a few days later. So anecdotally, very well, but I would definitely agree that in terms of randomized trials and stuff like that, that wasn't really there.
All right, what about the antivirals, though? We should mention that.
Yeah, so the antiviral treatments are still recommended. Now, a quick note about Evusheld in case you had been giving Evusheld. Again, Evusheld, that prophylactic treatment. So that was something to be given to high-risk people before they got COVID-19. That also, it seems to be less active against the current variant. So that also, I believe, has officially lost the EUA, at least here in the United States here. The current antiviral treatments are still the same. In order of the official kind of ranking in terms of which ones do you give. So the first one is still Paxlovid. That is the combination nirmatrelvir-ritonavir. Should be given within 5 days. The next rank one is the remdesivir. Operationally, a lot harder to give than Paxlovid here. So remdesivir, at least the insurances I've seen, you've got to get CBC, CMP, and coags. They've got to have clean of those labs, and then it's an infusion given IV for 3 days in a row. And that's just kind of a hassle. And number one, it costs a lot. So even our clinic that was very specialized did not have this in hand. So I don't know how well remdesivir is being operationalized, so to speak. Because I live in Dallas, Texas, pretty big city, and it's hard to get there, okay? Lastly, molnupiravir, that is kind of seen to be much lesser effective compared to the other two. The nice thing there is that the drug-drug interactions. I think that's why a lot of people don't want to get into the whole Paxlovid thing, because you have to check so many drugs and make sure that they are safe to take Paxlovid with all the different polypharmacy the patient already has. And who are these high-risk patients? These patients who are older and already have polypharmacy. So molnupiravir, less polypharmacy concerns with mixing, but the other concern is can't be given to kids or pregnant women. Less effective than the other two.
Was it a mortality benefit for Paxlovid?
In terms of what?
Was it a mortality benefit?
As far as like more effective, so to speak?
So did it decrease mortality?
So I think that...
Or did it decrease hospitalizations? Or
Yeah,
did it
no, I
decrease
know.
duration of symptoms? I'm trying
There
to...
you go, there you go.
Okay.
I know I like this talk, you know, like, I think that the data is still evolving, of course, right?
Good answer.
Epic HR is kind of the biggest study out there right now that deals with high-risk patients. By definition, for this study, this was non-vaccinated patients. Okay, so already, if you're dealing with a vaccinated patient, you know, what are we dealing with here in terms of like certainty of data?
Well, the external validity to a vaccinated patient really is if it was tested in unvaccinated patients and they're very severe, you would expect the magnitude of effect to be better in that cohort. But if you've got patients that aren't as severely unwell and are vaccinated, how much benefit can you expect, and would it be an objective benefit?
I did like the retrospective study coming out of Israel. It's been out for a little while now. It really broke down in kind of terms of 4 quadrants of patients. So just bear with me, visualize this for a second here. Imagine one quadrant, one half of the patients are 65 and older, and the other half are 65 and under. So that's one big division. And then you split each of those age cohorts into exposed to COVID previously, whether by vaccine or some other infection, or not. Okay, have we drawn those 4 boxes in our head kind of a little bit? So this kind of retrospective study from Israel suggested that if you are 65 years old and over, regardless of your previous COVID history here, there was some potential benefit in terms of hospitalization and death, preventing those things, 65 years and older, regardless of your history with COVID. Lesser benefit if you were under 65 and not exposed, but there the confidence interval crossed a certain line to where it's like, that data was not as reliable, so to speak. In the 65 and older patients, the short story there is a little stronger evidence that these things did seem to help. So yeah, I agree the jury's out.
But it's observational
It's observational, it's retrospective, so yeah. So
and it's
you kind of go with what you got.
Subgroup analysis of a retrospective study.
Yeah, I mean, we are definitely kind of getting to those like qualifications and decreasing levels of evidence here. I think this is one of those things where you're kind of in a way stuck. Because if you've got...
That's just what I was going to say.
You're stuck.
Because it's making me laugh.
This is the biggest pandemic of our time. Knock on whatever wood is next to you right now.
Let me knock on Ken's head.
There's no shortage of recommendations about give Paxlovid if it's an old person. Give Paxlovid if it's an old person here. And so if you fail to treat a person with Paxlovid, I think you may face an uphill climb in terms of why you didn't.
I totally agree with that. And we talk a little bit about that tomorrow during the cold and flu talk with Tammy Flu. So.
Perfect.
You know, anyway, we said the COVID segment would be quick.
Be quick, yeah.
So.
A nice quick COVID segment.
That's
just like all COVID segments. Nice, quick, and really clear in terms of evidence here. Yeah.
Right. Okay, so next segment we want to talk about mastitis, okay? So we typically think about this next topic in regards to pregnant women, but it can happen in any woman, and in men actually, who have gynecomastia, but very, very rare in men. Male breast infection in general is very uncommon. But if someone has severe immunocompromisation or diabetes, we might want to consider that. In general, this term, mastitis, refers to the female breast as swollen, hot, and painful. And it can occur, like I said, outside of breastfeeding, but certainly can happen any other time. When it occurs during breastfeeding, this is the lactational mastitis. And that's about between 2 and 10% of our breastfeeding women.
Usually we're dealing with, again, complaints of breast pain, maybe some sort of other discharge from the nipple beyond, what looks like milk, swelling, redness, pain to one or both breasts. This can radiate all the way down to the abdomen, all the way over to the axilla. And on exam, the breast is often kind of very firm, very hard. You want to look on exam for fluctuant areas, for little discrete areas where there's fluctuants that suggest an abscess, but generally it's more kind of diffusely firm and painful. Okay. Now, where this kind of came about, this including in the podcast today, is because there was a Substack that came out from this Dr. Emily Oster. So she is a economist, if I believe I understand by trade here.
Economist talking about mastitis, I love it.
Well, but they are all about the numbers game.
I know, but she's an awesome evidence-based practice doctor that specifically looks at the evidence and writes about it in a non-biased way. And I think her writing is very interesting. She wrote some really good books on parenting as well.
Yeah, and she's caught a lot of flack during this pandemic for different reasons, and I think for good and bad reasons here. But what she covered in the Substack, and what we're going to link to in our show notes, tview.fireside.fm, are these recommendations from the Academy of Breastfeeding Medicine, ABM, not a journal to whom I subscribe currently, okay? But we'll put this new paper in the liner notes here. It's got a lot of good graphics. I'm really glad I didn't print that out in color for my plane ride here, because that can kind of interesting as far as, hey, what are you reading over there? Oh, nothing. Don't mind me.
I was working on the Paranikia video that we're going to show you in a minute, and the guy next to me literally said, he's like, do you have to do that right now? And I go, yes, I do, actually. Exactly. Look away.
Seriously. I'm not forcing you to look at what I'm doing here.
Oh, my God. Okay. I've learned not to edit those on the plane. It was not my best moment.
Well, it's a relatively short paper, and do you want to kind of go over the keys you think that you see?
Yeah, so the keys of this paper, in the past, mastitis has been regarded as a single pathological entity in a lactating breast. However, scientific evidence now demonstrates that mastitis encompasses a spectrum of conditions, ductal inflammation, different types of edema within the breast. Anyway, so, there's a lot of really nerdy pathophysiology things that go on with mastitis. And this paper sort of breaks that down as well if you need a review of the pathophys.
One of the big problems with mastitis, how it kind of comes around, is there's kind of a supply and demand mismatch, so to speak. There is an oversupply of milk being made in the breast to what is being demanded out of the breast and being relieved from the breast, okay? And like any other problem in medicine where you have stasis of a fluid, right? You have someone who has a big prostate and their urine is static in their bladder, they're going to get urinary tract infections, okay? You have blood static in an extremity, you're going to get DVT. Well, if you have breast milk that is static in a breast, sometimes things can cause problems there as well, okay? This oversupply issue, usually most common in the early weeks of breastfeeding, or again, supply-demand mismatch. A lady is trying to stop breastfeeding, and so they're not having their child feed as much, and so that milk's not going anywhere, and that can cause a problem too.
How dare she stop breastfeeding? I mean, really.
Everyone's got to stop sometime.
I'm still breastfeeding.
The World Health Organization, I think, still recommends to the age of 2.
To 2, yeah exactly.
No, I know that they do.
I haven't looked recently, but I think that's what the
But I'm telling you, it's a lot of pressure that we put on women to continue to breastfeed.
Not exclusively breastfeeding until 2, but, I don't think we should be putting pressure on women to do anything that they don't feel comfortable doing.
Oh, I knew I liked you.
Yeah, no, but I mean, you do what you can, and there's no guilt involved.
Well, so
I still recall in PA school, my favorite instructor, I'll just go ahead and say it, Dr. Sylvester, you were my favorite instructor, if you didn't know that already, okay? And so he was our pediatrics instructor, and he said, all right, all class, raise your hands if you were breastfed when you were a child. And like roughly half the hands went up. Raise your hand if you were bottle fed only, not breastfed. And of course, the other half of the hands went up. And he looked around and he said, well, it looked like it worked out pretty good for all of you, didn't it? Okay, kind of saying, look, it's not breast is best, fed is best. Just make sure the kid has enough calories and for their brain.
Well, so we're going to talk more a little about this oversupply, right? So some people aren't gifted with this oversupply, and actually those people may consider themselves a little lucky to be at less risk for mastitis. But when you have that oversupply, you have bacterial growth, and then potentially this swelling, painfulness, tenderness, the engorgement essentially can lead to a really severe infection. They may complain of fever, fatigue, and many of these cases we treat with antibiotics. I do want to note that it is still fine to continue to breastfeed. We're going to get to why that's difficult in a moment when you're on antibiotics, okay? The correct antibiotics, and you can use your medical apps that we've talked about at this course to sort of review some of that.
I think maybe a new concept to us is that mastitis, early mastitis, if they came in, after just a couple hours or a day or two into the presentation here, some of this mastitis can relieve itself on its own, especially if it's before bacterial overgrowth has happened. You know, you fix the supply-demand mismatch, and that can kind of help there, okay? So how do we kind of fix that? What are some recommendations here? So increasing fluid intake. I think it's pretty rare for someone to say, like, you should be drinking less fluids. Like, generally, increasing fluid intake, good idea here, okay? Rest, acetaminophen, avoid anything putting a lot of pressure to the chest, so make sure the bras you're wearing are fitting appropriately, just for your new body habits here. Okay.
Hold on, before you read these next things, Mike, I want to just point out that what we're about to read you is now considered not suggested.
That's a good point, yeah. So these are all the things that you would have read, in fact, today. If you pull up to date today, this is what you'd probably read from up to date. And so let's kind of just go ahead to here. So these are kind of the old recommendations, what is thought of as kind of the current, what do you do? Okay, so old recommendations: warm compresses to the breast, take warm showers, breastfeed frequently starting with the affected breast, pump to get that milk out between feedings, and also massage the breast area. So these are all the old things, and these are the things that ABM is suggesting need to be changed in terms of our counseling of ladies with mastitis.
Right, and so what we're actually looking at in this paper, what is recommended, is that we're actually applying ice to the breast area. Warm compresses in general could make this worse, and it's painful. Continue to breastfeed, but do not favor the affected breast. In some cases, use only the unaffected breast. Also, recommendation to minimize breast pump usage. Do not pump and empty the breast. We don't want the breast to think it's going to make more milk, more milk, more milk. We don't want more milk. We already had too much milk. And then, of course, avoid deep massage of the breast, which might be a disappointment for some husbands or wives, whatever.
There you go. All right.
So in these new recommendations, did they give you a strength of recommendation, like a grade criteria, like how good was the data to back each of these recommendations up? Is level 1 evidence, level 2 evidence, level 3, or A,
Yes,
B,
so there
C?
were several studies cited by ABM.
Yep.
And I will post those. There were multiple.
Yep.
And
I'm just wondering what the grade recommendations were for each of them. So
yes, well, we will post those for sure.
I feel like we talked about this too. It's that a lot of this is more eminence over evidence. Would you agree, in terms of like, hey, we've seen these studies and they're compelling enough for us to change our stance as the American breastfeeding, sorry, the term escapes me right now.
ABM.
I just
ABM,
think,
there you go.
I just always think that the strength of the recommendation should be proportional to the strength of the evidence. And again, you brought it up before, you know, what did you say, fed is best, or right?
Yes.
You know, so I don't want to come up with a bunch of new recommendations saying, see, you aren't icing your breasts enough, you know, and like, do we have great evidence, or is that a consensus statement, a level C recommendation from a bunch of breast experts? But is that a level C recommendation to be wagging fingers? And so I'm just very cautious about saying thou shalt do this or thou shalt not do that, because it can lead to a lot of guilt during a time that is very difficult for new parents.
And this is especially true since these recommendations are just 180 degrees opposite from each other. It's,
so it'd be confusing, right? You know, like, am I hot, am I cold, do I massage, do I not massage? And how much evidence do we have to say that this is the right thing to do?
I hear what you're saying. I think this makes a good point. It's difficult. We were talking about the CDC yesterday, their recommendations and guidelines, and some of the things that Diane and I both disliked, but things that we liked also. So again, when a large certifying body of some sort, specialists of that, suggest something that we do based on evidence or literature. I know I don't have the specific evidence or literature to show you right at the moment. It's hard to say that you don't want to follow that guideline, that you don't want to do what they suggest. I mean, these are breast experts. These are the people, you know what I mean? So
it's in the name itself. They're guidelines.
Oh, sure. I don't disagree with you there at all.
And if you look at a large organization that writes the largest guidelines or the most recommendations, that would be the AHA, the American Heart Association. And they've looked at their recommendations over the last 10 years, and they took their thousands of recommendations and said, how many are level A recommendations based on really good evidence, randomized control trials, multiple randomized control trials, things like that. How many were level B and how many were level C? And only 9% were level A recommendations. Well, why did you tell me about the thousands of others that you don't have great evidence for? I mean, it's just a big signal to noise problem for me. And if half the recommendations were based on level C, just a bunch of experts sitting around, okay. But like how many times in the arc of the history of medicine have a bunch of experts sitting around been wrong?
Okay,
Like
again,
in the past year?
I
or?
get it.
Yeah.
I get it. So again,
She's reining me in.
and
that's fine.
I appreciate you.
These are experts,
Okay.
man.
But I just want to see what the grade recommendations
And-
are for how strongly I will make this recommendation when I'm counseling a woman when she comes in and she's breastfeeding and I'm diagnosing her with mastitis. How strong should I go? And so that's the more information I look forward to reading.
Well, yes, I hear you there, but a lot of these new recommendations, I feel like I have been putting into practice telling patients for a while. They make sense to me, and I wish I had done my own study on this. I mean, I would never put a warm compress on a hot red breast. Oh my gosh, that's so uncomfortable. Ice for sure. And then the oversupply, of course, I don't want to make more milk to cause more problems. So those things make sense to me as well. And I can tell you, the last one, yeah, that never helped either.
Okay.
So you can just take my word for that on that. But again,
You tried and tried. And
we tried, and it did not work. But I will say that, looking at the evidence in the literature, absolutely important. I will show you the papers. This is a large certifying body in regards to breast experts, and I don't hate it. I don't hate it.
maybe a way that this is going to be like operationalized. I keep on using that word because I just like saying it. Maybe this can kind of the real when you're with the patient is that like, hey, look, obviously you're uncomfortable, and you may have heard a lot of ways from your girlfriends or from your OBGYN in terms of what you should be doing for this mastitis here. I think the jury's out a little bit. I think you could try some other things if those things weren't working. Okay, at least give them the option of, hey, let's consider some other things, especially if you've tried what were the first line treatments and they failed. Okay, well, that opens us up to some other things maybe work better.
I just love having a bunch of dudes up here talking to me about what we should do with the boobs.
Well, there's
I'm
all
not.
of these.
Oh no. I'm just talking about the level of evidence.
Just saying.
That's all I'm sticking to.
Whatever. Okay.
I'm not touching that.
Don't touch that.
Let me explain.
Okay,
breasts
listen.
to
Can you
you.
not mansplain breasts to me right now? Okay.
Okay, fair enough.
Oh, phew,
Damn
something
it, man.
quick.
Well,
Code paronychia. Did you come up with this term?
Paronychia. Let's go to
Before we
paronychia.
do that,
yeah.
could I ask what is the antibiotic of choice
Oh,
for these
yeah.
conditions? Because we kind of skipped over that. Please.
Yeah.
Oh,
Did
sure.
they change the recommendation?
No.
Because I would think this is going from memory, cephalexin.
Yes,
I think
absolutely.
It's basically
Cephalexin's fine.
a staph bug.
Staph, strep, yes.
And you could even do some of these that aren't used for other things, like you could do like dicloxacillin, these other kind of like, what are they called here? The name eludes me. Basically, they have kind of resistance to the resistant enzyme for beta-lactamase. Beta-lactamase resistant. There we go. Hey, I was getting there. I was getting there.
I meant it.
We have all day, though,
Okay, all right, we gotta hurry. We gotta move it along.
All right. Speaking of antibiotics and such here, so yeah, paronychia.
Oh my God,
It's
code
never
paronychia.
Code paronychia.
Holy cow. Okay, so listen, I put a lot of work into this paronychia.
If you listen to this part of the lecture, all your metrics are going to improve, right?
Exactly.
I hate getting emails from the paronychia nurse. That's the
I
worst.
mean, seriously.
The
Gosh,
QI
I've had 3
department?
calls tonight. I wish Jillian was here so bad. So we joke because part of why we're talking about this, and I make a joke about paronychia. And Ken, why don't you tell the story of why this even came up?
Why? Oh, it came up. It's come up multiple times with regards to when we throw resources at a problem, the problem is better addressed. And so whether that is a code sepsis team, a code team, like just for a code team in your hospital, a code stroke, code MI, everything becomes a code. And if you add additional resources to that, you can get better outcomes, you can get better patient satisfactions. You can look at all these metrics that may not be patient-oriented, like how fast did they get treated? How fast did they get seen? How fast did they get their antibiotics, if that's the case? All of those things can be improved. And is it any of those individual components, or is it just say, we're going to call a code, and everybody stops in the department and focuses on that one individual, when we've got a whole department that are full of important people that have problems that they care about. And so I came up with this sarcastic sort of, well, then we should have a code paronychia team.
Anyway, get that man a hot water bath. Stat. Okay. Stat. I'd like to bring up the video. I don't want to go through all the pathophysiology of paronychia.
You have a video of code paronychia teams?
I do!
Of them, everybody, like, code paronychia,
There we go.
code paronychia, and everybody descends?
They come in.
Oh, wow.
It's crazy. Dave's going to cue that up.
It is crazy.
Okay, yeah, okay. So we're going to talk through this as we play it. So basically, this is your pretty angry paronychia here, right? At the base of the nail. It's not just something you can gently lift up and have expressed. You can see it takes up a large portion of the upper part of the digit. Doesn't involve, it's not a felon, right? So it doesn't involve the pad. So you're going to get your lidocaine, you're going to draw some up, you're going to grab yourself an IND kit and an 11-blade scalpel, and plus or minus a culture wand, right? So this is one of my favorite hand surgeons who actually wanted to remain nameless. A very modest physician who does a very good job draining these. Now, I don't normally call hand specialists to come drain these for me because you don't need to. See, she's doing the block here. This is just your typical.
I love this.
And the
This is modified
patient didn't
transthecal.
even flinch.
Yeah.
There was no flinching.
Yeah, you like that? You like that? Yep.
Because his finger hurts so much.
Right. So the only reason I called hand specialty down to do this was because we had 55 people in the waiting room and I had sicker people. And this person was more than happy to come down here and do that.
Well, it was nice to see the single puncture technique being used rather than, you know.
So now, but hold that thought. This particular physician truly believes in doing anesthetizing on both sides of the finger and the web space as well, because she says they will not feel a thing. They will not feel a thing, and the patient didn't. Wow. And she knows that she has achieved full anesthesia to the tip of that finger. She's not messing around. She wants that finger numb. Okay? So she does her little block. She finishes this out. You may not have to do this. Test the finger, see if it's numb. But this was her recommendation.
Make sure you're giving 15 minutes, by the way. After you do the block, give it some time.
Yeah,
I walk away and see another patient.
Exactly. Yeah. Discharge somebody or print out their paperwork and then come back.
The other thing is, are you using lidocaine or bupivacaine?
I use lidocaine. Bupivacaine is a better choice.
Yeah, it is, because this finger is going to hurt like mad.
We don't have any bupivacaine where we are right now, so that's why we use lidocaine. Long story.
I agree.
Anyway, so again, cleaning the finger, not soaking it in betadine. Don't do that. I get really mad. I get mad when people soak things in betadine.
It's just killing time.
Yeah, come on. Okay, she's testing the tip here, and here is the big reveal.
Oh boy.
Now, key
stand
to this. Look how she makes the incision. Pay attention here.
Hopefully she's wearing iPro.
The incision is not made straight across the nail bed for this intense paronychia. And the reason is because if it heals or starts to heal, it's going to seal off that area where the pus is draining. You want that to come out. She's going to get a little culture here. She loves cultures.
Yeah, I was going to say.
She loves them. You don't need to do this.
Only specialists do cultures.
But she loves them, and she wants them. She also does a lot of studies, so it's good for her.
Plus, if they failed antibiotics, that's when you do a culture too. Like if it's your second time, that's a good time to do it. First time, yeah. Oh.
Right, so she's finishing up, not much more time in the video here. She's expressing, she's pushing and expressing. Glad she did that finger block, pushing and expressing. She's going to push and...
That's with betadine on there too?
Express.
Is that blood?
Mm-hmm. And watch what is really interesting about this specific paronychia that she takes care of. So once she's done getting out all the pus, we know you want to see that. That's the fun part, right?
I thought more would be coming.
Yeah,
she goes way behind, and milks the finger.
I feel underwhelmed,
you know, honestly, there's nothing much coming out of there.
I was hoping for something like pimple popper.
It looks like more of a cellulitis.
You guys are just spoiled.
I wanted pus to splatter on the camera.
I wanted like, right in my eye.
Very little.
You know, my subungual hematoma video has 1.4 million hits on YouTube.
Really?
We should show that. It literally shoots up into the sky.
No, you don't want
and
it
I
to
do
hit you
slow-mo.
in the eye. You should wear appropriate eye
Yeah.
protection.
Okay, other key here.
Oh, okay.
She says, get rid of that flap of skin. You don't need to keep that on there. Get rid of it. People think that you should just fold it right back over.
It looked pretty dusky.
Yeah, get it out. You don't need it. We're done with that piece of skin. Okay? So she just carves it away. It's going to grow back. This is an otherwise healthy patient. And
So wait, tell me again, you were just saying that she doesn't cut one way, she cuts the other way. So like obviously that way is the way she cuts. How else would she cut this?
horizontally.
Parallel to
Yeah,
the
parallel.
proximal fold?
Correct. Yes.
Okay.
So
That heals funny, she
key,
says.
yes, she does. The key here is a dressing that stays on for 24 hours. Don't touch it for 24 hours. Okay?
Because why?
Because it needs that time to not only start the healing process, and I'm not saying there's literature for this, I'm just saying it's her preference. If you want to tell patients what to do, put the bandage on, take it off tomorrow night, and wash it with soap and water. It's also extremely painful to change these dressings.
leave it alone.
So you want to pre-medicate with some Motrin or Tylenol before you do a dressing change. I'm a big fan of that because they hurt. They're really painful. So anyway, that's the video.
How about this?
Is it approved?
Yeah, I was kind of surprised at how little pus was there. I was disappointed. I'd give it a 2 out of 5.
There's going to be a Yelp review, isn't there? Okay.
All right, moving on.
These are our last topics.
This
We're
is
going
an
to get out
important
of here.
question in my opinion, okay? So when it's that bad, when the finger is that bad, and I know you guys know the answer to this, I'm just kind of like tossing you a softball here. How do you know it's a paronychia and not a felon?
Because it didn't involve the pad of the finger.
But how do you know that?
Because I looked.
Okay, but how else? Like, what if it's all swollen? I'm asking you questions just so you can,
Well,
then
you
you know
know-
what to ask the patient.
Oh, I see.
That
'Cause-
was a worse looking finger than I would normally
looked-
expect with a paronychia.
It looked bad. That's what I'm saying. How do you know?
Okay, so you can take the ultrasound and look on the pad. Oh, go ahead. Yeah, it could be, a little bit. But more what you're looking for is fluctuance when you tap at it. And you can definitely throw the ultrasound on there. You could poke at it if you want.
To find the felon is what you're talking about?
To find the
or-
felon.
Okay. Well, Ken, do you have any opinion on?
No.
Now, a felon is a totally different 20-minute conversation, which we're not going to have. And there's some great videos that I have you can take a look at online. But we'll post all that for you in the liner notes.
Maybe this is just controversial, but like, I want to know where their pain is. Like, where is your pain worst? Is it worse to the pad, or is it worse up here?
Oh, is that
by
what
the
you
nail?
wanted me to
That's
say?
kind of where I was going.
Why don't you
yeah.
just say that, then?
I'm really disappointed that you didn't pick up.
I'm getting hangry. We need to end this.
Okay, I got there. So that's what I like to talk about with patients. When someone has a rowdy looking figure like that, where is your pain? Is it by the nail fold, or is
Do you
it
go like
pulsating?
this? Does
Is
it
the
hurt
pad?
here?
Yeah.
Does it hurt here? Does it hurt here? Oh, it's the pad of your finger. Is that how you do it?
If it hurts everywhere, then it's your finger that hurts.
Yeah, exactly.
Okay, very good.
All right, so let's end this with 4 really interesting cases I had 2
Quick
weeks
ones,
ago.
right?
They're super quick.
Super quick.
Super quick.
You know that it'll all be evidence-based. Yep.
This is
Ken,
where
tell me
evidence
more.
fails.
Tell me
okay?
more.
These are weird stories.
Something in my eye.
I got someone on my nose. Okay. These are 4 cases I had last week, and I just want to know briefly what you think you would do. The first one is a man comes in with his dog. Okay, he has no papers to say that it's a support animal
Or a service animal.
or a service animal of any kind, and he has no friends or family or anybody that can take the dog. What do we do?
As a hospital administrator, I would check with if we have any kind of policy on that to make sure that we're following the appropriate hospital policy. Because while I want to respect that patient and their needs, I also have to consider the needs and respect all the other patients in there. Some of them might have may be triggered by a dog. Some of them may have allergies to a dog. There might be other considerations besides that one individual, but it'd be one of those conversations with that individual to see how we can both accommodate them and their dog, because you know that I am a dog lover, so I would want to make sure if I was on shift, it might be the time for maybe I'll take my 10-minute break while somebody assesses them or something like that. So, and I would have puppy time, because there is good evidence that shows that having a dog come in for therapy can really help your staff morale.
Yeah, so if you have dogs come in from therapy, it's not like dogs are not allowed in the building kind of thing. They're dirty and they're going to contaminate everything.
But
So
those
I would
dogs
tend to
would,
lean
those
on
dogs
the-
would have been vetted, though, right? Whereas this would
That's
be an
true.
unknown dog. We don't know
Yes,
if they
it's an
have
unknown dog.
of all their.
Looks like
This
a
is a
reasonable
stranger dog.
No, but I assume that
We haven't told me the answer, though.
the dogs that come in, for therapy dogs,
What is the
have been
answer?
screened and cleared.
What is the answer? This is the kind of stuff that I have every week at the General. What do you do?
You're going to want to autoclave those therapy dogs too before they come in. Just
Is that
make sure
how-
they're really
yeah.
clean.
I would tend to let them bring the dog in.
Okay, it's wrong. You can't. You can't bring a dog
Wait,
in.
huh?
Nope, you can't do it.
Says
As
who?
Ken said, says
There's
almost
hospital
every hospital
policies.
policy. So
Well,
what you have to
that's-
do is
that's
call
the
animal
difference.
control.
If you have a policy, it's one thing, but if there's no policy, I would
So-
tend to lean on the more forgiving side.
Unfortunately, as much as I would love to have that dog stay, animal control must be called. They come retrieve the animal.
Oh my God.
And the patient has 30 days to pick up the dog, and
I
typically
don't know that we have anything to learn from this because that's ridiculous.
Don't get mad at me.
Okay, so here's what you would learn then. Okay, so this is where you get your house soup involved. This is where you call the administrator on duty.
Yeah.
And
That's why I said
that's what I'd
just
say.
check, because it's an unusual situation for me and when an unusual situation comes up, I don't want to be the one making a solo decision. I'd be like, that's unusual. Check with a colleague, check with the hospital administrator, check if you have a policy on that to address that situation. There's nothing life-threatening going on, so we have time to actually find out.
Do you have a question? We have a question, you guys.
We've done that before too.
Do you
so
work
the
critical?
comment from the audience. Go ahead, sorry.
I was just going to say a critical access hospital.
Yeah.
Yeah.
Rural
Rural
hashtag
hospital.
rural.
Vermont? Was it Vermont? Oh, Texas.
So an
All right.
audience member
repeat
said
what
that they
you
had
said.
one of their
So-
nurses agreed to take the dog home while that patient was being cared for. They cared for the dog,
Right.
and they worked at a critical access rural hospital. I think that's a wonderful story, and it's one of the reasons I love working in rural areas.
Look, if I could take every homeless person's dog home with me and feed them for several days,
You'd have a lot of dogs.
I'd have a lot of dogs.
All right.
Okay.
Next.
What's your next
Next.
next easy case?
How about even more difficult? Mom comes in with a 2-year-old child, has no friends or family. What do we do with her child when she's admitted?
Well, you call animal control, and then
Look at hospital policy.
Okay, yeah, what else?
That would be children. That would be child services, wouldn't
Yeah,
it?
right.
No,
No,
not always.
not always.
So anytime.
nothing is always though.
No, but so I'm saying your immediate instinct is to call CPS. No, it's not. It's actually to call social work.
Social worker, and then they
Okay.
can.
Because
they
as
can
soon
do
as you file anything with CPS, that patient potentially could have her children taken away. Like for a long time.
Yeah, that's
Well,
right.
that doesn't make
Some
a lot of
hospitals
sense.
don't have social
So
workers, though.
social work is necessary to help you coordinate this. Don't jump on the phone with CPS. This isn't a mandatory reporting thing. The mom is sick.
No, we just need a little help here.
You just
that's
need a
all.
little help.
You know.
Yep.
Now, are you taking that child home to your access area? There you go.
See?
Church. You said churches would get involved.
Churches are going to get involved there.
So there you go. That's a good one. So maybe you don't have robust social work
Yeah.
at your hospital, engaging local civic groups. Yeah, it's a good idea.
Just saying, these things happen. This is all last week.
This is all
Okay, second to last. Man, I love this one. Man took an edible at work, and he states that this is workman's comp because it happened at work. And his boss says, "Yeah, I guess it is workman's comp."
No, it's not.
It's not.
I would think.
Rick,
it's
do you want to
not.
explain why it's not working?
Well, it's what happens if you get sick eating your lunch that you brought to the to work. If you get sick eating your lunch, you brought this edible to work. It's like they're perfectly analogous. You can't say I got sick eating lunch. I had the staph endotoxin in it, and I already got it was the mayonnaise that was bad, and I got the vomiting and diarrhea. No, that's ridiculous.
So listen, in my hospital, this is a workman's comp case.
But I don't
I'm
think the
telling
state,
you.
the state of California would not go for this, though.
It is currently happening.
Okay, this will fall off eventually. I'm just
just-
predicting right now.
Yeah, I
so
agree.
here's the deal for people in the audience and listener, you at home here. So it's not about whether the thing happens at work or near work or on the way to work. It has nothing to do with that. It has to do with, does the injury or the whatever happen in the performance of your duties, of your actual duties. So eating lunch in the break room and you choke on your peanuts, That's not in the like your duties at work don't involve you eating peanuts unless you work for planners.
What if you work at
If
planners?
you work with planners, then maybe it does.
Peanut
Okay, that's
tester.
different.
Bad example.
Okay, bad example. Okay, moving on. If you are walking into work and it's icy in the parking lot and you slip in the parking lot, that's not a workers' comp claim. Okay, it just happened to be that where you slipped was in the parking lot. Walking as much as you have to enter the building to go to work, the way you walked through that patch of ice was not in the performance of your duties. This is how it's been explained to me. I've had a lot of, half the military is workers' comp. Let me just say that right now. Military is basically a great preparation for going into workers' comp as a civilian PA. And that's what I did after I got out of the military. I did a lot of workers' comp stuff. And so we had a lot of these kind of cases. This happened to work. I was driving to work and I got into an accident. Is that workers' comp?
Well, clearly that's not workers' comp.
You say
I mean, that's clearly. But an edible sure is. Okay, look, your hospitals, they're all going to be different. We got to get to this last one because, again, real case. And I want to see what you would have done. Woman puts marbles in her butt. Do we remove them or do we wait for a bowel movement? What would you do at the critical access place? Give her a laxative. What would you do? Would you go fishing for these marbles? Do you want to know how many marbles?
I do.
I'd like
How
to
many
do
Do you want to
rectal.
guess?
Can we do a rectal?
Marbles come in different sizes too.
They're the regular shooter marbles.
So the small ones.
Little
Yeah.
guys.
Yeah.
I would think that they would come out with some laxatives.
Okay.
I would ask the patient,
Oh, there you go again.
Okay.
because
What would you do?
there's more than one way to address this problem, right? And, each way may have some potential benefits and potential harms, and what's taking place in the department at the time, what are your resources, and what's their expectations, and so my answer is it all depends.
Okay.
I feel like she put them in, she could take them out, And you could even give her a glycerin suppository to kind of aid the passage here.
Okay, so what actually happened was I said, how many marbles did you put up there? I hadn't said that ever.
32.
No, she only put 12 up there, 12 marbles. And I said, well, what would you like to do?
Is this HIPAA in any way?
No, no one's.
'Cause- no, okay.
No, no one, no.
No, because
It's not.
it's a unique case. so.
No, you'll never hear about this case, and it could have been last week or it could have been last year.
All right.
I
I just wanted to bring that up because patient confidentiality.
Absolutely. It was not advertised in the newspaper, and it was not, and you'll never know any more about the patient. So,
Identifying details have been changed in case anyone's listening.
yeah, okay, actually, it could have been any number of marbles.
That's what I was getting at.
Okay, could be any number of marbles.
Sure.
So we'll say 12. And we gave a glycerin suppository, and patient had to go to the restroom, and we counted those marbles. There were the number that she said.
Whatever number.
Then we re-x-rayed. We were good.
There's a great study on how long it takes for bowels to pass, and it was done by a group in Australia called Don't Forget the Bubbles, and it's a pediatric
Oh,
group.
yeah.
And they swallowed Lego heads, and there were 6 members who swallowed the Lego heads, and then they sifted through their poop. This is all for the sake of science. And they sifted through their poop to see how fast this little Lego head would pass. They found 5 out of the 6. One person never discovered the Lego man's head.
Was that person you?
No, it wasn't. But they had all these very funny scores that went with it, and it got published. It got tons of hits. I think it was on one of the late night television shows, and yeah.
That's
Well,
a great group. Yeah, don't
yeah.
forget the bubbles. It's a great group.
Don't
All right,
forget the bubbles.
we need to stop. We're going to end this. We got to go to dinner. I'm really hungry, and we really appreciate your insight. Ken, you definitely push my buttons. But
I know.
I'll get that information for you. Okay, at the end of the day, you need to do what's best for your patient. You need to take into consideration your hospital policy. If you want to take that dog home, go for it. But I don't suggest fishing for marbles. So that's the end of the show. We are doing this every month. Next month, we'll be back at home at our desks. We definitely don't have time for that.
It's quick.
Okay, fine, go.
All right, so it's a tradition at this point. 22 episodes in, our 2-view trivia questions. Every time we have a 2-part trivia question, and for you guys and ladies who have been here so long, a long day, you will get a chance to win something right now, tonight. So prepare for your turn to be called on. We're going to look for the first hand to go up and we're going to call on that first hand. So just get stretch or whatever you got to do here, okay, in a second.
I'm glad you're putting out the rules.
Yeah.
Do you have to be in the audience?
I was just about to tell you, you cannot be
Okay, that's all I wanted
in the
to know.
running. God damn it, Ken. Go again. Go keep going.
All right, so well, first we do over last month's question and answer. So the trivia question from last month is, what is the nickname of the U.S. state of California and why? The answer is the Golden State, but why? The answer is this. California has a reputation for its golden hills, fields of gold, and of course all the gold in Hollywood. The California state nickname was given to it by miners who found large deposits of gold there during the 1849 gold rush. You want to give your joke? It's a funny joke.
No, you can tell my joke.
Okay, all right. I'm just going to pass.
If I-
It's your joke.
Wait,
I don't
so
wanna...
it's not funny? Well, let me read my
you
joke.
read it then.
Hold on.
Right there.
We will also accept the fact, we will also accept the fact that in summer, all the grass turns yellow or gold in color, hence making all the green fields shimmering in gold, ready to burn most of the time.
Yes. So our winner this time, appropriately from the U.S. state of California, is Jennifer Carlquist, PAC. She's a longtime listener and supporter of the two of you, and she wants to give a shout out to her husband, John.
Oh, John.
Aww.
Hey, John.
Hi, John.
Thanks, John.
All right, so congrats to you both. All right, do you want to do this month's?
This month coming up.
I should just do it because I wrote this part. I'll do it. I got this.
Can
Okay.
you do it in 2 minutes so that
Yes,
we can...
yes. Okay, get ready to raise your hands quick, okay?
Put your hand down.
And when I say go, okay, wait for it means I say go. Here is this month's two-part trivia question. Should we say what they're going to win first?
Yeah, they win a free online course.
You'll win a free online course. So
Just
whether
so you know,
it's
boss.
advanced boot camp, the heart course, high-risk EM, any one of these courses.
Trauma.
Emergency medicine and acute care.
Oh, my God.
Yes. So the possibilities are not endless, but there's an end.
No.
It's a high variety.
Well, the bleeding stops eventually, yeah.
Yeah, gotcha. All right. So wait till I say go. How many antivirals are currently approved for outpatient use against COVID-19, and how many monoclonal antibodies are currently approved for use against COVID-19? Go.
Right back.
In the back?
I don't know. It was either blue
You were
or
looking
critical
up.
access dude. I don't know. I think it was critical access dude.
I think you're right.
All right, critical access dude. What's the answer?
He has a name.
What's your name? Good. Ding ding ding.
Yeah, so outpatient antivirals is the first half of the question. So give your answer for that. You're saying one? One. Okay. Okay. Loudly say your answer just so it's not in doubt. Okay, so half of that answer is correct. I want to
Coat
throw
chick
it
in
to
the
the
back.
back.
Okay, good. What's your answer?
What's your name, first of all? Katie. Katie, so first off, give us your answer. How many outpatient antivirals are approved for the treatment of COVID-19 currently as of today? Okay.
God damn it.
Don't say that. All right. And okay. You were next. What's your name? Carrie.
Carrie, come on.
How many outpatient antivirals are approved? There are 3.
Yeah,
okay?
was anybody listening?
Two oral. The trick is 2 oral and 1 IV. That's where people got tripped up.
Yeah,
So I understand what
that's
you're saying.
That's all right.
So yeah, the Veklury, the Remdesivir, that's IV. Okay, 3 outpatient antivirals. How many monoclonal antibodies are approved right now?
Zilch.
0.
Yeah, you go.
Carrie wins. All right, very
Whoop,
good.
whoop,
Congratulations,
great
Carrie.
course.
All right.
Come see me after.
Yes, we'll chat after. Okay, well, great.
Okay,
so
that's
we can
it.
do our ending. Do you want to do the
We're done.
classic ending here?
This is it. We're just going to tell you how to email us. If you want to email us and give us your feedback, you can email us at 2viewcast@gmail.com. You can listen to the show on Google Podcasts. You can listen to the Apple iTunes. We have over 500,000 downloads now. I'm pretty excited about that. It's really crazy. And also, please rate us because that helps us get feedback and know what we're doing. And then if you want to look at any of our other courses, you can go to ccme.org.
Yes. And I also want to give a shout out, as always, our video engineers, Dave Pett over there, Dave Pett.
I love you,
You saw his
Dave.
naked torso if you were here for the ultrasound course previously. Okay, and Ricky Bucata, you might have seen the naked torso some other places. I don't know where. He's
And
the other
Chris
video.
Navarro, Chris, thank you so much for helping with everything today.
Yes,
I really
he was
appreciate
on the
it.
live today. Thank you, Chris Navarro. And then show notes always by Meg Dipple.
Meg,
I
thank
hope you
you.
are warm wherever you are right
So
now.
thanks again for tuning in, friends in EM. Share this podcast with a friend, share your thoughts via email, and thanks for sharing your time with us on the two of you.
Bye for now.
Have a
Bye-
good
bye
day and
for
a
now.
great shift. I never get to say that part.
Oh my
Yay!
God, Bill.
Woo!
Yeah.
Thank you, guys.